Hey everybody, Dr. Roviso here. In this video, we're going to talk about the lymphoid tissue, and this is a new unit, so we're just starting immunology here. We're really going to start with the bare bones basics in this video, and then we'll build up on some of the more difficult concepts to grasp. But in this video, we're primarily going to just talk about, some basic types of lymphoid tissue. We'll talk about some of the primary lymphoid organs, and then towards the end of this chapter, we'll talk about the secondary lymphoid organs, most notably the spleen and the lymph node. Like I said, we're just going to start with the basics here. So when we're talking about lymphoid tissue, the way to organize this in your brain without, going back to your histo and having to know all of the little details, the big thing here is to just organize this into primary and secondary types of lymphoid tissue. And so the primary types, the two big ones being the bone marrow and the thymus, which we'll talk about here. And, the thing to remember about the primary lymphoid tissue, that's primary because this is where your lymphocytes are usually going to form, particularly in the bone marrow, okay? And then we're also going to have lymphocyte development. So in the bone marrow, think B for bone marrow, B for B cells, primarily development of B cells in the bone marrow and development of T cells in the thymus. So we'll talk about that in a second. And then in terms of secondary forms of lymphoid tissue, the big two here are going to be the spleen and then the lymph node. And we'll talk about each of those in a little bit more detail in the upcoming video. But the idea here is these secondary tissues are not necessarily creating the lymphocytes, right? Like you'll see in the bone marrow, but instead this is where we're going to have lymphocytes activated, antigens that are coming in or antigen presenting cells that are coming into the lymph node, for example, to cause activation of B cells, T cells, and eventually proliferation of those cells. Okay, starting with the primary lymphoid organs, we're talking primarily about the bone marrow and the thymus. And remember, the bone marrow, the big thing to remember here is that this is where these cells are going to form. That's where we're going to turn hematopoietic stem cells into cells of the lymphoid lineage. So this process, again, is happening in the bone marrow. Okay, so this is going to be happening in the bone marrow. We're going to start off with a hematopoietic stem cell. And so these cells, they can differentiate a couple different ways. Two of the big categories here is going to be the lymphoid lineage and the myeloid lineage. Now, in general, the lymphoid lineage is what we're primarily focused with when we're talking about immuno. Okay, so in this unit, we'll primarily be on this side of the diagram. When we go on to hemonc, right, we'll talk more about some of the myeloid lineage cells here, okay? But for this video especially, and this chapter in general, we're mostly going to be talking about lymphocytes. And so the lymphoid lineage forms lymphocytes. And the three big ones to remember here are going to be B cells, T cells, and NK cells. These are natural killer cells, okay? And now the natural killer cells in general are going to be part of the innate immune system. Okay, so these are going to mostly be innate immune system. And you'll see that the B cells and the T cells are going to be part of the adaptive immune system. Everything here, by the way, is pretty much all also going to be part of the innate immune system. Kind of confusing, but again, these are just ways to organize these in your brain, is that you can see that all of these cells come from hematopoietic stem cells in the bone marrow. And so they're all going to be formed initially in the bone marrow. That's the important part. So the B cells and T cells both come from bone marrow. Where they mature is what's different. So the B cells are going to mature in the bone marrow, right? So they're going to stay in the bone marrow and mature in the bone marrow. Remember, B for B cells, B for bone marrow. That's where they're going to mature. Now the T cells, they're going to be formed in the bone marrow, but they mature in the thymus. So T for T cell, T for thymus. Okay. But remember that all three, the B cells, the T cells, and the natural killer cells, all form from hematopoietic stem cells that undergo into the lymphoid lineage. And this is stimulated by interleukin 7. We're going to talk about this in great detail to come. And again, the big point here, B cell proliferation and maturation happening here in the bone marrow. Now, the second major primary lymphoid organ is going to be the thymus. So I put on here a couple of the big things to know. Now, in general, there's a lot of information you can talk about when you're talking about the thymus, but I just want to remind you again, we're just kind of focusing on what's the big high yield stuff that we have to know. First thing that I would say, just to go back to your embryology, because we kind of already hit this a little bit in some of the previous videos, but remember the thymus is derived from the third pharyngeal pouch. Remember, your pharyngeal pouches are associated with endoderm. So pharyngeal pouches, remember, these are going to be associated with endoderm. It's important to remember this because remember, in DiGeorge syndrome, we have some abnormal development of the third and the fourth pharyngeal pouch, right? So these pouches don't form correctly in DiGeorge syndrome. So you can imagine, because the thymus comes from that pouch, if it doesn't form correctly, you're going to have deficiencies with the thymus. And so this is why with DiGeorge syndrome, we classically see this thymic aplasia, right? The thymus doesn't really form the way that it's supposed to in DiGeorge syndrome. And this has implications in the lymphoid system because remember, the T for thymus is for the T of T cell maturation. Okay, so if the thymus isn't working, then the T cells are not going to mature like they should. Remember, this is where the T cells are going to come to mature, and we're going to talk about that process in great detail. But there's a selection process essentially that's going to happen in the thymus as these T cells prepare for maturation. So again, if we have a disorder where the thymus isn't working, or we have thymic aplasia, we're not going to get T cell maturation, and so that's going to have some pretty significant consequences, as we'll talk about in the upcoming videos. Also, a little bit lower yield, but it's important to remember the thymus is an encapsulated organ. It has a pretty fibrous, thick capsule, as opposed to some of the other tissues like the spleen, which is very thin. And in general, you'll occasionally get histology images. The thymus isn't as high yield as compared to like the lymph nodes, for example. But just one thing to note here about the thymus. So in general, remember the cortex is going to be darker staining. So we're going to have a higher concentration of lymphocytes out here. So this whole area out here, this is going to be your thymic cortex. And then in the center, you're going to have the medulla, which is going to be lighter staining. In general, the cortex is going to be more superficial. For these lymphoid organs, the medulla is going to be deeper. And the one classic histologic image that occasionally comes up here for the thymus is going to be these Hassel corpuscles. Now, they don't really have, a very clear function. So there's nothing to really remember in terms of, physiologic function with these Hassel corpuscles. But the thing to remember is that, number one, they're located in the medulla, and just kind of recognize their appearance. When I see this kind of whirling, swirled appearance, I'm almost thinking of what you see with keratin pearls in a way. They're not completely related, but the representation of these Hassel corpuscles, that's kind of what it reminds me of in a way. And so that's kind of how I would organize it in my mind. Now, we already talked about DiGeorge syndrome, thymic aplasia, because you have abnormalities in the formation of the third and fourth pharyngeal pouch. You can also see severe combined immunodeficiency, is where you're basically wiping out your B cell and T cell population. And again, I'll talk about this in much greater detail to come, but this is also classically associated with thymic aplasia. The other big place that the thymus comes up is with thymomas. And myasthenia gravis, if you ever have a question, like we talked about in the neurology section, where you have a patient that has myasthenia, or very classic symptoms of myasthenia, right? You do an ice pack test or something, and their symptoms improve or whatever it is, or they have some fatigable weakness, and you're thinking myasthenia. In those situations, if you have solid evidence for myasthenia gravis, usually they'll say, okay, what's the next best step? CT scan just to look for a thymoma, okay, which would be some kind of mass, potentially something that's perineoplastic, releasing antibodies causing myasthenia, or causing worsening of symptoms potentially from the thymoma. Okay, so that's why we look for those. Now, what I want you to remember, and this gets very confusing, especially for your first couple of years of medical education, when you look at, a pediatric x-ray here, okay, so you might be saying, what is going on with this patient? Why is there this mediastinal widening? If I see mediastinal widening like this in an adult patient, I might immediately start to rattle off my differential. Is this an aortic dissection? Does this patient have anthrax, right? If I see some mediastinal widening like that. But if we're talking about a pediatric patient, particularly a patient that's like an infant, normally they're going to have a prominent thymic sail sign, is what it's sometimes called. In general, they're going to have a larger thymus. And so this is actually quite normal to see this very wide thymic tissue here, believe it or not. Now, as we age, what happens is over time, that thymus starts to involute a little bit. So that thymus is going to get a lot smaller, and it's going to get replaced with fatty tissue. And that's completely normal. That's what's supposed to happen. We shouldn't see massive mediastinal widening in a patient that's 40 years old, for example. In those situations, we might be going through our differential. Potentially, if they have myasthenia, we might be thinking thymoma. Okay, so just kind of keep that in mind. It's important to recognize the age of the patient you're dealing with when you see some of these images. All right, so let's talk a little bit about the secondary lymphoid organs. So the first one we'll talk about here is the spleen. When I think about the spleen, I like to organize it into two categories. I think about the white pulp and I think about the red pulp. Now, what I want you to do is just to think about how you would get into the spleen, right? If you were a cell or an antigen potentially, you'd come in through an artery here, okay? And you'd eventually kind of go off into one of the arterioles. And eventually, as you come out of this arteriole, the first thing you're gonna hit here is gonna be this white pulp. Okay, so you can see this white pulp is surrounding the arteriole. Okay, so that's the important thing. Now, what is in the white pulp? So there's two kind of major things. We got B cells and we have T cells. We have them both. The B cells are going to be in follicles. When you hear follicles in the lymphoid system, right, you're going to think about lymph nodes, you're going to think about the spleen. In both cases, follicles represent B cells. Okay, so that's going to be pretty consistent throughout. So remember that. Periarteriolar lymphatic sheaths, if I took a cross section here, let's just say that I, blowed this image up, right? I blow this image up and I have, I'm going to do this in kind of 3 dimensions. Here's my arteriole coming in. And then, maybe around this arteriole, I might have a bunch of T cells. Okay, let's just put a bunch of T's here. So here's a bunch of T cells. They're all kind of surrounding this vessel as it comes in. And remember, this whole thing around this arteriole is going to be surrounded in white pulp. Okay, so this is all going to be white pulp. So this whole area here, it's all going to be surrounded in white pulp. And that area around the arteriole, remember it says peri, right, around arteriolar lymphatic sheaths. It's almost like a sheath of T cells surrounding that arteriole. The whole purpose of that is if I have antigens coming in, right, those antigens can be recognized by the T cells. Okay, so that's the point. That's why they're there. So it's a dense lymphoid tissue surrounding the arterioles as you come in. Again, all in the white pulp. And like I said, we also have follicles there. Those follicles are going to have B cells. What are the B cells going to do? These B cells essentially will be producing antibodies. Okay, and so when we talk about things like, IgM, right? This is an immunoglobulin M. It's a type of immunoglobulin. IgG, right? IgE, all of these things, right? B cells are going to be producing those, right? These are going to be antibodies. We're going to draw them like that most of the time. But some of these, like IgM, they're going to have really, big structures, okay, potentially. They're all shaped a little differently, and we'll talk about that. But the point here is that the B cells will be making antibodies. The T cells here are going to be recognizing some of these antigens coming in, and we'll talk about all the details of what they're going to do. Okay, but for the purposes of this video, white pulp, follicles, B cells, periarteriolar lymphatic sheaths, T cells. Now, what happens when you go from the white pulp to the marginal zone? Okay, so the marginal zone, first of all, what is the marginal zone? Marginal zone is the area between the white pulp and the red pulp. So it's kind of like this really smaller zone here. I'm just going to put marginal zone here. And, if we were to kind of put a line out here to represent it, you can see here's all white, here's all red. And so it's this area kind of right between the two. Okay, so that would be your marginal zone. Okay, and this is a gross oversimplification, but it's really all you have to know in terms of this. Now, the marginal zone, you just have to remember there's a lot of phagocytic cells there, right? The antigen presentation from things that are coming from the blood can happen here. You can have macrophages or antigen presenting cells that can digest bacteria, foreign substances, present these to nearby lymphocytes. That's really the extent of it that you'd have to know here. Now, what about the red pulp? Okay, so you can see the red pulp is all this area around the white pulp, again, separated by the marginal zone. Now, red pulp is kind of easy to intuitively make sense of. So the red pulp is going to manage a lot of the red blood cells. Okay, so the arterioles are going to come in and they're going to go into these sinusoids. Okay, so let me kind of draw this out for you a little bit. So I'm going to use this pink color here. So let's just say this is my red pulp back here. Okay, again, the marginal zone is going to separate the white pulp and the red pulp. Red pulp is going to be back here, but think of your red pulp as having, maybe like more of a web-like characteristic shape. At least that's kind of how I think about it. Now, the reason I think about it like that is because the red blood cells that come out through here, right? The red blood cells that come out through here, they're going to have to traverse that red pulp and the sinusoids that go along with it. And they're going to have to come out of the other side. So take a look at this, right? So if you were just coming in here, right? If you were a red blood cell and you came in through this arteriole, you're going to have to traverse the white pulp, traverse the marginal zone, and get into this red pulp. And from this red pulp, you would eventually get to a venule and you'd find your way out and eventually get into the portal circulation, right? Through the splenic vein, etc. The point is, though, is that you're coming into this arteriole, you got to traverse this red pulp. Okay, so if you're a red blood cell, you got to get through the red pulp. And the red pulp is going to have a lot of these kind of sinusoids that are made essentially to try to trap the old red blood cells. Okay, because initially, right, you have a red blood cell that has a characteristic shape. But over time, that red blood cell is going to get very rigid and it's going to lose its flexibility, okay, and lose its shape. And so it's going to be unable to traverse through these sinusoids eventually. What happens is if that's the case, these macrophages, right, they're going to come up and eat up that red blood cell. The concept, though, is, let's just say you had an infection here of this red blood cell. Okay, so you had some infection in that red blood cell. Well, if we had the ability to eventually destroy these red blood cells because maybe the infection destroyed the structural integrity of the red blood cell, right? So the sinusoids would pick up on that, macrophages would digest this red blood cell and destroy this red blood cell and potentially the infection along with it. But if you had a patient that did not have a spleen, you wouldn't be able to digest these red blood cells, number one. And so you're going to get very characteristic red blood cell shapes, which we'll talk about in the hemonc section. I don't want to get too off track here. And the other thing, though, not only will you get very characteristic red blood cell shapes, but you'll also have difficulties, if you don't have a spleen, in clearing infections that attack red blood cells, like malaria. If we're talking about a patient that's from a more underdeveloped country where, malaria is endemic, that's usually how they'll tee up the question initially, right? That's going to be very classic. If they have their spleen removed, that's going to be a problem in a lot of these patients. What about in the US, northeastern US? What are you thinking about? right, of infections of red blood cells. You might be thinking about babesia. Things to keep in mind. If you have a splenectomy, my point is, don't just go to encapsulated bacteria. That's the classic kind of old school way that's presented, but also remember malaria and babesia exposure as well. Now, let's just take a step back here. I explained this part, but why, if you had your spleen removed, would you be at risk of these encapsulated bacteria? Okay, so let's clean this up for a second here. Okay, let's just imagine here I have some bacteria. Okay, so here's my bacteria, and normally I have some antigen presenting cells here in my body, and these antigen presenting cells, when they see this bacteria, they come in and they try to eat up this bacteria. Okay, so that's essentially what they would do. They undergo phagocytosis, present the antigens, right? And we'll go into all the details on that in a perfect world. However, there are things that bacteria can do to prevent that from happening. One of those things that's very classically asked about are going to be these capsules. Okay, so bacteria can have a capsule. Now, the three classic ones to know of that do this, the biggest one, number one, strep pneumo, by far. That's the important one to know. If you can only know one, Haemophilus influenza type B, Neisseria meningitis, those are also important. So they have a capsule. What this capsule does is it can prevent this antigen presenting cell from being able to digest it because it has this rigid capsule on it now. Okay, so the antigen presenting cell needs a way, essentially, to try to digest this bacteria now, right? It can't do it through just phagocytosis alone. So what can happen is, right, we have antibodies, right, in our blood, right? Let's just say we have some IgM antibody here floating around, and maybe this IgM antibody binds to the surface of this bacteria, okay? And in doing that, now this bacteria is essentially tagged for destruction. So now certain antigen presenting cells can bind to the other portion of this IgM. They can bind to this, and that will give them the signal to say, hey, you can digest this bacteria. Okay, and now the antigen presenting cell can engulf our bacteria again. Okay, so let's say this is my antigen presenting cell. Now the antigen presenting cell can engulf the bacteria because there was the IgM, there was the antibody on the surface. The other thing is, when you start tagging these bacteria, you open the door for complement. Okay, so you can have some complement floating around in the blood, particularly C3b, right? That will bind here and it would help destroy this bacteria eventually, right? So that's the concept. The concept is, if you have antibodies like IgM, they can bind to the surface of bacteria, target it for destruction. If you don't have a spleen, that's a problem because the spleen is very important in antibody production. In fact, nearly half of the body's total immunoglobulins come from the spleen. So if you don't have a spleen and you have encapsulated bacterial infections, right, that's a big problem because you can't tag that bacteria for destruction. And so again, if you don't have a spleen, you want to be very cautious with strep pneumo, Hib, Neisseria, so you vaccinate these patients because we have a vaccine for each of these, right? All three of these we have a vaccine for. The point is that you can vaccinate these patients because they're at increased risk of infection with encapsulated bacteria. Now, in what situations would a patient not have a spleen to begin with? Well, trauma is a big one. Particularly, think about patients that have mononucleosis, EBV infection, younger kids, usually adolescents, 16, 17 years old, right? If they have mononucleosis, that spleen's at risk for rupture with trauma, right? So remember, left upper quadrant between the 9th and 11th ribs usually is the area we're talking about. Now, hereditary spherocytosis, we'll talk about this on HEMONC. What's the treatment for it? Definitive treatment, splenectomy, right? You take the spleen out, but then these patients are at risk, right? You got to make sure they're vaccinated. Sometimes this vaccination schedule is actually even more aggressive than a patient that didn't have a splenectomy. And the same is true for sickle cell disease. In sickle cell disease, these patients can have a spleen physically, right, in their body, but it doesn't mean that it's working correctly. Sometimes all of these sickle cells can cause there to be decreased filtration, decreased perfusion to the spleen so that it eventually just doesn't work. It can atrophy. Okay, so that's something to keep in mind. Also keep in mind that a lot of the platelets are stored in the spleen and can also be filtered in the spleen. All right, let's talk about the lymph nodes. So the lymph nodes are probably the most important secondary lymphoid organ overall that you're going to get asked about. Now, the lymph nodes are broken up again into three categories. Again, cortex, we can think of that as being the more superficial layer, medulla, the more deep portion of the lymph node. And the paracortex is kind of like the inner cortex, so to speak, of these lymph nodes. Okay, so we'll talk about all three of these. And again, it's important to know, like previously, where are the B cells, where are the T cells? Okay, so again, B cells, we already said, when there's follicles, there's B cells, right? So the B cells are going to be located in the follicles, just like we saw with the spleen. Now, the difference in the lymph nodes is you do have to keep in mind there's primary follicles and secondary follicles. Okay, so this is actually one of those topics that, you know, it seems very detailed, but this is something that comes up quite frequently. So here's a lymph node. The thing that I want to call your attention to in this lymph node, two things. So the first one here, right, you can see that there's this kind of circular structure. There's a difference in the color gradient between, you know, this darker purple and this lighter pink purple color here. This circle here, this is going to be a primary follicle. Okay, so this is going to be a primary follicle. And I'll talk about what that is in just a second. And we also have secondary follicles. Okay, so, you know, this structure here will be a secondary follicle. So what's the difference? So the primary follicle, you can see that it has a pretty dense, dark color primarily around most of it. Okay, so that dense color is going to represent more lymphocytes, right? So this is going to have more lymphocytes that are kind of just sitting around dormant. Dense amount of B cells that are dormant. They haven't really been activated. Okay, that's the concept. That's why they're not moving. They're sleeping, so to speak, if that's an easy way for you to remember it. Now, the secondary follicles, on the other hand, you can think of these follicles as being activated. So I'll talk about how this whole process works in just a second to clear this up a little bit. But the secondary follicles, again, are going to be the ones that are activated. And so when they're activated, think about them moving around. So if you were trying to take a picture of them, right, on this slide, it'd be hard to pin one down, right, because they're moving around so fast. And so you don't get that dense, dormant appearance where you have really darker staining like you see with the primary follicle. Instead, you kind of have this very lighter color in the center of your follicles. And that lighter color is sometimes called the germinal center. Okay, so we can call this the germinal center of the follicle. Okay, and so those B cells that are in the middle that stain lighter, those B cells are undergoing isotype switching and being activated. And remember, what is isotype switching? Isotype switching is essentially where you're taking your standard IgM antibody, okay, which we'll talk about, that's going to be produced initially, and you can change the heavy chain of this antibody to make it IgG, you can make IgE, you can make IgA, okay, we'll talk about all of this, like I said, in great detail. And you do this by changing the heavy chain. Okay, so the heavy chain is going to allow you to change, you know, the structural integrity, so to speak, of the immunoglobulin. However, what you're going to notice on all of these is that the light chain is the same. So the light chain is essentially what is antigen specific. Like I said, we'll go through this in greater detail, just introducing it here, but that's the concept. So we have activation, antigen switching. There's a lot of things going on in the secondary follicles. They're staining lighter because we can't quite pin down those B cells. They're just moving, they're being activated, and that's just my intuitive way of remembering that. You can imagine, when would you have more activity in these secondary follicles? Well, if you had an infection, right? If you had an infection, B cells are more likely to be activated because there's an active infection, and so you're probably going to see more germinal centers, more secondary follicles. If a patient, for whatever reason, had a disease where they would have a deficiency in maturing these B cells, for example, X-linked A-gamma globulinemia, what's the issue here? Well, you can't make mature B cells. If you can't make mature B cells, right, we might not have follicle formation. So we can see a significant decline in the number of follicles just in general when we have X-linked A-gamma globulinemia, or SCID for that reason. But this classically gets asked about with X-linked A-gamma globulinemia because this primarily just affects B cells, whereas T cells tend to be spared here, and so that's why they like to test that. Again, big point here, follicles, B cells, germinal centers are going to be very classic for activated B cells likely undergoing isotype switching. Classically going to see more of this in the setting of an infection, less of this with diseases that prevent B cell maturation. Now, paracortex, so think about, you know, if you're just looking at this image here, right, so this is kind of the cortex that we talked about, and you can see here would be, you know, a secondary follicle, here would be a primary follicle potentially, and then there's an outer cortex out here, which is kind of what we were just looking at. The inner cortex, though, would be this region closer to the medulla. That's staining a bit lighter here on this image. And that inner cortex is sometimes called the paracortex, okay? And that's where the T cells are going to be located. So paracortex, T cells, follicles are in the cortex, and that's where we'll have the B cells. Okay, so paracortex, we have structures similar to the periarteriolar lymphatic sheaths. We have the high endothelial venules. Okay, and this essentially allows lymphocytes to enter the blood. And let me just kind of walk you through this. So again, you want to think about if you were a cell or bacteria potentially coming into a lymph node, right? You're going to come in through the artery, and then there's going to be some capillaries that aren't really well depicted here. So let's draw them in. So there's some capillaries. Okay, so you might have some capillaries running through this area around the paracortex and the medulla potentially, right? Okay, so let's just blow this up with a cross section. So let's just say that here's my post-capillary venule. We're blowing it up. And, you know, normally these venules will have endothelial cells. Okay, so I'm just going to draw some endothelial cells that surround the capillary. In these situations in the lymph node, sometimes we'll have these kind of gaps in here between some of the cells. Okay, so we might have some gaps there, might have some gaps here, might have some gaps here. Let's just say I had a T cell here, all right, a couple T cells here. Okay, they're inside of my blood vessel. When they're coming through here, right, they came in through this artery and they want to go into this lymph node. They want to go into the paracortex. Maybe they have an antigen that they want to present to a B cell potentially to allow class switching to occur. Okay, so these T cells are coming in hot, right? Maybe they have an antigen and they need to get here as soon as possible. So what they can do is, instead of them kind of going through, the venous side and eventually getting the lymphatic circulation and getting over to the lymph node, they can just cross over through these venules and get into the lymph node, particularly into the paracortex. So that's essentially what's happening here. So these T lymphocytes can kind of jump through, you can think of them as little spaces in between the wall, allowing the T lymphocytes to just get into the lymph node directly. Okay, so that's what they're there for. And these again are called the high endothelial venules. I'll circle it here. HEVs. And remember, those are in the paracortex. Now remember, the T cells, we'll talk about this in great detail, very much associated with viral and fungal infections. So if you had a viral or fungal infection, you would see a pretty significant increase in the density of the paracortex. In general, you might see some paracortical hypertrophy. Now, DeGeorge syndrome, remember, we talked about thymic aplasia, third pharyngeal pouch. Remember that. That's associated with DeGeorge syndrome. Now, if you had thymic aplasia, remember, the thymus is where the T cells mature. If you don't have mature T cells, you're going to have paracortical atrophy, right? You're going to have the opposite. Just like if we said, if you don't have mature B cells, you're going to have atrophy of your follicle. So just kind of, this is where you put all of the pieces together by understanding where these cells are from. Okay, so that's the multi-step integration and what we're talking about. Okay, finally, last thing here, the medulla. Again, that's going to be this inner layer. You're going to have your sinuses here. Here you'll see plasma cells, lymphocytes, and macrophages. The idea here is, right, we're bringing in this blood. Eventually, this blood is going to come out through our venous system. It's going to come out through an efferent vessel. And then we also have lymph coming in through afferent vessels and then leaving through efferent vessels. Okay, so we have lymph coming in through lymphatic vessels, and that lymph coming in is going to bring in lymphocytes, antigens, but we also have cells coming in from the arterial side, and that's all essentially getting mixed here. Let's just say that we have a B cell here. Okay, so we're just going to say we have some B cell. All right, so our B cell is going to run in to an antigen. Okay, so maybe we have a bacterial infection, and maybe there's an antigen from that bacteria floating around in the blood, and that antigen is going to run into smack dab into our B cell in the bloodstream somewhere. Okay, so this is all going to be happening in the bloodstream. And let's just say that this antigen has the same epitope as the B cell receptor, and we'll talk about all of that in a minute. But let's just say that that's the case. Essentially, let's just say that these guys are a match. So the B cell, what it will do is it might get activated, potentially. Okay, so this B cell might get activated. Let's put an orange circle around it. This is indicating that our B cell is now activated. So once this B cell is activated, one thing that it can do is it can turn into a plasma cell. Okay, so it can turn into a plasma cell. And plasma cells, you can think of them as factories for antibodies. So it can just pump out a bunch of antibodies against this bacteria, hoping that this antibody runs into that bacteria that had this antigen and then attaches itself to the surface, allowing it to undergo complement-mediated destruction or phagocytosis, like we kind of talked about. So that's one thing. But what the majority of B cells will do is they'll end up going to the lymph node. And since this is an activated B cell, once it gets to the lymph node, it's going to start forming germinal centers. Now, you can imagine, like I said, there's this pale area here. That's going to be the activated B cells. And the activated ones are kind of pushing all the dormant B cells out of the way. And so that's why you get this clear center region, and then you have this dark dormant region around it, because all of the B cells that are not part of the party, essentially, right? They don't have that same antigen receptor. They're going to be on the outskirts, while all of the B cells in the middle, these are all kind of planning their defense from this antigen. Okay, and that's the germinal center that we talked about in the secondary follicles that are activated because they ran into this antigen in the blood. Okay, so that's where the majority of the B cells are going to go, in the lymph node. And that's where this activation comes from. Okay, so that's that secondary germinal center. Now remember what I said. Once you get into the germinal center, those cells will undergo isotype switching. So these B cells that are in here, in the germinal center, that are activated, those cells are going to be undergoing isotype switching. So what that means is now they can make other antibodies. So you might get some of the B cells in that germinal center maybe some of these B cells will start making IgG antibodies, for example, or IgE antibodies, right? Depending on what this antigen was, right? If it's a parasitic infection, we might need more of our IgE antibodies, for example. So that's all going to depend. Okay, so there's certain cytokines that will stimulate that. We'll talk about it. And this whole isotype switching is going to happen largely because of some interaction with activated T cells. Okay, which we'll talk about, like I said, in greater detail. The idea is that you're also going to have T cells that are going to be floating around here in the bloodstream, right? So T cells can also potentially run into our antigen that's floating around in the bloodstream, right? It might run into that same antigen that can bind to it, and then these T cells might go on into this lymph node to stimulate the B cells to go isotype switching, which would form IgG, IgE, different isotypes here, IgA, etc. Okay, so that's going to happen because the T cell and the B cell will link up, and that will allow isotype switching to occur. And the specific markers that we talk about with this is going to be CD40 and CD40 ligand. Okay, and we'll go into more detail on all of this. But again, just to recap, we had a B cell in the bloodstream. It ran into some antigen. It went to the lymph node, then became very active in the germinal centers. We also had a T cell that ran into that same antigen. That T cell would also come into the lymph node, bind to that B cell. Okay, you have an interaction at a specific receptor, CD40 ligand. That's going to stimulate the isotype switching process to occur so we can turn our IgM antibodies into IgA, IgG, and IgE. Some of these B cells too might stay in the center here and form memory cells. Okay, so then if we ever get infected with this bug again, we would have cells already ready for it. Okay, so some of these B cells would form memory cells, and then some of these B cells here are also going to form the plasma cells that will undergo isotype switching that will create a host of different antibodies. Like I said, we'll go into all of this in much greater detail, but I just want you to have the framework for when we talk about the specific cofactors in the future. Okay, just to wrap this up here, Peyer's patches, just know that they're in the ileum, and know that if you had an antigen out here, that antigen, for it to get into this lymphoid tissue in the Peyer's patches, it would have to traverse this tissue via a specific cell type, and that cell type is the M cells. Okay, so that's important to remember. So the M cells allow the antigen to transport to the macrophages, to the antigen presenting cells, and then these B cells would eventually identify those antigens, right, that are in this lymphoid tissue. And you can see this kind of looks similar to the lymph node, right? You have this area in the center that looks very similar to that germinal center we just talked about. Okay, and so these active B cells would then go on to become plasma cells, plasma cell factories, and produce IgA. Whenever you have mucosal tissue, IgA is the antibody you want to think about. So particularly here in the GI system, so we sometimes call this the mucosal associated lymphoid tissue, the MALT. Okay, so just remember IgA, M cells, ileum, Peyer's patches, and then also just remember that the tonsils are also a secondary lymphoid organ. And these are the references for this video. I'll see you in the next one. Hey everybody, welcome to this end of chapter question. We'll give you 15 seconds to pause the video, read the question, and then we'll go through the answer and explanation. All right, so here we have a 22-day-old male with an uncomplicated prenatal history who's presenting to the emergency department with recent seizure activity and failure to thrive, okay? Vital signs reveal a temperature of 38.3 degrees Celsius or 101 degrees Fahrenheit. So this child has a fever, evidently here. Respiratory rate is 72 breaths per minute and heart rate is 164 beats per minute. Now, one thing just off the bat here, you might be reading some of these and, especially if you're like in a testing environment, if you're not sure what a normal respiratory rate is or what a normal heart rate should be, especially in a 22-day-old infant, in these situations, a lot of the times, step one doesn't expect you to know the correct reference ranges for these things. And when you're in situations like this where you're starting to read this and you're like kind of panicking, okay, I don't know if this is normal or not, just kind of keep going in the question. Usually there's something that will kind of indicate what's going on. Now, we already know that, 101 degree Fahrenheit temperature is obviously not normal. So there is something going on here. So just kind of reading through this a little bit further here. Physical examination reveals a harsh systolic ejection murmur at the left upper sternal border with a single S2. If you see an infant, especially, and they start to mention any kind of heart murmur, potentially you immediately want to start to think a little bit about congenital heart defects. So we'll kind of draw an arrow out here. You want to think a little bit about congenital heart defect. But let's kind of keep reading here and we'll kind of put this all together. So the initial labs that are done on this infant are significant for severe hypocalcemia. Remember, hypocalcemia in general is one of those electrolyte derangements that can potentiate seizure. Calcium supplementation and broad spectrum antibiotics antibiotics are initiated. Okay, so the antibiotics probably because the child's febrile, and then again the calcium because they're hypocalcemic. Chest X-ray reveals cardiomegaly, right? That might have something to do with the murmur that we heard here, and an absence of a thymic shadow. So far in this question, there's a lot of kind of non-specific things. An absence of a thymic shadow, though. Remember, when you're talking about an infant in particular, remember they're going to have a relatively large thymus, and remember this chapter we talked about the thymus being the site of T cell maturation, right? So if there's an absence of a thymic shadow, that's suggesting that potentially this infant might not have a thymus, right? Because we would expect a thymic shadow or a sale sign, for example, is another term you might see when they're referring to the imaging findings in infants. Okay, so if there's no thymus, right, we're concerned about T cell maturation. And in general, when you see an absence of a thymic shadow in an infant, especially in the setting of hypocalcemia, the first thing you want to be thinking about, right, no thymus, and you see hypocalcemia, the first thing you want to think about is going to be DeGeorge syndrome. Okay, in general, DeGeorge syndrome will very classically kind of present in this fashion. All right, and we'll talk about what DeGeorge syndrome is. There's a kind of a classic way to remember this, a mnemonic that's referred to very frequently as this catch-22, which I'll walk you through in a second. But before we do that, let's finish reading this here. So it looks like they did tracheal aspirate cultures that grew Enterobacter. Okay, so this child did have some form of infection. Over the following days, the infant develops pancytopenia and multi-organ failure with DIC. Unfortunately, despite numerous attempts at medical intervention, the infant will later expire. Okay, biopsies are obtained and reviewed. So the mediastinal soft tissue biopsies here failed to reveal significant parathyroid and thymic tissues, just like we kind of saw with the imaging findings, right? We said that there was an absence of a thymic shadow, and we're failing to reveal thymic tissue as well as parathyroid tissue, right? And so this is all kind of interlinked. The most important thing I want you to remember whenever you're doing any kind of board question, especially when you have kind of these like longer style vignettes that are becoming more popular, as you read through this, it's really easy to kind of, get a little nervous because you don't really know where this question's taking you. But the thing that you want to pay the most attention to is going to be the last sentence of the vignette where they're actually asking you a question, right? So here, lymph node specimens are most likely to reveal which of the following findings. So if we were to biopsy a lymph node specifically, right, that's the important part. We're biopsying a lymph node, what would we expect to see? We got to put the pieces together. First of all, we have to understand what's going on, right? And so there's some key things that you could take away from this to figure out what's going on. The first thing is there's an absence of a thymic shadow on imaging. The child presents with hypocalcemia and seizures and some form of infection. And we also did mediastinal soft tissue biopsies where we're not seeing any parathyroid or thymic tissues. So this is actually very classic for DeGeorge syndrome. So let's kind of walk through this. First of all, what's the problem in DeGeorge syndrome? The problem is we have a microdeletion, okay, a microdeletion on chromosome 22. And that's why we kind of remember this catch 22, because the deletion is on chromosome 22. Now, the problem here, what this does is essentially you have failure of the third and the fourth pharyngeal pouches to migrate, right? You have failure of third and fourth pharyngeal pouches to essentially go where they're supposed to go. And because of that, you end up with a hypoplastic or aplastic thymus, right? And the other problem is you can also end up with a hypoplastic or aplastic parathyroid gland, right? So your parathyroid gland can also be affected, right? And if the parathyroid gland is affected, remember the parathyroid gland is releasing parathyroid hormone, right, to maintain calcium levels, right? So if this is defective also, these patients can present with hypocalcemia, right? So we can presume that the hypocalcemia was probably the cause of the seizures in this infant. So the next question is, why did this infant expire from sepsis, right? What happened exactly here? Well, part of the reason could be because they had defective T cell maturation. And typically, especially infants with DeGeorge syndrome, these infants will have recurring infections, right? Classically, they'll present with recurrent infections and they'll have a difficult time kind of fighting off these infections. Now, this is kind of a lot of detail here. Do you have to go into all of this detail to answer this question? You really don't. You just have to understand that this is DeGeorge syndrome, and the key thing that we talked about in DeGeorge syndrome that you'll see is paracortical atrophy. And you might be wondering, why in the lymph nodes would you see paracortical atrophy in DeGeorge syndrome? And remember, the paracortex, right? The paracortex in the lymph node is where we're going to have a lot of the T cell, right? And so if you have defective T cell maturation, right? We just said in DeGeorge syndrome, you have defective T cell maturation, right? This isn't working because you have a hypoplastic or aplastic thymus. Well, if you don't have the T cells here, the paracortex is probably going to have some degree of atrophy. You might be saying, well, wait a second, this infant had an infection. Wouldn't we see something like a reactive paracortical hyperplasia. In other words, wouldn't we see the paracortex kind of undergoing hyperplasia in the setting of an infection? Now, normally you can see this. The paracortex can undergo hyperplasia in the setting of an infection. That's because the T cells are going to be very active, when there's a viral infection or a fungal infection, and we have stimulation of cellular immunity, right? But the concept here is that if we don't have the T cells to begin with, then we're not able to fight off the infection, right? And so you're probably not going to have reactive paracortical hyperplasia. If anything, it's going to be most likely to be atrophy in the paracortical tissues. And this is, can vary in an infant. But in general, when you see DiGeorge syndrome, because the issue is with the T cells, you have to make the association T cells paracortex, right? So that you'll most likely have paracortical atrophy. If we had an adult patient that, had an infection, then we would expect to see some degree of reactive paracortical hyperplasia, especially if it was a viral infection, right? Or we had some cellular mediated immune response. Now, while we're here, let's just kind of go through these other options here. So underdevelopment of primary and secondary follicles. So the primary and secondary follicles are also in the lymph node. Now recall, the primary follicle, so I'll just put a 1 for primary follicle, this is kind of where the dense dormant lymphocytes will be. And when we're talking about the follicles in the lymph node, remember, these are primarily going to be B cells, right? So the primary and the secondary follicles will primarily hold B cells, right? That both the B and the T cells, they're going to kind of start in the bone marrow. But the T cells will go to the thymus to mature, whereas the B cells will mature in the bone marrow, right? So the B cells are not really affected by the fact that we don't have thymic tissue. They're going to be more affected if we had an issue with the bone marrow, right? Their maturation, at least, would be more affected if we had an issue in the bone marrow. So we shouldn't really expect to have any issues in the primary follicles or the secondary follicles. And again, recall that the secondary follicles are kind of composed of kind of two areas. So you're going to have a kind of dark staining outside to the secondary follicles, where you still have some of the kind of dense dormant B cells. And then the inside is going to be more kind of pale staining, and this is going to be your germinal center. And this is going to be where you have a lot of B cells kind of moving around here, very active. And for us to have underdevelopment of primary and secondary follicles, this would be more classic for a disorder that would affect B cells. And in DiGeorge syndrome, we're mostly just affecting the T cells. The other options on here, we have central lobular necrosis and massive sinusoidal congestion. This is really just a distractor. This is more of something you might see in the liver. Now, it's possible you could make an argument that, well, maybe you'd see, sinusoidal congestion, you might see increased clotting factors, right? Because this child eventually, this biopsy happened after this child had DIC, potentially as a cause of death. But this isn't something that we, would classically see in the lymph node, at least. And then the last option on here, adipose tissue infiltration and hypocellularity. When you see adipose tissue infiltration and you start to see low degree of cell lines, you're thinking about something that, we'll talk about a little bit in the hematology section with the bone marrow specifically, where you can get like a myelofibrosis or an aplastic anemia, for example. But this would not be, very classic for, the lymph node in general. But again, more classic for a myelofibrosis or an aplastic anemia. Right? And this is going to be something that we see in the bone marrow specifically, usually not in the lymph nodes. Let's kind of wrap this up, just going through this catch-22 mnemonic. If you had trouble identifying that this was DiGeorge syndrome, one thing I want you to remember, when you're just memorizing catch-22 and all of these different acronyms and, easy ways to remember things, what we're writing here for this catch-22 is kind of hard to integrate into a vignette. So let me give you an example, right? So if I put, okay, C stands for cardiac anomalies, right? Well, you can remember cardiac anomalies, but you also have to understand how does that present in a question, right? So the hard part is taking this and then understanding that, a harsh systolic ejection murmur, cardiomegaly, right? These things all kind of come together in a question, and you have to associate that with the fact that the C is cardiac anomalies, right? So the thing that I like to do is I like to look for the most important findings of the catch-22, and then the other ones I can kind of integrate as I'm reading the stem. Now, I don't think cardiac anomalies is the most important thing in DiGeorge syndrome, but you can see things like, ventricular septal defects, you can see atrial septal defects, you can see tetralogy of Fallot also is very classically associated with this. The other thing you can see here, the A is usually anomalous face or facial defects, like a prominent nasal bridge. This C down here, just kind of jumping here, is cleft palate. So a lot of these, you can see these kind of, facial anomalies here also. The key things that I really want you to understand are going to be the H down here, which you can put for hypoparathyroidism, or you can put hypocalcemia, right? Kind of go hand in hand here. And then the T here is going to be thymic aplasia. Now again, in a board question, how does thymic aplasia present, right? You got to kind of put the pieces together. Thymic aplasia might present with them telling you that there's an absence of a thymic shadow, or they might tell you that they did a biopsy and there's not significant thymic tissues, or they could just give you an infant that has recurrent infections in the setting of hypocalcemia or seizures, right? So again, it's just putting this catch-22 into a practical kind of vignette style question to make sense of it. Hey everybody, Dr. Roviso here. In this video, we're going to talk about innate immunity, and then we'll touch on adaptive immunity in the next video. We really just want to compare these two and see kind of what's similar, what's different, what type of cells are we talking about, and then we'll use this as an opportunity to transition a little bit, just kind of introduce antigen presentation and that whole process. And this is something that we're really going to get the reps in on antigen presentation as we go through this video series to nail down a lot of these high yield facts, and we'll keep kind of adding layers to it as we go. All right, so when we're talking about innate immunity, we're talking about non-specific responses, right? Think of this as like, this is your standard defense. It's not really specific to a pathogen, right? It's just in general, these are our standard defense mechanisms. And I just want to say here with innate immunity, we're not just talking about cells in the bloodstream, for example. I mean, there's a lot of things, a lot of different defense mechanisms that your body has. For the skin, for example, right? The skin is protecting us from interaction with bacteria that are on the surface of, things that we're using every day, right? So our skin is going to be a defense mechanism. The gastric acid in the lumen of the stomach, that's a defense mechanism. So we have a lot of different defense mechanisms. When we're talking about questions in the immunology section, though, we're really going to focus on the specifics here, particularly in the blood and in the tissue parenchyma. So like I said, for innate immunity, it's just like your standard defense you're mounting. Again, non-specific, it's very rapid, right? As soon as you're exposed to a pathogen, you're going to have a rapid response. This is compared to adaptive immunity, right? In adaptive immunity, it takes time to build up that memory response for future exposures. Every response should be equal to the initial response. You're not going to get any memory here with innate immunity, okay? So that's important. Again, no memory with innate immunity, and all of this is juxtaposed again to adaptive immunity. Now, when you're talking about, okay, well, what kind of things would set off this innate immunity? What are some of the classic examples here? Okay, so let's just say that we have some immune cell here, okay? So this is going to be our immune cell, and this immune cell is going to at some point interact with this bacteria. Now, let's just say, for example, that this bacteria is a gram-negative bacteria. Maybe it's a gram-negative rod, for example. Now, one of the features of gram-negative rods is that they have lipopolysaccharide, right? They'll have LPS. Okay, so let's just say this has some LPS here. And so that LPS is an example of what we'll see as some kind of just general molecule that our body will recognize, right? Some type of pattern our body recognizes and says, hey, this is not good. This isn't something that is not supposed to be in the blood right now, right? It doesn't matter what type of bacteria it is. If it has LPS, the cells can recognize it. And that LPS is an example of one of these pathogen-associated molecular patterns. Now, how do we actually recognize these patterns? Well, our cells, right, our immune cells will have on them receptors called pathogen recognition receptor. The PRRs, the pathogen recognition receptors, are going to look for things like LPS, right? And this is being the pathogen-associated molecular pattern. It's looking for some non-specific pattern that in general, the body knows this is not good. It doesn't tell you that it's a specific antigen with a specific epitope. It just recognizes things like LPS. And an example of a pathogen recognition receptor, the classic one to remember, is going to be the toll-like receptors, okay? The TLRs, toll-like receptors. And we have that written here, toll-like receptors. So the toll-like receptors can recognize things like LPS, for example. And so these pathogen recognition receptors can bind to these molecular patterns that some of these pathogens have, the classic one being LPS. And when they do that, they'll recognize that this is something that is not right. And so this is going to set off the alarm bells, right? And so this is going to generate some type of immune response, right? We're going to release things like interleukin-1, which we'll talk about, TNF-alpha, right? We're just going to generate some kind of inflammatory immune response. Okay, that's the key. Another one here would be interleukin-8. Okay, so this is going to generate some acute inflammatory response. Notice what I said. This was non-specific, okay? It wasn't specific to one bacteria versus another. It's any bacteria that has lipopolysaccharide in their wall. It's rapid. As soon as it binds, we set off an acute inflammatory cascade. It's always going to be pretty much equal. It's always the same, right? It's not going to be different if I'm exposed 1 month versus another, okay? It's always going to be the same. There's no memory to these receptors. We're just identifying a pattern that we know shouldn't be there potentially. Now, how do we go from this immune cell to releasing all of these different cytokines in the blood? There's one particular transcription factor out here in the cytoplasm. So we have NF-κB. Okay, so NF-κB is going to go from the cytoplasm into the nucleus, and that's going to code for all of these kind of different acute inflammatory reactants. Okay, so that's how this whole process happens. So just to recap, right? So our immune cells in our blood, they have some non-specific pathogen recognition receptors. The classic one here is the toll-like receptor. There's different variants of these, but these pathogen recognition receptors are going to identify pathogen-associated molecular patterns like LPS, like bacterial flagellin is actually another very classic one. Viral nucleic acids, these are all very classic. So they're going to recognize these. And so These immune cells will then bind using these receptors, bind to these patterns, and then that's going to cause NFKB, this transcription factor, to go into the nucleus and then encode for these acute inflammatory reactants. And we'll go through all of these in the upcoming videos. Interleukin-1, TNF-alpha, interleukin-8 are all very classic. And these are the things that help stimulate the body to reset the hypothalamus set point, right? So you end up having a fever and regenerating an inflammatory response to kind of attack this infection. Again, very non-specific, very rapid. Now, in the category of innate immunity, there's some different things that you want to be familiar with. How do we actually go about targeting this bacteria for destruction? What can we do to actually destroy this bacteria once we've recognized it? Well, the big thing here, in our bloodstream, we have IgM. Now remember, IgM is an immunoglobulin. So IgM will actually bind specifically to its epitope. Okay, so we'll talk about this in the adaptive immunity section. However, IgM in general might just be floating around in the blood. IgM is going to kind of be like your standard immunoglobulin. So I want you to kind of think about it like your standard immunoglobulin. And the one thing that makes this different from some of these other things on here is that it actually is specific to one pathogen. Okay, so immunoglobulins in general are specific to a pathogen. However, IgM isn't involved in memory responses per se. It's just kind of your standard immunoglobulin that's going to be released usually in an initial infection, okay? And then later on, we'll have class switching, right? When we have class switching, we can upgrade this to IgG, IgE, IgA, right? We'll talk about all of this in the next video. When IgM binds, it does bind specifically, so just keep that in mind. That's kind of tricky, but it's sometimes categorized here in the innate immune response because it doesn't involve class switching and having any type of memory response per se. Okay, the other things on here, complement membrane attack complex, C3b. We'll talk all about this. Lysozyme, which can change the pH of some of these cells for destruction. Lactoferrin, also very classic. So these are just things to be familiar with, part of the innate immune response. And then the respiratory burst pathway, which we'll talk about in great detail in a video to come up on neutrophils. By the way, this thing that we're looking at here, this is going to be a neutrophil. Okay, so we're looking at a neutrophil, and I'll talk about how to distinguish these in just a second. But this neutrophil, how is this neutrophil going to attack this bacteria with this innate immune response using some of these things we talked about? So the first thing this neutrophil can do is it can use phagocytosis. Okay, so thinking of the Pac-Man, right? This neutrophil can eat up this bacteria, and once it eats up this bacteria, it can take the components of that bacteria and put that into phagolysosomes. Okay, so it can put it into phagolysosomes, and then it can use chemicals like lysozyme to try to break down the components of this bacteria, right, as it's digesting it. The other thing that it can do is it can use the oxidative burst pathway, which is what we're just talking about. So it can use the respiratory burst pathway to generate things like superoxide radicals, hydrogen peroxide, to essentially break down the components of the bacteria. So the key is with neutrophils, we have phagocytosis, right? They can use chemicals like lysozyme, for example, and they can also use the respiratory burst pathway, oxidative burst, to help break down these bacteria components. Now, the key thing that you want to remember, though, with neutrophils do not present these bacterial antigens to other cells. That's important. Okay, and that's going to be different from some of these other cells down here, which we'll talk about in just a second. So in general, when my neutrophil in the blood runs into this bacteria, that neutrophil can engulf it. It can try to digest it using phagolysosomes and the respiratory burst pathway. As this is happening, right, this acute inflammatory response occurring, the bone marrow is going to increase the number of neutrophils. It's going to say, hey, we need more of these neutrophils. We need more of these guys so they can go eat more bacteria. The bone marrow just starts pumping out neutrophils. And in the process of doing that, it's also going to release some immature neutrophils. And these are sometimes called band cells. Okay, so these immature neutrophils are called band cells. And I'll talk about this a lot in the hemonc section. But this is why if a patient has an infection or bacteremia, for example, you can use criteria like the amount of band cells that the patient has, or the percent band cells, to help give you a higher conviction that the patient has an infection. Remember, we talked about SIRS criteria, right? Having a high percentage of band cells would suggest an infection. And so that's what's happening. We're pumping out more of our neutrophils, as well as some of the other cells here, like the eosinophils, for example. So this is an example of an eosinophil. So notice the eosinophils, they're going to stain pink. Okay, so eosinophils in general stain pink. Again, we have the multi-lobe nucleus here with eosinophils, multi-lobed nucleus here with neutrophils. And that's kind of why the neutrophils, eosinophils, basophils are all classified as PMNs. The P is polymorphonuclear, right? Polymorphonuclear. They're going to have multiple lobes in their nuclei, right? And so that's what we see. Again, eosinophils staining pink, and you can see the neutrophils staining a little bit lighter blue in their cytoplasm. And then here we have a basophil. Okay, so I'll do this one in blue. Okay, so the basophil, you can see this one's staining a little bit deeper blue. And just to keep things simple, I don't want to go into too much detail on this here, but the basophil, like the eosinophil, they're both seen in parasitic infections. The basophil more classic for allergic reactions overall, and the eosinophil more classic for parasitic infections. But you can see basophils with parasitic infections as well. The thing about basophils sometimes gets overlooked, they're non-phagocytic, so they're not going to be digesting bacteria. Eosinophils, on the other hand, can do that. And the mast cells we sometimes see with allergic reactions, mast cells usually will not have multiple lobes to their nucleus, like you see here with the basophil, like you see here with the eosinophil. Mast cells are not included in that PMN category. So all of these cells are going to be getting pumped out usually when we have some kind of inflammatory cascade, like we talked about. All started up here when that immune cell used its pathogen recognition receptor to run into, in this case, LPS being one of the pathogen-associated molecular patterns causing interleukin-1, TNF-alpha, interleukin-8 to get released because NFKB, the transcription factor, coded for them as this interaction took place between the pathogen recognition receptor and the PAMP. All right, just a couple other things here. So the monocyte, so this cell is a monocyte. Okay, so the monocytes sometimes can be tricky to differentiate from some of these other cells. So the monocytes usually have more of a horseshoe kind of appearance to their nuclei. That's classically how it's described. Now the monocytes, remember, the monocytes are primarily going to be in the bloodstream. Once these monocytes get into tissues, when they migrate into tissues, they're going to become macrophages. And those macrophages, just like the neutrophil, they can go into that tissue and they can use phagocytosis to try to digest the bacteria. And the difference between the macrophages and the neutrophils is the macrophages actually can take the antigens from the bacteria and put them on the cell surface to present them to other cells. So we'll see that in the next slide. Now, monocytes don't just turn into macrophages, they can turn into dendritic cells, which are also antigen-presenting cells. So just keep that in mind. When we talk about antigen-presenting cells, the dendritic cell is kind of like the poster child for that whole process. So remember, dendritic cells can come from monocytes as well. Then we also have things like natural killer cells, which I'll talk a lot more about when we start to talk about major histocompatibility complex and that type of thing. So we won't go into too much detail on that here. But again, all of this is part of your innate response and checks a lot of the boxes that you see up here. So just to recap this, the primary function here is rapid. That's important. It's a very rapid recognition and hopefully a resolution of some new infectious agent. Now, when I say new here, it doesn't mean that we weren't previously exposed to that infectious agent. It just means that we're now exposed to that infectious agent. It's a new infectious agent. It hasn't been around for a long time, right? It's not a chronic infection. It's something that we were just exposed to and now rapidly recognizing it and then attempting resolution of that infection. Particularly effective versus fungi and parasites. And we'll talk more about why that is as we proceed here. That's not to say that innate immunity doesn't work against bacteria or viruses. It just isn't as effective. And the last thing here is that this is all germline encoded. So what are we talking about germline encoded? That means that the innate immune response can vary from one person to the next person. But the key is that this whole process in the innate immune system is not going to change over time. Once you have your genetics for innate immunity, that's it. That's what you got. Okay, it's not going to get better. It's not going to get worse. I mean, over time, right, as we age, our ability to respond to infections kind of comes down a little bit for other reasons. But in general, we're not going to generate more memory responses or anything like that. Remember, this is no memory response. It's equal to the initial response. It's always going to be the same. So whatever you have that's germline encoded, that's what you're going to have pretty much for the rest of your life. And so this all develops in utero. When we're still a fetus is when this whole process is going to form, which is going to be different from what we talk about in the adaptive immune system in just a minute. So this is all inherited from mom and dad. And the last thing I just want to touch on here, I kind of brushed over this, but really quickly, we talk about these neutrophils as polymorphonuclear cells. Here you can see that this neutrophil has 3 lobes. And sometimes people say, well, how do I tell a neutrophil from a monocyte, right? So the neutrophils, like we said, are going to usually have multiple lobes. Classically, neutrophils will have 3 to 4 lobes. Most of the time, they're going to have 3. If you see a cell that looks like a neutrophil, but it has like 6 lobes, remember, that's a very classic for megaloblastic anemia, okay? So think about folic acid deficiency, B12 deficiency. I just wanted to remind you of that. I think I wanted to talk about that, but I forgot to bring it up. But that's particularly important when you're looking at these cells because you have to distinguish these. Remember, eosinophils stain pink, basophils are going to stain darker blue, mast cells will not be PMNs, neutrophils with more than 5 to 6 lobes, now you're starting to think about B12 deficiency, monocytes classically with more of the horseshoe appearance, and then it's going to usually have a higher nuclear to cytoplasm ratio. Okay, so just keep all of that in mind when you're looking at these cells. We're going to talk about them more in HEMONC, but I just wanted to cover that here. So now that we have some basis on innate immunity, let's talk about adaptive immunity. And what I'm going to do is I'm going to go through this slide pretty quick, and then we're going to go into how this whole process works, and then I think it'll make a little bit more sense. So I'm just going to kind of hit the points really fast on this slide. We'll circle back though. Okay, so again, this is going to be a specific process. Okay, so we're targeting a specific antigen, a specific epitope usually, or a specific group of epitopes potentially. The speed in general, when we're talking about adaptive, it's going to take us time to adapt to that response. However, if we're exposed to that pathogen in the future, we have a heightened response from previous, and that's because we have some memory that's present after the exposure. Again, there's some previous epitope that we were exposed to that we're targeting. That epitope bound to IgM initially, and eventually we'll have class switching, which we'll go through here. And the key points here to remember, some of the key players, at least T cells, CD8 and CD4, we'll talk about that in a minute. B cells that can turn into these antibody producing factories, plasma cells, specific immunoglobulins after class switching. So these are all part of the adaptive immune response. And again, I'm going to go through all this in a second. I'm just kind of introducing it here. So the primary function here, again, is going to be recognition and resolution of a previously encountered infectious agent. For example, people that may have been exposed to COVID-19, right? They may have developed some memory response to future exposures. But then when you introduce new things like a Delta variant, for example, that might change the body's ability to respond to that pathogen, because now maybe it has some protection against that epitope that we were using to mount an immune response against. So we'll get into the details on that. It's going to involve more of VDJ recombination and hypervariation, as opposed to having something that's germline encoded. With VDJ recombination, which we'll go through this all in the antibody video, we're generating different receptors that can hopefully target that epitope that we're being exposed to. Okay, so the key here is these are not germline encoded. They don't come from mom and dad, right? It's not like the innate immune system. These are all going to come from our initial processes of VDJ recombination when we're creating the variation in our receptors to have something that hopefully can bind to some of these epitopes. Let's go through what this process of adaptive immunity looks like. And this is really going to be the first layer into these immuno videos that kind of put the big picture together on what's happening here, because it's really easy to get lost in the weeds on some of this stuff. So the first thing is, like I said, dendritic cells are going to be our poster child for antigen presentation. All right, so let's see how this process starts off. So we're going to go back to our example in the last video. We had some bacteria potentially that came into the bloodstream, and we talked about what the neutrophil can do in the macrophage. We can digest it, we can have it go through phagolysosomes, and we can even potentially present that antigen. And so that's what we're going to talk about here. How do we present that antigen? So again, dendritic cell here is going to run into this pathogen. Okay, so it's going to run into this pathogen, and the dendritic cell, what it can do is it can try to digest that pathogen. So again, we're just going to pretend that we're undergoing phagocytosis here, right? We're going to eat this pathogen, we're going to digest it, and then what this dendritic cell will do after it digests the pathogen, it can present components of that pathogen on its surface. Okay, so it can present components of this pathogen. Now remember what we just said, neutrophils do not undergo antigen presentation. It's important to know what cells actually do undergo antigen presentation. Again, the classic one is dendritic cells, that's why I'm using it here, but this could be a macrophage in a tissue. It could be a monocyte in the blood. It can even be a B cell, which we'll talk about in just a second. But for the example right now, let's stick with a dendritic cell. So again, it's loading these protein components, right? These are proteins from this pathogen that it digested onto its cell surface. Now we're going to start to integrate some of the material from the last video. So let's just say we have a lymph node here. Okay, so we're going to say this is a lymph node. So this dendritic cell can travel to a lymph node now with these antigens presented. And inside of our lymph node, remember what we talked about. In the paracortex, right? In the paracortex, we're going to have some T cells here. Okay, so we're going to have some T cells. And this dendritic cell is going to come in and it's going to present those antigens to the T cell. And so the T cells in here, there's going to be a whole bunch of different T cells. A rare number of these T cells might actually have a receptor that is able to bind specifically to this antigen, okay, to the epitope of this antigen. And this is where that hypervariation, that VDJ recombination comes into play, because you have to have a whole bunch of different receptors to have one that eventually binds to this very specific antigen. And so let's just say that this is the T cell, in the paracortex that binds specifically to this antigen. So this T cell is going to wake up, right? It bound to this antigen, and now this T cell goes from being naive meaning it was kind of just sitting there in the lymph node, not really doing much, to all of a sudden It found its antigen, now we wake it up, right? So I'm highlighting in yellow here, now it's activated. That's what we would say. It went from naive to being activated. Now we have an activated T cell. Now remember, this thing here in purple, that's the T cell receptor. Okay, so the T cell receptor bound to the antigen, but what exactly is that antigen on the dendritic cell? Well, the dendritic cell uses the major histocompatibility complex to present the antigen. So it uses a major histocompatibility complex, an MHC. Okay, now, dendritic cells can use different types of MHCs. Okay, so it can load the protein components onto an MHC receptor 1 or an MHC receptor 2, and there's a consequence to this. And I'll talk about that in just a second, but just remember, it can load it on MHC 1 or it can load it on MHC 2, and depending on which MHC it's on, it's going to target different T cells, and we'll talk about that in a second. All right, so this is the general process. We digested a pathogen, we took the components of that pathogen, we put it on our major histocompatibility complexes on our dendritic cell, went to a lymph node, presented it to a T cell that has that same type of receptor and activated that T cell. Now, I also told you that interestingly enough, the B cells can also present antigens. So down here, I have my B cell. So what happens if my B cell runs into this pathogen? Well, the B cell can also phagocytose this antigen. Okay, so B cells are also antigen-presenting cells. They can use phagocytosis, break up this pathogen, and then present the pathogen on MHC complexes. Okay, so the B cells will also have these MHC complexes that they can use to present the antigen, kind of like the dendritic cell. The B cell can also go travel to the lymph node, right? It can go travel to the lymph node and it can find a T cell, just like the dendritic cell. And it can also, just like the dendritic cell, present this antigen to the T cell. Okay, so again, when the B cell goes to the lymph node, right, it's presenting the antigen on MHC2 to the T cell receptor on the T cell that matches that antigen, and then our T cell wakes up. T cell is now activated. Now, what's the difference between these two? Okay, so let's talk about that. So when the B cell presents this antigen, remember, this T cell is going to get activated, and there's a specific connection that's going to happen between the B and T cell. And I'm going to talk about this more as we kind of move through the series here. So if you're a little overwhelmed, don't be overwhelmed by this yet, but this is going to be the CD40 ligand. Okay, so this is kind of like a co-receptor that's binding as the B cell binds to the T cell. And that CD40 ligand binding is going to allow the T cell to send a signal to the B cell and say, hey, I need you to undergo some class switching. So this additional binding is going to have the T cell telling the B cell to potentially undergo class switching. So what happens is the T cell is going to send a signal to the B cell, right? And now the B cell, okay, can turn into a plasma cell, and then it can just start pumping out antibodies. Okay, and again, and if we undergo class switching, we might start pumping out antibodies like IgG, IgE, IgA. It's all going to depend on what type of cytokines that T cell releases to tell the B cell, hey, this is the antibody I need you to produce. I need you to class switch the heavy chain on IgM to IgG, IgE, IgA, all from this process where the B cell presented the antigen to the T cell. Okay, and like I said, we're going to go into that in even more detail. I'm just kind of laying the framework because this is kind of a complicated process. Okay, but essentially, again, when the B cell binds here to the T cell, and we have CD40 ligand binding, the T cell will stimulate the B cell to become a plasma cell, which is essentially like an antibody producing factory, right, to produce these antibodies. Okay, and we can also have the class switching because of the CD40 ligand binding. That's the important part to remember. And this whole thing where we have all these antibodies being produced, this is known as humoral immunity. When you actually class switch to IgG or IgA or IgE, that takes a while. That could take a few weeks potentially. And that's why we say, adaptive immunity in general, adapting these memory immunoglobulins. IgG, you think of more as your memory immunoglobulin. It shows that you were previously exposed to that pathogen. When you're looking at hepatitis, for example, very frequently we're going to look at the IgG. Again, it's going to differ depending on the type of hepatitis, but IgG is going to tell us we were previously exposed or we were vaccinated because at some point we had exposure to that specific epitope or antigen. Whereas IgM, again, is going to be kind of more of a first line antibody or immunoglobulin. Okay, so IgG is part of the adaptive immune response. It takes class switching to get IgG. You have to have a B cell binding to a T cell, activating that T cell, right, stimulating cytokines to cause the class switching to IgG. Now, the thing to remember is that we bound to a T cell here to cause this whole process to happen. But remember, this was all on MHC2 and B cells. Okay, so the way to remember this is that you always want to get to 8. It's kind of like the rule of 8s here. So if we have anything on an MHC2 receptor, if we multiply 2 by 4, we get to 8, which means the reason I'm showing you this is because MHC2 receptors will bind to CD4 positive T cells. Okay, so CD4 positive T cells are kind of like your helper T cells. Okay, so the helper T cell, so this in this case would have been a CD4 positive T cell because the B cell loaded it on MHC2. And we want helper T cells to release cytokines to help stimulate these B cells to turn into plasma factories. Okay, so that's how you remember. If anything is loaded on MHC2, it's going to bind to CD4 positive T cells. Those are the helper T cells. Now, conversely, with our rule of 8s, if we load something on MHC1, right, 1 times 8 equals 8. So this cell up here, let's say that we loaded it on MHC1 on our dendritic cell. If we loaded it on MHC1, then it would have had to bind to a CD8 positive T cell. CD8 positive T cells are going to be your killer cells, okay, your cytotoxic T cells. And so these cells, what this CD8 positive T cell will do is it will actually release enzymes to destroy that dendritic cell. You might be saying, well, why is it destroying it? Remember, the dendritic cell is infected with something. CD8 positive T cells usually will be very effective when we're talking about viruses. Most of your cells should express MHC1. So if a T cell sees that another cell is expressing an antigen on MHC1 that's not supposed to be there, it thinks that that cell is infected. If you have a virus, that's exactly what happens. If a virus infects a cell, the T cell will recognize it on MHC1 and it will kill that infected cell. So the cell in some ways is essentially sacrificing itself knowing that it's infected, right? Because a virus can hijack a cell and then use that cell's machinery to make more viruses. And so the idea here is the CD8 positive T cell saying, hey, you're infected, you might be infected with the virus, let me wipe you out so that this virus doesn't reproduce even more. Okay, so that's like a very simple explanation to it, but that's essentially what's happening. And that's cell-mediated immunity. The T cell is directly targeting the infected cell. So again, CD4 positive T cells are going to bind to MHC2, which are very classic for the antigen presenting cells. In general, when these dendritic cells are presenting things to the T cells, usually we'll talk about it with MHC2. The tricky thing here that I want you to remember though, and again, we're going to keep talking about this, is that in general, the cells that are going to be the antigen presenting cells, they're pretty much going to express MHC2. So this dendritic cell, it could express this pathogen on MHC1, it could express it on MHC2, for example. If it expresses it on MHC2, it would be binding to CD4 positive cells. So this dendritic cell can bind to CD4 positive cells or CD8 positive cells because it can load its protein components on MHC1 or 2. Almost all of your cells are going to express MHC1. Let's say it's not an antigen presenting cell. It's kind of just like your everyday cell in the body gets infected with a virus. What happens is that T cell, CD8 positive T cell, if it runs into that cell, it's going to kill it, right? It's going to destroy it because it doesn't want that virus to reproduce. Okay, so when you think about MHC1 and CD8 positive T cells, think about kind of like your everyday cells expressing MHC1. Of course, dendritic cells also will express MHC1, but classically, we think about dendritic cells usually with MHC2. So I don't want this image to confuse you too much. So just to recap this, going back to the innate immunity, this pathogen enters our body. We have a bacteria enters our body, okay? The bacteria can run into a neutrophil, for example. The neutrophil might digest it, and then the neutrophil will try to break it down using the phagolysosomes, using respiratory burst pathway, and it's gonna do all of that because it used a pathogen recognition receptor to recognize LPS, for example, on the surface of this pathogen. Okay, it might use toll-like receptors, right? Or it might recognize the bacterial flagellum. It'll recognize some pathogen-associated molecular pattern, right? That's what we talked about before. Using pathogen recognition receptors, very nonspecific, generates an immediate response. We have interleukin 1, interleukin 8, TNF-alpha being released for an acute inflammatory response. That's what happens initially. Now, eventually, we might have some antigen-presenting cells that are going to run into this pathogen, like this dendritic cell, and it'll digest this pathogen. It'll present that pathogen on its MHC2 or MHC1. It could be either one. It'll go to the lymph node, present that to a T cell, activate the T cell that binds specifically to that antigen, right? And then that T cell can either destroy the dendritic cell if it's on MHC1, or the T cell can release cytokines if it's CD4 positive. Okay, B cells can do the same thing. B cells can run into this pathogen. They can present this pathogen to CD4 positive T cells on MHC2, and that can cause class switching. We can turn these B cells essentially into plasma cell factories, releasing some of these very specific markers that we talked about in the adaptive immune response. Okay, IgG being very classic to show that there's been some previous exposure because we had to have class switching prior. And remember, if we go back to the first video, as these B cells are pumping out these IgGs, IgEs, IgAs, remember, they're all going to happen in the germinal center of the lymph node, right? So you're going to get that pale staining in this area after these B cells have started to go through class switching and are starting to kind of replicate themselves. You know, just remember, the majority of these B cells might go to be plasma cells, but there'll be a small number that kind of hang around in the lymph node and become memory cells. Okay, and that's true for the T cells too. There'll be some memory cells that stick around. Okay, and so those memory cells, if the exposure happens again, if we run into this pathogen in the future, right, maybe 2 or 3 years down the road, we get infected with that same pathogen, these cells are going to get this epitope presented to them, and they're going to generate a very strong response very fast. That's going to involve antibodies like IgG from the class switching, for example, before, and we'll be able to readily target this pathogen with a much more robust response. In some cases, not even getting to the point where we have a huge acute inflammatory reaction because we're able to respond so quickly. So the patients might not even have symptoms when they're re-exposed because we can target the pathogen much more rapidly and effectively. And like I said, if you're a little overwhelmed by this, we're going to go through this piece by piece through this video series. So don't worry too much about this, but I at least like to introduce it all here, and then we'll kind of build on it as we go. Pause the video if you need to. We'll give you 15 seconds to read the question, and then we'll go through the explanation. All right, so we have a researcher that's studying the relationship between pattern recognition receptors present within host cells and Crohn's disease. The pattern recognition receptor nucleotide binding oligomerization domain protein 2, NOD2, has been shown to detect conserved motifs in bacterial peptidoglycans such as intracellular muramyl dipeptide and promote activation of host inflammatory pathways. So let me stop right there, because this is a situation where you want to stick to the things you know, because you're going to see things that are kind of thrown at you in questions that, you know, are different than anything you've seen in your study material. So, you know, you want to stick to the things you know. So what do we know? We know a little bit about pattern recognition receptors, which I'll talk about in a minute. Okay, and you might have heard of NOD2. If you haven't, that's okay. We'll talk about that. The bottom line is, you know, they're basically saying here that the pattern recognition receptors, you know, one example of the pattern recognition receptors is NOD2, right? So we can kind of write that down. So pattern recognition receptors, and we'll talk about these in a second, they're basically telling us that an example of a pattern recognition receptor is NOD2, okay? And NOD2 is going to detect conserved motifs in bacterial peptidoglycans, and they give you an example here, and promote activation of host pro-inflammatory pathways. Even if you didn't read that, right, you should know, right, from the video series we've kind of just covered in this chapter, what pattern recognition receptors are and what they do, right? So pattern recognition receptors are going to recognize pathogen-associated molecular patterns, or PAMPs, right? They can also recognize damage-associated molecular patterns, right? So these receptors can kind of recognize these very non-specific patterns in certain bacteria or viruses, for example, right? And we kind of talked about some of these. So we said, look, there's some PAMPs, for example, LPS, right? And gram-negative bacteria. That's very non-specific. A lot of different gram-negative bacteria, right? They're going to have LPS, and we can recognize LPS non-specifically. It's not a specific antigen and a specific idiotype that are coming together. This is just a, you know, LPS in general sets off this host inflammatory cascade. It's very non-specific, right? So LPS can do this. We said viral nucleic acids can do this. Even bacterial flagellin is another classic example. And then the damage-associated molecular patterns are usually things from host cells. So, you know, if a host cell is, you know, has defective DNA repair or something along those lines, for example, there's going to be very non-specific patterns that can be recognized to target that host cell for destruction. Again, these are non-specific. So if something is non-specific, it's generally going to be part of the innate immune system, right? So this whole process is really part of the innate immune system. Because again, these are non-specific patterns that kind of set off that initial cascade. When you have a pattern recognition receptor like NOD2 or a toll-like receptor, which we kind of talked about, TLR, toll-like receptor, these can recognize these non-specific patterns. And what they end up doing is once these bind together, right, once LPS binds to this toll-like receptor, or flagellin binds to, something like NOD2, whatever it is, what ends up happening here is we eventually end up getting an inflammatory cascade. Okay, and this is kind of what we talked about in the last video. And the way this all starts is by increasing transcription of NF-κB, which is particularly high yield. Okay, we talked about this being a very important step in starting this inflammatory cascade. And then this kind of sets off multiple cytokines like interleukin-1 to change temperature set point, interleukin-6, right, TNF-alpha, all of these kind of acute phase inflammatory reactants. Okay, and so this is kind of how this whole process works, and that's what you're kind of expected to know. You're expected to know this is very non-specific, sets off an inflammatory cascade through the regulation of NF-κB, and then kind of the big ones to remember here are TNF-alpha, interleukin-6, interleukin-1, maybe even some interleukin-8, right, for chemotaxis. With all that being said, going back into the question here, we're going to read this line again. The pattern recognition receptor NOD2 has been shown to detect conserved motifs in bacterial peptidoglycans, where you just said, we already know that, right? Conserved motifs, right? Things like flagellin, LPS, etc., right? That's something we already know. And that gives you an example of one here, intracellular muramyl dipeptide. And when doing this, it promotes activation of host pro-inflammatory pathways. Okay, that's very important. So NOD2 has been known to be highly expressed in the Paneth cells of the intestine. That might have something to do with the fact that they're looking at this relationship in Crohn's disease, right? The researcher attempts to induce mutations to further elucidate the effects of ileal inflammation on NOD2 deficient mice. So we want to see the effects of inflammation on NOD2 deficient mice. Key word here is deficient, right? So these mice do not have this, presumably this gene that codes for this NOD2 receptor, right? So based on the information above, which of the following would most likely be impaired in NOD2 deficient mice? Okay, what would most likely be impaired? Now, if you kind of understand this, which is what we kind of talked about, it should make sense that NF-κB activity would actually be impaired. And you could say, well, why is that? Well, remember, these mice don't have this NOD2 receptor, right? So if they don't have this NOD2 receptor, we can make the assumption that, look, if I don't have this receptor, if I'm deficient in it or it's dysfunctioning, whatever it is, I'm going to have an issue setting off an inflammatory cascade, right? I'm going to have an issue setting off an inflammatory cascade. So what will happen is potentially, right, I'm not able to go through this next step to upregulate NF-κB because I don't have the receptor to make that whole process happen. I don't have the receptor that then binds to, in this case, this intracellular muramyl dipeptide, right, to set off this inflammatory cascade. I don't have the receptor to bind to flagellin or viral nucleic acids or LPS to kind of go through these steps, right? So if I don't have that receptor, then everything downstream is affected. So I might have, low levels of interleukin-1 in the setting of an infection, or interleukin-6 or TNF-alpha. In this case, it has to do more with Crohn's disease, but the point is still the same. The point is that we can't set off the inflammatory cascade, and the point is that you should understand that these pattern recognition receptors are associated with the innate immune system and setting off the inflammatory cascade through the regulation of NF-κB. Now, let's quickly just go through some of these other options here. And if you're just kind of watching these videos sequentially, we haven't really talked about some of these other things yet, but I'll just give you a little bit of a rundown as to why they're not correct. So B7 protein binding to CD28. So B7 and CD28 are kind of linked because these two come together essentially to perform a co-stimulatory signal. And this has to do with the activation of T cells, which ends up being part of the adaptive immune system. And this is done in situations where you have a specific antigen, right? And you might be creating a memory response, for example. In these situations, though, again, this is going to be more adaptive immune system, not really directly related to the NOD2 receptor or this innate immune pathway that we're talking about. Okay, so not directly related to this and would be unlikely to be directly affected. Certainly not the best choice here. CD40 membrane receptor activity. Now, this is actually a pretty big one. So CD40 and CD40 ligand, which we're going to talk a lot about in this series, kind of come together to allow for class switching of antibodies. Now, remember what we kind of talked about? We said, look, IgM is kind of like this generic antibody that we have. And we can make more specific forms of our antibodies by adjusting the isotype. Okay, so we can adjust the isotype of the antibody to make things like IgG, right? Great for our memory responses, IgA at mucosal surfaces, IgE, right, etc. So we can make these different types of antibodies, but to do this, to undergo this process, we have to undergo class switching. Okay, so we have to do some kind of class switching to let this happen, to change the isotype. And to do that, the key receptor binding to do that is going to be the CD40 ligand, which is going to kind of set off this cascade. And I'll go through the entire pathway, all the details, as we kind of progress through this unit. But what I just want you to understand here too, since we're on the topic of this, I don't want to go too far down into the details yet. So you have a heavy chain, which I'm drawing in black here, and then you also have a light chain. Okay, so you have a heavy chain, and then you have a light chain. And the heavy chain has kind of two regions here. So this pink region is the constant region. Okay, so we just say this is the FC region, the constant region. And then we also have a FAB region, an FAB region. So the light chain and this part of the heavy chain are going to make up the FAB region, or the FAB region. When you're changing the isotype, right, this is what we're doing to go from like IgM to IgG, right? When you're changing the isotype, you're going to be changing the FC region here, okay, when you're changing the isotype. Now, if you changed the idiotype or changed the variable region where this antibody can bind, that's going to be in this area, in this FAB region, okay? So this FAB region is going to contain, hypervariable regions that bind to very specific antigens that underwent VDJ recombination, whereas the FC portion is going to be more regulated for complement binding and the isotype. Anyway, the point of this is because IgM is kind of like our generic antibody, IgM can be thought of as part of the innate immune system, right? Because it's kind of our generic antibody. But for us to go to class switching, that's where we're now kind of transitioning into the adaptive immune system, right? Because we're creating antibodies for memory responses, making antibodies like IgG, for example. And so we can say that IgG is actually more part of the adaptive immune response because we require class switching. And again, we're primarily talking in this question about the innate immune system specifically, right? With the NOD2 receptor. The class switching would be kind of out of the scope of what's being tested, in this study. All right, so if we look at option D, this is really just along the same lines of option C. It sounds kind of complicated, alterations within the heavy chain constant domain of immunoglobulins. What does that mean? It's just what we just said, right? Here's the heavy chain, right? This is the heavy chain, this black line. Here's the constant domain. If I change the constant domain, I end up with IgG, IgA, IgE, right? Some different form of the immunoglobulin. So this would not be the correct answer also for the same reasons, because it would have to do with class switching, adaptive immune response. Now the last option on here, terminal deoxynucleotide transferase activity. Now what this is, and you do have to know a little bit about this, but you don't have to know a ton of details, but what this is it's a DNA polymerase that kind of randomly adds nucleotides to immature T and B cells. Now the thing about terminal deoxynucleotide transferase, number one, you sometimes kind of think about this when you're thinking about things like RAG1 and the RAG2 genes, which are basically like recombinase genes that allow for VDJ recombination to create this kind of hypervariable region here to make all different forms of these, idiotypes, for example. Now, this process, is not directly related in any way to what we're talking about with the pattern recognition receptor, so it's clearly not the best answer. But the other thing I want you to understand when you see TDT, right? If you see TDT positive, in a question stem or a lab value, you start to think about, a little bit about, especially in the setting of blastic tissue, you start to think about acute lymphoblastic leukemia. And one of the ways that we start to differentiate the different forms of leukemia is you can look at acute myelogenous leukemia. Typically, AML is TDT negative. And that's because the blastic cells in AML typically are from the myeloid lineage, not the lymphoid lineage, right? The lymphoid lineage would typically have more cells that might have this TDT, this polymerase, essentially, that's allowing for VDJ recombination in these very immature blastic cells, right? Blastic cells are immature. So the point is that you can see TDT positivity in ALL, especially in the setting of blastic tissue. That's what I want you to remember. But again, this is not directly related or linked to this question, right? If you understand this pathway that we talked about in the previous videos in this chapter, you can pretty much solve these questions where they start to throw some information at you that seems a little convoluted, seems a little complicated. Just stick to what you know. Look for the things that you know and stick to the pathways that you've kind of gone through already, and usually you can decipher some of this. Hey everybody, Dr. Roviso here. In this video, we're going to talk about inflammation, and this is a really big section overall, but what I want to do is I really want to focus on what are the major things that we have to know in this section before we move on. And this section's categorized, differently in different textbooks and that kind of thing, but we're going to cover a lot of the components surrounding inflammation here. So we'll talk about the acute inflammatory response. We'll end with the chronic inflammatory response, which doesn't have quite as much information, but we'll touch a little bit on granulomas. And then in between, we'll talk a little bit about neutrophil migration and then some disorders of leukocyte migration. Okay, so just starting off here with the acute inflammatory response. The big thing is, let's start big picture and then we'll kind of narrow things down. So the big thing is, how does this whole acute inflammatory response take off? And if you've been watching the video series so far, we've kind of already talked about it a little bit. So we said, there might be some pathogen associated molecular pattern. Okay, and this is going to be something that is going to either be released from bacteria or from a virus. And some examples of this include things like LPS, right? Lipopolysaccharide. We see this a lot with gram-negative bacteria. Okay, and then we can also see this with lipoteichoic acid, very classic with gram-positive bacteria. Okay, so these are a couple examples. And then also just in general, we talked about bacteria flagellin also being a pathogen-associated molecular pattern. And again, these are non-specific things, right? Cells recognize these and they know something's wrong. It's not specific to that bacteria though. It's just the body recognizing that there's something there that shouldn't be there. And now guess what? We got to do something about it, right? And so how do we recognize this? We recognize it with recognition receptors. Okay, and we talked about this a little bit in the last video. So these receptors will recognize the pathogen-associated molecular pattern. And so an example of this, we can see here, you have your toll-like receptor on the surface, right? There's different types of toll-like receptors. Here we can see toll-like receptor 4, which is one of the classic toll receptors that sometimes gets asked about. And then we can see back here our lipopolysaccharide, right? So we have this bacterial component that's binding to the toll-like receptor. Again, very non-specific, but if we follow this process down here, so we go down this arrow here, we can see that eventually this is going to lead to the nuclear translocation of our NFKB. And remember, this is the major transcription factor that you want to be familiar with, right? The bacteria enters the body, and then we use our toll-like receptor to bind to components of that bacterial cell wall in a non-specific way, stimulating innate immunity. That's going to trigger a cascade causing increased stimulation of NFKB, right? That's going to be pro-inflammatory, and that's going to lead to the release of certain cytokines, which we'll talk about in a minute. Interleukin 1, our tumor necrosis factor, TNF, interleukin 6, certain chemokines, and then we'll talk about these endothelial cell adhesion molecules when we talk about how the neutrophils respond to this inflammation and get to one part of the body. Kind of how things are set off. That's the whole cascade of what we're talking about. Now, there's also a couple other things that can happen here. So it's not just the pathogen-associated molecular patterns. Okay, that's what we're going to see usually from the invading species. The bacteria or the virus will have these pathogen-associated molecular patterns. But then we also have our own cells that can bind non-specifically. And so what we think about, right? So if I have my cell here and my cell has a plasma membrane around it, right? If this membrane gets disrupted for whatever reason, maybe a virus hijacked the cell's machinery, right? And now this membrane is disrupted for whatever reason. Well, what will happen is there are certain proteins that can leave this cell once the cell is destroyed. There's certain components here, and these are sometimes known as the damage-associated molecular patterns. Okay, similar to the pathogen-associated molecular patterns, but these are more related to our own cells releasing cell components because that cell was infected by, some invading pathogen. And so again, the damage-associated molecular patterns, or the DAMPs, these can also bind to the recognition receptors. And so this whole process has to do with the pathogen-associated molecular patterns, again, non-specifically binding, the damage-associated molecular patterns from our cells non-specifically binding to the recognition receptor, and then triggering this whole inflammatory cascade. And that's this acute inflammatory response that we get when we have some pathogen in the body. And so how does the body respond to that? Well, there's, this is kind of the classic, very basic, four-corner inflammatory response components to keep in mind. So just important to remember, calor represents heat, right? So when we think of acute inflammatory response, we're thinking about heat, we're thinking about redness, right? The rubor is from redness. And a lot of this is, the heat and the redness, the erythema. That's because we have vasodilation happening. And we'll talk about that in a minute. And then we have pain. Okay, so pain is definitely a component that has to do with bradykinin release, nerve sensitization. When we have an acute inflammatory response, right, when you roll your ankle, it doesn't have to be an infection that causes an acute inflammatory response, right? You can have an allergic reaction, you can have trauma to a certain part of your body, and those will also trigger the acute inflammatory response. You might be saying, well, Dr. Roviso, how does that work? If there's not a pathogen there, who's going to stimulate these receptors? Well, I just told you, right? The damage-associated molecular patterns. If our cells get damaged, right, if I have some trauma, right, and I break a rib, there's going to be cells that are probably going to lyse, right? And there's going to be some components that are non-specifically going to bind to these recognition receptors, and those are going to be known as the damage-associated molecular patterns that will stimulate this whole cascade, and we'll still get NFKB to be stimulated, and we'll still get an inflammatory response to that area. And so again, that's going to be the pain, and then we have tumor, which is swelling. So just to recap these, the calor is heat, the rubor is redness, the dolor is pain, the tumor is going to be swelling, and this all can eventually lead to loss of function, particularly if this is chronic inflammation. If this happens over a long time, there's fibrosis, right? And this is very non-specific, but again, just high level, that's what you want to think about. When you're thinking about these toll-like receptors and recognition receptors, recognize, we already talked about this, pathogen-associated molecular patterns and damage-associated molecular patterns. That triggers an inflammatory response. The classic one we talked about is toll-like receptor 4, right? Toll-like receptor 4 and LPS, lipopolysaccharide from gram-negative bacteria. That's the classic poster child for this. The toll-like receptor 4 has a co-receptor known as CD14, and these are expressed, again, in phagocytes of the innate immune system. These are the cells that are going to be kind of looking for these pathogen-associated molecular patterns. And again, this all leads to NFKB nuclear translocation, as we saw here. And then that translocation is going to stimulate the transcription of a lot of the cytokines that will then trigger the inflammatory response. Okay, now some other things that you just want to kind of keep in mind here, big picture. So the arachidonic acid pathway. Now you can make a whole video just on this alone, but I just want to remind you that there's two kind of segments that we talk about when we talk about arachidonic acid as a precursor. The lipooxygenase pathway, and the big thing, the only thing I really want you to take away from this, we're just going high yield here. We're going to go down our pathway of our leukotrienes. The big leukotriene to remember here is LTB4. LTB4 is going to stimulate neutrophil chemotaxis. Now you know me, I like to think of things in terms of threes. So LTB4 stimulating neutrophil chemotaxis, that's one of the big three that are going to stimulate neutrophil chemotaxis. And if you're not sure what that means, I always think of the end of the term like taxi, right? So you kind of have taxi in the name here. Neutrophils taking the taxi to where they need to go. Okay, so neutrophils are going to get signals, that's where the chemo comes in, chemical signals that taxi the neutrophils to the location where they need to go. So if you have inflammation, neutrophils are kind of like the first responders. If there's a car accident, right, you have your first responders, your EMS, that go out to the scene. Well, that's kind of what your neutrophils are. They're the first ones on the scene. There's chemicals that are going to taxi them to the scene. Okay, and LTB4 is one of those three major taxis to get it there. The other thing on here is the cyclooxygenase pathway, and we're going to talk about this in a lot more detail. There's a lot of specifics here, but the point that you really want to know, just taking away from this big picture, is that prostaglandins are going to get stimulated, they're going to get released. The big repercussion of this really is that you'll see that TXA2, thromboxane A2, is going to also be released, right? You're going to have increased levels of thromboxane A2. And remember, TXA2, if you go to the hem-onc videos, this is going to lead to platelet aggregation. It's going to help platelets get together and aggregate. And this is why when you give a patient an NSAID, for example, so if you give a patient an NSAID like aspirin, for example, okay, so let's just say aspirin here. So aspirin is going to irreversibly inhibit a component of this cyclooxygenase pathway, right? And so by doing that, it's also going to inhibit the formation of TXA2. Okay, so that's what NSAIDs are doing. They're inhibiting cyclooxygenase, right? You might remember, if you think about the pathway of NSAIDs, they are COX inhibitors, right? They're going to inhibit the cyclooxygenase pathway. And this is the same pathway that we're talking about right now. That's why these are anti-inflammatories. What does NSAID stand for? Non-steroidal, right? They're not steroids. It's not a glucocorticoid. They're non-steroidal anti-inflammatory drugs. And they're anti-inflammatory because they're inhibiting the inflammatory process by inhibiting this pathway right here. And they're also sometimes given to decrease platelet formation, right? That's because it'll eventually inhibit the creation of thromboxane A2. Okay, so that's kind of how NSAIDs kind of fit into this. That's how aspirin fits into this acute inflammatory response. We have a whole video just on complement. So I'm going to go through this kind of quick, but we'll talk about this in greater detail. I'm just teeing it up here. So C3A and C4A, probably the least high yield of the ones on here, but it is important to remember that these are responsible for that vasodilation. Remember, I told you, you're going to have some heat. You're going to have some redness. That's because you get vasodilation. Where does that come from? C3A, C4A, right? This complement cascade, and this is all because we have histamine being released from our mast cells. That's what's causing causing that. Now, probably one of the most high yield ones on here to remember is C3b. This is going to be associated with opsonization. And I know I touched on this before, but remember, you got to tag your bacteria before you digest it. That's what opsonization is doing. So if we have some bacteria here, right? We have some bacteria, and let's say we want to mark this bacteria for destruction. Well, there's two major ways you can do it. You can put complement on top of that bacteria, right? You can put C3b, and that's going to mark this bacteria for destruction. Now, the other thing that you can do that's very effective is you can use IgG. Okay, so IgG, immunoglobulin G, which is typically from the memory response, right? So you're usually going to get this from the memory response because you have to undergo class switching. That's what we talked about in the last video. So this IgG and C3b are very good for marking this bacteria for what? For opsonization. Now, by having these on the surface, you can have other phagocytes nearby, right? You can have a phagocyte nearby here, and this phagocyte now knows to destroy this bacteria or to phagocytose it because it's marked for destruction. And the other thing that can happen is your complement can eventually lead to the membrane attack complex forming on that bacteria. So remember, the membrane attack complex is the kind of the terminal part of complement. So it's C5b to C9. That's going to make the membrane attack complex, and that can also destroy, can basically punch holes into the cell wall of that pathogen. Okay, now I said C3b is one of the most high yield things to remember here in the complement section. The other major thing you want to remember is going to be C5a. Now, C5a is important because it kind of does a couple things, but the big thing it does is it's going to cause neutrophil chemotaxis. And where did we hear about this? We heard about this with LTB4. So LTB4, C5a, remember I said, I promised there's going to be three major chemotactic factors for neutrophils, C5a, LTB4, that's two of them. Okay, so we got two of them. We're going to get the other one as we keep going here. Also, C5a, what else does it do? It also causes vasodilation, very similar to C3a and C4a. So you can just remember C3a, C4a, C5a, they all pretty much do the same thing. The only difference is C5a is the high yield one because it's very good at causing neutrophil chemotaxis. It gets neutrophils to the scene of the crime, okay? Now, bradykinin and Hagman factor, I'll talk about this more coming up, but the big three things you want to remember about this, bradykinin in particular, remember that bradykinin is associated with increasing pain sensitivity. That's very important. Now, it also does other things, increases vasodilation, vascular permeability, but the thing that they love to ask about bradykinin is that it increases the sensitivity to pain. Okay, so remember that. Now, inflammatory cytokines, we have a whole video just on cytokines. Again, a lot of this stuff is interweaving, so we get our reps in, right? So you see this a couple times. But the big inflammatory cytokines you want to remember for the acute inflammatory response, the first one is going to be interleukin 1. Okay, so interleukin 1 is going to have a few different effects. Now, you might have seen this somewhere in this slide, right down here, right? So remember that NFKB, once that's stimulated from that non-specific binding of LPS or some pathogen-associated molecular pattern, that's going to stimulate NFKB to form interleukin 1, interleukin 6, and TNF alpha. And look at that, they're all right here. These are all going to stimulate the acute inflammatory response. Sometimes these are called acute inflammatory reactants. That's another name for them. And I told you that there's one more major factor we want to talk about for neutrophil chemotaxis, so that's interleukin 8. So you have your big three here. You have LTB4, right, coming from the arachidonic acid lipoxygenase pathway. You have C5a from complement, and then you have interleukin 8 from your inflammatory cytokines. Interleukin 8 also does a really good job of continuing inflammation. So if we have some ongoing inflammation, interleukin 8 is really good at stimulating that. Now, the last thing I want to talk about here is some of the additional effects you can get from interleukin 1 and sometimes also from tumor necrosis factor. And the big thing is these can increase the temperature set point. So again, remember, remember this pathway, right? If you remember the pathway here, you can kind of intuitively figure out what's going on, right? We stimulated some non-specific response. This is our innate immune system, had increased NFKB, and now interleukin 1, interleukin 6, TNF are all being transcribed essentially at a much higher rate, and that interleukin 1 and TNF are going to increase your temperature set point. So this is where you get a fever, right? The hypothalamus, the anterior hypothalamus, is going to increase this temperature set point. And then interleukin 1 also can increase the amount of E-selectins and ICAMs on endothelia. And you might be saying, well, what's that? In the next video on neutrophil migration, I'll show you where these selectins are. Essentially, these different molecules are helping either kind of slow down neutrophils as they get to the blood vessel or kind of lock them in one place and have a tight adhesion so that the neutrophils can get to that location. And so you'll see interleukin 1, tumor necrosis factor, will help more of those proteins sit on the endothelium so you can get more neutrophils into the area of inflammation faster. Okay, and the last thing on here, damaged endothelial cells. So when a cell is damaged, it's just important to remember this. We talked about this a little bit in cardiology, but you increase your nitric oxide. And the whole reason for that, remember, cGMP is going to cause smooth muscle relaxation, and so you're going to end up with vasodilation. Okay, so you can get vasodilation of the vascular smooth muscle. And then also, the other thing that's going to happen here is when there's cells that are damaged, when there's endothelial cells that are damaged surrounding that area of inflammation, you can increase the number of adhesion proteins. These are your adhesion proteins. Okay, so these can get increased from interleukin 1, from TNF alpha. They can get increased just because there's damage there. And again, the whole point of that is you can get more neutrophils to kind of slow down as they hit that endothelial wall so they can go into that location. And I'm going to show you some really good images of that in the next video. I just want to kind of introduce it all here, and then we'll go into more detail in the next video. The neutrophils, if you haven't got it already, neutrophils are going to be first responders to get to the site, right? So neutrophils are going to be like your first responders. And so we'll talk about neutrophil migration next. Now, after a couple days have gone by, this is going to be more representative of macrophages kind of coming into the tissue. Okay, so as some time goes by, we end up with macrophages. And so this is kind of the general concept. Like I said, we'll hit on this more in the next video. So we said neutrophils are the star of the show. So it's really important, even from a testing perspective, to understand, what are neutrophils doing? Why are neutrophils so important? How do they get to the site of inflammation? So the first thing that you want to understand is that, this is really a 4-step process. And I like to think of things in terms of 3s. And, really the big 3 things are going to be, down here. Sometimes you'll see this process with, 5 or 6 or 7 steps. They can, stick an activation step in here somewhere. But the point is, what you see here is what you really have to know. And so the whole idea is, what is this neutrophil migration? It's taking a neutrophil. Okay, so here's our neutrophil. We're taking this neutrophil, and we want this neutrophil to go from the bloodstream, from the vascular lumen, right? This is a big blood vessel here, right? So we want it to go from the bloodstream into the tissues, particularly, specifically to the site of the infection. So we want the pro-inflammatory cells like neutrophils, we want them to start going after this infection. We want them to start phagocytosing this bacteria or whatever this pathogen is. So we got to get them in there. We got to get them to the site of infection. So to get this neutrophil in here, there's a 4-step process that you want to be familiar with. The first step is margination. Let's just say this was the lumen of my blood vessel, right? Maybe this is a really big blood vessel. We don't want the neutrophils out here, right? We want the neutrophils towards the site of infection, towards the endothelium. And so to do that, to get the neutrophils kind of towards the edge here, what we can do is we can increase the vascular permeability. By doing that, by increasing vascular permeability, there's going to be more fluid, essentially, that's going to leak out through these endothelial cells. And so I know it doesn't look very leaky here, but there's going to be more fluid kind of leaking through these. And so by doing that, you're hemoconcentrating. And you'll hear this term a lot when you go in the wards, when you work in the hospital. Hemoconcentration is basically saying if you took volume out of the bloodstream, okay, the cells that would be left in those blood vessels would be more concentrated, right? Because you've taken out some of the fluid, and that's what we're talking about. So the increases in vascular permeability promote hemoconcentration. And if there's more concentration here, it's going to be more likely that there's a neutrophil here as opposed to fluid. It's more likely that you'll have a neutrophil hit these sides of the endothelium. That's the concept. So the increases in vascular permeability with inflammation, part of the reason for that is for hemoconcentration, so we can get an increased propensity for neutrophils to contact their endothelia. Okay, so that's the first concept. That's what margination is. Pretty straightforward. Like I said, the big 3 are down here. So going into that, the next one here is rolling. So what's rolling? Rolling is, eventually this neutrophil might get pretty close to the endothelium here. And what's going to happen is it's got Sial-Lewis X, which is a protein that's on the neutrophil. Now, it's important that I wrote it this way, that you know what's on the neutrophil and what's on the endothelium. You don't have to go into a extremely large amount of detail on this. Just know that this is going to be on the neutrophil. And the neutrophil, as it kind of gets close to the surface of this endothelium, it's going to start to use that Sial-Lewis X to transiently kind of bind to some of the proteins here, particularly the E-selectins and the P-selectins. Okay, and it's also important to remember that the P-selectins are going to come from the Weibel-Palade bodies, and I'll talk more about that to come. But just know that the E-selectins, P-selectins, they're kind of selecting the neutrophil. They're not stopping the neutrophils in their tracks, right? This neutrophil is coming in hot, right? It kind of just touches this and keeps going. Okay, so the neutrophil is not going to stop here because of this binding, but it's going to slow down a little bit. Okay, so this is going to help slow the neutrophil down. Think of this as like a big snowball coming in with a really high velocity. So it's going to kind of start to slow down as it starts to hit these E-selectins using its Sial-Lewis X receptor. Okay, so that's the concept. So that's rolling. Okay, so make sure you're familiar with the proteins in rolling. Now, once we get through this rolling phase, eventually we slow this thing down so much that it links into one of the integrins here, and it just completely stops moving. So we're essentially going to have an adhesion moment, right? A tight adhesion where this thing is not going to move at all. And this tight adhesion is from a combination of two things. It's from the ICAM proteins, which stands for intracellular adhesion molecule, 1. So kind of, it's like it says, right? It's in the endothelium, it's intracellular, and it's going to cause there to be a tight adhesion, a really tight linkage there to just slow that neutrophil down. It's like, hey, you're not going anywhere now. Okay, so that's ICAM1. If you want some bonus points, that's CD54, not as high yield, but it is important to remember that it is ICAM1 here that's going to be responsible for this tight adhesion step. And the neutrophils typically will have their protein, right? So they're going to have something called LFA1. And LFA1 is the protein that's going to be on the neutrophil. Okay, so we have LFA1, and I'll unhighlight this so you can see it here. So we have LFA1 on the neutrophil, and then we have the ICAM1 coming out of the endothelium, and that's locking this neutrophil in place now. Now also notice there's another receptor here, and I didn't write this one down, but this is going to be the CXCL8R receptor. You might be saying, well, that's a really hard receptor to remember. How am I going to remember that? Well, if you watch the last video, remember the interleukin 8 receptor. Look at, you can see right here. It kind of looks like interleukin 8. If I just put an I right here, we'd have interleukin 8 receptor. Okay, so that's essentially how I remember it, right? So you have L8R. I think of that as interleukin 8 receptor. And that's what it is. So this receptor binds to interleukin 8, right? You can see it binding right here. What does interleukin 8 do again? Interleukin 8 is responsible for chemotaxis, right? Chemotaxis, what are the big three for chemotaxis? We talked about this in the last video. LTB4, right, from the lipooxygenase pathway, interleukin 8, C5a. What's the other thing interleukin 8 does? It causes ongoing inflammation. So if there's a lot of interleukin 8 here binding to this receptor, potentially, it can help stimulate ongoing inflammation and get these neutrophils to go through chemotaxis into the site of infection. So that's what's happening here. Okay, so that's this tight adhesion step, largely driven by intracellular adhesion molecule 1 binding to LFA. Now, there's also a couple different receptors that you might see. You know, there's a lot of variants here. MAC1 tends to be more asked about with macrophages, just like the name implies. MAC1, macrophages. So macrophages have a similar process, but it's really the neutrophil migration that's the heavily tested one. So that's what we're focusing on. Now, the last step here is transmigration. And it's just like it says, right? We're migrating between these endothelial cells to get this neutrophil to the site of infection. The whole goal from the beginning was to get this neutrophil in down to the site of infection. And this one's kind of easy to remember because it's the same receptor. It's PCAM1, which essentially stands for platelet endothelial cellular adhesion molecule 1. Now, I know that doesn't directly make complete sense with, you know, a neutrophil migrating through here, and so it's kind of tricky, but I always remember PCAM is kind of like the bigger CAM. ICAM is the first CAM. So ICAM is for like tight adhesion, then PCAM comes after that because it's bigger. Okay, because it's a bigger word. I know it's kind of simple way to remember it, but sometimes simple is good, right? So PCAM1 is going to be responsible for this transmigration. So what this neutrophil is doing is once we lock it in place, we say, hey, you're not going anywhere, that interleukin 8 is going to say, hey, come this way. This is where we want you to be. This is where there's going to be a site of infection. We want that neutrophil here, right? That's what's happening right here. Neutrophil says, hey, I have nowhere to go anyway. I'm locked in. So the neutrophil is then going to transmigrate using this PCAM receptor between endothelial cells to the site of infection. Okay, and that interleukin 8, you can see it all over here, that's basically telling this neutrophil where to go. Interleukin 8, LTB4, right, and then C5a. And another term you'll see kind of synonymously used in this step is this term diapedesis, which is very frequently used kind of when the neutrophil is between these two steps. So you might see diapedesis in there, in terms of terminology, but really the big stuff you have to know is what's already on the slide here. All right, so now that we talked a little bit about neutrophil migration, we're gonna kick things up a notch and just talk about some of the pathologies associated with it. There's a bunch of different types of this. I don't wanna go into all the details on the different ones. I wanna just talk about the big one that you have to know, and that's leukocyte adhesion deficiency type 1. And if you really wanna read up on the different types, we can go through that. In step 2, we'll probably go into more detail as it tends to be more pertinent there. So if you have an absence of LFA1, remember what LFA1 did, right? LFA1 was what bound to ICAM1, right? So remember ICAM1, LFA1, that's this binding right here. So you can see there's like an exclamation point right here. If we don't have LFA1, right? If we don't have this receptor to bind to ICAM1. We can't lock in that neutrophil so that eventually can undergo crawling diapedesis and transmigration. We can't do that if we don't have LFA1. Okay, and LFA1, if you go back to that previous video, you'll see in parentheses, there were some CD markers associated with it, but the big one is CD18. So when you think about leukocyte adhesion deficiency, the number one thing I want you to think about off the bat is going to be CD18. This is one of those times where, sometimes it's important to remember these CD markers, other times not as big of a deal. This is one time you really want to remember it. Now remember, if we're talking about macrophages, this would be MAC1. Okay, so MAC1 usually more so on macrophages, LFA1 more on neutrophils. But the big point is you're unable to have a tight adhesion step. So basically from step 3 on, you're kind of in trouble, right? Because you can't lock this neutrophil in. The whole idea was these neutrophils are coming in pretty fast. You slow them down with the E-selectins binding to Sial-Lewis X and possibly P-selectins, right? Then you lock things in with the ICAM1, the intracellular adhesion molecule 1. You lock things in with that. Now, if ICAM1 is there, but the receptor that it binds to is not, well, that's a problem. That neutrophil is not going to get locked in. You're not going to get it to the site where it needs to go. So the problem is by not locking this neutrophil in, it just ends up kind of leaving this area, or at least a lot of them do. And they don't end up going through these later steps to get to the site of infection. Now, if you think about it, right, if you don't get neutrophils to the site of infection, that's going to be a problem. These patients are going to have recurrent infections. We're never going to get to a high level of immunity from certain infections if we can't even get the first responders to the site of infection. So that's why you have these recurring infections. But the most important thing to remember, there's a lot of different diseases that present with recurring infections, as you'll see in this immuno unit. But the big thing here is there's an absence of pus. This CD18 and absence of pus, that's pretty much the most important things that you have to know about this disease, okay? And because this is very unique, right? So if you think about it, like what is pus, right? So if you have, a dermal infection, you say, oh, what's pus, right? What's in it? Well, it's mostly going to be dead neutrophils, right? A lot of pus is really just dead neutrophils. You can imagine, right? If you don't have neutrophils going to your infections, well, you're not going to have them in the pus that's going to come from those infections, right? Because they never got to the infection to begin with. So that's why you have the absence of pus. You have absence of pus because you have absence of neutrophils, okay? And so you can also see impaired wound healing here. And then another big thing, if you had to put in a third thing besides CD18 and absence of pus, the umbilical cord being delayed in terms of its detachment. Very classic for leukocyte adhesion deficiency. So just keep this one in mind. Again, it has to do with neutrophils going to the site, and neutrophils play a very pivotal role in the umbilical cord coming off when it does. CD18, absence of pus, umbilical cord detachment. Now, Shirayama-Higashi syndrome is going to have to do with impaired microtubule polymerization. And again, it's really these mechanisms that you have to be familiar with. So if you don't have good microtubule polymerization, right, this can result in a decrease in neutrophil chemotaxis. Chemotaxis, again, interleukin 8, LTB4, C5a, right? Just remember those. Those are your big three. Okay, but this process is impaired. So it's the same concept here. You're just not going to get neutrophils coming to these sites because you're not able to get neutrophil chemotaxis working the way that it should. Okay, so that's the first thing. The next thing here, and there's kind of two major problems, is you have lysosomal dysfunction. Phagolysosomal fusion, remember we talked about you digest the bacteria into a phagolysosome and eventually you're trying to break it down using things like respiratory burst, things that we've talked about already. And so again, there's dysfunction in doing that. And so you get these really enlarged vesicles because you're pretty much just housing components of these pathogens, but you're not really breaking them down. And this is due to a defect in the LIST gene. And so LIST is for lysosomal trafficking gene defect, okay? So again, combination of this impaired microtubule polymerization and lysosomal dysfunction, just some things to remember when you're talking about Shirayama-Higashi syndrome. Autosomal recessive, I always tell people, I don't remember autosomal recessive diseases. I remember all of the X-linked dominant, X-linked recessive, and autosomal dominant. Everything else is going to be autosomal recessive. So this kind of just fits in with everybody else. Now, in terms of the presentation, again, recurrent infections. And there's a lot of things, like we said, that present with recurrent infections. So this doesn't make anything stand out from the bunch. However, the things that do stand out are partial albinism. Okay, so if you have a patient that has silvery hair or they're photophobia, right? And they don't like to be in the sun or it's painful for them to be in the sun. And they have a peripheral neuropathy. Again, peripheral neuropathy, think about microtubule polymerization. That's what happens when you start taking drugs like vincristine, vinblastine. You start to damage some of those microtubules. And we'll talk about all of that in the biochemistry section. But those patients can end up with a peripheral neuropathy secondary to chemotherapeutics like vincristine and vinblastine, and paclitaxel is another classic one. That's essentially what we're talking about here. Defects in microtubule polymerization, peripheral neuropathy. The last thing they'll sometimes show you are these giant cytoplasmic granules. You might be saying, well, what do those have to do with? Well, we already said you have these large vesicles, non-functioning lysosomes, and so you get these massive granules in here that are basically representative of that. If you see a cell like this, right, and you're like, well, what type of cell is this? Look, it's got 3 lobes. What did I tell you about the lobes, right? If it has about 3 to 4 lobes, start to think about a neutrophil. Unless it's staining pink or dark blue, right? It's usually going to be a neutrophil. If it has 6 or 7 lobes, now you're thinking B12 deficiency, right? Hypersegmented neutrophils. But anyway, I don't want to get too far off track, but that's what you're looking for. You're looking for these giant cytoplasmic granules. So these are the big 2 that I want you to be familiar with. So we talked about acute inflammatory response. Let's wrap things up with the chronic inflammatory response. And so this is going to be a little bit simpler in terms of, how much you have to know. You just really have to know some of the big players here. But what I do definitely want to hit on here are going to be granulomas. And so we'll talk about that in a second. But again, chronic inflammatory response, we're usually talking about ongoing destruction and repair of tissues. That's going to be more characterized by monocytes, plasma cells, and occasionally macrophages as well. When we talked about the acute inflammatory response, we talked about things like heat, vasodilation, edema, swelling. We're not talking so much about that with chronic inflammation. This is going to be more fibrosis and angiogenesis, and sometimes calcifications you can kind of throw in there too. But fibrosis and angiogenesis are really the big 2 components of a chronic inflammatory response. Tuberculosis is kind of like your classic example of this, okay? And so, tuberculosis is where we get into this conversation about granulomas. So before we get into that, the things that I want you to know here, number 1, interferon gamma is going to be one of the major promoting factors for macrophages to be pro-inflammatory. Okay, so you kind of think about, a scale of some sort. Okay, so you think about a scale of some sort. You can think of interferon gamma as being on one side of this scale. Okay, interferon gamma is going to kind of be over here. Okay, and so this is going to be pro-inflammatory. And then on the other side of the scale, you can have your interleukin 4 and interleukin 13. Okay, and so these are both going to be anti-inflammatory. Okay, so you have your pro-inflammatory, and then you have your anti-inflammatory, okay? Interleukin 4, interleukin 13 being more anti-inflammatory. And you can see that the pro-inflammatory, right? So the pro-inflammatory response, that's going to largely be driven by T helper 1 cells. Okay, so I'm going to put a T helper 1 cell, and that's what's going to be releasing this interferon gamma. Okay, on the other side of that, the T helper 2 cell, okay, the T helper 2 cell, you can see is going to help decrease the inflammatory response. Okay, so 1, 2, right? Interferon gamma, primarily pro-inflammatory. Interleukin 4, interleukin 13 are going to be more anti-inflammatory. Then we already talked about a lot of the other factors down here that are going to help stimulate the acute inflammatory response, which is not necessarily, going to be the same as what we're talking about here. But we talked about interleukin 1, interleukin 6, and TNF being the big 3 that are going to kind of kick the party off for an acute inflammatory response. Remember, these are all synthesized by NF-κB, and that would be more of the acute inflammatory response. Okay, let's get back to this slide, though. Don't want to get too off track here. So, again, that's what we just talked about here. Interleukin 4, interleukin 13, decreasing the inflammatory response, and then interferon gamma is going to be increasing the inflammatory response. So these 3 bullets down here are all really specific to this chronic inflammatory response. Now, what I want to call your attention to, because some of this gets tricky. So FGF stands for fibroblast growth factor. Fibroblast growth factor is not the thing that's typically increasing fibroblast collagen synthesis. The thing that normally does this that gets asked about is going to be platelet-derived growth factor. Okay, so this is why this is kind of tricky. The platelet-derived growth factor, remember, is the thing that's primarily increasing fibroblast collagen synthesis. That's what's responsible for this fibrosis that you're going to see. Okay, so that's going to mostly be platelet-derived growth factor, not fibroblast growth factor. Fibroblast growth factor is mostly associated with angiogenesis, and then this one actually doesn't make sense. VEGF, vascular endothelial growth factor, also responsible for the angiogenesis component. Okay, and you'll see VEGF when we talk about certain medications. When we talk about cancer, the big one is bevacizumab, or commonly known as Avastin, that targets VEGF, but we'll talk about that coming up. The other big one, now this is probably the single biggest cofactor here that I want you to remember from this slide, and this is going to be tumor growth factor beta. This is really going to be the kind of the poster child for chronic inflammation and also wound healing to some degree. Okay, so that's essentially chronic inflammation. When we talk about granulomas, it's important to just recognize the big players and be able to identify a granuloma. But a lot of people will look at this and say, look, I've heard this granuloma thing, I just don't get it. Like, what is a granuloma? So let's kind of just go through that really quickly here. Let's look at an image. So in this image down here in the corner, you can see all of these different cells, and you'll see they're kind of all in a circle. And the thing that's in the middle of the circle, that's the pathogen. Okay, so it's essentially what the body is doing is it sees something that's not supposed to be there, whether it's a bacteria, chemical, beryllium being a very classic one. And so the body just doesn't know what to do with it. It can't digest it. It's not doing that effectively. It can't kill it. And so it just walls it off essentially and says, look, we're just going to block you off until we can figure out what to do with you. And a lot of times it doesn't necessarily figure out what to do with that substance or bacteria. Okay, and so you just end up with this walled off structure that's called a granuloma. And you can see that a lot of the cells around the granuloma are going to be T helper 1 cells. That's all these green cells around here. Okay, so those are T helper 1 cells. We'll talk about what they do in just a second. But they're helping wall this thing off. And then if you go one layer deeper, okay, past them, you can see that there's all of these kind of blue rectangular cells. Those are epithelioid macrophages. And even deeper to them, you can see that we have some other macrophages in the middle here, and then we have some of these really big cells that have multiple nuclei. Those are called giant cells. Okay, so we're going to talk about where all these things come from now that we've kind of introduced it. But when you look at this, if you're looking at this kind of on a slide, you can see what we're talking about, right? You can see all of these cells kind of on the outside here. Let me use a different color here. So you can see all of these cells kind of on the outside back here. Okay, look at all of these cells on the outside. But then as you kind of move in to this thing, there's not a lot of cells here, right? There's very few cells in here. Okay, and that's usually the area that's walled off. And that area, eventually, because it's walled off, right, it's not going to be getting a lot of nutrients and that type of thing. It's not really going to have a lot of cells in that area. And so this is going to become an area of necrosis. Okay, and so this is what we call a caseating granuloma. In other words, it has a core in the center, right? In the center, it's a central necrotic core. The classic things for this are going to be TB and certain fungal infections, like we'll talk about when we talk about histoplasmosis, things of that nature. Okay, but TB is the number one thing to think about when you see caseating or necrotic granulomas. Now, there's also going to be non-caseating granulomas. What does that mean? That means that the center, instead of it being necrotic, it's actually going to have some cells. And you can see here, there's a whole bunch of cells that are in this core here. Okay, so you can see cells pretty much all throughout this. Okay, so there's your core, but then around the core, you can also see that there's going to be a lot of lymphocytes and other tissues. So there's less cells here overall, we'd probably say, but it's not necrosis that's happening here. Okay, so that would be a non-caseating granuloma, an absence of a necrotic core, very classic for sarcoidosis and beryllium. Those are probably the big two to remember. Okay, so notice that these are non-infectious. Now, that doesn't mean that non-caseating granulomas are always 100% non-infectious, but that's kind of an easier way to think about them. So if you're dealing with something that's non-infectious, you can think of, in terms of your big things, it's probably less likely to be caseating, if you had to guess, right? Like sarcoidosis, autoimmune, beryllium, you're talking about more of like a pneumoconiosis type thing. Okay, so that's the principle. Let's just go through this pathway and then wrap things up here. So this is kind of the steps you want to know. You want to know the big players involved. So let's just imagine, right? We have an antigen presenting cell. Let's just say it's a dendritic cell, for example. So we'll talk about all these receptors here coming up. But the antigen presenting cell, we already talked about this. What does it do? It's going to present this antigen to a CD4 positive cell. So maybe it, digested one of these mycobacteria from tuberculosis, and now it's presenting it to this helper T cell. Okay, and we know this is a CD4 positive helper T cell. So we know that it must be binding one of these receptors to MHC class 2. Right, we talked about that previously. Okay, so anyway, it's going to bind here, and the antigen presenting cell is going to say, hey, here's some interleukin 12. Why don't you turn yourself into a T helper 1 cell? So this interleukin 12, okay, is going to help stimulate the CD4 positive T cell, which is pretty much naive at this point. Now it's going to get activated, and it's going to turn into a T helper 1 cell. Okay, so again, antigen presenting cell binds to the CD4 positive helper T cell, plus interleukin 12 turns it into a T helper 1 cell. And remember what we said. T helper 1s, what do? Pro-inflammatory. What are they going to release? Interferon gamma. So here you go. Surprise, surprise. T helper 1 cell releases interferon gamma. What else did I say about pro-inflammatory molecules? Remember, TNF alpha is in that conversation. So interferon gamma, TNF alpha, they're going to help stimulate macrophage activation. You can see that here. Here's your T helper 1 cell, releases interferon gamma, releases TNF alpha. The macrophages that are formed from monocytes, right? You're going to get them to be activated. Okay, and that's all because of interferon gamma and TNF alpha, and we know that because they're pro-inflammatory. Okay, so that's the concept. So you want these macrophages more active because you have some antigen that you identified. Okay, so the T helper 1 cells are helping kind of stimulate that pro-inflammatory response. So the macrophages at this point, now that they're activated, they're going to go after this bacteria, right? They're going to go after whatever it is that this antigen is coming from. And these macrophages, in the process of doing that, will also release more TNF alpha. Remember what TNF alpha is doing. It's kind of your big three acute inflammatory reactants, right? We already talked about them: interleukin 1, interleukin 6, and TNF alpha, right? These are like the big three that are going to be responsible for increasing the temperature and setting off a lot of these acute phase reactants. What happens is, as these macrophages are trying to digest this material, a lot of the times, if we're having a tough time digesting this bacteria and we start wanting to wall this thing off, we start forming these macrophages that actually resemble an epithelial cell. And so they're called epithelioid cells. These are cells that have abundant pink cytoplasm. But it is important to at least understand that epithelioid macrophages are classically associated with granulomas. And these epithelioid macrophages can actually fuse here on the periphery. So you can get two of these or more fusing to form giant cells, where you have a whole bunch of nuclei in one macrophage. And so giant cells are very classic also. And the whole idea is these are essentially just trying to wall this thing off, whatever it is. Okay, and so that's why we're forming these kind of rectangular epithelioid cells and eventually fusing to form giant cells to kind of just block this thing off completely. And what maintains the granuloma? We already said TNF alpha, these macrophages releasing TNF alpha, T helper 1 cells releasing TNF alpha, because we can't break whatever it is down. We're stuck. We're in this repetitive cycle. And the other thing is interleukin 12. So we have a lot of interleukin 12 being released. The antigen presenting cells keep presenting this thing. Hey, we're presenting this thing, but nothing's happening, right? And so this just keeps perpetuating this whole cycle, the TNF alpha and the interleukin 12. Okay, so those are pretty important cofactors to remember when you're talking about granulomas. Interleukin 12, TNF alpha. 15 seconds to pause the video, read the question, and then we will go through the answer. All right, so we have a 1-month-old male who's presenting with family to a pediatric ward in rural Chile for irritability. Physical exam reveals tenderness and erythema at the umbilical stump. Okay, and there's also serosanguinous drainage. Notably, the umbilical cord remains attached from birth. This is a particularly high-yield couple findings here, which we'll talk about in a minute. But the big thing that I want you to take away from this, anytime you see the umbilical cord being attached from birth, especially when we're 1 month out, and when you see tenderness, erythema, some sign of infection at the umbilical stump, this is all very, very classic off the bat for leukocyte adhesion deficiency. So this is one of those situations where, again, when we start to see certain findings, what jumps out at you in terms of the presentation, there usually are certain key kind of things you're looking for, and this is definitely one of those things. Okay, just to continue here, so we have some induration is also noted at surrounding tissues. Okay, so certainly some evidence of an infection at the umbilical stump. Examination of the tympanic membrane reveals a bulging tympanic membrane with opacification and loss of light reflex. So essentially, when you see a loss of light reflex and you see a bulging tympanic membrane being mentioned, this is kind of the way that examiners will sometimes test acute otitis media. So I'll just put AOM here for that. And initial laboratory evaluation is shown below. So again, another situation where we kind of talked about this at the end of the chapter 1 video, where you're going to get reference ranges sometimes, and you're going to wonder, are these normal for a 1-month-old? And if you're ever in a situation where you don't know, you're probably not expected to know, right? So, you'll see what I mean here. So hemoglobin 16.5, right? Is this normal? It is normal in a 1-month-old, but again, it's not going to change the course of us getting to the correct answer, right? So sometimes these things are in here to kind of throw you off a little bit, but again, if you stick to what you know, it usually will kind of get you down the right path. Now here you see this leukocyte count of 45,500. Now again, is this normal in a 1-month-old? One thing I'll say is that in general, infants will tend to have a little bit higher normal reference ranges for their white blood cell counts. However, 45,500, this seems pretty elevated, right? This seems like it's a little bit high, okay? So this is a little bit high from what we would expect. Platelet count here, 185,000, right? That looks okay. C-reactive protein is elevated. Okay, so remember, C-reactive protein and the erythrocyte sedimentation rate, both of these are kind of non-specific markers of inflammation. Okay, that's the way I want you to think about them. They're non-specific, but in a board question especially, they're telling you that there's some underlying inflammation. So you might be thinking about rheumatologic disease, you might be thinking about an infection potentially, right? These are different things that can potentially cause us even malignancy potentially. Okay, now the nitroblue tetrazzolium dye reduction test, this is a very specific test. So if this test is mentioned, there's usually a reason for it. In our situation, this test is positive. Okay, and we're going to talk about this in just a second as we go through the different options here. Which of the following are most likely linked to the underlying condition in this infant? So, again, if we understand that we have the umbilical cord, being attached from birth, we have this infection at the umbilical stump, we also have acute otitis media, which is evidence that there's potentially multiple sites of infection going on here in the setting of a very elevated white blood cell count and inflammation. This is all very suggestive of leukocyte adhesion deficiency. And there are some other pathologies that kind of run very closely to this, and so we have to be able to distinguish them. But just going back to leukocyte adhesion deficiency, we kind of talked about this. There's some key findings that we're looking for. The number one thing is delayed umbilical cord detachment, right? If this is something you see in a board question, this is the first pathology I want you to think about. Now, there's certainly other findings, but again, this is the kind of the hallmark finding. When we see delayed umbilical cord detachment, we're immediately starting to think about leukocyte adhesion deficiency. Now, of course, recurring infections is certainly something we can see, right? Particularly if the infection is at the umbilical stump. That would be very classic. So an infection at the umbilical stump and then potentially at other sites, maybe a skin infection, right? Acute otitis media. Those are all things that are very classic. The other thing that is very classic is in the setting of these infections, we usually will have absent pus, right? You're usually not going to mention pus. And, if you kind of think about leukocyte adhesion deficiency, if you're thinking, well, why is there no pus? We kind of touched on this in the videos, but remember, the whole idea here with leukocyte adhesion deficiency, especially type 1, which is the, very commonly tested type, what's essentially happening is we're lacking CD18 or LFA1. And in some situations, this might be written as MAC1. So it just has to do with either the neutrophil, right, the neutrophil or the macrophage. And so the neutrophils really can't get to the site of infection, right? So if my infection is over here, right, here's all this bacteria infecting this tissue, and here's my neutrophil is not able to get to that site and eventually get into the site of infection. So because of that, right, I'm probably not going to have a lot of pus here, right? Not a lot of pus because the neutrophils, right, a lot of the dead neutrophils are essentially going to make up the components of pus, right? And so if I don't have neutrophils getting here, then I'm probably not going to have a lot of pus. Okay, so that's kind of what we talked about. And so if you see, absence of pus, or they use terms like serosanguinous drainage, right? Kind of a clear or like a pink tint to the fluid potentially, but not a purulent or pyogenic infection, right? These are things that would be classic for leukocyte adhesion deficiency. They mentioned that there's, thick green discharge, or it's a pyogenic infection, there's a lot of pus. They're probably not asking you about leukocyte adhesion deficiency, especially in a classic kind of style vignette board question. So with all that being said, the answer here is going to be absence of CD18 or LFA1. Okay, so if we don't have CD18, we don't have LFA1, we have difficulty marginating the neutrophils. You notice that this leukocyte count is very elevated. Part of the reason for that is because we can't get these neutrophils into the site of infection. And a lot of these neutrophils are probably remaining in the bloodstream, kind of kicking up our leukocyte count. All right, let's go through some of the distractors here. So a LIST gene defect or impaired microtubule polymerization, both of these are very classic for Chidiac-Higashi syndrome. With this syndrome, there's kind of a twofold issue. The first issue is that we have difficulties with the lysosomes working correctly to break down pathogens. And that's kind of how I remember this LIS, right? LYS, lysosome is what I'm thinking about, right? There's a problem with the lysosomes. Okay, and the other problem here is we have impaired microtubule polymerization. And that's how I kind of remember that this Chidiac-Higashi syndrome is associated with a peripheral neuropathy. And you might be saying, well, how does microtubule polymerization make you think of that? Well, remember, if you go back to your hematology or oncology, remember you have drugs like vincristine, paclitaxel. All of these are going to kind of affect microtubule polymerization. When you affect microtubule polymerization, the classic pathology that's associated with that I want you to remember is peripheral neuropathy. And that's how I remember that Chidiac-Higashi syndrome usually presents with some form of peripheral neuropathy. Now, the issue with the lysosomes also kind of reminds me that there's usually going to be giant cytoplasmic granules. You might be saying, well, why is there giant cytoplasmic granules? Well, again, if you have difficulty breaking down a lot of these, pathogenic substances potentially, right, they're going to kind of sit in the granules in your cells, right, in the cytoplasm. And so that's where you get these kind of giant granules that'll sometimes get mentioned. And we don't really see any of that mentioned here. The other kind of classic finding that goes hand in hand with these two findings when you're thinking about Chiari-Kagashi syndrome is albinism. So, usually that they'll have a patient with like silvery hair or very, sensitive skin to the sun. But we don't really see a lot of that mentioned here. We have very classic findings for leukocyte adhesion deficiency. Impaired superoxide production. Okay, let's just kind of talk about this. So again, let's just imagine we're in a phagolysosome here. Okay, and let's just say that, there's some bacteria around. So I'm just going to kind of draw this bacteria here. Okay, so we have this bacteria and we want to essentially destroy this bacteria. So what we can do is we can take oxygen, okay, and we can take some NADPH, all right, with this oxygen, and we can create a free radical. Okay, the free radical that we can create here is superoxide. Okay, and this free radical does a really good job of destroying invading species. It can cause damage to this bacteria. This superoxide can help destroy this bacteria. Okay, now the enzyme that allows this whole process to happen is NADPH oxidase, which makes sense, right? NADPH oxidase to form superoxide, right? Because we're using NADPH to do this. In chronic granulomatous disease, I'm just going to put CGD, we don't have this enzyme, right? We don't have NADPH oxidase. And for that reason, because we don't have this enzyme, what happens is we cannot form this superoxide very well. And so you can get impaired superoxide production, right? So if this patient that we're looking at here had chronic granulomatous disease, right, we would suspect that they would have impaired superoxide production, predisposing them to infections like this child has. However, the thing that would really kind of get you off of this diagnosis here is this bottom line. So sometimes you're going to see very pertinent findings that aren't necessarily suggestive of the underlying disease, but more so integrated to kind of rule you out of another disease, right? So in this situation, the nitroblue tetrazolium dye test will usually be negative, right? This test will usually be negative in chronic granulomatous disease. So if this test is mentioned to be negative, that's suggestive of chronic granulomatous disease. Because the test is positive, it's unlikely that this patient has impaired superoxide production. If we had a patient with CGD and they couldn't make superoxide, right? They couldn't make superoxide to destroy this bacteria. Well, then this bacteria would kind of proliferate, right? We'd have a tough time destroying this bacteria. And so, there are some other things that can happen. Well, this bacteria can also produce H2O2. And so what the body can essentially do is take this peroxide, H2O2, and we can actually break this down into HClO radicals. And these radicals can destroy the bacteria. So let's just say that I have a patient that has chronic granulomatous disease. Well, guess what? I can't produce the superoxide to help destroy the bacteria, right? This is not going to work. But what I can do is take the bacteria's H2O2 and convert it to HClO. And this involves using the enzyme myeloperoxidase. Okay, so we can use the enzyme myeloperoxidase to create this HClO so we can still destroy this bacteria even though we can't make superoxide. Now in a normal situation, right, we can actually even take this superoxide and convert it to peroxide and make our own hydrogen peroxide to make our own HClO radicals, and we can use the enzyme superoxide dismutase for that. Okay, so I know I'm kind of throwing a lot at you here, but the concept is if you kind of understand this pathway, then you also understand why patients with CGD typically are affected by catalase positive organisms. So let me kind of explain that to you. Remember, if we have CGD, we can't make superoxide to destroy this bacteria, right? We are not able to do that because we don't have NADPH oxidase. So what that means is we have to rely on the bacteria's hydrogen peroxide so that we can make HClO to then try to destroy the bacteria. However, what the bacteria can do is the bacteria that have catalase, they can take this H2O2 that they're producing, they can essentially convert it to water and oxygen, which are not harmful substances to the bacteria. And they can do this using the enzyme catalase. Okay, so the bacteria that have this enzyme catalase can take this H2O2 and convert it to the non-harmful water and oxygen. Okay, when remember, if you have CGD, you're relying on this H2O2 essentially to make HClO radicals to destroy the bacteria, right? So if the bacteria can convert this to water and oxygen, then this bacteria is going to eat up your supply of H2O2 that you would use to form free radicals and essentially proliferate. So that's why patients with CGD will typically have infections with catalase positive organisms, because those organisms are able to break down the H2O2 the body needs to destroy the bacteria. Okay, so that's the concept. The last thing on here is this HAX1 gene defect. Occasionally you'll see something on the exam that you're not super familiar with, or it's a gene defect that you maybe haven't seen before, and this is just another example of this, just kind of another distractor. The HAX1 gene specifically, you'll see some of these defects when there's mutations in the neutrophil elastase gene. And what this can sometimes do is this can sometimes cause the patients to have, a pretty severe neutropenia. And typically they'll present with, really low absolute neutrophil counts, or ANCs, and these will be like less than 200. In this situation, we have a really high leukocyte count, so that would argue against that. And again, this is more of, kind of just another distractor. You're not expected to know all the details about HAX1 gene defects. You're just expected really at the end of the day to make this association, right? This is the key association, and then kind of go through some of these options, and you should be able to rule out most of the other distractors. Hey everybody, Dr. Roviso here. In this video, we're going to talk about cytokines. And this is one of those chapters where it's really good to use the immunology bites that you'll see on the site. Those will really help you kind of categorizing some of this information. This is one of those areas where you want to use flashcards or something to remember these. But what I'll say overall is if you can classify this information and understand what these cytokines are doing in terms of communication, it makes the mechanisms a lot easier. And so we'll start with the pro-inflammatory cytokines, just because we've talked so much now about the acute inflammatory response. It's going to make for an easy transition. And then we'll talk about some additional cytokines, some things that we haven't quite talked about as much yet. Going on to that, we'll talk about pro-inflammatory cytokines, like we said first. And when you're thinking of cytokines, what are we talking about? We're talking about, if you have two cells here, right? You got an antigen presenting cell, you got a naive T cell. Essentially, we're saying, what do these two cells use to communicate? And what they use is cytokines, right? So one cell can release molecules to tell a dendritic cell to do one thing or the other. And you can see different cytokines can cause different types of responses and can cause, this dendritic cell to essentially behave differently. Okay, and so that's what cytokines are doing. They're communicating between cells. Okay, so again, when we categorize this in terms of what these cytokines are doing, I like to start with the acute inflammatory response, just because this is where it all starts. This is what we keep talking about, is this acute inflammatory response. Remember, how does this happen? And again, I'm going to go through this fast because we've talked about this, probably in 3 of these videos already. So go back, check the other videos out if you're not familiar with this. But again, pattern recognition receptors are going to bind to these non-specific pathogen-associated molecular patterns or damage-associated molecular patterns, right? Things like LPS, for example, binding to toll-like receptors, or the damage-associated molecular patterns. Cells that are infected with a virally infected cell, for example, that is releasing its cell contents, those contents binding to these pattern recognition receptors is going to set off a non-specific innate immunity cascade increasing NF-κB. NF-κB is going to lead to the downstream transcription of interleukin-1, interleukin-6, TNF-alpha, leading to production of acute phase reactants and increases in temperature set point, or we can just say increase in fever, okay? And also an increase in expression of endothelial adhesion molecules, right? We've talked about this in great detail in the last video. What's the point of that? Well, let's say you have an infection somewhere, right? You want neutrophils to get to the site of that infection. You want them to get to the site of inflammation. And to do that, you need to put endothelial adhesion molecules on those endothelial cells. So when the neutrophils come in rolling, they're going to bind really tightly to those endothelial cells and get in through diapedesis to the site of infection. And again, we talked about all of that in the last couple of videos, but it's essentially this process that causes that, right? Interleukin-1, interleukin-6, TNF-alpha. So if there's nothing else that you want to remember from this first category, if there's only one thing you can remember, it's definitely going to be this. And you're going to remember neutrophil chemotaxis is largely driven by interleukin-8, LTB4, C5a. And again, we've talked about all of this multiple times in the last few videos. But again, these are the communication pieces that the body is using to, number 1, increase temperature set point, set off an acute inflammatory cascade, and then number 2, allow neutrophils to taxi to the location of an infection. The thing that we haven't talked about as much is going to be the proliferative response. Now, when you're thinking about the proliferative response, I've got the innate response down, right? We got innate immunity. But what about my immune cells? What about my T cells? What about my B cells? What about my natural killer cells? That's going to be this proliferative response. We want those cells in the party too, right? Because they're ultimately going to help build memory responses, cell-mediated responses, humoral immunity, right? And so to do that, the number 1 cytokine you need to remember is interleukin-2. So let's just say that we have some cell here, okay? We're just going to take an example here. Let's just say that we have a T cell here. Now let's just say that it's a naive T cell. Now you've heard this term before, right? You've seen it here too. What is a naive T cell? Naive essentially means that this T cell has not kind of run into its antigen yet. So if I were to draw a T cell receptor on here, maybe I have a unique structure here, okay? So this cell's T cell receptor, TCR, okay? So this T cell has a T cell receptor, and it's got some other receptors out here too. Let's just say it has another receptor here. This will be its interleukin-2 receptor, and you'll see where I'm going with this in a second. So what will happen is, at some point, this T cell has a very unique T cell receptor, and it might even have some neighbors here, okay? But this T cell has a different T cell receptor, okay? But it does have the same interleukin-2 receptor. So that's kind of its neighbor cell, and then maybe it has another neighbor cell on this side. Another T cell here, again, unique T cell receptor, okay? So there's a T cell receptor, but then it also has that same interleukin-2 receptor. Eventually, what can happen is, let's just say that there is some dendritic cell, okay, or some antigen-presenting cell, and that antigen-presenting cell, right, so this is my dendritic cell, okay, this dendritic cell is going to eventually, maybe it runs into a bacteria or some pathogen, right? And so that dendritic cell is then going to take that pathogen and it's going to display, an antigen, right? A component of that pathogen on this MHC receptor. So let's just say that this is the antigen, okay? So it's displaying on this MHC receptor. Now, if this dendritic cell presents the right fit for that antigen to the right fit for that T cell receptor, if these two can bind and lock in, and let's just say that these two are a perfect match, this T cell will then become activated, okay? So it will go from naive to activated, to that antigen that fits nicely into that T cell receptor. And again, this antigen, if it binds here, it might not fit nicely. It might not fit nicely at this T cell. Okay, it's going to bind to a very unique arrangement of a T cell receptor. Now, what will happen is once this T cell gets activated, it says, okay, hey, look, there's a problem here, right? There's potential pathogen present. And so what this T cell will do is it can start to release interleukin-2. Interleukin-2 is going to allow for increased proliferation of immune cells. T cells will have increased proliferation. B cells will have increased proliferation, natural killer cells as well. Now, it does this in a few ways. One of the classic things that sometimes gets asked about for interleukin-2 is that it has autocrine action. Now, let's just talk about that for a second. Let's start with something that we already know. Okay, let's just say away from these cells here, there's a lymph node, okay? There's a lymph node. And inside that lymph node, maybe we have another T cell. Okay, maybe we have another T cell inside of this lymph node. I'm going to put LN down here for lymph node. And to get into that lymph node, maybe there's an afferent arteriole over here. Okay, so you got to get into the bloodstream to get into that lymph node. Now, maybe this interleukin-2 can travel through the bloodstream, right? It can travel through the bloodstream all the way to this lymph node to eventually bind to this T cell's interleukin-2 receptor. That would be an example of endocrine action. Okay, and so that's what we talk about when we talk about the endocrine system. We're talking about hormones that are traveling in the blood to get to a distant site. That's what endocrine is. If we talk about paracrine action, okay, so paracrine would be if this interleukin-2 that this activated T cell released, maybe it bound to this interleukin-2 receptor, or maybe it bound to the interleukin-2 receptor over here at the neighboring cells, the cells around this T cell. That would be an example of paracrine action. Okay, so that's paracrine. Now, if this interleukin-2 went and maybe it bound to the same cell that released it, okay? So in other words, this activated T cell is releasing interleukin-2 that is then binding to the cell that released it. That would be an example of autocrine action, okay? So I know that can be a little confusing, but the classic thing to remember when you think about autocrine action is interleukin-2 is the one that usually is going to get asked about in relation to autocrine action. Now, interleukin-3, okay, remember in the very beginning, the series when we talked about, okay, this is kind of the lymphoid lineage, your myeloid lineage. When you're thinking about interleukin-3 in general, just high level, you're usually talking more about, stimulating the bone marrow to release some of those cell lines that we're going to talk more about in hematology. Okay, so I think of interleukin-2 more in immunology. I think about interleukin-3 more in hematology. Okay, so we'll make more distinction on that as we go into hemonc. But that's kind of my way of thinking about it. It's going to increase hematopoiesis. This is your acute inflammatory response, more of the innate response, proliferative response. Now we're starting to ramp up into a specific T helper response, which we'll go into next. So let's just start touching a little bit on this T helper 1 response. And we actually talked about this quite a bit when we talked about things like granulomas. The T helper 1 response is going to be very closely linked to a cell-mediated immune response. And we're going to talk about this in great detail when we talk about the T cells. But in general, you want to think about kind of your end game here is CD8 positive T cells and natural killer cells. Okay, so that's where this is kind of headed, okay, this whole process, and you'll see what I mean. So let's just say, if we wanted to just explain this a little bit, let's just say that we have some antigen presenting cell here. Okay, let's just say that it's a macrophage. I'm just going to write MO here for macrophage, and it's going to have interacted with some pathogen. It's going to present that pathogen on an MHC receptor. Now remember, there's two types of MHC. There's going to be MHC1 and MHC2. Remember, MHC1 is going to bind to CD8 positive T cells. Remember your rule of 8s. 1 times 8 is 8. So MHC1 binds to CD8 positive T cells. But for the sake of this example, we're going to say this is MHC2, which means that the antigen on here is going to bind to a CD4 positive T cell. Okay, so here's my antigen. Okay, and so there's my macrophage. So it's interacted, maybe it phagocytosed some bacteria, for example, and now it's presenting that component, that antigen, to a T cell. Okay, and let's just say that over here, I have my T cell. Okay, so I have my T cell, it's CD4 positive, and it's naive. It hasn't interacted with an antigen that meets the criteria for this antigen receptor. Okay, so let's just say that this T cell receptor fits nicely with this antigen, right? And let's just say that this antigen binds to this T cell receptor. Okay, so in that case, if these were to bind, this T cell, like we just said, would then become activated. Okay, so then this T cell would be activated. It would no longer be naive. Okay, so we'll cross out naive, now it's activated. Now after this binding happens and this starts to get activated, the macrophage is going to release some cytokines, okay, some cytokines over to the T cell. In particular, we're going to release interleukin 12, okay, and that's what you can see here. So once this macrophage presents the antigen to this T cell, it's going to release interleukin 12. Okay, and that interleukin 12 is going to help stimulate this T cell to become a T helper 1 cell. Okay, a T helper 1 cell, which is going to take us into this T helper 1 response. Now you have a T helper 1 cell, and it's going to say, hey, right back at you, macrophage. It's going to send interferon gamma going the other way. Okay, so now this T cell is going to send interferon gamma back to the macrophage. Okay, and we'll talk about what this is in just a second. Okay, so the interferon gamma is going to stimulate the macrophage and activate the macrophage. Okay, so you're going to get some macrophage activation too from this interferon gamma. I'll do this in pink just to keep my colors consistent here. Okay, so this macrophage is going to get activated now because we sent some interferon gamma its way. Okay, I'm going to put an A here for activated. And it can also send some of this interferon gamma to the CD8 positive T cells. I always think of them as the scary cytotoxic T cells. Okay, so these are the really scary, mean cytotoxic T cells. We're going to CD8 positive T cells. And it's going to send some interferon gamma to them too. And that's also going to activate these CD8 positive T cells as well. And so that's essentially what's happening. So just to recap this really quickly, the macrophage had an antigen that was bound to its MHC2 protein that fit to this T cell receptor on this specific T cell, and then that macrophage released interleukin 12 to turn this T cell into a T helper 1 cell. This T helper 1 cell then released interferon gamma back to the macrophage, activated the macrophage, and also some of this interferon gamma could potentially reach some of these cytotoxic CD8 positive T cells to also look for this pathogen. Okay, so that's this whole process. And remember, there's also other things happening. You might say, like what? The other thing happening is interleukin 2, right? We already talked about interleukin 2 can also be released as a general proliferative response for all immune cells. It's not as specific to T helper 1 or T helper 2 response. Okay, but this is the process for the T helper 1 response. And where did you see this response already? Well, you saw this response when we talked about granulomas. It's very classic to see this T helper 1 cell-mediated response for granulomas because you have all these macrophages getting activated, turning into epithelioid cells, and then eventually giant cells. Okay, and you have all this interleukin 12 that's essentially sustaining this granuloma. And you can kind of see that up here. So if you look, interleukin 12, right, being released from the dendritic cell to the naive T cell. Remember, these are our communication lines. This interleukin 12 can then cause your T cell, your naive T cell, to form a T helper 1 cell that then releases interferon gamma. So that's the T helper 1 response. If you got that down, if you know where these factors fit, right, you you can make sense of a lot of these different processes. It's not as complicated as it looks. And again, it's the same thing here. You have the antigen presenting cell binding to a naive CD4 positive T cell, MHC2 binding to the T cell receptor. Okay, we'll talk about this in a future video, but essentially what's happening here is this connection is causing lines of communication to be sent from one cell to the other, right? Interleukin 12 and then interferon gamma going back the other way. Okay, that's what these polarizing cytokines are. They're very specific for the T helper 1 response. Now, the last thing I want to touch on here is going to be interferon alpha and beta. Interferon alpha and beta, think of them as kind of in this separate class from interferon gamma. These are going to be particularly important for managing viral infections. So the big thing that these two cytokines are going to do is they're going to allow for there to be an increased expression of MHC1. Now remember, MHC1 is on almost all of our cells. Okay, so cells that have nuclei are very classically going to have MHC1 on them. So it doesn't have to be an immune cell. It doesn't have to be a phagocyte or an antigen presenting cell. It can be almost any cell that has MHC1. And the whole point of that is if there's something wrong with one of our cells that's not involved in the immune system, it will then potentially be presented on the MHC1 to mark that cell, to say, hey, there's something wrong with that cell. Let's destroy it now before a potential virus or cancer in that cell replicates, right, and then affects the cells around it or metastasizes. Okay, so that's the whole point of MHC1. It's a marker for each cell. Okay, so if you have all of your cells, right, you have essentially a receptor on there, and if there is something wrong, right, if a virus gets in, let's just say we have a virus here. Okay, we have some virus here. If this virus infects this cell, then this marker on the cell is going to tell us, hey, this virus infected this cell. And that marker, again, is MHC1. It's on all of these cells. Once we find out that there's something wrong with this MHC marker, then these CD8 positive T cells, remember, they are the ones that are binding to MHC1. They are going to go after that cell to destroy it before that virus can hijack the cell machinery and then affect all of the cells around it. Okay, so that's the point of MHC1 simply. And interferon alpha and interferon beta are the cytokines that are essentially upregulating the MHC1 exposure here. So they're putting more MHC1 receptors so that there's a higher likelihood that these cells will then present these viral antigens, right, so that they can more quickly be destroyed if infected. That's the point of interferon alpha and beta. So if there's a viral infection present, interferon alpha and interferon beta might be upregulated, especially locally here, to tell these cells, hey, upregulate your MHC1 receptors. There's a high risk of a virus around us potentially. Okay, and so that's what they're doing. And also they have some other effects. They can also break down mRNA so that a virus that does infect a nearby cell can't hijack gene encoding processes to allow for viral replication. Okay, but that's the key here. Interferon alpha, interferon beta classically going to be used to kind of protect from viral infections. Again, interferon gamma in a whole different spectrum. Interferon gamma, we're talking mostly about things like T helper 1 response, granulomas, activation of macrophages. Now, when we go into the different deficiencies and diseases, if you just understand this process, you can make complete sense of this. For example, if you have a patient that has interleukin 12 receptor deficiency, okay, so the receptor that binds to interleukin 12 here, let's just say that it's not there for whatever reason. If you don't have interleukin 12 receptors, right, then when the macrophage tries to activate the T cell to make T helper 1 cells, it's not going to work because the CD4 positive T cell doesn't have a receptor for it. So to get around that, you can give the patients interferon gamma. You can bypass that step and just give the patient interferon gamma, and that will continue to protect patients from things like TB. If the patient did not receive interferon gamma, right, and they have an interleukin 12 receptor deficiency, right, you're never going to be able to have a good T helper 1 response. And so these patients will have higher risk for conditions that can predispose them to things like granulomas, right, which are maintained by interleukin 12, specifically mycobacteria, tuberculosis specifically being the big one. Okay, so that's just how you got to think about it. Conversely, if you have a patient that has an interferon gamma receptor deficiency, if you give them interferon gamma, it's not going to help the situation because the macrophages can still not get activated because they don't have the receptor. So in a situation like that, you might just want to treat the underlying infection. For example, if a patient has TB and they have interferon gamma receptor deficiency, you would just treat them more aggressively for TB using RIPE therapy, etc. Okay, so again, just making this big picture, that's how you think through these mechanisms. Okay, coming right off of the T helper 1 response, let's talk a little bit about the T helper 2 response. So remember, we have this initial starting point here where we have some antigen presenting cell presenting an antigen to a naive T cell, right? A cell that hasn't been exposed to this antigen before. And there's a lot of different ways we can go by communicating with that cell using different cytokines, for example, okay? And we already talked about, look, if we go down the T helper 1 pathway, that macrophage or that dendritic cell potentially will release interleukin 12, sending me down a T helper 1 pathway, which will ultimately result in interferon gamma being released from that T helper 1 cell to then activate that macrophage, activate CD8 positive T cells, and potentially natural killer cells. CD8 positive T cells, again, think cell-mediated immunity. You're going after cells to attack them, essentially going after cells that have MHC1 that are infected. Okay, so that's the process of interferon gamma. And remember, this interleukin 12 is very classic for stimulating this pathway to lead to macrophage activation, epithelioid macrophages, and giant cells in the setting of a granuloma. And we talked about that in great detail. So that's this first pathway that we just talked about. Now, if we look at interleukin 4 here, this is going to take us down the pathway of the T helper 2 pathway. Okay, and again, this is humoral mediated. When we say humoral mediated, what are we talking about? We're talking about primarily B cells, okay, and more specifically, we're talking about plasma cells. And remember what I said about plasma cells. Plasma cells are essentially like antibody factories. So high levels of antibodies is going to be pretty much associated with this humoral immunity. So you can see here, interleukin 4, interleukin 5, interleukin 9, interleukin 10, and interleukin 13 all going to be very classic for this pathway. You might be saying, well, why? Why are those cytokines so specific to the T helper 2 response? And it goes right into this next segment here. So remember, this dendritic cell is then going to send interleukin 4 over to this naive T cell, and in doing that, will stimulate this T cell to become a T helper 2 cell. That's step number 1. It's a CD4 positive T cell here, right? CD4 positive binding to this antigen presenting cells MHC2, right? Because antigen presenting cells usually are going to be using their MHC2 to express antigens to CD4 positive T cells, and then stimulating a cascade. 2 times 4 is 8. Remember your rule of 8s. So then this naive T cell is going to get stimulated with interleukin 4 to go down the T helper 2 pathway. T helper 2 cells will then go on to release specific cytokines. Okay, cytokines that include interleukin 4, interleukin 5, interleukin 13. And we're just going to say that we have some antigen presenting cell here. It's got MHC2. It's got an antigen on it. Remember, MHC2, it would have to be for it to bind to a T cell. And then let's just say that we have some T cell here. Okay, it's going to be a CD4 positive T cell. All right, and this T cell is going to be naive, right? It hasn't bound to its antigen, okay? And let's just say it has a T cell receptor right here, okay? And that T cell receptor just so happens to be a perfect fit for that antigen. So these two are going to bind, right? And then what's going to happen is this T cell will then get activated, okay? It will get activated. And when this T cell gets activated, now what can happen is the antigen presenting cell can send over a signal. We talked about in the T helper 1 response, this can be interleukin 12. Okay, but it can also be, right, it can also send some cytokines over that are interleukin 4. If it sends interleukin 4 over, it's going to turn this into a T helper 2 cell. And let's just say that we have some B cell here. And remember what I told you in the beginning, B cells can also bind antigens, right? So this B cell might have the same antigen that this antigen presenting cell had. And that can also bind to this T helper 2 cell. Okay, so when this happens, the B cell can also become activated. So the T cell is going to have a CD40 ligand receptor, and the B cell will have a CD40 receptor, okay? And this CD40 ligand binding is going to cause this B cell receptor carrying the antigen binding to this T cell receptor, right? It's going to cause this link up to eventually lead to this B cell undergoing class switching and potentially forming a plasma cell, potentially, okay, and undergoing class switching. And the thing that helps assist with this class switching process to go from a B cell that's primarily releasing IgM to a B cell that then releases some of these other antibodies with class switching is going to be this CD40 ligand linkage. And I'm getting a little off track because we'll talk about this in another video, but that's really this whole kind of process from start to finish. Again, started with an antigen presenting cell, sent interleukin 4 over to the T cell, caused it to become a T helper 2 cell. That T helper 2 cell can then run into a B cell that also is presenting this antigen. It can link up CD40 ligand and cause this B cell to develop class switching, IgG, which would be great for a memory response. If we wanted an IgE production, right, then the T helper 2 cell might release more interleukin 4 to this B cell. So it might send more interleukin 4 to the B cell. If it did that, we would get more IgE production. Okay, that would cause more IgE. Now, if instead the T cell sent interleukin 5, right, to this B cell, so let's just say instead it sent interleukin 5. So if it sent interleukin 5 to this B cell, then this B cell might produce IgA, for example. Okay, so that's where these interleukins come in. The initial interleukin 4 is largely driven by the antigen presenting cell sending it to this T cell, CD4 positive T cell, causing it to become T helper 2. This interleukin 4 is being sent to the B cell to cause that B cell to basically become a plasma cell, an antibody factory for IgE, right? As opposed to if we use interleukin 5, then becoming a factory for IgA. And interleukin 13 also has a similar effect to interleukin 4 in that it causes increases in IgE. Also remember, this sometimes gets looked over. IgG, which is probably the most common antibody that we talk about, also is coming from this interleukin 4 response, being sent to the B cell to switch, to class switch the heavy chain from IgM to IgG or IgE. Okay, so now if you're thinking about parasitic and allergic responses, it's also important to remember that interleukin 4, 5, 10, 13, 17, all very classic for those responses, which, I mean, it makes a lot of sense here. I mean, especially in an allergic response, right? You're thinking interleukin 4, interleukin 13. Why? Because IgE response, right? IgE is going to be very classic for the allergic responses in general. They're going to be binding to mast cells, for example, causing degranulation. And then interleukin 5, you might be saying, well, how is that related to an allergic response? Remember, interleukin 5 also causes upregulation of eosinophils. Okay, so eosinophils are also very classic in these responses. And you can also see that here, right? So interleukin 2, we already talked about it being kind of more nonspecific. The antigen presentation really driving this interaction to cause this naive CD4 positive T cell to go down to the T helper 2 route. So think of interleukin 4 kind of as the interleukin 12 equivalent of the T helper 2 response. Okay, and the last thing I want to talk about on here is going to be the Tregs and the T helper 17 response. And we're not going to go into too much detail on this. We're just talking high yield, high level overview. So think of TGF beta as the most high yield cytokine to remember when you're talking about a decrease in this immune response. If the immune response gets out of control, if it gets too high and you start attacking your own cells, you have some autoimmunity, the Tregs are essentially going to come in to control things, to get things to step down. And they're going to do that through the release of TGF beta. That's the most important cytokine to remember. The next most important will be interleukin 10. These are going to stimulate Treg development, which are essentially, like we said, going to prevent autoimmunity. You can imagine if you don't have these regulatory T cells or these Tregs, then you're at higher risk for autoimmune reactions because you don't have the cells that prevent autoimmunity, right? And then also this TGF beta will also be involved with the T helper 17 response, which is why I kind of include them here. T helper 17, it's pretty straightforward. It's going to classically be associated with interleukin 17, and these are mostly related to neutrophil function. We don't have to go into all the details on that. That's, pretty much the extent of it. So again, you can see here, TGF beta kind of being the classic molecule to remember when we're thinking about T helper 17 expression versus Tregs, but interleukin 10, much more specific for bringing down that immune response. And the way to really differentiate these two, again, interleukin 10 more associated with the kind of decreasing the immune response altogether, whereas when you're thinking about the T helper 17 response and neutrophils, you're thinking more about interleukin 17. And so that's kind of an easy way to distinguish both of these, even though they both involve TGF beta. Take 15 seconds to pause the video, read the question, and then we will go through the answer. All right, so we have a 74-year-old female presenting to the emergency department with acute onset diplopia and severe unilateral right-sided headaches. Her past medical history is significant for hypertension, hyperlipidemia, and osteopenia. The patient reports that she has had 10 pounds of weight loss over the past 3 months. Semi-concerning, especially in a 74-year-old, right? We might be thinking about potentially malignancy as a primary cause here, especially if it's unintentional. She has also had increased fatigue and symmetric bilateral shoulder, hip, and neck pain that is worse in the evening. Okay, that's interesting. Kind of sounds a little bit like polymyalgia rheumatica, right? This could be GCA. Let's keep reading here. Physical examination reveals a right temporal artery distension and tenderness to touch over the right temporal region. Okay, so, actually, let's re-highlight that this is actually a very important finding. So this, again, there's always certain things that you're going to see in these vignettes that are more important than others. This line right here, pretty much, to me, it kind of tells us exactly what we're dealing with. So when they start to talk about tenderness over the temporal artery or pain over the temporal artery or distension, especially in the setting of, double vision here and these unilateral right-sided headaches, it's very classic for giant cell arteritis. So I'm just going to put GCA, and this symmetric bilateral shoulder pain and hip pain is very classic for polymyalgia rheumatica. And these two are often kind of interlinked in board questions, especially in a older patient, usually a female patient in kind of the classic vignette style. All right, so let's kind of keep reading here. Laboratory evaluation reveals a significantly elevated ESR. All right, we talked about this before, ESR, CRP, they're kind of non-specific markers of inflammation. Now, usually if a patient has, GCA, the concern is that we don't want them to lose their vision, right? And so usually we start the steroids even before we confirm the diagnosis. So here, intravenous methylprednisolone is administered and her symptoms improve. Okay, great. 2 weeks later, the patient returns to the emergency department reporting worsening jaw claudication and visual loss in the right eye. Okay, so fundoscopic examination is shown below. We'll talk about this in a second. Urgent treatment with intravenous tocilizumab and methylprednisolone is initiated. Based on the vignette, which of the following are most likely inhibited by the pharmacologic management utilized in the treatment of this patient? If you take the time to memorize all of these different monoclonals, it would definitely pay some dividends here. The answer is interleukin 6. So tocilizumab is actually an interleukin 6 antagonist. So when you're talking about giant cell arteritis, what is exactly going on here? Well, the problem is you have this inflammatory reaction essentially happening here, right? You have this acute inflammatory reaction. And remember, when you have a lot of inflammation, right, you're talking about things like interleukin 1, interleukin 6, TNF alpha, right? These are all kind of your acute phase reactants, right? And so we've talked about this a couple times now. And, especially in the setting of this elevated erythrosedimentation rate, these are kind of all interlinked here. Now, if you give a patient, methylprednisolone, what are you trying to accomplish? Well, if you give a patient a steroid in general, if we kind of go back to the basics here, remember you have your PLA2, phospholipase A2, which eventually can turn into arachidonic acid. And this arachidonic acid can go down to form prostaglandins, right? It can go on to form leukotrienes like LTB4, which we've kind of talked about already. Glucocorticoids in general are going to kind of inhibit this process upstream here, right? So the methylprednisolone, the idea here is by inhibiting this, we're going to inhibit a lot of these pro-inflammatory downstream products that can be formed, okay? So that's what the methylprednisolone is doing. Tocilizumab is more specific to interleukin 6, which is actually pretty effective because interleukin 6 tends to rise very rapidly or fall very rapidly also. People that memorize tocilizumab might be rewarded here, but the point is, you can actually rule out a lot of the other options here. And let me kind of tell you what I mean by that. So if we look at option B, interleukin 10, right? Interleukin 10 and actually option D, transforming growth factor beta, both of these are actually going to be very much associated with anti-inflammatory reactions, right? So remember, interleukin 10 and TGF beta are both going to be more anti-inflammatory. So they're going to kind of attenuate the immune response, whereas interleukin 1, interleukin 6, TNF alpha, they're all going to be pro-inflammatory. So what are we trying to inhibit with our pharmacologic management? Are we trying to inhibit anti-inflammatory markers? No, we don't want to inhibit anti-inflammatory. We want anti-inflammatory because we're in the setting of an inflammatory state that's causing loss of vision, right? So we want to inhibit the things that are causing inflammation, like interleukin 6, for example. Okay, so these two you can pretty much rule out here. Receptor activator of nuclear factor, KB ligand. So this is just referring to rank L. Okay, so you might be more familiar with it written as rank L, but again, you got to remember, you got to know what these things stand for, right? So rank L, remember, this is going to promote osteoclast activation osteoblasts are typically inhibited, right? And when we give patients things like methylprednisolone, right? Methylprednisolone, recall, can actually stimulate rank L to stimulate osteoclasts to cause bone breakdown. So that's kind of a risk we take, even though this patient has osteopenia, but they have a much more, severe acute pathology where we would necessitate, steroids in this case. But remember, steroids can cause stimulation of rank L. So the fact that we're giving the patient steroids, we're not going to be necessarily inhibiting rank L. We actually, because we're giving glucocorticoids, we might actually be worsening the osteopenia or stimulating the rank L potentially, kind of as a side effect to the management of the GCA. Okay, the last one on here is alpha-4 integrin. Now this one, it's not as closely linked to a lot of the other things that we're talking about. The reason that this is a significant option here is because you have to know that alpha-4 integrin is very much associated with a very specific medication, and that medication is natalizumab. Okay, so I really want you to make sure you're familiar with natalizumab being the monoclonal antibody that targets alpha-4 integrin. Now, when would a patient use natalizumab? This is going to be very classic if a patient has like refractory or really, really bad multiple sclerosis. Okay, so it's usually not a first-line option, but in severe disease, it can be used in MS. Okay, natalizumab, the thing that you have to know about it, besides its use here and its target, is that very frequently when you put a patient on this, they're at risk of reactivation of the JC virus, right, which can cause PML. Okay, so this is a big thing to be familiar with. Again, similar to rituximab, you want to be familiar with that. But again, not directly linked to the target here. The target of tocilizumab is, again, to bring down the inflammatory response, targeting interleukin-6, an acute inflammatory reactant. Again, just be familiar, when you see this image, you see this kind of cherry red spot located right here, kind of surrounded by this pale area and discoloration of the retina back here. This cherry red spot is really at your fovea, and this is very, very classic for a central retinal artery occlusion. Okay, and we'll talk about more of this in another video, but central retinal artery occlusion, there's really three things that I want you to just kind of be familiar with. So the first one is carotid disease. So a patient that has, a carotid bruit, for example, these are the patients that are very classic to be at risk for having central retinal artery occlusion. The second one on here is a patient that has AFib, right? So they can throw emboli up to cause a central retinal artery occlusion, right? So you throw emboli up, right? You can have an emboli that goes to the kidneys, right? It can go to the brain, it can go to the central retinal artery. Okay, so that's the concept. And the third one on here is GCA. Okay, so you can get central retinal artery occlusion from GCA. Like we said, vision is something that we're hoping to maintain, which is why we give the steroids early to attenuate the inflammatory response. Remember, when you have a central retinal artery occlusion, this is classically described as kind of like a painless, sudden loss of vision, like a curtain's kind of coming over the eye. And again, we'll talk about more of this in another video, but I just wanted to make sure we kind of touched on that here. But again, the answer here, interleukin-6. Hey everybody, Dr. Roviso here. In this video, we're going to talk about T cells. And so this is a pretty big video. We'll talk in the beginning about T cell development. What are the big things you have to know in regards to, how T cells develop, positive selection, negative selection. These tend to be particularly high yield. We'll talk a little bit about the MHC, or major histocompatibility complex 1 and 2, and then we'll talk about the process of T cell activation. If you've been following this video series so far, again, everything is really going to start here in the bone marrow, and we're going to have, CD34 positive hematopoietic stem cells that eventually form the myeloid and the lymphoid lineage. And we're primarily concerned, especially in immunology, with the lymphoid lineage. And this lymphoid lineage is going to give rise to T cells, to B cells, to natural killer cells. Now, the B cells, remember, the B cells are going to not only originate in the bone marrow, but they'll also then go on to kind of develop in the bone marrow. But the T cells are a little bit different. They'll also originate in the bone marrow because they all come from the lymphoid progenitor cells, right, which are going to be found in the bone marrow. However, the T cells are a little bit different in that they'll develop in an outside lymphoid organ, and that is going to be the thymus. And you might be saying, well, how do you even get these lymphoid progenitor cells over to the thymus? Well, there's certain chemokines that are released that essentially are going to signal the lymphoid progenitor cells to shuffle over some of their inventory over to the thymus so that we can develop some T cells. Okay, so this lymphoid progenitor cell is going to leave the bone marrow through the bloodstream and eventually go to the thymus. Okay, so that's what we have here. It leaves the bone marrow, goes to the thymus. And at this point, this cell is CD4 negative, CD8 negative. There's no CD4, there's no CD8 on this cell. And these are two markers you want to be really familiar with a T cell, particularly in the stages of development, because different stages, there'll be different receptors, and this tends to be confusing. And the way I remember it is, look, this is a lymphoid progenitor cell. We haven't started kind of classifying it as a T cell until it gets to the thymus, right? And so at this point, we would expect it, as it arrives to the thymus, to be CD4 negative, CD8 negative. Now, once it gets to the thymus, though, there's going to be certain enzymes, certain genes that are going to stimulate shuffling of some of the genes in this precursor T cell. And the one that you really want to be familiar with is going to be RAG, which is essentially this recombinase activating gene. If you think about, a recombinase enzyme, what are we talking about? We're talking about taking the DNA, shuffling it up, mixing it up so that we get some variation and some diversity in those genes. And the idea here is, if we're shuffling up all of the DNA here in this precursor T cell, we can create a very unique T cell receptor that will bind to a unique antigen. If we create a whole bunch of different T cell receptors, we're going to have more immunity to different types of antigens. And that's essentially what these RAG genes are doing. And so the two big recombinase genes, like we said, is going to be RAG1 and RAG2 that are going to be kind of stimulating this process, this recombinase process, to eventually lead to the development of the T cell receptor. Now, remember what I said, you do have to keep in mind where's CD8, where's CD4. And you can see here that this precursor T cell, after it comes into the thymus, it's going to have that recombinase gene causing the formation of a T cell receptor. And with that T cell receptor formation, there's also going to be the addition of CD4 and CD8. CD4 and CD8 are essentially co-receptors to the T cell receptor. Okay, so we're basically putting everything on this precursor T cell, including CD3. CD3 is usually going to be, in terms of board questions, a marker to tell you that you're dealing with a T cell. Doesn't necessarily tell you what type of T cell, like CD4 and CD8 will, but CD3 is kind of just like a general T cell marker. So you're going to get a T cell receptor, CD4, CD8, and CD3 all placed on this precursor T cell once it gets to the thymus. It's essentially the body's way of saying, look, now that we've got this lymphoid progenitor cell here, we're marking this as a possible T cell. Okay, and so that's what all of this stuff going on to this T cell is for. Now, as you'll see in a minute, we'll eventually have a CD4 receptor or a CD8 receptor along with the T cell receptor and the CD3, but we won't have both CD4 and CD8 when this process is done. But in the beginning of the process, we have both of these receptors. And so sometimes these precursor cells, once they get to the thymus and they have RAG1 and RAG2 activation, they'll be called double positive T cells. Okay, and so just to recap this here, we have this initial pre-selection process, which I'll talk about in a minute. The T cell receptor will be created using RAG1 and RAG2, like we said, and it will be CD4 positive, CD8 positive. Now, the next step in this process is particularly high yield. This is positive selection. In positive selection, we're essentially trying to find the right antigen. You can think of it in some ways as a positive match in terms of an antigen that we can bind to that T cell receptor that we created using the RAG genes, RAG1 and RAG2. And so just to take this for example, what will happen is, again, the blue structure here is going to be your T cell receptor. And you can see that T cell receptor can bind to some of these thymic epithelial cells. Okay, so this would be a thymic epithelial cell. And these thymic epithelial cells will either have MHC1 or MHC2. Okay, now remember, the CD4 positive co-receptor will help that T cell receptor bind to MHC2. Conversely, the CD8 positive co-receptor will help that T cell receptor bind to MHC1. Okay, and again, this goes back to your rule of 8s. Okay, so 8 times 1 is 8, right? So we're talking about CD8 positive times MHC1. That gets you to 8. Now on the other side of that, 4 times 2 also equals 8, right? So CD4 positive cells that are going to bind to MHC2 receptors will also get you to 8. Okay, so that's the way to remember. CD8 positive cells are going to bind MHC1, CD4 positive cells will bind MHC2. And you might be saying, okay, hold on a second there, Dr. Roviso. You said that this cell has CD8 and CD4. So how do I know which one is going to bind? In reality, one of these receptors will find their specific antigen on these thymic epithelial cells and they'll bind. And when they do that, they're going to essentially select themselves to either be a CD4 or CD8 positive T cell. Okay, so it's kind of, in some ways, it's a bit random how this happens. But the point is, the big point that you want to remember here is that in the process of positive selection, what we're essentially doing is we're finding the right fit. We're finding the antigen that binds specifically to this receptor. Now, if that antigen binds too tightly or it doesn't bind strong enough, what will happen is these T cells will eventually get an apoptosis signal. So if the binding is too strong or too weak, that T cell will eventually undergo apoptosis. You have to have just the right amount of binding to get to the next step, which would be negative selection. Okay, so in positive selection, you're looking for adequate binding. And again, the CD8 positive co-receptor will bind with MHC1, the CD4 positive co-receptor will bind with MHC2. So it's kind of completely random as to if, this precursor T cell binds to CD4 positive MHC2 or uses CD8 positive to bind to MHC1. But once that process happens, then we're essentially selecting the route that this cell will go down, okay? Once it chooses to bind to whatever specific antigen is present. And again, if the binding is too strong or too weak, then it's going to undergo apoptosis. But if the binding is just right, then we can get to the next step. And the next step is going to be negative selection. Now, negative selection, unlike positive selection, is going to take place in the thymic medulla. Again, we're going deeper into the thymus as we proceed here, okay? So negative selection is the process of essentially, again, binding to these same type of receptors that we bound to in the initial step, but the difference in negative selection is that we're using our own self-antigen. So these medullary thymic cells, instead of presenting a foreign antigen, we're presenting antigens from our own body. And the idea in negative selection is we don't want our T cells to attack our body, right? We don't want our T cells to attack our own cells. And so we're presenting our own cells, kind of like a test to say, hey, we just want to make sure that you're not going to be attacking us. Okay, and so that's what this second step is. Now, if the T cells bind really tightly to our own antigens, that's concerning because then we're thinking, well, it's possible that these T cells could attack our own cells. Okay, so self-antigens again, self-antigens being the key point, right? Antigens from our own cells presented on the MHC1 and MHC2 receptors. If strong binding occurs to self-peptides, again, our own peptides, then those T cells will likely undergo apoptosis. So you can see that again here. So if the binding is really strong, again, these T cells will then undergo apoptosis, okay? Now, the T cells that do not bind, right? So the T cells that do not bind, those cells will then go on to form mature cells, okay? So again, this being the example of the CD4 positive T cell, and then this being the example of the CD8 positive T cell. And again, in both situations, if there's no binding, then we go on to essentially have a matured T cell, okay? Once we complete negative selection, we have a matured T cell. Now, keep in mind, this T cell is still naive. What does that mean? Naive means that this T cell has not yet run into its antigen that binds to its specific T cell receptor in the body yet. Okay, once this T cell runs into that antigen, that T cell can then become activated. Okay, typically when a macrophage or dendritic cell presents that antigen to the T cell and activates it, then that T cell would no longer be naive. But at this point, it's important to understand the terminology. The T cell is mature because it went through this whole process. It's been tested for positive selection. It binds to its antigen, not too strong, not too weak, and it won't attack our own cells, most likely because we didn't have binding to self-peptides. Okay, so that's the concept. So that's why it's mature. It's naive because it has not yet run into its antigen in the bloodstream. So just keep that in mind, or in any lymphoid organ in the body. What you'll notice here at the very end of this, you might be saying, what happened to those CD4, CD8 receptors? Okay, so you can see here, we had a CD4 positive cell in negative selection. It still had on this CD8 receptor. So basically, throughout this whole process, these cells were double positive T cells. Through positive selection, through negative selection, they were double positive. But what will happen is after the selection process has occurred, you'll start to see downregulation of whatever receptor was not used during this process. So if we look on the left, this was mostly going to be the CD4 positive T cell because it bound to MHC2 initially, right? Going back to our rule of eights. So what happened is eventually you'll see that this CD8 co-receptor eventually falls off as it matures into a mature T cell. Okay, so when you get to a mature T cell, you don't have CD4 positive, CD8 positive. You have one or the other. It just depends on which pathway this T cell went down. So you can see here, once you have a naive T cell post-selection, an immunocompetent mature T cell, it's either going to be CD4 positive, CD8 negative, or CD4 negative, CD8 positive. Again, if it's CD8 positive, we call those cytotoxic T cells, CD4 positive T helper cells, and we'll go into a lot of detail on this in the next couple videos. But the point is that there's downregulation of that receptor after we go through selection. And the last thing that I want to touch on here, remember we talked a little bit about these Tregs or T regulatory cells. Now, a small percentage of these cells that actually do bind to self-antigens will actually stick around. So you might be saying, what are we talking about here? We're going back to this step at negative selection. Okay, so right here, again, we presented our own antigens, a self-antigen. We don't want the T cell receptor to bind, right? When the T cell receptor binds to that, we basically are saying, hey, this thing has got to go. It's got to undergo apoptosis because it could attack us. A small percentage that actually do bind don't undergo apoptosis and instead go on to form regulatory T cells. Okay, and this is particularly classic for the CD4 positive line here on the left. So what these T regulatory cells essentially do is they help kind of damper down the immune response. They regulate the immune response, basically so it just doesn't get out of control. Okay, that's kind of a simple way of explaining it. And again, we'll go into more detail on this coming up. But the important thing to know here when we're talking about this self-antigen presentation with regulatory T cells and negative selection is there's a very classic protein here, and that's going to be this ARI protein. And this is very classic because this particular protein is responsible for allowing this process to happen. In other words, it allows us to give self-antigen presentation so that we can kind of show these T cells, hey, this is what our antigens look like. If this protein is not functioning accordingly, if there's a defect in this, then you can imagine we might have a higher risk of essentially attacking our own cells because we're not able to effectively undergo negative selection. And the classic pathology that this manifests as is going to be autoimmune polyendocrine syndrome, which is essentially a combination of a bunch of different endocrine-like disorders due to this autoimmune response where we're attacking a lot of our own cells, leading to endocrine dysfunction. So you get things like adrenal insufficiency, you can have hypoparathyroidism, chronic mucocandidiasis is also very classic. And again, we'll probably talk about that in greater detail, but just kind of keep that in mind, big picture. Okay, so just to recap this, right, we had some lymphoid progenitor cells, we had chemokines that brought that lymphoid progenitor cell from the bone marrow where it originated to the thymus to mature. Once it got to the thymus, CD4 negative, CD8 negative, the recombinase gene shuffled up the DNA, we made a T cell receptor, and it was double positive at that point. And again, I want to say that all of these, if you look at all of these, they all have this CD3 receptor on them. So throughout this entire process, right, we also had a CD3 receptor, and that stays on all of these cells even when they're mature. Remember, CD3 is very classic for marking a cell as a T cell in general. Okay, so remember that. But the CD4 and the CD8 receptors, we're going to basically go down one of the two paths where we end up keeping one or the other. Okay, so again, if we initially are going to bind to MHC2 thymic cortical epithelial cells, we'll then probably go down the CD4 positive route. If we bind to MHC1, we'll go down the CD8 positive route. You can always remember that with your rule of 8s. Okay, so the first step was positive selection. We wanted to see if there's adequate binding to an antigen that is not self, right? Some other foreign antigen usually. And if there was adequate binding, the T cell will go to the next step. If not, it would undergo apoptosis. With adequate binding, the T cell moves to the medulla. Then there's negative selection. We present self-antigens largely driven by this protein, the ARI protein. And if there's binding to self-antigens, then that cell needs to undergo apoptosis because we don't want it attacking self. Some of the small percentage of those cells will become Treg cells to help regulate the immune response. And then eventually, once this process is completed and this cell survives, then it will become a mature T cell, either CD8 positive, CD4 positive, and then downregulate the other core receptor. It will still have a T cell receptor and it will still be CD3 positive. And so what is this major histocompatibility complex anyway? It's really just another form of communication. It's a communication receptor. We talked about cytokines kind of assisting with communication, and the MHC complex is going to be very classically associated with binding to these T cell receptors, and usually the MHC receptor is either going to be on kind of like your everyday nucleated cell or an antigen presenting cell. Now, when we're talking about class 1 MHC, we're talking about the kind of the standard MHC receptor. That's how I remember it. Class 1, it's kind of just like your baseline MHC receptor. It's pretty much going to be on almost all of your cells, particularly most nucleated cells. So remember, when we say nucleated cells, we're not talking about red blood cells, right? Red blood cells will not have MHC1 because they're not nucleated. Okay, so this has repercussions down the road when we talk about some of the pathology, but that's just something to keep in mind. Now, the key is the MHC1 receptor is essentially looking at every cell, and it's making sure that there's kind of nothing suspicious going on with all of our cells. So it allows for recognition of healthy versus infected cells. So you can imagine, right? So if you just have some normal cell here, okay, so this normal cell is doing what it's supposed to be doing, and on its surface here, it has this kind of MHC1 receptor. And, you know, if I have some T cell nearby, okay, so I have some T cell over here, this T cell will also have a T cell receptor. And this, you know, kind of healthy cell might present some of the self-antigens. So there's a lot of proteins and that type of thing that are in the cytosol of the cell, and some of those proteins might end up going into the rough endoplasmic reticulum and eventually getting transported to the surface of this MHC1 receptor. And this T cell might recognize that and say, hey, okay, that's a self-antigen. And remember, we already talked about this. In negative selection, we had our T cells undergo negative selection, right, in the thymus when they were maturing. And in negative selection, we tried to bind to self-antigens, but the T cells that survived did not bind to self-antigens. So this T cell that's then seeing this healthy cell putting a self-antigen here, it's not really going to bind to it that tightly. And so there's nothing to worry about, right? Now, let's see what happens though if I had a virus come around. So if I had some virus come around, okay, so here's some virus. All right, and this virus then gets into this cell. So it's going to go into the cell, it's going to hijack the cell's machinery so it can make more viral proteins. Well, the cell, what it will do is it will take some of these proteins, like we just talked about, it'll bring them into the rough endoplasmic reticulum, okay, and then it'll break them down and then transport them to the surface of the cell. And so now when this T cell's kind of jumping around here, checking out all the cells, it's going to see, hey, look, there's an antigen that's presented here that isn't really supposed to be here. It's going to bind to this antigen because it's a foreign antigen. It's going to be the right antigen to match that specific T cell receptor. And then we'll talk about what this T cell does, but you have to keep this in mind, right? On all of these kind of normal everyday cells, they're going to have MHC1 receptors, right? They're going to have MHC1 receptors. So that means that this cell that's binding to MHC1, what did we say? Well, it must be CD8 positive according to the rule of 8s, which means that this must be a cytotoxic T cell, cytotoxic killer T cell. Okay, and so you'll see what we'll talk about in the next video. This cytotoxic T cell will then essentially destroy this cell using granzyme and using enzymes to essentially punch big holes into the cell membrane, because the idea is this cell, we're basically sacrificing it because we don't want this virus to then kind of burst that cell and then have even more viral particles infecting other cells. So that's the concept. And remember, what this cell will also do, it will also release some interferon alpha and interferon beta to the nearby cells. Okay, and so it'll essentially try to tell them to upregulate their MHC using interferon alpha and interferon beta. Remember, this will then upregulate MHC1 on the nearby cells so that there's a higher probability that if those other cells are infected, they will be detected early by more cytotoxic T cells. MHC is not just in humans, okay? So the way that we kind of classify it or grade these, we call these the human leukocyte antigens. And it's just important for you to understand that for MHC class 1, you can see there's only one letter after this human leukocyte antigen or HLA class. So the specific one here, A, B, C, there's only one letter, okay? So one letter for MHC class 1. You'll see in MHC class 2, there's 2 letters. So that's how you remember it. One letter, think MHC class 1, 2 letters, think class 2. Now, sometimes you'll get questions on the actual structure of the MHC receptor. We can make a whole 2-hour video on, the different receptors, but just make sure you understand that these receptors have beta-2 microglobulin, okay? So that's this component here. And you can see that the MHC1 receptor is kind of asymmetric compared to the MHC2 receptor. The MHC2 receptor looks a little bit neater. It looks a little bit more symmetric. So sometimes you'll see that, this MHC1 receptor, they'll say it's either asymmetric or has 2 polypeptides of different lengths. So just kind of keep that in mind. There's a little bit of asymmetry here, and it also uses beta-2 microglobulin. Now, the MHC1 receptor complex, like I was talking about here, it's developed in the rough endoplasmic reticulum, which is a little bit different than the MHC class 2. So again, these are just kind of some of the details that sometimes come up that you want to be familiar with. And the key thing that we talked about here is that, again, a virus has to usually infect a cell, right? So it's usually an intracellular pathogen, something that infects the cell so that then we can, once it's in the cell, we can take its proteins, put it in the rough endoplasmic reticulum, eventually get it through the Golgi back up to the MHC1 transporter. So again, this is going to be, MHC1 is going to be usually intracellular pathogens for that reason. Okay, and again, CD8 positive T cells are the ones that are going to recognize MHC1. We talked about that already, usually leading to cell-mediated destruction of that cell. Now, the particularly high yield thing, this is very high yield. If there's an absence of an MHC1 receptor, in other words, if the T cell comes by and says, hey, this guy doesn't have an MHC1 receptor, if there's a cell that doesn't have MHC1, natural killer cells will tend to destroy those cells. Okay, so natural killer cells are kind of on the hunt to make sure everybody's got their MHC1 receptor. And you might be saying, well, what's the point of that? Well, remember, if you have a virus that comes by and infects a cell, through evolutionary processes, these viruses have learned to downregulate MHC1 receptors, right? Again, we're releasing interferon alpha and beta because we want more MHC1 receptors, but the viruses have trying to downregulate them. Everybody's trying to kind of compete to see if these cells have an infection, okay? And the viruses obviously don't want to be detected, okay? So they can downregulate MHC1. The same thing is true for cancer cells. Cancer cells can also do this. Natural killer cells are always on the look for an absence of MHC1. And again, MHC1 receptors will be upregulated by interferon alpha and beta, and I think we talked about that earlier. Now, when we're talking about MHC class 2, we're not talking about just your kind of like everyday nucleated cell. We're talking specifically about antigen-presenting cells. Remember, we said this is going to be macrophages, dendritic cells, B cells, right? These are all going to be very classic for presenting antigens to either B cells or T cells. And again, the HLAs are going to be 2-letter HLAs, specifically for MHC class 2. Now, again, we talked about the receptor has chains of equal length, which is going to be different from the receptor in MHC class 1, which is going to be asymmetric and have beta-2 microglobulin. The other thing that sometimes comes up here when we're talking about MHC class 2 is this invariant chain. When we talked about MHC class 1, we're talking about an intracellular pathogen. For MHC class 2, because we're talking about antigen-presenting cells like this macrophage here, this macrophage, right, how is this process going to start? This macrophage is eventually going to get into some contact with some bacteria here. Okay, so let's say that this is a bacteria. Okay, so this macrophage is going to get into contact with this bacteria. It might attempt to destroy it or phagocytose it. And once it does that, it's going to break that bacteria up in the phagosome, right? And eventually it'll fuse with a lysosome to break down that intracellular bacteria. Okay, so it's going to kind of keep them in these phagolysosomes to break down the bacterial contents. So that's what the macrophage is initially going to do. And we already kind of talked about how this process originates. Now, once you get this bacteria in this phagolysosome, you're going to acidify it, right? Macrophages, we also talked a little bit about the superoxide radical formation, respiratory burst pathway. So you're essentially breaking this bacteria down. Now, once you break it down, this macrophage is going to take components of that bacteria and present it on MHC2. Okay, and so once you do that, now you can have a CD4 positive T cell come around, bind to that MHC2 receptor, detect it, right? And then it can activate this macrophage. And it does that through interferon gamma classically. Now, notice what's different here. When we talked about the first pathway, we talked about this whole thing happening because it was an intracellular pathogen that infected the cell, that being the virus. Here, it was an extracellular pathogen that a macrophage digested and then presented to MHC2. Now, in the process of this happening, there's kind of like a little chain on the MHC2 receptor inside of this phagolysosome, and that's this invariant chain. And the invariant chain just essentially prevents the antigen from binding prematurely. And it's one of those things that, you know, I wouldn't remember every step of the process unless you have a lot of extra room in your brain, but the invariant chain is one component that I would associate with MHC class 2. So think of it like a little hook on this MHC receptor as it's in this phagolysosome before it gets transported to the cell surface that essentially prevents the antigen from binding before it's broken down completely. Okay, so that's just a simple kind of way to remember that. And remember, when we're talking about MHC class 2, extracellular pathogens, CD4 positive T cells, usually resulting in a humoral response, at least primarily a humoral response. Whereas when we're talking about MHC class 1, we're talking about intracellular pathogens like viruses in particular that result in CD8 positive T cell mediated destruction, usually more of a cell mediated process. The goal here is to essentially take the concepts that we've been talking about and then integrate them into this slide. Okay, so let's start off with the basics here. So cytotoxic T cell activation, which we kind of just talked about, very good versus intracellular pathogens. Again, we have our kind of everyday nucleated cell here. It's presenting it's usually going to be presenting self-antigens on MHC1. However, if this cell was infected with some kind of virus, for example, right, like we just talked about, if there was some virus around that infected this cell, okay, here's my virus infecting the cell, then that viral antigens might be presented on MHC1, CD8 positive T cells, again, binding to MHC1. These are going to be cytotoxic T cells. They'll recognize that this cell is infected by some intracellular pathogen, and they'll release perforin and granzyme B to destroy the cell. So perforin, just think of perforating the cell membrane, right? So these are essentially going to be molecules that are going to be cutting holes into this cell to essentially destroy it, to prevent this virus from hijacking more of the cell machinery and eventually leading to a terminal lytic cycle in the cell and then kind of reproducing accordingly. And so that's what the cytotoxic CD8 positive T cell is doing. It's trying to destroy the cell because it's infected, again, through this process that we just talked about. So I think we've hit on that a couple times. Now, the important thing to remember is that, again, the antigen that's presented was endogenous. In other words, it came from inside of the cell. It was a viral protein. Usually we expect self-antigens to be presented in MHC class 1, and normally our body should not be binding to those because we went through negative selection. However, think of one of the correlations of this, and this is kind of some next level stuff, but if you have a patient that has a transplant patient, for example, or you put a donor graft in a patient. So let's just say you put a graft in a patient, and now that patient has somebody else's cells, right? And if that person doesn't have, the same type of HLA receptors there, right, they're going to present different self-antigens. And so what's going to happen is if you put a graft in another patient and they have different MHC1 receptors or different variants of these, right, different HLA variants, and the person that received the graft, right, that person has T cells, right? They have CD8 positive T cells that could attack the grafted cells. So you can imagine, let's say that this cell, right, this cell came from the donor. Okay, and then this CD8 positive T cell, let's say that this was from the host. Okay, so this is the host or the recipient that received the graft. So what can happen is, again, this MHC receptor might be somewhat foreign, right? It might not have the same exact HLA compatibility. And so these host cells will recognize, hey, this is not a self-antigen, and they'll actually start to destroy these donor cells for that reason. Okay, and so this is something that you'll sometimes see. And then again, there's variants of this. We'll talk about all of this in transplant rejection, but essentially this is what's happening. If you don't have self-antigens on MHC1, those cells could get attacked. And that's why we immunosuppress patients after they get a kidney transplant or bone marrow transplant, because you don't want the immune system attacking these cells. But then that does open the door for a virus to potentially start to infect these cells without any regulation if you're immunosuppressed. But I'm going to get off the soapbox there, and we'll go back to the next topic here, which is going to be the helper T cell activation. Now, one thing that's going to be a little tricky here, when you're talking about helper T cells, you can go two different routes. You can go a lot of different routes, actually. You can go T helper 1, T helper 2. Those are the big ones for step 1. But then, of course, there's regulatory T cells, there's T helper 17 cells, etc. But what I just told you earlier, okay, and again, we're just kind of adding layers to this, but what I just told you earlier is usually when you're talking about T helper cells, number one, this is CD4 positive, meaning that there's going to be MHC2 binding to CD4 positive T cell receptors, and this is usually going to be from an antigen presenting cell, right? An antigen presenting cell binding to a CD4 positive T cell, okay? So that's kind of what we've already talked about, and you can see it here. Here's the MHC2 receptor, here's the CD4 positive co-receptor, here's the T cell receptor, but there's also going to be a B7 CD28 binding, okay? And so essentially this is going to be a co-stimulatory signal. It's essentially going to help activate this T cell. Okay, and without that co-stimulatory signal, there's going to be a significant drop off in the ability for these T cells to get activated. And so this is just one of those things that you want to be familiar with. Now, B7 can also be referred to as CD80 or CD86. Okay, so just kind of keep that in mind. And a lot of people remember this as saying, look, 7 times 4 is 28, right? 7 is B7. 28 is what it's binding to, and the 4 is a CD4 positive T cell. Okay, so again, these are all kind of ways to, just remember this, because a lot of these are kind of confusing, and it might help to use some flashcards, go through some of the recall questions on here. But again, that's the general concept. So antigen presenting cell presents an antigen via MHC2, like we talked about, to a CD4 positive T cell, and there's a co-stimulatory signal that's B7 CD28, right? 7 times 4 is 28. Now, the thing that I told you earlier, I was kind of only giving you the half truth here, in general, when you stimulate helper T cells, there's usually going to be a very effective response versus extracellular pathogens, right? We talked about this. If it's an antigen-presenting cell, usually like a macrophage, right, they're usually going to run into things like bacteria, okay? And they'll digest this bacteria, right? They're going to eat up this bacteria, and then they're going to put the bacteria in these phagolysosomes that will essentially get acidified. Once the invariant chain kind of pops off, they'll present these antigens on their MHC2 receptors to T cells. Okay, and again, these were extracellular pathogens that they're presenting, right? So this was an extracellular pathogen. And usually what will happen is in these situations, these antigen-presenting cells will then release interleukin-4, like we talked about earlier. And the interleukin-4 will stimulate this T cell to become a T helper 2 cell. Okay, so again, this is going to be stimulated by interleukin-4 released from the antigen-presenting cell. And then these T helper 2 cells, right, once this becomes a T helper 2 cell, that T helper 2 cell can then go on to release more interleukin-4, it can release interleukin-5, it can release interleukin-13. Okay, and we already kind of talked about some of the implications of this. These are all going to help stimulate eosinophils, basophils, mast cells. They're going to help cause class switching on B cells, which we'll talk about in the next video. Okay, so that's kind of the whole process. So when I think about helper T cells, this is really the process that I'm referring to when I'm thinking about helper T cells. Now, but we can't forget that there are also T helper 1 cells. You might be saying, well, you know, how is that different from the T helper 2 response? Well, the T helper 1 response is pretty interesting. The T helper 1 response, let's just erase some of this here. So in the T helper 1 response, remember the difference is that we're going to be using interleukin-12 to stimulate this naive T cell to form a T helper 1 cell. Why would this antigen presenting cell want to release interleukin-12 instead of interleukin-4? Like, what would cause that? Well, let's just say, for example, that I'm dealing with an intracellular bacteria. Okay, so something a little different. Let's just say that I have an intracellular bacteria here. Okay, so not talking about a virus. What intracellular bacteria is very classic that we talk about very frequently? How about Mycobacteria tuberculosis? Okay, I'm just going to put MTB here for tuberculosis. Okay, remember, this is acid-fast intracellular bacteria, and a lot of times our body doesn't know how to destroy tuberculosis, right? And so this is going to be an intracellular pathogen. Okay, so it's intracellular in the antigen-presenting cell, not necessarily affecting all of the cells systemically, but more classic for antigen-presenting cells. But again, it's intracellular, right? The body digested this bacteria, but it doesn't really know what to do with it. It's having a hard time breaking it down. And so it's just going to kind of hold it here and present some of those antigens. And in the process of doing that, it's going to say, hey, we're dealing with something different here. It might release interleukin-12 instead to this T cell, but causing this T cell to become a T helper 1 cell instead of a T helper 2 cell. Now, once we get a T helper 1 cell here, it might stimulate this macrophage and say, here, let me give you some extra juice. It'll give it some interferon gamma to activate this macrophage. Okay, and again, these macrophages can eventually go on to form epithelioid macrophages, giant cells, and the whole idea is we're essentially going to use these macrophages to kind of help digest and wall off this infection. And that's where you get your granuloma formation, okay, which is very classic for this T helper 1 response. And the key is that this all kind of happened because, again, this was an intracellular pathogens. So in the last video, when I talked about MHC complexes, I said in general, if you're talking about CD4 positive cells, you're usually talking about extracellular pathogens that you're digesting. However, with the T helper 1 response, this is more so specific for intracellular pathogens. So I know that's kind of confusing, but just keep that in mind. And usually this is going to come up when we talk about things like granulomas or viruses that are potentially infecting antigen-presenting cells. And these T cells will go on, like we said, to release interferon gamma to the macrophage to activate the macrophage, and we'll also get some interleukin release and then TNF-alpha. And remember, the other thing I want to say here is interleukin-2, when we talked about cytokines, you're going to get some interleukin-2 release pretty much with almost all of these different steps. Interleukin-2 is going to stimulate all immune cells, T cells, B cells, natural killer cells, etc. And the key thing to remember the high yield thing about interleukin-2 is it can also have autocrine action. It can actually kind of stimulate the same cell that released it. Okay, so we talked about that in the cytokine video. Finally, the last thing on here is going to be these regulatory T cells. And regulatory T cells, like I said, they're kind of going to help damper down the immune response. These are essentially going to come from CD4 positive T cells that had some binding to self-antigens. Okay, and so these regulatory T cells are very very cognizant of that. So they're protecting us from self-antigens, preventing autoimmunity. That's the key with regulatory T cells. So you can imagine if you had some defect in your regulatory T cells or in the process of negative selection, you might end up with an autoimmune phenomena, right? So you can see the CD4 positivity in these cells, which kind of tells you where they came from. But the key to look for if you're trying to distinguish these cells from others, CD25 positive, FOXP3 positive are very classic for regulatory T cells. And again, if we're bringing down the immune response, right, we're going to be releasing things like TGF-beta. Okay, this is kind of like the opposite to the interleukin 2s of the world, the interleukin 1, the interleukin 6, right? This is going to be the complete opposite response. Don't get TGF-beta confused with TNF-alpha, right? TNF-alpha, we're stimulating, upregulating immune response, TGF-beta, downregulating immune response. And again, these regulatory T cells will be inhibited by interleukin 6. That should make sense. Interleukin 6, pro-inflammatory, TGF-beta is going to be anti-inflammatory. Now, once these cells are stimulated, they can release more TGF-beta, right, to increase the anti-inflammatory response, but they'll also release interleukin 10. So the big two to remember for anti-inflammatory response is going to be TGF-beta, interleukin 10 to decrease the immune response. Kind of a lot of information here, but I think this is really pretty much all you need to really nail down T cells, even though it's such a big topic. And in the next series, we'll take this one step further with B cells to see how we end up developing antibodies. Take 15 seconds to pause the video, read the question, and then we will go through the answer. All right, so we have a 10-month-old female who's presenting to her pediatrician with a 4-day history of irritability and decreased appetite. Okay, her mother reports that her symptoms were accompanied by a fever that resolved yesterday. Shortly after the fever subsided, a generalized erythematous rash on the trunk was noted by the family. Shortly after this fever subsided, now the patient has a rash that is new, that's proximal, right, so starting here on the trunk. Since that time, the rash has spread to the face, neck, and lower extremities, so spreading distally from the trunk. Immunizations are current, okay, that's kind of an important point, and the family denies any recent illnesses or sick contacts. On examination, the infant is well appearing with stable vital signs and a blanching maculopapular rash extending from the trunk to the bilateral lower extremities. CD56 positive lymphocytes in this patient most likely targeted infected cells through which process. Okay, so there's a couple things going on here. First of all, like a lot of these questions, and again, and this is kind of the evolution of step one questions. You don't necessarily need to know everything that's going on in the question to get to the right answer, right? If you kind of understand, first of all, what is a CD56 positive? So when you see CD56 positive, right, the first thing that should kind of jump in your mind when you see CD56 positive, you want to immediately start to think about natural killer cells, okay? Natural killer T lymphocytes specifically. So these cells, they have a couple different functions, but one of the major functions of natural killer cells that we've kind of touched on so far is that natural killer cells can kind of go around and sample host cells and look at their MHC1 receptors. Okay, so for example, our regular cells, right? So maybe these are just some cells not necessarily directly involved with the immune system, but these cells typically, right, all of the nucleated host cells should have an MHC1 receptor, right? So these cells should have an MHC1 receptor. Now, typically what will happen is if the host, for whatever reason, is infected with a virus, right? So we'll just say there's some virus here, right? So this is my virus, and this virus, let's just say this virus hijacks this cell's machinery, right? So now this cell is actually producing viral particles for this virus, right? And so eventually what happens is the host will then digest some of these particles, bring them up through the rough endoplasmic reticulum, and transport this eventually to the MHC1 receptor, right? So these viral particles will actually get placed on the MHC1 receptor. Now, this is a risk for the virus because once these particles get presented on the MHC1 receptor, now this cell is basically known to harbor this virus. So if a CD8 positive T cell came around, which remember, these are these cytotoxic killer T cells. Remember your rule of 8s, right? So MHC1 is going to bind to the CD8 T cell receptor, right? 1 times 8 is 8, right? So this CD8 positive receptor, right, with a similar idiotype can bind to that MHC1 receptor and then realize that, hey, this cell is infected with a virus, and then start to release granzymes, perforins, right, to destroy this cell. Okay, so that's the concept. What this virus can do to try to counteract this whole process after infecting a cell, so let's just use a different color here. Let's say that we have a smarter virus, so to speak, on this side. So this virus infects this cell. The difference is, right, once this virus starts to kind of have this cell produce its viral particles, what this virus can do is it can actually code to downregulate the MHC1 receptor. Okay, so it can code to downregulate this MHC1 receptor. So now the CD8 positive T cell that's kind of coming around here, it's sampling the different MHC1 receptors. Well, guess what? There's no MHC1 receptor on this host cell. And so it's not able to detect the viral particle there, for example. Now, what the natural killer cells can do is they can come in. Remember, these are going to be these CD56 positive cells, right? These cells can come in and they can identify that, hey, this cell does not have an MHC1 receptor. Okay, and that's particularly problematic. And actually, the natural killer cells have various mechanisms also of destroying host cells that are not displaying MHC1, which is significant not only for viruses, but when you're talking about things like cancer, for example, right? So cancer can do something similar. Cancer can downregulate MHC1 receptors so that it can go undetected. When you see questions where they're referencing viruses in general and CD56 positive cells, the thing that you want to think about is downregulation of the MHC1 receptor on tissue, right? How is the CD56 positive lymphocytes targeting the infected cells? It's targeting the infected cells by identifying the lack of MHC1 receptors. And then, you could take this a step further if you really want to kind of understand what's going on here, right? So you have a 10-month-old, okay, 10-month-old who's coming in. She had 4 days of kind of irritability, decreased appetite, kind of non-specific symptoms. We might be suspecting something viral potentially. She had a fever, but to really kind of nail this down, the key line here to figure out what's going on, shortly after the fever subsided, a generalized erythematous rash on the trunk was noted by the family. That is very, very suggestive, especially in this age range, of HHV6 usually, sometimes HHV7. And this is an example of roseola infantum. So the key point here, the key takeaway, number one, you're looking for, kind of non-specific symptoms with a fever for like 3 to 5 days, somewhere in there. And then once this fever breaks, right? Once that fever breaks, now the patient presents with the rash, right? As soon as that fever breaks. Okay, the second thing that you should remember too when you're talking about HHV6 or HHV7, a lot of these different viruses, you kind of want to understand where the rash starts and where it ends, and then, a little bit about the rash. So in this case, this is going to be a proximal, usually in the trunk is where this will start, or maybe the thighs, and then it's going to spread distally, right? The rash is going to spread distally, very similar to what we see here. So this is very classic, but again, the giveaway line here is definitely the fever breaking. Now the patient has an erythematous rash, that's blanching, that's maculopapular in nature. This is all very classic for HHV6. Now there's other, viral syndromes that potentially could show up in a question like this. You could think of something like, for example, measles, where you might have coryza, cough, Koplik spots. You can also think about something like erythema infectiosum from parvovirus B19, but that typically would be present in an older child, usually like 9 to 12 years old. When you're talking about a 10-month-old, HHV6, HHV7, definitely in that like 9 to 21-month age range is very classic, especially like we said with this classic presentation. Now, let's just quickly walk through the other options here. So we already said absence of MHC1 receptor is the correct answer. Interleukin-5 release. Remember, the big thing, about interleukin-5 that we've kind of touched on is that interleukin-5 actually assists with class switching, right? When we have our CD40 ligand binding, the interleukin-5 cytokine can kind of stimulate the B cell to become a plasma factory that then produces IgA antibodies. Interleukin-4 release, on the other hand, is kind of going to do the same thing, but it's going to more so promote IgG and IgE class switching antibodies. Now, again, class switching isn't really classic when we think about natural killer cells, right? We're talking about CD56 positive cells. If we said something about CD4 positive T helper cells or something along those lines, that would be more classic for a class switching type mechanism. But again, we're talking about natural killer cells. This wouldn't necessarily be consistent. Remember, interleukin 10 here is actually associated more with an anti-inflammatory reaction. So this is more used to kind of attenuate the immune response. And remember that we said, interleukin 10, TGF-beta, these are really good cytokines, especially in questions where you have a patient that has like autoimmunity, right? And you need to bring that autoimmune response down. So you want more of an anti-inflammatory effect in those situations. All right, the last one on here, presence of MHC2 receptors. And just recall what these MHC2 receptors are essentially doing. So, antigen presenting cells, APCs all right here, are typically the cells that are going to have the MHC2 receptor. MHC2 receptors are not going to be on all of your host cells. They're primarily going to be on your antigen presenting cells, and they're going going to bind to CD4 positive T cells or T helper cells in an effort essentially to destroy usually extracellular pathogens. Okay, so more classic to see, the humoral type response where we're activating a T helper cell, then we're getting, class switching with a B cell to eventually produce a, very specific humoral response. All right, but in general, we don't really think about the presence of an MHC2 receptor necessarily having anything to do with a CD56 positive lymphocyte. If this was a CD4 positive lymphocyte, again, this would probably be more of a more representative answer. Hey everybody, Dr. Viso here. In this video, we're going to talk about B cells. So we're transitioning from T cells to B cells. We'll talk a little bit about just a high-level overview. We don't have to go into as much detail as we went into when we talked about T cell development, but we will build on some of what we talked about with T cell activation when we talk about B cells here. So just to give an overview, again, for step 1 purposes, you don't really have to know quite as much detail as we did when we talked about the T cells kind of going through the thymus, positive selection, negative selection. Not the case really with B cells. Now you might have learned more in your, immuno courses, really for B cells in general in terms of their development. The big thing that you have to know is, again, they originate from the bone marrow, just like a lot of the other hematopoietic stem cells that then go on to form lymphoid progenitor cells. Now the B cells, like the T cells, will also have precursors. The difference is, remember, the T cell precursors are going to get chemokines that essentially cause them to migrate to the thymus, whereas the B cells, these are going to stay in the bone marrow to mature. That's the key difference. Remember, B for bone marrow, B for B cells, T for thymus, T for T cell. Now, once these B cells mature, and there is a process that goes along with that, but it's not particularly high yield for step 1. Again, you might cover it in your immuno courses, but not particularly high yield for step 1. The big thing here is that once these B cells stay in the bone marrow and they mature, then they become naive mature B cells. Now, remember, you be careful with your terminology here. Remember, naive means that this particular B cell has not come into contact with its antigen. Now, here we're essentially looking at an antibody. And what's really interesting here is that the B cell receptor is going to actually be membrane-bound immunoglobulin. Okay, so in other words, you're going to have membrane-bound antibodies on the surface of the B cell. So you can kind of see that here. You can see these antibodies that are bound on the surface of the B cell. And these antibodies are essentially going to be your B cell receptor. Okay, so this is a little bit different than T cells. T cells didn't have antibodies bound on their surface. And again, we'll talk about antibodies in great detail here, but you can see the antibodies that make up a variable region up here, and there's a constant region on the bottom. And then there's also a couple different mechanical components here that we can see. We can see that there's a light chain here, and then we can also see that there's a heavy chain down here. Okay, and like I said, we'll talk about all of this in great detail, but the point that I want to convey here is that the antigen binding site, where your antigen is going to bind, is going to be up here in this region. Okay, so the antigen binding site is going to be up here in that variable region, and that variable region is going to be generated through somatic recombination of the VDJ segments as these antibodies are formed. And again, we'll talk about all of that. We touched on it a little bit in the adaptive immunity section, but we'll talk about that in great detail in the antibody video. Now, the other thing that I want you to kind of keep in mind here with B cells is there's usually going to be specific markers that call you to this being a B cell. In this case, CD19, CD20, CD21. Okay, so these are all representative of your B cell. And so when you see these markers, I want you to start to think about B cells. And you might remember, if you watched the video on T cells, that there are specific markers for T cells. And the specific marker for T cells is going to be CD3. Sometimes we'll take, a sample from a patient and we'll run it through flow cytometry just to see how many B cells, how many T cells that patient has. And, just for example here, let's say that I put on this side, let's do CD3. And on this side, let's just say I did CD19, for example. Okay, I'm just using one of these B cell markers. It could be CD20, CD21, right? But the point is that, you have to recognize, okay, this is CD19. So when I see CD19, what are they trying to tell me? They're trying to tell me that this is a B cell. Okay, so when you see CD19, you're thinking B cell. When you see CD3, you should be thinking T cell. And so you can get these graphs where you'll see like a bunch of dots, for example, here, and you might see a bunch of dots over here. And essentially what this is representing when you see these diagrams is it's showing you that, hey, this person has, some amount of B cells and T cells that were identified when flow cytometry was conducted. The point that I just want to hit home here, and we're going to go into this in a lot more detail when we talk about how to read these graphs and that type of thing. But the point here being, if I gave you this and I had a whole bunch of density here at the CD3 line, but I had maybe 1 or 2 dots at CD19, that might suggest that, hey, this person, maybe they have a whole bunch of T cells, but when I look here, I don't really see anything in the area around CD19, right? That might be suggestive of potentially a B cell deficiency, right? Or if it was vice versa, if I had a whole bunch of dots at the CD19 mark, but if I didn't really have any density of CD3, right, then I would be more concerned about a T cell deficiency, right? So that's kind of how you read these. Again, these are just markers to kind of tell you what cells you're dealing with. Remember, CD3 is for T cells, CD19 for B cells. Now, these B cells, not only will they have a B cell receptor on their surface, which we already said is going to be membrane-bound IgM, or in some cases it can be IgG, and we'll talk more about this in the next video. But you can also have the MHC2 receptor. Remember, the MHC2 receptor, the whole point of an MHC2 receptor is so that you can present antigens to T cells primarily. Remember, B cells are also antigen-presenting cells. It's not just dendritic cells and macrophages, right? B cells can also present antigens. So like, let's just say, for example, how would that happen, right? If I had some antigen floating around in the body, right? Here's some antigen that then binds to this antigen binding site on this antibody, right? So it would bind to this variable region. So this is going to be, the perfect match for this immunoglobulin B cell receptor. So then that antigen can get internalized into this B cell. And then what that B cell can do is it can take its MHC2 receptor. Okay, this is my MHC2. Okay, so this B cell also has these MHC2 receptors, so it can internalize that antigen, and it can take that antigen, right, and then it can present it on the MHC2, and then it can take this antigen to a T cell. So once these B cells bind to this T cell, for example, right, then we'd get a proliferation signal, and they would go to the lymphoid follicles, and we talked about this. Primarily go to areas that are very active. Secondary follicles, you'd have germinal centers that are forming, where you'd have a lot of B cells that would be undergoing affinity maturation, isotype switching, and I'll talk about that also in the next video. And finally, activated B cells can become plasma cells. Even activated B cells that don't involve T cell interaction can do this, and they can produce and secrete antibodies, which again, I'll also talk about in the next video. But I think this at least gives you a high-level overview of what we're talking about in terms of B cells. And like I said, next video we'll go into more of the details. Here are the references for this video, and we'll see you in the next one. All right, so we finally have an opportunity to integrate kind of all of the concepts that we've been talking about thus far, and that's when we get into this B cell activation, particularly the T helper dependent B cell activation. But before we do that, let's just take a step back here. So remember, when we're thinking of B cells, we're thinking a lot about humoral immunity. We're kind of looking at the end goal here of essentially generating antibodies and potentially a memory response, right? And so at the end of the day, when I'm thinking humoral immunity, I'm thinking of the end goal here is going to be producing antibodies, right? That's going to be immunoglobulins, and particularly IgG in the setting of some memory response, okay? And the whole point of, immunoglobulins and antibodies, if you think about them, what are they doing? They're floating around usually freely in the bloodstream, right? And they're eventually going to attack or bind to extracellular pathogens. Okay, so that's going to be the key to humoral immunity. We're going to be very effective at targeting extracellular pathogens because we have all these antibodies floating around in the bloodstream. It's not going to be as effective against intracellular pathogens. Intracellular pathogens, I'd want something like cell-mediated immunity, where I can identify viruses or intracellular bacteria using T cells specifically, whereas with humoral immunity in general, this is going to be more effective against extracellular pathogens. Okay, so that's the concept here. So let's just erase this for a second, and let's kind of talk about what we know so far so we can put this all together. So we're going to recap what we talked about in the T cell video, and we're going to go through it a little bit faster because we already talked about it with T cells. But essentially what we're talking about here is, right, we had some bacteria, for example. Okay, so we had some bacteria or some pathogen potentially, and then we had a dendritic cell around. Okay, so then we had some dendritic cells. So I'm just going to kind of draw it like this. This is my dendritic cell, and this dendritic cell phagocytosed this bacteria, okay? And then essentially presented components of that bacteria to a T cell, right? And so it's going to present these antigens. Usually, because it's an antigen presenting cell, it will present them on MHC2. Presents this antigen from the bacteria on MHC2, and it's going to present that to a T cell. Okay, so then let's just say we have some T cell here, right? So we have some T cell, and so here's my T cell, and this is going to be usually a naive T cell. It hasn't yet kind of ran into its pathogen, and on this T cell is going to have a receptor that's going to bind to that MHC2, and you might know that receptor by now. That receptor is going to be the T cell receptor, and it's going to co-bind with CD4. Right, so the T cell receptor, CD4, is going to bind to this MHC2, and this antigen is presented, and then there's going to be a co-stimulatory signal that we talked about in the T cell video, right? There's going to be a co-stimulatory signal, and that's going to be this CD28 binding to B7, okay? And this B7 is also sometimes written as CD8086. Okay, so this is all stuff that we talked about in the T cell video, and it's all recapped right here. We had a bacteria digested by an antigen-presenting cell, presented that on MHC2, usually in a draining lymph node, to a T cell receptor, CD4 positive co-stimulatory signal. Remember your rule of 8s, 4 times 2 is 8. That's how you know this is CD4. And again, it's an antigen-presenting cell, which usually was going to be MHC2. And then you have a co-stimulatory signal that helps this activation of the T cell occur, and that's going to be B7 and CD28. Remember, 7 times 4 is 28, right? So that's how we remember that. So that's essentially the T cell process. Once this happens, now this T cell can say, okay, is this thing you digested more of an intracellular bacteria like tuberculosis, where I'm going to release interleukin 12 and then cause a T helper 1 response? Or is this more of an extracellular bacteria that I want to generate more of a T helper 2 response? For example, if this was an extracellular bacteria, which is primarily what we're talking about with humoral immunity, right? That's what we just said. In that situation, we would want to generate a T helper 2 response. So if I want to generate a T helper 2 response from the previous videos, what do I want to release here? Well, remember, T helper 1 response would be interleukin 12. T helper 2 response would be interleukin 4. So this antigen presenting cell might say, hey, we need that humoral immunity, right? Because this is extracellular. I'm going to target this T cell with interleukin 4. Interleukin 4 will cause this T cell to go down the T helper 2 route. Okay, we'll go down the T helper 2 route, and we'll talk about the significance of that in just a second. So that's where we're at. Now, before we go any further, if this is kind of too sloppy for you, I have it all written here too. So you can see the antigen presenting cell presenting MHC2 to T cell receptor CD4, and then you can see CD8086, which is also known as B7, right? So this is also, let me write this in here, this is also B7, binding to CD28, releasing cytokines, right? If it's interleukin 12, then it would stimulate the T helper 1 response. If it was interleukin 4, this would stimulate the T helper 2 response, right? So this is all the things that we just kind of talked about already. And that's where we're at. So we're activating a T cell. Now, the B cell, like I said, can also do the same things as an antigen presenting cell in the sense that it can also interact with bacteria and then present them on these immunoglobulin receptors. And that's essentially what you see here. So let's just say that we have a B cell here, and maybe there's some extracellular bacteria here. So this B cell might come into contact with this bacteria or potentially this bacterial antigen, and maybe it's a perfect fit for its B cell receptor up here. Okay, so I'm just going to draw it up here on the B cell receptor. Then what the B cell can do is it can internalize this antigen or bacteria and then represent it on MHC2, just like the antigen presenting cell did. So I'm going to draw an MHC2 here, and so we can put it on, let's just say this is our MHC2 receptor. Okay, so the B cell can place it now on this MHC2 receptor. Remember what we said, what's an MHC2 receptor? Essentially, it's allowing communication with T cells. Okay, so once this B cell binds to that antigen using its antibody, internalizes it, and then represents it on MHC2, now it can go to this step where the B cell can bind using that MHC2 receptor to a T cell. Okay, and that T cell can use its co-stimulatory signal. Again, it's going to be CD4 because we're talking MHC2, and that can help activate this B cell via a T helper dependent response. That's where this T helper dependent comes in. You have a T cell that is interacting with the B cell in order to stimulate the B cell to then go on to have B cell proliferation and eventually the formation of antibody secreting plasma cells. Remember, the end step of humoral immunity is essentially producing antibodies, and this T helper response is assisting with that. It's kind of giving it a huge upgrade in terms of giving the B cell the signals to proliferate, to undergo affinity maturation and isotype switching. Okay, so that's what's happening. This is very similar to what we saw with the antigen presenting cell. It's just when it happens with a B cell, it can then go on to form a humoral response. That's the difference. Okay, so that's essentially what's happening. Now, there's a couple kind of nuances to this that I haven't told you yet. So sometimes when you digest these antigens, these B cells, instead of them directly going to bind to T cells, sometimes these B cells can actually just become plasma cells themselves. Okay, so sometimes this B cell can just become a plasma cell instead of even going to the T cell. Now you might be saying, well, why doesn't it just do that? Why would I go through all of these steps to make a plasma cell when this B cell can essentially just do it on its own? What's the point of that? Well, when the B cell becomes a plasma cell strictly because it bound to its antigen and never interacted with a T cell, in those situations, that's a T helper independent response. In other words, the B cell never really interacted with a T cell. It's completely independent. The B cell is on its own. Okay, it didn't need the T helper cell to get activated. Now, the downside to that is typically when this happens, response that's generated is much weaker. Okay, it's much more weakly immunogenic, and that's sometimes how it's said. Now, to organize your thoughts here, you want to think about this in terms of proteins or peptides, right? Proteins, peptides, or you want to think of non-proteins or non-peptides. So things that are like carbohydrates, for example, like lipopolysaccharide, for example, would be a non-peptide. Lipopolysaccharide, LPS, on gram-negative bacteria, it's a polysaccharide. It's a carbohydrate. It's a non-peptide. Things that are non-peptides are not going to be able to be presented to T cells. T cells will only recognize peptide antigens. In other words, they'll only recognize protein-based antigens or peptide-based antigens. Okay, so if something's non-peptide and it's a conserved sequence, right? Something like LPS, something like flagellin. And we already talked about these conserved sequences. We gave them another name before though. Okay, when we first started this video series, we said the name for these are pathogen-associated molecular patterns, right? Or PAMPs. And these are what are recognized by toll-like receptors or pattern recognition receptors, right, to stimulate that initial immune response that goes on to generate interleukin 1, interleukin 6, TNF alpha, right? So these are these same structures. And so you might be saying, okay, well, they set off the immune response. Why do we have to have this T-independent response? The reason is because the T-independent response is what allows us to generate antibodies, like IgM, for example. These plasma cells that are activated independent of T cells because there was a carbohydrate antigen, for example, bound here, they will go on to release IgM, which is kind of like your standard immunoglobulin. Now, it's important to note that IgM is not really involved in the memory response. It's kind of like the initial response to an infection from the immune cells, right? You have your inflammatory response from neutrophils, which is largely driven by pattern recognition receptors and toll-like receptors recognizing LPS and flagellin. The immunological response, right, from B cells is driven largely by this T helper independent response where B cells can bind to LPS, can bind to carbohydrates, right? But instead of going to the T cells, they just become plasma cells and release IgM. What I'm saying here is this is more or less driven by the T helper independent response. That's why it's all in orange here. Whereas if you go up this way, right? If you go up this way, this is more so the T helper dependent response. And a lot of this is driven by the type of antigen. Is it non-peptide like flagellin or LPS? Our pathogen-associated molecular patterns are very classically going to fit into this category, things that are non-peptide based, and not all of them necessarily fit into that category, but that's one way to think about it. Or is it going to be a peptide antigen? If it's a peptide antigen, it's most likely going to go down this route. Now, some peptide antigens will also kind of just generate an IgM response. Okay, but more or less the way that you want to think about it is the way that we have it kind of listed here. Now let's just clean this up for a second. And so with the T helper independent response, right, these specific carbohydrates cause cross-linking of the surface antibodies. That's how this B cell will get activated by non-peptide antigens, and that will lead to production of IgM, which is what we just said. The T helper dependent response involves T cell activation via an antigen presenting cell. That naive B cell is going to bind its antigen to the B cell receptor. That's what we just said here. So antigen binds to the B cell receptor. That's this step. Then the B cell receptor has mediated endocytosis of the antigen. That's this step, right? It internalizes that antigen. Then the next step would be to display that antigen on the MHC2 receptor, which we can see here. So we found the antigen bound to our immunoglobulin, we internalized it, and then we presented an MHC2, and there you can see it right there, bound to MHC2, binding to a CD4 receptor, right? Activated T helper cell binds to that B cell using a T cell receptor and CD4 positive co-receptor. And then the last step here, there's another co-stimulatory signal. And this signal, CD40 ligand co-signal, essentially involves CD40 ligand on the T helper cell and CD40 on the B cell. And this specific step is involved in isotype switching. And that's very high yield to remember that CD40 ligand, CD40 binding, and this is one of them that I would absolutely remember, is involved in isotype switching. So it essentially will cause this antibody to change its heavy chain. Okay, so remember, you have a variable region out here that binds to a very specific antigen, and then you also have another region down here that's the heavy chain. So the heavy chain will tell you, are you dealing with IgE, IgA, IgM, but the actual variable chain is what binds to that specific component of a pathogen. Now, once this B cell goes through this whole process, presents on MHC2 to the T cell, and CD40 ligand interaction occurs, you're going to have specific interleukins that can be released. Okay, and we already talked about this a little bit when we talked about the cytokines. These different interleukins can cause different types of responses. So for example, if this T helper cell releases interleukin 4, that will stimulate mostly IgE, but also some IgG response. Interleukin 5 is going to be IgA. Interleukin 13 is also IgE. So just make sure you're familiar with these, particularly interleukin 4 and interleukin 5, probably being the two big ones I would remember. Once that happens, those B cells can then go on to proliferate. Okay, so the B cells will become activated, they'll proliferate, and then they can eventually become plasma cells, which are essentially going to be antibody factories. And if they, were stimulated with interleukin 4, they might be pumping out a bunch of IgE or a bunch of IgG, for example. Some of these B cells, through this proliferation, will eventually become memory cells, so that if we ever interact with that antigen again, we'll have a much more robust response in the future. Okay, so that's where the memory response comes from. Now note, in the T helper independent response, right, when we went down this road over here towards this IgM, we never generated memory B cells. We only generated plasma cells. Okay, so that's why there's not a really strong memory response when I have T helper independent antigens. Okay, I need T helper dependent antigens to generate a very robust memory response. This is where it all comes from, is from this pathway. Now, the last thing on here is this affinity maturation. So what is that talking about? So affinity maturation is essentially talking about the B cells that have these kind of variable regions up here that bind to specific antigens. What we want to do is we want to make that binding as strong as possible. And so once this interaction occurs with the T cell and the B cell, at some point these B cells will eventually migrate to a lymph node and, like we said, go into the secondary follicles, and you'll have your germinal centers that are going to have proliferating B cells in there. Inside of those proliferating B cells, there's going to be very slight variations that are going to happen to this variable region. And the idea is we know that there's some antigen that is able to bind to that B cell receptor. But what we want to do is we want to maximize that binding. So we kind of know we have the right formula. We just want to make little tweaks to it, and we make these little tweaks to a whole bunch of different B cells. And then the B cells that bind the strongest, right, from those tweaks are going to stick around. And so there's random mutations of the B cell receptors so that only the strongest affinity B cells survive. And again, this is all happening in the lymph node, in those germinal centers that we talked about in the last few videos. And again, here's a lymph node, right? It's going to be more of those pale staining regions in the lymph node where you have the germinal centers. And again, we're just trying to keep the strongest binders in there. And essentially that's what affinity maturation is. Again, we know we have something that binds, we're just tweaking it to get the absolute strongest binding. And again, you get affinity maturation largely driven by T helper dependent responses. So both affinity maturation and isotype switching are a result of a T helper dependent response and not a result of a T helper independent response. That's particularly important. So again, we got isotype switching because of the T helper interaction. We also get affinity maturation because of the T helper cell interaction with the B cell. If I don't have this interaction, if I just go this way, I'm just generating IgM kind of blindly here against that antigen without developing a robust immunogenic response. That's the key, so just keep that in mind. And you might be saying, well, is this applicable at all in real life? And it absolutely is. I mean, if you think about things like vaccines, for example, right? So and we'll talk about this when we talk about vaccines here, but your strep pneumo vaccine, right? There's different variants of it. The PPSV23 variant is going to have a capsular polysaccharide. So the PPSV23 vaccine for strep pneumo is going to have a capsular polysaccharide. And this is what generates the immune response. Okay, so it's going to be the polysaccharide capsule. Remember what we're talking about. It says it right there. Polysaccharide. What's a polysaccharide? It's carbohydrate, right? Go back to your biochem. So this is going to be a carbohydrate. A carbohydrate, is that a peptide? No, it's not a peptide. And if it's not a peptide, then it must be a T helper independent antigen. Okay, so if I give somebody this vaccine, I'm giving them a T helper independent antigen, right? It's an independent antigen. So I know that I'm not going to get this interaction with the T cell. I'm going to go down this road. So do you think I'm going to get a strong immunogenic response if I give somebody a vaccine that has a T helper independent antigen or a polysaccharide? Probably not. I'm not going to get a really robust immune response. That's why we add things like adjuvants to these vaccines, for example, or that's why a peptide vaccine in some situations might be stronger. And in a lot of these situations too, if you're giving these independent antigens, you'll see there's in some situations there might be more boosters involved potentially. But I don't want to get too off track. That's the general concept. And if you got to this point in the video series, kind of building up the material, adding up the layers, this is kind of like the peak. And from this point forward, we can start integrating all of these basic science concepts to understand the pathology and some of the implications. Take 15 seconds to pause the video, read the question, and then we will go through the answer. All right, so we have a 32-year-old male with a past medical history of microscopic polyangiitis and end-stage renal disease. Okay, kind of an interesting start to the question. We're just going to kind of note this here. End-stage renal disease, which means this patient could be on dialysis, for example, presents to the emergency department with a fever of 102.4. Okay, so our patient is febrile here. They have abdominal pain, general malaise over the past 6 hours. The patient states that he is on home peritoneal dialysis. So, there's different forms of dialysis, right? So there's hemodialysis, there's peritoneal dialysis. The fact of the matter is, for step 1 examination, you really don't have to know a lot about this, until maybe you do your first nephrology rotation or something like that. This does make the abdominal pain more interesting to me, the fact that they're on home peritoneal dialysis. So I'm kind of, as I'm reading this, I'm kind of slowly in my mind juggling some of these concepts. The patient recently had his catheter replaced 5 days earlier without complication. Okay, so that's a good sign. So it was recently replaced. Tenderness is noted over the abdomen at the peritoneal catheter insertion site, though. Okay. The patient states that his recently adopted dog playfully bit the insertion site of the dialysis tubing, causing a small puncture in the material just prior to symptom onset. There is something going on here at the peritoneal catheter site, and this dog essentially bit the insertion site of the dialysis tubing, right? So you're kind of thinking in your mind, what are some things that you want to associate potentially with a dog or a cat, or, one of the things, certainly I can just read ahead here, Pasteurella, right, would be very classic. Rabies is usually not asked about as much in dogs as frequently anymore. Usually if it's like a rabies question, it's usually going to be a different animal, not like the classic cat or dog in most questions, but it could be, it's still possible. It's something you're going to keep in your mind here. If this patient, had salivation and, hallucinating and things of that nature, we might be thinking more along those lines, but we don't really see that here. So we just see tenderness along the insertion site of the catheter. Relevant laboratory studies are shown below. IV antibiotics are initiated and blood cultures later grow Pasteurella. So Pasteurella in general, when you're thinking about this, you think about cat bites, dog bites, not as much scratches. Cat scratches, right? If you're thinking cat scratch disease, you might be thinking more Bartonella. But Pasteurella, usually thinking cat or dog bites. And remember, Pasteurella is a gram-negative bacteria. Because remember, this is how the question starts, and then they usually go on to ask like a specific fact about that bacteria. So you want to make sure you're kind of sharp on the general stuff here. But that's the big stuff. I mean, if you really want to add something to this, you can say, okay, well, it's also catalase positive, right? Maybe if you had a question on, I don't know, chronic granulomatous disease or something along those lines. You just want to kind of be familiar with that too. But again, these are the big things here. Okay, let's look at these lab values. Hemoglobin 11.1. Now, that might seem low, but to me, this is not super alarming. And the reason I say that it's not super alarming is because I know this patient is on dialysis. A lot of times, dialysis patients in general can have a lower hemoglobin, right? Patients on hemodialysis, they're usually aiming for a hemoglobin between like 11 and 12. Now, are you expected to know that for step 1? No, you're not expected to know that. It's just like a little clinical pearl here. This is not a completely alarming hemoglobin. Again, remember erythropoietin, right? Erythropoietin comes from the kidneys, right? EPO comes from the kidneys. And so patients that have end-stage renal disease, right? These patients might be on erythropoietin, for example, or some analog. But again, we're not going to get too off track. Not going to let this bog us down. Again, a lot of these questions have a lot of superfluous information. We want to just get to the point. What are they going to ask us? Just for the sake of this, I'm walking through kind of all of these steps with you. So leukocyte count. For people that, aren't super familiar with reference ranges, right, you might look at this and say, oh, it's not too bad. But actually 3,200 is kind of low, right? Especially like the reference ranges that you're going to see on most tests will be something like 4,500 to 11,000, right? They're usually going to be kind of around here. Now, a lot of people usually when, you see a leukocyte count of like, 20 20,000 or something, right? You start to think, oh yeah, there's probably an infection or at least some form of, inflammatory response, or there's something going on there, right? Is the patient on steroids? But we got to remember, a low leukocyte count, so like something like we see here, this 3,200, that can also be concerning for an infection, right? It's not just a leukocytosis that's necessarily associated with infections, it's also a leukopenia, right? So you have to also kind of keep that in mind, right? A low leukocyte count is not necessarily normal either. Immunoglobulin M is quite elevated outside of the reference range here. Immunoglobulin A is kind of just on the border of the reference range here, so then yellow. Immunoglobulin G, again, in the reference range, which makes some sense because, again, if we go back to the timeline here, this happened over the past 6 hours, so we might be getting kind of an initial response from the IgM, right? More of the innate response before we develop a memory response. Okay, B cells producing high quantities of immunoglobulin M in this patient are most likely responding to which antigen? Okay, all right, so the answer here is lipopolysaccharides. Let's just talk kind of a little bit about this. First of all, the thing that we have to understand here is we kind of have to go back to the basics, right? So what exactly is happening here, right? So we have some bacteria, right? We have this gram-negative bacteria. Okay, so this is going to be by Pastorella, right? The Pastorella is probably coming in through the catheter tubing because the dog, the clue here is that the dog bit the insertion site of the dialysis tubing, and now this patient, since that time, is febrile, has abdominal pain, tenderness, right? We might be concerned even of some component of peritonitis. But the point being in this question is they're asking us about the IgM levels. So here's my Pastorella. So the Pastorella is in this patient's bloodstream. And so initially, right, the first thing that's going to happen is, remember, because Pastorella is gram-negative, right, it's going to have LPS, right, in its bacterial wall. And we know that when LPS gets out here in the bloodstream or is identified, this LPS acts as a pathogen-associated molecular pattern, right? We've talked about this a few times. And it can be non-specifically recognized by some of our cells. Now remember, in the B cell lecture, if you've watched that video, right, in the B cell lecture we talk about the B cells, right? This might be a naive B cell that runs into this LPS. And it might identify this LPS as a T helper independent antigen. In other words, this antigen is not a protein antigen, right? It's in this situation, this could be more of a non-specific binding potentially that causes this naive B cell to realize, hey, this is not normal, right? This is going to then cause this B cell to potentially become activated. Now, these B cells, instead of undergoing class switching by binding to a T cell and having CD40 and CD40 ligand come together, this B cell can just go on to become a plasma cell factory, essentially producing IgM. Now, remember, this happens because this is a T helper independent antigen. Let's say, on the other hand, that this Pastorella infection has some specific antigen on it, right? So Pastorella maybe has a specific antigen. And now I have a B cell that comes along, right? So this B cell, again, is another naive B cell, but this B cell has a very specific receptor for this antigen. Okay, so the B cell can bind to this antigen. And again, this antigen that we're talking about here is usually going to be a protein antigen. Now, one way that this can happen is this B cell can actually phagocytose Pastorella to then digest it to get this protein antigen. So that's one way that this can happen, right? This B cell can represent this to a CD4 positive T cell. And we can also get our CD40 ligand binding to occur, right? Which would then stimulate class switching of this B cell. So this B cell can then effectively go on to produce, right, specific antibodies, right, after its class switch. So then it can go on to become a plasma cell. But in this case, the plasma cell, depending on, what cytokines are released and what antibodies we need to respond to this infection, the plasma cell can then go on to produce IgG, IgA, IgE, right, because we had this T helper dependent response. And that was because we had a protein antigen. Okay, now, in general, to generate a T helper response, right, to have isotype switching occurring, somatic hypermutation, all of these things that we talk about, it's difficult for this to happen, in a short time period usually. So usually you're going to get an initial IgM response before that happens, right? Especially the first time you're exposed to this pathogen. And that's evident if we look at these labs, right? We can see that there's an isolated immunoglobulin M elevation compared to some of the other immunoglobulins. So it's most likely that it was more of a non-specific reaction with a pathogen-associated molecular pattern than it would be with a specific protein antigen. And for those reasons, it's more unlikely that it would be a peptide in general, right? Because a peptide is a protein antigen. Protein antigens are more likely to have a T helper dependent response, more specific response. Now, I'll talk about these three options in a second, but let's just talk about why it's not lipoteichoic acid. Because again, lipoteichoic acid, much like LPS, is a pathogen-associated molecular pattern. What's the big difference here? Well, remember that lipoteichoic acid, all right, LTS here, lipoteichoic acid is also a pathogen-associated molecular pattern, but this is specifically in gram-positive bacteria, right? Whereas lipopolysaccharide we know is in gram-negative. So you kind of have to understand here that Pastorella is not a gram-positive bacteria, which is, again, why you still have to know some of the attributes of these different bacteria in these questions, right? Because this is how they integrate this information. Okay, so for that reason, it would be less likely that lipoteichoic acid, right, highly unlikely, that lipoteichoic acid is where we're getting this IgM response from in the setting of a Pastorella infection. Now, going through these other options here, exogenous bacterial peptides. Remember, exogenous bacterial peptides typically are going to come from digested bacteria, much like we just talked about here, right? This B cell can essentially phagocytose this Pastorella bacteria and then present as antigens, right? But going through this process, right, after phagocytosing it and presenting a protein antigen, a peptide, right, we're going to end up with a T helper dependent response. We would expect some elevation in these other immunoglobulins, and we quite frankly don't see that here, right? We have still these immunoglobulins in the normal reference range. Endogenous bacterial peptides, we're usually talking about things like viruses, some fungi, for example, some intracellular bacteria. We really don't see anything here suggestive of that again, and the isolated IgM elevation, again, would be more suggestive of a T helper independent response versus a T helper dependent response. Finally here, host peptides. Sometimes you can see this, if a patient has like an autoimmune reaction or something like that, they might start presenting their own host tissue to their lymphocytes. This is basically why we go through this kind of arduous process in the thymus, right, of selection in general to avoid things like this happening. But again, this isn't particularly relevant to the fact that this patient appears to have an infection of sorts that isn't necessarily consistent with an autoimmune reaction or a peptide antigen in general. So lipopolysaccharide here is the best answer. Hey everybody, Dr. Roviso here. In this video, we're going to talk about antibodies. And I feel like this is a pretty good graduation from the B cell lecture where we talked about plasma cells that are going to go on to produce these antibodies. So we'll start by talking about just some basics about the antibody structure, some specific regions that you want to be familiar with. We'll talk a little bit about the properties of antibodies, which a lot of this we already kind of touched on, but we'll go into slightly more detail here. And then we'll talk about the different immunoglobulin isotypes that we touched on when we talked about class switching. So the first thing here, when we're talking about antibody structure, really you can organize this pretty simply into two regions. So you have the FC region, and the FC region, as you can see down here, this is going to be kind of the constant region. So that's what the C is. It's standing for fragment constant region. Okay, so the fragments are going to be all of these kind of little squares you see here. And sometimes these squares will get named. You might call this, region 1 and region 2 and region 3, but even when you get to that level of detail, you start to get beyond this step 1. So we just call these regions constant regions. And so again, what we highlighted here in orange is going to represent the heavy chain. Okay, so we have the heavy chain, and then we'll also have a light chain. Okay, and the light chain, you can see, I just remember the light chain, it's lighter. It's not as big as the heavy chain. So the light chain is this area that I'm kind of highlighting in teal here. Okay, so we have our heavy chain, we have our light chain, and then in the middle, you can see that occasionally we'll have these disulfide bonds that are going to link these two portions of the antibody together. And so we already said the FC region is kind of like the constant region. Okay, this is kind of like the constant region. That's what that C is standing for. And then the AB here stands for antigen binding. Okay, so this is the antigen binding region, which actually makes a lot of sense. So if you understand some of these terms, you can kind of understand what's going on here. Let's just say, theoretically, we run into some bacteria. Okay, so I'm just going to draw some bacteria here. Okay, so here's some bacteria. And on this bacteria might have an antigen. And it might just so happen that this antigen binds to this portion of the antibody here in the FAB region. And so that's kind of where this name comes from, because the antigen binding will occur in this region. Okay, so the antigen might bind here. And again, there's going to be a very specific antigen that's going to bind to this FAB region, particularly the kind of distal end here of this region. And that's why this is sometimes also called the variable region. Okay, so let's recap some of this just to clean things up. So, there's a few different ways you can categorize this antibody. The first kind of way is we have a heavy chain, which is in the middle here. So this whole thing is your heavy chain. And then we also have a light chain, which is on the outside here. Okay, now the heavy chain you'll see is denoted with this H next to each of these letters here. So you can see there's an H, there's an H, there's an H, and there's different H's, right? This is going to be 1, this is H2, this is H3, right? So there's different ones, but all of these are representative of the heavy chain because it's in the middle. Remember, this is the heavy chain, that's why it gets the H. And then again, the light chain is denoted with the subletter L, right? Because that's the light chain. And then this letter here, there's a V and a C. So the C, again, stands for the constant region, okay? So the C is kind of the constant region, meaning it's going to be consistent more or less throughout similar forms of this antibody, which we'll get to. But there's also a region on the end here that has a V, and so the V stands for the variable region, okay? So the variable region is highlighted here in pink, and again, the variable region is going to be different for different antibodies, and these variable regions will have specific antigens that they can bind to, different shapes, different sizes, right, that these different antibodies can bind to. And the last thing that we talked about is you can split this up into a constant fragment, which is more or less going to be down in this region, and then an antigen binding segment, which is mostly going to be up here. Sometimes you'll see the term epitope used, and this is really just referring to the specific part of the antigen that that variable region on the antibody is going to be binding to. So you might say that, you know, this antibody is binding to its epitope, right, or the epitope on this antigen, that specific region that it can kind of match up geometrically to kind of fit into that space molecularly, okay? So that's what we're talking about when we say, you know, that it's binding to its epitope. So the FC region, again, the FC region down here is basically going to consist of our heavy chains, right? So we have some of our heavy chains in the constant region, and this is going to determine the isotype of this antibody. In other words, when we say isotype, we're talking about things like IgM, IgA, IgE, right? All of these different immunoglobulins. So again, isotypes, you know, you have your IgM, IgG, IgE, these are all different isotypes of the antibody. This region doesn't determine what epitope the antibody can bind to, right? That's for the antigen binding region. In the constant region, we're just determining the isotype. So what type of antibody is it? And in this region, we also have the C terminus. And so some people remember this by saying, hey, there's the constant region here, constant is C, and there's also a C terminus. And there's also, since we're talking about C, site of complement binding. IgM and IgG will use this region in particular for binding complement and then activating complement. So if we go back to the scenario where we have some bacteria here, right? So we just have some bacteria here, okay, that's floating around in the blood, and then potentially this bacteria might have an antigen on its surface, or a couple different types of antigens on its surface. Okay, and then what we might have happen is we might have, let's just say we have an antibody kind of floating around here, and it binds to one of those antigens, okay, and again, it's going to bind using the Fab region, and then we have our constant region down here, okay, so that's essentially what's happening. Now, once that binds, we can then activate the complement cascade, right? So we can activate the complement cascade, so we can get complement to activate its cascade and eventually lead to a membrane attack complex punching holes through that bacterial cell membrane. Okay, so that's what we're talking about with complement binding. And again, this happens with IgM and IgG. Specifically, the complement will get activated by this portion here, the CH2 constant region. So that is the portion where we will have complement binding. Okay, so I'm just going to write that in here. So complement will bind to that region on the FC portion like we shown here, and that's going to activate the complement cascade to then lead to the membrane attack complex coming in here and punching some holes in this bacteria. Now, the other route we can go here is opsonization, right? So it's kind of a similar concept. So again, if we take our antibody, so again, let's take our antibody binding here. And again, this is going to be the Fab portion. And then we have our FC fragment back here. And again, it's the same concept. If I have, you know, some phagocytic cell around here, so let's just say that I have, I don't know, let's just say that I have like a neutrophil or some phagocytic cell here. This cell can kind of get roped in to binding to this FC portion. Okay, so it's going to have a receptor here that can bind to this FC portion, and that FC portion will essentially stimulate this phagocytic cell to then undergo phagocytosis and digest this bacteria. Okay, again, binding to the FC portion, and so that's actually going to happen here at this third heavy fragment. This is where we're going to stimulate phagocytosis through opsonization. I'll just put that down here, opsonization. So the idea is if we can mark these bacteria with antibodies, we can have a few things happen. We can stimulate complement binding, we can stimulate opsonization, which will lead to phagocytosis of that bacteria. If we have enough antibodies around, we can essentially neutralize this bacteria or virus, right? We can bind to a lot of these antigen binding sites and prevent this bacteria from going on to reproduce or to infect different cells, whatever this pathogen is. By binding to multiple antigens here, we can essentially neutralize this pathogen. Okay, so the three things we can do: complement activation, opsonization, those are the big two, but we can also neutralize this bacteria by just basically flooding it with antibodies. So that's the tricky part. So in the FC region, we have a couple things going on. Complement activation, opsonization are going to happen at this heavy chain region. The variable region is what's binding the epitope. Remember, that's what's binding the epitope, binds antigens via the epitope, and this variable region will determine the idiotype. So the idiotype is referring to what this antibody can specifically bind to, what specific structure, specific epitope can it bind to, and with what strength can it bind to that epitope. So there's usually going to be a very unique antigen binding pocket, and that's referring to this idiotype. And this idiotype is going to be formed through things like VDJ recombination, which we'll talk about in the next slide. And just to put a plug in here, again, going back to opsonization, remember, what are the two big things that are going to kind of lead to opsonization? So this is particularly high yield. Remember, it's going to be IgG and C3b. Okay, so when you're thinking opsonization, right, when you're thinking phagocytosis, think of the constant heavy region 3, right, this region closest to the C terminus on IgG, and then also keep in mind that complement is going to be, again, like we said, at the CH2 region here. Okay, so now that we've talked about some of the structure of antibodies, let's focus in on some of the properties of antibodies. And really, we're just focused here on the high yield information. So looking back at our antibody structure here, we can see, again, we have our variable region that's going to be up here in the pink color. And then we also have this constant region that's down here in the blue color, as we just talked about. And this is functionally how we want to kind of think about dividing the structure. And again, this variable region, it's going to contain the area that we'll call the idiotype. Okay, so the idiotype is going to refer specifically to the binding of this antibody receptor to some epitope, right? So that's some region on our antigen. So the idiotype being this structure here. And again, the constant region representing the area where we have our isotype. The isotype representing what type of antibody do we have? Is it going to be an IgM antibody, an IgG antibody, etc.? Okay, so we have the idiotype up here, the isotype down here, again, the FC region, and then we have the FAB, the antigen binding region up here. Now remember that this can also be divided based on the types of chains that we have. So we have a heavy chain, right? So the heavy chain is going to be this chain right here down in the middle, and then we also have a light chain, okay? So the light chain is going to be this one that's on the outside, only in the antigen binding region, the FAB region, right? So that's how we separate this. And again, the thing that you want to remember is that there's different genes when we're talking about our gene transcripts that kind of get shuffled around randomly to create a whole bunch of different idiotypes so that we can bind to all types of antigens. Okay, and those shuffling of genes is sometimes referring to specific segments here, VDJ recombination. And you can see that this D is in parentheses. The reason for that is because the heavy chain segments use the VD and J shuffling, whereas the light chain segments primarily are going to use the V and J shuffling. So this is just a little thing just to be familiar with. Again, it's these little details that sometimes come up. But the thing that I want you to kind of take away from this is that this whole process of VDJ recombination, if you think about it, right, you have some B cell, and inside of this B cell is going to have these genes with the V segment, with the D segment, with the J segment. It's going to have those genes inside of the nucleus, and it's going to shuffle those genes around until we get some unique immunoglobulin receptor, right? So we shuffle all of these genes around, and then we come out with this very unique idiotype on this B cell receptor. Remember, what is a B cell receptor? A B cell receptor is essentially a membrane-bound antibody, right? So it's like we created an antibody, like we see here, we just stuck it on the surface of a B cell. Specifically, IgG and IgM are going to be kind of notorious for being on these membrane-bound surfaces for B cells. You can also see this with IgD a little bit, as we'll talk about. But the point is this VDJ recombination is going to happen in these B cells, but there was no antigen that stimulated this process. This process happened as B cells matured. When B cells were maturing, where are they maturing, by the way? They're maturing in the bone marrow, right? We talked about that. While these B cells are maturing in the bone marrow, they're shuffling these genes around, these V, D, and J genes in the heavy chain and the V and J genes in the light chain, and they're making unique idiotypes, right, that are going to go on the variable region in the fragment antibody portion that we just talked about right up here. Okay, so that's what this whole process is. Again, the big thing I want you to remember is that this is going to be antigen independent. Okay, so there was no antigen that stimulated this process. It's just going to happen as B cells mature. We're going to make a whole bunch of different receptors, right? That's the point. And that's why this is completely random. It's random recombination of these genes, but you got to remember, we're doing this amongst millions and billions and etc. B cells, right, on a mass scale. So we're going to get all different kinds of receptors, and ideally, certain receptors are going to favor the binding of future infections, right? So that's the concept. And this is all going to happen in the fragment antigen binding portion up here, which is where we're going to bind those cells, right? The constant region, we're not binding antigens in the constant region, right? The constant region we talked about in the last video, it's about complement binding, it's about opsonization, phagocytosis, etc. So that's the concept here. Now, when we go into this next category here, somatic hypermutation, affinity maturation, isotype switching. So these are things that we've also kind of already hit on a little bit if you've been following the series so far. And really, somatic hypermutation, essentially think of this as, once we've interacted with that antigen. So we go back to our B cell here. Once we've actually kind of found our antigen. So let's just say that we have some, we'll draw some pathogen here. Maybe it's a bacteria, right? So we have some pathogen here. And again, on the surface of this pathogen, we might have an antigen. So let's just say that there's some antigen here, okay, some antigen here. And then our B cell receptor might interact with that antigen. It might be the perfect fit, right? We might find our epitope here on this antigen that this B cell binds to, and it's a perfect match. And then what happens, right? These B cells can potentially get activated. Remember that B cell can then kind of internalize some of that antigen potentially, and then redisplay that antigen in MHC2 to then activate T cells if this was a T helper dependent response. If it was T helper independent, this B cell might just turn into a plasma cell potentially and release IgM. Okay, so these are all things that we talked about in the B and the T cell video. But again, this process, once we activate this B cell, these B cells, some of these activated B cells can go to lymph nodes, right? And they can go into those secondary follicles we talked about initially, those pale staining germinal centers, and they can proliferate. And so you get a whole bunch of B cells proliferating in the lymph node, in those germinal centers. And as they're proliferating, what these B cells are doing is they're essentially saying, look, I know this receptor binds to this antigen, but what if I just tweak it a little bit, right? Maybe I'll just add maybe an extra couple peptides here or amino acids here. Then let's see if it binds more tightly or more weakly. And essentially the B cells are doing this in the lymph node on a very large scale. So they're randomly mutating the known binding receptor and trying to see if we can get it to bind even stronger. And those receptors that do bind the strongest survive. And that's called affinity maturation. We're essentially maturing the affinity of the receptor. We're finding the receptor that binds the tightest. And how do we do that? Well, we do random variations, again, in the variable region. Same region, right? We're just making little tweaks to the variable region that we already know binds to the antigen. Now, that's different from VDJ recombination. VDJ recombination, we're just mixing up stuff. We don't know what we're doing. We're just shuffling genes everywhere, and we're just trying to make a diverse pool of B cells. With affinity maturation, we're looking for something that is already bound to its antigen. We just want to make that binding stronger. And for that reason, this is going to be antigen dependent. Okay, so this is going to depend on the antigen that binds to it. That's what's going to trigger this whole process. So somatic hypermutation, affinity maturation, here, let's kind of highlight these. These are going to be antigen dependent. Okay, isotype switching is as well, which I'll talk about in a minute. And then VDJ recombination, that's antigen independent. Now, why is isotype switching antigen dependent? Well, you can kind of put the pieces together based on what we've already talked about. So remember, the whole point of isotype switching is after this B cell gets activated, what is it going to do? Well, like we just said, it's going to internalize this antigen, right? So it's going to take that antigen, it's going to internalize it potentially, and then after it internalizes this antigen, it can display that antigen on MHC2 receptors, because remember, B cells are antigen presenting cells. So let's say that there's some MHC2 receptor here, okay, so the B cell can then display it, and this is really the same song and dance that we keep talking about. So this B cell then is just going to go to a T cell. What's that MHC2 receptor going to bind to? It's going to bind to a T cell receptor, CD4 co-receptor, right? 4 times 2 is 8, rule of 8s. So that B cell, that's an antigen presenting cell, then presents this to a T cell, then it becomes activated. And that T cell will also have this CD40 ligand that binds to CD40 on the B cell. Remember, this is particularly high yield, and we've talked about this a couple times. So that binding between the B and T cell is going to stimulate class switching. Okay, so we have kind of two receptors binding, MHC2 binding to the T cell receptor and the CD4 co-receptor, and then we have CD40 ligand binding also, like we talked about before. And if this is unfamiliar, go back, check out those previous videos on B and T cells. We'll go into this in greater detail, but essentially that binding is going to stimulate class switching. And then we're going to have certain cytokines that are released that'll stimulate different versions of class switching. If we want to make IgE antibodies, right, we might see interleukin 4 and interleukin 13 being released. If we want to make IgA antibodies, we might see interleukin 5. So again, we want to remember these specific cytokines as they're particularly high yield to note in this isotype switching. But going back to my original point, how come this is antigen dependent? Well, it took an antigen to start with to get this whole process going, right? We had to internalize this antigen, display it on MHC2 to eventually present it to a T cell to get isotype switching. So that's why both of these are antigen dependent. Again, VDJ recombination, antigen independent. Now, the big difference between these two is that somatic hypermutation, affinity maturation, we already said it's taking place at the variable region, right? It's taking place at the variable region. We're slightly changing this idiotype so that it gets the strongest binding to our antigen. Whereas with isotype switching, what we're doing is we're changing the constant region. So if I change the constant region, what can I change? I can change it from IgM to IgG to IgA to IgE by using these cytokines, right? So that makes sense that we'd be changing the constant region in isotype switching. Now, the last thing I want to talk about here is the primary response versus the secondary response. And this is actually pretty intuitive to kind of understand. So let's just say that this is time, and then let's just say that this is antibody concentration in the serum. Okay, I'll just put an S there for serum. So this is my antibody concentration in the blood or the serum, and then I have time here on the x-axis. I'm going to move it over so we can see it better. Okay, so this is time, and then we have antibody concentration in the serum. Now, let's just say that at some point here, we are infected with some antigen. Okay, so we'll just put a 1 here to signify that this is the first time that we've seen this antigen. Maybe it's a bacterial infection, okay? So let's just say that we have some bacterial infection. This is the first time we're seeing this antigen. So what will happen is initially we might have some stable level of IgM that spikes. Okay, so our IgM level, after realizing that we're infected with this antigen, again, we're going to have an inflammatory response, and some B cells will recognize this antigen for the first time and turn into plasma cells and increase the amount of IgM being released. Okay, so we'll get some IgM release here. So we might also get some IgG being released. And the IgG response we'll get after class switching is actually going to be much greater than that initial IgM response. Okay, it's going to take B cells a little bit of time to undergo affinity maturation, isotype switching, but eventually we're going to generate an even stronger response using the IgG, all from that first exposure. And now what will happen is, remember, after we have an initial exposure, there'll be memory B cells that are around for future events with this antigen. And let's say we get infected with that same antigen bacteria a second time. Okay, so the second time, what's going to happen to the IgM concentration? The IgM concentration is going to do pretty much the exactly same thing. Okay, it's not really going to change much, right? The peaks here are about the same. Okay, and the amount of time it takes for IgM to respond, it's pretty much all going to be same song and dance. IgM doesn't involve class switching. It's kind of like your standard antibody, right? Even the T helper independent responses will still release IgM, like we talked about in the B cell video. However, the difference here is that now we have some of those memory B cells that are around, and they've already undergone class switching, and they have very strong affinity maturation and high levels of IgG that can be produced. So what will happen is we'll get a slightly faster and much stronger response from IgG. So I'm just drawing a massive jump here in your IgG response. So we have an exponential increase in our IgG response this time. And that's because we have memory B cells that have already undergone this whole process, really, right, from some kind of T helper dependent response that are now generating, significantly more amounts of IgG. And specifically, that IgG is going to come mostly from plasma cells, right, from this memory response, okay? So again, the key is on that second exposure, you're not really seeing a huge change in IgM in terms of timing or the absolute concentration of it in the blood serum. However, on re-exposure, you can see there's a lot more IgG that can respond actually slightly faster even potentially. And this is where you see things like, if you want to see if this person was ever infected with a certain bacteria, you can try and draw their antibody to that bacteria. Or if you vaccinated somebody, you can see their titers, right? You can see how much IgG, how much of a response they generated when they were vaccinated. And so you can see if they're immunized by having a set level of IgG after re-exposure. All right, let's wrap up antibodies by talking about immunoglobulin isotypes. And here, the important thing to know is really the structure of some of these isotypes, and then when do we specifically see them in terms of their function. So let's start off with IgM, which is kind of like our base immunoglobulin, right? Because with IgM, if we have a T helper independent response, or this is a first response, usually it's IgM that we're going to see initially. Now, IgM can be a pentamer or a monomer. Now, classically, it's thought of mostly as a pentamer, and you can see an example of that down here. So you can see this IgM molecule, and you can see that there's all of these different binding sites here on this IgM molecule. So you can think of these as like individual kind of antibodies based on the antibody structure that we talked about before, and you can see that they're all linked to this structure in the middle here, and this link is the J chain. Okay, so that's going to be this linkage kind of in here, call that the J chain. Okay, so they're linked by this J chain or J protein, and again, if you look at how many antibody binding sites there are on one of these pentamers, you can see that there's 2 for each antibody, which is pretty much the case across the board. Every one of these antibodies is going to have 2 antigen binding sites, which means that a pentamer of IgM is going to have 10 binding sites, right? So it's going to have 10 binding sites for antigens. Now, the reason that's significant, if you think about some of your antibodies that are monomers, right? So, let's just say that you had an IgG antibody that already underwent affinity maturation for some antigen, and it's really strong binding, right? We've already had a response to generate this IgG antibody. And so we can say that this IgG antibody in particular might have a higher or stronger affinity for an antigen. Maybe it already had a T helper dependent response where we had a B cell that went to the lymph node and then underwent affinity maturation. And that B cell is now a plasma cell producing IgG to our antigen. And now we can say, okay, well, maybe this IgG antigen then has a higher affinity than that same IgM antibody, right? An IgM antibody with the same idiotype as this IgG might have a lower affinity. Okay, and this might vary in real life, but again, just for comparison's sake, let's just say that for those reasons, we have a higher affinity IgG and a lower affinity IgM. Where this gets tricky, where this comes in questions, you have to remember this IgM immunoglobulin has 10 binding sites for antigens. So it's got 10 binding sites for antigens. Now, if you compare that to IgG, IgE, IgD, this only has 2, right? It only has 2 antigen binding sites. So that's kind of tricky, right? So one has 2 and one has 10. So what we call this, we could say, look, even though this IgM immunoglobulin might individually, each one of these sites might have a lower affinity, right? So each one of these sites, so each one of these idiotypes here might have a lower affinity. Overall, the whole molecule, if we add up all of the binding from all of these individual sites, right, we might actually have an overall increase in its ability to bind antigens. And so that we would call the avidity, okay? So that's if we totaled up all of these different sites together, right? That would be the avidity, avidity, right? And so the affinity is we're just referring to that one site. And so we might say that this IgM antibody potentially might actually have a higher avidity, right? Because it has so many more binding sites as opposed to the IgG. Now, again, like I said, there's specific examples of this that might be different, but this is kind of a high-level way to just think of the terminology when they use avidity versus affinity. Okay, just cleaning things up here again, let's just recap some of this. So again, IgM, usually referring to the pentameric structure. Okay, we said 10 binding sites linked by a J chain. Early response to infection, that's what we just talked about previously in the last video, where we initially, that primary response is going to come out IgM initially. And again, when we have repeated exposures, we have a similar response on repeated exposures to the antibody serum concentration of IgM. We talked about that in the last video, okay? So go back and check that out. In terms of its function here, the primary functions of IgM are going to be to activate complement, and that's part of the reason for that is because it's so big, but remember, it also acts as a B cell receptor. So also, IgG is kind of the other big B cell receptor to be familiar with, and I feel like we've kind of talked about a lot of this already. Let's transition over to IgG now. So IgG is the most abundant immunoglobulin in the blood that's particularly high yield. Also remember, this is now a monomer. Okay, so we're talking about monomeric structure generally versus the pentameric structure typically of IgM. And again, this is going to be a little bit more of a delay in terms of its response to an infection when we compare it to IgM. Usually you're going to get your IgM being released first. However, if there's repeated exposure, right, you're going to get greater responses of IgG because a lot of that is going to come from plasma cells that have already undergone class switching. And so those plasma cells and memory B cells are going to be stimulated to have a greater IgG response. And that's why we use IgG for things like titers, like we talked about in the last video. And again, the big functions of IgG: also activating complement. We already talked about that. That's primarily going to be done in the FC portion back here, and opsonization also done in the FC portion. Remember, opsonization, there's two really big opsonins that you want to be familiar with for step one. IgG is going to be one of them, and the other big one is C3b, like we talked about a little bit earlier in the series. Okay, so complement C3b is one of the classic opsonins, and IgG also will do this. And the way that we're doing this is if we have some antigen that we're binding to, right, on the surface of a bacteria. So we're just going to draw a big bacteria here. Okay, so let's just say that, our immunoglobulin is bound to this bacteria. It's going to have a region there in the FC portion where essentially you can kind of pull in a neutrophil here. So maybe there's some neutrophil here, okay? And this region can essentially kind of lasso in the neutrophil to bind here and then phagocytose this bacteria. Okay, so that's what opsonization is. That's what we're talking about. And again, largely driven by IgG and C3b. Also, the IgG structure, like the IgM, both of them can act as B cell receptors. And we'll talk a little bit more about this coming up when we talk about things like hemolytic disease of the newborn. But the big thing you want to remember is that the IgG antibody, because look at how small it is, right? In general, it's a lot smaller than the IgM. And so for that reason, that's how you kind of remember that the IgG antibody can be transferred through the placenta from mom to the fetus. Okay, so what mom's doing is mom already has antibody. Throughout mom's life, she may have been vaccinated, right? She may have had multiple types of infectious agents that now she has a memory response to, and she has those IgG immunoglobulins floating around in the blood, and those can go to baby until those IgG immunoglobulins are turned over. Okay, once baby is delivered, mom's not going to be supplying IgG immunoglobulins through the placenta anymore. Okay, so initially that newborn might have some amount of mom's immunoglobulins that are eventually going to start to kind of come down during the first few months of life. And so how does that newborn continue to get some immunoglobulins from mom? Well, that would be through IgA, through breast milk. After the baby is delivered, right, through the breast milk, we can give IgA antibodies. And that's how you remember that IgA antibodies are associated with things like mucosa, mucosa-associated lymphoid tissue like Peyer's patches, or the mucosa of the GI tract. So again, classically in breast milk, also sweat and saliva. And IgA initially in circulation, it's more of a monomeric structure like this, but again, it's linked by a J chain like we saw with the IgM. Here's the J chain again, to form a dimer once it's into the mucosa. These IgA antibodies, they don't activate complement. And one big pathology you'll see IgA come up a lot in is going to be, and there's a few of them, but this is one of the big ones, is celiac disease. Okay, and the thing that sometimes gets asked about in celiac disease, the classic antibody that you want to be familiar with is going to be tissue transglutaminase. Okay, so tissue transglutaminase, and sometimes they'll just write it as TTG. Okay, so tissue transglutaminase, and they'll sometimes ask you, you'll be like, oh yeah, I know this is for celiac disease, but they'll ask you which antibody specifically, which isotype is it? And it's IgA, right? Celiac disease is primarily affecting small bowel in general and absorption. And again, when you're thinking small bowel, when you're thinking mucosa, GI tract, you're thinking more IgA, right? So this is an IgA antibody. All right, let's jump down to the IgE antibody. So the IgE antibody, also a monomer like IgG. And the thing that you want to remember with IgE, there's two big things. It's really going to be its ability to respond to helminthic infections. So we're talking about worms, parasites. Also, its effects when we're talking about type 1 hypersensitivity reactions and things like asthma. We have a whole video on that already, so I don't want to go into too much detail in this video, but the concept essentially is, remember, you have mast cells and basophils that are housing essentially a lot of the histamine, proteases, leukotrienes. So let's just say that I have some, I have some mast cell here. Okay, so we're just going to call this a mast cell. Okay, so here's my mast cell, and this mast cell will have on its surface a specific type of receptor. We're just going to call it Fc epsilon 1. Okay, and it's not super important to know that, the exact name of all of these, but the point is that this receptor, like it says, it will bind to the Fc portion of antibodies. And so what do we mean by that? So hold that thought on the mast cell and let me show you. So and let's say that, we have some patient that had been exposed to ragweed pollen or bee sting or something like that. And initially, the initial response, they probably initially responded to IgM. Okay, so initially we might have had some, B cells with IgM receptors, for example, and let's just say that, this antigen bound to the IgM portion of this immunoglobulin. And what will happen is those B cells that have IgM on their surface, for example, that bound to this specific antigen might go and present this to a T cell. And they might undergo class switching. And so then what happens? And so then we start to make plasma cells that start releasing IgE antibodies through the stimulation of interleukin 4, like we talked about before, and interleukin 13. Okay, so now if our patient comes into contact with ragweed pollen again, or if they get a bee sting again, they have some plasma cells that are releasing IgE to our antigen. Now what can happen is some of these IgE antibodies can actually make their way and bind to the surface of mast cells. And look at how it's bound, right? So here's the Fc portion bound to the Fc receptor. And remember, this is your Fab portion out here. Okay, and now if we bind, remember we have the same idiotype as this IgM receptor because we went through class switching. And now let's say that we have a second exposure to the ragweed pollen, for example. So now, right, we're going to bind to that same region, okay, because we have the same region, we have the same idiotype. But now what happens is with these IgE antibodies on this repeated exposure, they're all bound to these mast cells. We might have a whole bunch of them here. And they can cross-link once they bind to their antigen. And that will stimulate these mast cells to degranulate. And so these mast cells, because of this binding, right, of the IgE receptor on its surface, now bound to its antigen and cross-linking, these will start to release substances, histamine being a big one, and leukotrienes, okay? So all of these will start to get released, and we call this process degranulation, okay? So the granules that are housing all of these structures are releasing them. So we call this degranulation. Okay, so the mast cells will degranulate, release all these substances, and you can imagine if you have repeated exposures, right, you're going to make more and more of these IgE antibodies, and more of them are going to be sitting on these mast cells. So that's why if you're allergic to something and you get exposed to it multiple times, even if it's certain medications, can actually go down this route of anaphylaxis, because once you get to a significant enough amount of IgE antibodies bound to the surface of these mast cells and basophils, then what will happen is when you get exposed to that antigen, you're going to have so much degranulation that you can actually push this patient into anaphylaxis, okay? And so that would be the concern. This is a type 1 hypersensitivity reaction. We're hypersensitive to some antigen from repeated exposure. Now, in general, like we said, the IgE response is going to be particularly effective against helminths, and we can remember IgE with eosinophils, okay? And lastly on here, we have the IgD antibody, which is not particularly high yield in general. We won't go into too much detail on this. Just remember that it's a monomer. So the big things here, like we said, just make sure you're familiar with the different structures of the immunoglobulins, their function, and then any specific pathologies they're involved with. For example, IgE, we talked about type 1 hypersensitivity. IgA, we talked about celiac disease in breast milk. IgG crosses the placenta. Classic and opsonization, IgM acting in the early initial response, and then it's a pentamer. So just remember the key facts here. A lot of what's on here is a lot of what you have to know to distinguish some of these isotypes. Take 15 seconds to pause the video and read the question, and then we will go through the answer. You know, there's always certain questions that really kind of, either get under your skin or get you a little nervous. And this is definitely, for me, one of those questions. Just looking at this, it looks deceivingly short in terms of the question stem. But you see this table, you see some kind of complicated data, and it can be a little bit intimidating. So, let's just kind of walk through this here step by step. So, a researcher conducts an experiment to measure the effects of thymic tissue in adult mice. And again, you might not necessarily think of this the first time reading this, but again, thymic tissue in adult mice, right? When you're thinking about thymic tissue, at least, when you think about adults, you think about thymic tissue more so in newborns, right? Interesting that they're talking about adults here. So a control group and 2 additional groups of mice are studied. All right, this is important. We have to kind of stay organized in questions like this. So we have a control group. Okay, so we have this control group. And then we have 2 additional groups here. So it looks like group 1 mice undergo placebo surgical intervention, omitting thymectomy. Okay, so it looks like it's a surgical intervention essentially, but they're not taking out the thymus. Okay, so that's group 1. Okay, and then we have a second group here. So group 2 mice undergo surgical thymectomy. Okay, so group 2 go under for thymectomy. XX77, a primary immunization, is given 11 days prior to surgical intervention. Okay, we're not sure if this is relevant yet. And a booster immunization is subsequently given 21 days later. All right, and we can see that referenced here a couple times. All right, what's the question here? So the data below is collected at 30 days after surgical intervention. Okay, which of the following can the researcher most reasonably assume based on the results of the experiment? Okay, so again, kind of appears like a tough one. And, these things where you have to kind of keep track of the days here, right? So the primary immunization is given 11 days prior to a surgical procedure. So let's just write this out here. So here's the surgery, right? So they gave the primary immunization here. This would be let's just say this is day 1. Let's just say that this is day 11. And I'm assuming this booster is given 21 days after the primary here. So we can just say day 21. Okay, so just to kind of give us an idea. Now, the data below is collected at 30 days. Okay, so the data is collected at day 30. So this is where the data, just write data, is collected from. Okay, so this is the data in this table here. CD19, CD21 positive cells. So again, you got to know some of these markers, right? So these ones we've talked about in the series so far. So these markers are going to be consistent with B cells. Okay, so CD19, CD20, CD21, usually referring to B cells, and you should know that. I noticed that the control group has slightly more in the way of overall B cells. So the control group, I'll just put control, has a little bit more B cells, right? Group 2, slightly more than group 1, okay? If we look at the second column here, there's a pretty significant difference in the percentages here. So now this is XX77, this is the vaccination, specific heavy chain variable region mutation frequency. You read something like that, and that can definitely start to give you some palpitations on test days. So we're not going to panic, we're going to break this down. So heavy chain variable region, okay, so remember your immunoglobulin, right? So your immunoglobulin, you have your heavy chain, right? So you have the heavy chain, and then you also have your light chain, right? So you have your heavy chain and you have your light chain, and it's talking specifically about the variable region. So this region out here. Now remember, what's the significance about the variable region? The variable region, right, is going to be the idiotype. In other words, this is where we're going to have antigen binding. And we're going to have a lot of different variability in this, right, from birth with things like VDJ recombination, which we can see here is one of the options, right? So anyway, this XX77 specific heavy chain variable region mutation frequency. So showing how many different mutations there is in this region that can bind to this antigen essentially, right? So we can see in the control group, we have quite a bit more in terms of the percentage of mutation frequencies. If we look at group 1 and group 2, we can see that these percentages are a bit lower than what we see here with the control group. Right? What does this mean? Well, it's kind of telling us that, look, this variable region, right, when we talk about things like somatic hypermutation or affinity maturation, remember what this basically is, right? If I give somebody a vaccine or somebody's infected with a pathogen potentially, initially, right, my B cell, let's just write in CD19 positive, CD21 positive, right? Because that's one way to kind of make this stick, right? So this is our B cell. And so this B cell, initially, when it presents, right, it's going to phagocytose some pathogen. It's going to present a protein antigen, right? So it presents this protein antigen. And let's say it presents this to, let's say this is a CD4 positive T cell. So essentially what happens is this T helper cell can do a couple things, right? We already said one thing that can happen is this CD4 positive T cell can cause this B cell through CD40 ligand, can cause this to undergo class switching, right? Class switching, which this would change not the idiotype of the antibody, but this would change the isotype. That's going to change the heavy chain here, right, in the constant region so that we can make things like IgG, IgA, or IgE, right? So that's one thing that can happen. The other thing that can happen is this CD19, CD20, CD21 positive B cell can go to the lymph node, right? It can go to the lymph node. It can head to the secondary follicles, right? We talked about these. And these secondary follicles, particularly in the germinal centers, kind of in the middle where you have more of the pale staining, these germinal centers are areas where we have a lot of these different B cells, right, that have this specific antigen binding, much like we see this XX77 specific antigen. And what these B cells are doing in the germinal centers here, in the secondary follicles, is they're essentially basically taking this receptor right here, right? They're taking that very specific idiotype. Because remember, what is a B cell receptor? A B cell receptor is essentially going to be an immunoglobulin, right? Very similar to an antibody. And so what we're doing here is we're taking that specific receptor, right? So maybe this is my heavy chain, here's my light chain, and we're just making, fine-tune adjustments to it. We're just doing a bunch of random mutations. Maybe one B cell has a mutation here, and maybe another, B cell in this secondary follicle has a mutation here. And they're all just kind of making little mutations. And then they're going to see out of all of these B cells, which one's mutations have the strongest binding. And so the idea is if we have more mutations happening in that very specific site, in the heavy chain variable region of this specific antigen binding site, then we're going to have a higher likelihood of stronger binding, right, for this B cell. Okay, so this is why, and we'll get to the other options in a second, but this is why the answer is impaired somatic hypermutation after surgery. Okay, the key other point to this is after surgery. Now, if the options were, after thymectomy and after surgery, and you're like, oh, I don't know which one to pick, the answer is after surgery, right? Because in group 1 and group 2, in both situations, even though group 1 still has a thymus, right? Even though group 1 still has a thymus, the lower level of somatic mutation is still there. In fact, it's actually even lower than those mice that underwent thymectomy because they have a lower amount of these mutations in that idiotype, in that specific heavy chain variable region. Let's just go through the rest of this here really quickly. So XX77 specific IgM. Okay, so now we're talking about immunoglobulins that are IgM that bind to this antigen. And we can see that the levels of these, right? So this is just like a quantitative level here. So, the control, the group 1, group 2, they're all pretty consistent. I mean, nothing is like even 5% different, really, I don't think. So they're all pretty similar. The IgG levels, kind of the same thing. I mean, very small variation here. Now, what does this tell you? Well, remember, if we go back to what I said earlier, right? There's two kind of pathways here, right? There's two pathways here. I'm going to highlight them in red. The first one, right? You can go through class switching and you can change the isotype. The other thing is you can do somatic hypermutation to these B cell receptors, right? To these immunoglobulins, and these can go on to change the idiotype, right? So the idea here is we already know that the level of mutations in the idiotype are lower, right? Which is consistent with somatic hypermutation, impaired somatic hypermutation. But we can see that we're able to get some class switching, right? Pretty consistent with the control group who, didn't have the surgery presumably. So in all these situations, these are all pretty similar. So we can assume from this then, right, based on this data, that it's unlikely that there's impaired isotype switching after thymectomy, right? So if you just look at thymectomy, which is group 2 here, right? Group 2 actually has more IgG than group 1 or the control group, right? So impaired isotype switching is pretty unlikely. The same would be true for impaired CD40 ligand binding, because remember, we need this to get class switching, right? If we don't have CD40 ligand binding, it's going to be pretty hard to get class switching. That's why if you have a defect in CD40 or CD40 ligand, we call that hyper IgM syndrome, because then all you can really produce is your baseline IgM, which is not what we see here, right? So in both of these groups, we can clearly see that there is an IgG response. Now, impaired VDJ recombination after thymectomy. Now again, VDJ recombination is going to usually happen much earlier on. We're talking about adult mice here, right? And so it seems pretty unlikely, right? And if we're talking about adult mice, that this would be the most appropriate answer, because again, this is happening a lot earlier on, and we really don't have anything here to suggest that we have impaired VDJ recombination. There's clearly a better answer with somatic hypermutation. Finally, the last option here, marginal zone B cell hyperplasia. So remember, if you're talking about B cell hyperplasia, marginal zone, particularly in the lymph node, right after surgery, well, let's take a look at this. So here's the B cells. Now, hyperplasia would suggest more B cells, right, in this marginal zone. Now, if I look at, let's see, after surgery, so we're saying that essentially group 1 and group 2 have hyperplasia. If I look at group 1 and I look at group 2, in terms of the levels of their B cells, remember, they have less than the control. The control has more B cells than group 1 or group 2. So it doesn't really make sense that the marginal zone B cell hyperplasia would occur after surgery, right? Because if it did, I would actually expect to see more B cells in group 1 and group 2, which is not the case here. The control has more B cells. So for those reasons, impaired somatic hypermutation is the best answer. Things to take away from this. If you know your immuno, if you've been following the video series, you're building on the concepts, a lot of what's talked about here, you're just like, oh yeah, I've seen this like 5 times. You've talked about this so many times. And that's a good thing, right? Because if you're at that point and you've watched all these videos and you're like, yeah, I really get this now, that's fine. If it's annoying to hear the same thing over and over again, that's a good thing. However, if you're kind of going through these questions and you kind of back off a little bit when you start to see some of the details here, just go back to your basics, right? Even if you've been watching these videos all along and you get to this question and it's a tough question for you, go back to your basics, right? What do you know? What can you rule in? What can you rule out? And how can you try to break down some of this data with the topics that you feel the strongest on so far in the unit, right? And that's usually the best way to go about it. So hopefully that helps. Hey everybody, Dr. Roviso here. In this video, we're going to talk about complement, and we'll talk a little bit about the general properties of complement, some of the functional components to be aware of. Some of them we've kind of already touched on in the previous videos, and then we'll go through the three major pathways, all leading into the common pathway, and then we'll talk a little bit about some of the inhibitors, which makes a really nice transition into some of the disorders of complement, which we'll also touch on. So just to give a very high level overview here, when we're talking about complement, we're talking about plasma proteins that are typically going to be synthesized in the liver. When they're synthesized, again, they're in an inactive state. So they might be in the serum, but that doesn't necessarily mean that they're going to be setting off complement cascades on pathogens. Okay, so usually there's something that is going to trigger activation of the complement system. Okay, so once we get activation of the complement system, which could be by immunoglobulins, it could be by enzymes, certain carbohydrate moieties, which we'll discuss in the next video. Once we get that activation, there's two kind of endpoints to this complement cascade that you want to be familiar with. So the first one is going to be C3b. Okay, remember, so C3b is going to be very much involved with opsonization, and we talked about that previously. C3b and IgG being the two particularly high yield things to be familiar with when you're thinking about opsonization, when you're thinking about triggering that component of phagocytosis. Now, the other kind of endpoint to complement is going to be the membrane attack complex, which that's what this MAC stands for here, this membrane attack complex. And as we go through complement, we're going to kind of start at the top. So, we'll start with C1. Okay, so we're going to start with a C1, but then eventually, as we go through the complement cascade, we'll eventually end with this C5, C9 complex. Okay, and this is sometimes referred to as the membrane attack complex, or the MAC. Now, that doesn't necessarily mean that we go, exactly in order here. Okay, so that's not true, but we do start at C1 and then we end at C5, C9. Okay, and then everything in between is what we'll discuss in the next video. Now, do you have to understand every single component of complement? Not necessarily, right? It's not particularly high yield to know that, but there are certain functional components that are very high yield that you want to be familiar with. And a lot of these we've kind of already touched on, so this should be a little bit of a review if you've been following the video series. So we have C3a and C4a, which, remember, sometimes you'll see this written as anaphylaxis, right? So they're going to stimulate anaphylaxis. Now, we're not talking about anaphylactic shock necessarily, but the term anaphylaxis is simply referring to histamine release from mast cells, which is pretty consistent with what a patient experiences when they go into anaphylaxis, right? And so C3a and C4a will be promoting that process that ultimately leads to vasodilation. Now, a lot of this is really just kind of promoting the inflammatory cascade that we talked about in the acute inflammation video. Now, remember, C5a is very high yield because C5a actually does, the same thing as C3a and C4a, but also the thing that it's notoriously known for is its ability to kind of assist with neutrophil chemotaxis, and that's particularly high yield. So neutrophil chemotaxis with C5a, very similar to LTB4, right? We kind of had this discussion, interleukin 8. Those are your big players in terms of stimulating neutrophil chemotaxis to essentially take the neutrophil to the site of inflammation, taxing it over there using chemokines. And again, like we said, the terminal component of this complement cascade is going to be the C5b9 membrane attack complex. And this membrane attack complex, if you can imagine, you have some bacterial cell here. Okay, let's just say we have some bacterial cell, and essentially this membrane attack complex, what it does is it kind of just punches holes here in the membrane of the cell. So it's essentially going to be punching holes in the membrane of the cell, and so this cell will lose whatever gradient it has intracellularly to the extracellular space, and this can rapidly destroy pathogens. And this is essentially what this membrane attack complex is doing. Okay, it's essentially punching holes or perforating the cell membrane or capsid potentially of different pathogens, bacteria, viruses, etc. And where this is particularly useful in general is going to be against gram-negative bacteria. Okay, and this has to do with the cell structure, the cell wall, which is going to be covered more in the microbiology section. But in general, gram-negative bacteria are destroyed much more readily with the membrane attack complex, particularly Neisseria species in general. Okay, and this is going to come into play when we talk about terminal complement deficiencies. For example, if you don't have or can't form this membrane attack complex, you're going to have a really hard time controlling gram-negative infections, or particularly from Neisseria infections in general. So we'll touch on that in the next video. And the last thing that we kind of glossed over a little bit is inhibition with complement, right? So we talked about you can activate this complement cascade to go from C1 to eventually a membrane attack complex and a C3b component that can perform opsonization, but you can also inhibit different steps of the complement complement cascade. And I'm going to go into a lot more detail on this to come, but we have a delay accelerating factor, DAF CD55, and there's also a CD59, which I'll talk about coming up. And we'll go over the functions of these in more detail, but just to kind of introduce it here, we have activators and we have inhibitors that are going to affect different steps of the complement cascade. So in general, complement pathways always tend to be a topic that's very overwhelming in the sense that there's a lot of different steps. And we're not going to go through, every detail and every cofactor, but it is important to just have kind of a general understanding of this pathway and then, what factors we should be familiar with. So I'm going to go into a little bit of the detail and then we'll kind of zoom out and look at this big picture to try and understand, what do we really want to take away from this? And, and there are situations where you might get questions that are more detailed, but in general, you don't have to know every single detail. You just have to have an idea as to what's going on. Okay. And so that's essentially what we're going to try to kind of include here. And the thing that I want you to keep in mind as we're going through this, what are the things that you really have to know? Again, we really have to know these functional components of complement. Okay, that's the big thing. So if you had to take one thing away from all of this and you're watching this and you're like, I'm not really sure what I want to know. Number one is I want to know the functional components of complement and what they each do. Okay, so C3A, C4A, we talked about these being anaphylotoxins involved in anaphylaxis. When I say anaphylaxis, we're referring to histamine release from mast cells, right? C5A also does that, but it also stimulates neutrophil chemotaxis, which is particularly high yield. The neutrophil chemotaxis point, remember, we're getting neutrophils to the site of inflammation. C3B, very much involved with opsonization. We talked about that. And the other thing that we talked about was IgG, right? IgG, also very good at opsonization. Okay, and then C5B to C9, right? We talked about membrane attack complex, basically perforating holes into the cell membrane. So those are all the big things to keep in mind, and you'll see them all come into play as we're going through these pathways. All right, let's start by talking about the classical pathway. Okay, so we're just going to kind of go through this one. Now, if you understand this pathway, the other pathways are actually pretty straightforward. Okay, so this is going to be kind of the steepest learning curve, but once we get through this one, the other ones will make a lot of sense, I think. So the first step, we're going to have to bind to our microbe. Okay, so this is our microbe. It's our pathogen. It could be a bacteria, it could be a virus, whatever. And on this microbe, you can see there's some IgG antibody. Now remember, IgG antibodies at the Fc portion, like we talked about in the previous videos, particularly that Fc portion that's closer to the hinge region on the antibody can bind complement. And what is it binding specifically? It's binding specifically C1. Now remember, it's not just IgG that can bind complement. It could be IgG or it could be IgM. IgM, having more binding sites in the pentameric form, can make it more likely for it to bind complement. So just another thing to kind of keep in mind when you're talking about, the structure of some of these immunoglobulins. But again, the point here, IgG is on the surface, it's tagging this microbe, right? So here it's binding to the epitope. We have our Fc region portion down here, complement's binding to that, right near the hinge region, and we can see C1 is the component that's binding to it. Okay, so that's this C1 complex. Now this C1 complex, what it does, and remember what I said, we start at 1 and we end at 9, right? So it doesn't mean that we go necessarily in the correct order as we're going through the steps, but we do start at 1 and we end at 9, so that's something to keep in mind. So C1 complex is going to split C4 and C2. Okay, so you can see C4 here, you can see C2 here. It's essentially splitting them. And so one thing that I want to make kind of clear here with complement, if we start with something, let's just say we started with C4, and if we split it, when I say we split it, what am I talking about? I'm talking about splitting into two components, okay? So you're going to get a C4A, okay? So you're going to get a C4A, and then you're also going to get a C4B, okay? So you're going to get a C4A, and you're going to get a C4B. You can think of this kind of subletter as being more of an activated form, whereas more of the inactivated form you can think of as just kind of having the number. Okay, so this being more inactivated and these being my activated forms. Now we already know what C4A does, right? C4A, we already said, stimulates histamine release, right? It's one of the anaphylotoxins. C4B though, what does that do? C4B is going to go down into the next step, and the same thing is true for C2B. Okay, so both of these, all of the B's are going to stay in the complement cascade. Now, in the past, there was different notation for this, where the C2A was the component that stayed in the complement cascade, but kind of the updated way this is categorized is if it's going to be one of the B components, so if it's a C4B, if it's a C2B, if it's a C3B, that component can stay in the complement cascade, and that's the way to remember it. So if you get the B component, right, if it has the B here, it's probably in some ways possible that it's going to stay in the complement cascade. So if you have a B component, right, it's most likely going to be in the complement cascade here. Now C3b has some additional effects like opsonization, okay? But in general, these B components can stay in the complement cascade. This microbe marked with an antibody, the C1 complement factor bound to the Fc portion on the IgG antibody, or it could have been IgM, and then that cleaved the C4 and C2 complement factors to C4b and C2b. Those come together and now they form a C3 convertase. So the convertase is telling you what this structure does. It takes C3, right? It would take a C3, just like we did with our C4, and it's going to cleave it into two components. Again, this C3 convertase is made up of C4b and C2b, okay, on the surface of this microbe. And you can see that happening here. So now we're going to, once we form this C3 convertase, okay, so C4b2b forms a C3 convertase. Once we form this, now a C3 can be coming by and we cleave that C3 into two components, just like we talked about. So we have a C3a. Okay, so C3a, we already know what that does, right? We set up here, functional components. C3a is also going to be involved with histamine release from mast cells. And the B component, we just said, the B component sticks around. Okay, so the B component comes down into the next step and helps form the C5 convertase. Okay, now the C5 convertase, it's like it says, once again, the C5 convertase is going to convert C5. Okay, and again, this is formed now from C4b, C2b, and C3b. Okay, so this is kind of where it gets confusing, but again, it's telling you what it does, right? So it's going to cleave C5. Now, once we finally get to this step where we form this C5 convertase, we're able to cleave C5, and again, we get our two components. We get C5a, which we already know what this does, right? We go up to our functional components here, right? C5a, we know that it's going to stimulate histamine release from mast cells. It's also going to be involved with neutrophil chemotaxis, right? So that's what C5a is going to be doing. And then we know C5b, it has a B in its name, so it's going to kind of continue this cascade. And we know we're home free because if we remember the membrane attack complex, what is that made up of, right? We just talked about this. It's made up of C5b to C9, okay? C5b to C9. And so this C5b component is going to combine with C6 through C9, right? So they're all going to come together and they're going to form the membrane attack complex, okay? So once we get the membrane attack complex, remember that's the terminal step of this complement cascade. Okay, there's really two kind of terminal steps that I think about. The first terminal step, like we talked about in our first video on this, was going to be C3b. C3b, it has a B in the name, right? We said if it has a B in the name, it can continue down this cascade. So C3b can continue to form the C5 convertase, right, in the next step, or the C3b can then go on to stimulate opsonization. So the C3b can do either one, right? That's kind of the first terminal point of this cascade is opsonization from C3b formation. But the second terminal point of this cascade is going to be the membrane attack complex, in the sense that this is a structure that isn't going to go on to another step, and it's a structure that can punch holes into this microbe's membrane. Then we're getting into the common pathway, right? And that essentially we're saying common because all of these different pathways, right, they're going to have some slight differences up here, but once you get to this C5b step, you can see they all have C5b here, you're essentially going to be going down the same pathway, right? You get the C5b, the C5b is going to bind to C6 through C9 and form the MAC. Okay, let's go through the lectin pathway here really quickly. So the lectin pathway, and the nice thing about this lectin pathway is it's essentially the same thing as the classic pathway. The only difference is in the first step. In the first step of the classical pathway, we had IgG or IgM antibodies bound to the microbe surface, and so we bound our C1 complement to that. But in this situation, instead, you're going to have mannose, right? You're going to use these mannose structures on the microbe surface, and you're going to have mannose binding lectin, right? Mannose binding lectin, MBL, is going to bind to the mannose, okay? And then that structure is going to kind of act as that initial C1 from the classical pathway. Every step after is going to be the same. This mannose binding lectin, just like C1, is going to cleave C4 and C2. The B's are going to stay. We know what the A's do up here. The B's are going to stay, so the B's are going to come together and they're going to form a C3 convertase, which tells you what it does. It converts the two components of C3 to C3A, which again, we know what that does, right? It's one of our functional components. And then C3B can either go on to do opsonization or can go into this next step to form the C5 convertase. C5 convertase, it says what it does in the name. It converts C5, right, to C5b, C5a. C5b can combine with C6 and C9 to form the membrane intact complex. Go right back down the common pathway. So the only difference between the classical pathway and the lectin pathway is the first step. Okay, so that's where, if you're kind of thinking, okay, well, how would they ask me a question? Do I have to know all the details? You want to know the differences, right? So you want to know that the classical pathway is associated with immunoglobulins, and the lectin pathway is associated with mannose binding lectin, kind of triggering the cascade. The alternative pathway has to do with C3 starting things off. Okay, so it's a little bit trickier. So let's just go through that really quickly. So the first step has to do with C3 essentially binding to the cell surface to form C3b. Now, once you get C3b here on the cell surface, okay, which again is completely different from what we talked about with the other two pathways, there's also going to be a second component, a factor B. And when that factor B gets cleaved here, you end up forming a C3 convertase. Now, like I said, I'm not going through every single detail here because it's just not high yield, right? We don't need to know every single cofactor. But I am going into some detail because, this is one of those things where if you understand this a little bit, you can make a lot of sense of the disorders and see where some of this stuff comes from. So with the alternative pathway, it's a little bit harder because it doesn't have the same features as the other two pathways initially. Your C3 convertase is actually different. Okay, so if there was a question where they wanted you to distinguish what makes up a C3 convertase, right, you can see in the alternative pathway, it is completely different than in the classical and the lectin pathway. Okay, so this is made up of C3b and then this B factor sub B component. Okay, and then this eventually what it does is it acts just like the name says though. A C3 convertase is cleaving C3, and so you're going to get further C3 cleaved. You're going to make more C3b, right? That can go back into this pathway, just like in the previous steps, and form a C5 convertase. So again, after those first initial steps, everything, beyond the C3 convertase is the same, once again. So if you understand everything beyond the C3 convertase, pretty much, you can understand each of these pathways. It's just that the first step is a little different. So let's just go through the text here just to hammer this home. So again, when we're talking about the classical pathway, we're talking about immunoglobulins setting things off. Which immunoglobulin specifically? IgM or IgG? You get a C1 complex that combines to the Fc portion, splitting it C4 and C2. When we split something, we get the A and B components, right? We know where a lot of these structures go. If it has a B in its name, though, it can stick around. Okay, so if it has a B in its name, it can stick around. So the C4b and 2b stick around. They form the C3 convertase. We cleave C3. We get the B component that sticks around. Now we form a C5 convertase, right? And that takes us right into the common pathway, where we'll then form C5a, C5b. The B sticks around, helps form the membrane attack complex. Okay, lectin pathway, same thing. The only difference is we activate with mannose, and we have mannose binding lectin that forms the C1-like complex because it does essentially what the C1 complex does. Everything else is the same as the classical pathway. Alternative pathway, the difference is we're activating on the microbial cell surface with C3b bound to the surface. It's going to bind this factor B, and then we're going to form a C3 convertase, eventually forming a C5 convertase once we cleave C3b and add that to our structure. Okay, and so again, we get to the common pathway. It's the same thing. They're all going to end in this membrane attack complex formation. Okay, so they're all going to eventually get to that step. They just start a little bit differently. Okay, so the C1 esterase inhibitor, and we'll talk about the relevancy of this with C1 esterase inhibitor deficiency, but the C1 esterase inhibitor is going to prevent this first step. So if I had some, let's just put C1 C1 inhibitor here, it would essentially inhibit what this C1 component is doing. And what is it doing? It's cleaving C4 and C2, right? So it's inhibiting this step. So you can imagine if you had too little of this, if you had a deficiency of this C1 esterase inhibitor, you wouldn't be able to stop C4 getting converted to C4b, C4a. You wouldn't be able to stop C2 being converted to C2a, C2b, right? So you would have a lot of complement activation in this initial step. You'd have very low levels of C4 because you wouldn't be able to inhibit or regulate it going into form C4b. Okay, so that's why low C4 levels is very classic for C1 esterase inhibitor deficiency for that reason, right? Because you can't inhibit this step. So this C4 is constantly getting converted, right? Not regulated. All right, the next one on here, the next inhibitor is going to be delay accelerating factor, also known as CD55. And we see a deficiency of this with PNH, paroxysmal nocturnal hemoglobinuria, which we'll talk about in a minute. And this essentially prevents the formation of the C3 convertase. Okay, so you can see, where's my C3 convertase? I have them here, right? So decay accelerating factor is going to inhibit this step, right? It's going to inhibit these two structures coming together to form the C3 convertase. In our body, right, in homeostasis, these molecules like decay accelerating factor, what they're doing is they're regulating things, right? So if you have too much decay accelerating factor, you're not going to be able to have complement mediated destruction. But if you have too little of it, you're going to have too much destruction, right? So that's the concept. Essentially, these are helping to regulate this process so we don't have activation. And the final one on here is the membrane inhibitor of reactive lysis, CD59, which is going to prevent the formation of the membrane attack complex. So in all of these, right, it's going to combine with C6 through C9, and this is going to make our MAC, right, which is essentially going to be C5b through C9. And what this CD59 is going to do is it's essentially going to inhibit at this step. Okay, I'll just put MIRL here for membrane inhibitor of reactive lysis. Okay, so that's what that stands for. And again, it kind of looks like the MAC name, and that's maybe one way to remember it. And it's essentially inhibiting this step, preventing the formation of the membrane attack complex. All right, so let's put together kind of everything that we've been talking about to go over some of the disorders of complement. Probably the least high yield of the four on here is going to be this early complement deficiency. It's just like the name says, it's early, right? So it's in the first few stages. So you have some deficiency. It could be C1, C2, C3, C4. It's pretty nonspecific. But in general, if you had a deficiency of these early complement factors, the patients are more likely to have respiratory and sinus infections in particular. Okay, and there's an increased risk of developing lupus. Now remember, lupus, we tend to see low levels of complement, particularly the early complement in the setting of lupus. And you can kind of make a case, well, is that because you have more complement activation? Maybe you have an autoimmune hemolytic anemia, thrombocytopenia, etc. Is it kind of the chicken or the egg, which came first? But in general, there is an association here, so just keep that in mind. Like I said, probably the least high yield of the four, but it's good to have it in here just for inclusion's sake. What I would focus on that's much more high yield is the terminal complement deficiency. And the biggest thing that you have to take away from this is that these patients are at increased risk of Neisseria infections. And there's some repercussions of this where this can turn into kind of a more complicated question stem that I'll talk about in a second. But in general, what you really want to know, what you really want to take away from this is if for whatever reason there is a deficiency of C5 to C9, right? Particularly, we're talking about C5b to C9, right? That's going to form that membrane attack complex that we talked about. And that's going to be very much associated with, like we said, perforating pathogen membranes, particularly effective, like we said, against gram-negative bacteria. And the big one that we always talk about, again, being Neisseria. Okay, and we'll talk about this in a little bit more detail in just a minute. Before we do that, though, let's jump into talking about the C1 esterase inhibitor deficiency. So again, the general concept here is, right, if I have some microbe, right, this is going to be my pathogen, right? And then I tag this thing with an antibody. And then remember my FC portion here, if it's IgG or if it's IgM, let's just say it's IgG. This FC portion, particularly close to the hinge region, I can have complement formation. So I can have a C1 complex come here, and then I can take C4 and C2 and essentially convert these to C4a, C4b, and C2a, C2b. And I know the B's are going to stay, and these can come together to form my C3 convertase, which is going to be used to take C3 and then cleave C3, right, to C3a and C3b. But the point here is that for, if I have C1 esterase inhibitor around, that can inhibit this C1 from acting, right? It's just like the name says, C1 inhibitor. Okay, so it can inhibit the C4 and C2 from going down this pathway. And this is used to regulate, overactivation of complement and that type of thing. Now, in some people, though, they have a deficiency of this C1 esterase inhibitor. And the presentation they have, one of the things you'll see is that their C4 levels are very low. And again, you can make sense of this, right? So if for whatever reason you didn't have this C1 esterase inhibitor, let's do this in another color. Let's just say you didn't have the C1 esterase inhibitor, okay? So you didn't have it or you had really low levels of it. What would happen is it wouldn't be able to inhibit the C1 component, right? And so if it wouldn't be able to inhibit the C1 component, this C1 component might go kind of overactive, right? Because it's not going to get regulated at all. So you're going to have more and more of this C4 and C2 getting converted to their subcomponents, C4a, C4b, right? So what's going to happen to your C4 levels in the blood? They're going to go down, right? Same thing with the C2 levels. So you might have very low C4 levels, and that's typically one of the tests that come up when they're asking questions about C1 esterase inhibitor deficiency in general. There's a lot of stuff written here about bradykinin, so let's talk about that. Now, we said earlier that bradykinin in general, when we were talking earlier in this playlist, we said that this is very much involved with things like vasodilation, right? Vasodilation. And we also said it was very much involved with the pain response. When we feel pain, that has to do with those high levels of bradykinin when we have inflammation. And bradykinin comes from this high molecular weight kininogen. Okay, I'm just going to write it HMWK, sometimes written as kininogen, but we'll just write it as high molecular weight kininogen can form bradykinin. And what causes high molecular weight kininogen to form bradykinin? That would be kallikrein. So kallikrein will help stimulate the conversion of high molecular weight kininogen to bradykinin, and then bradykinin causing vasodilation and pain. So you can imagine if you have an inflammatory response, you're going to have higher levels of kallikrein, so you get more bradykinin around. That's the concept. We need regulators, right? We need some kind of regulator of this process. And so the regulator here is your C1 inhibitor, C1 esterase inhibitor. Actually comes in and it says not only does it inhibit C1 in the complement cascade, but it also inhibits kallikrein, again, keeping things in check, right? So things don't get out of control, and that's what the C1 esterase inhibitor is doing. Now, again, going back to the point I just had, if for whatever reason a patient had a deficiency of the C1 esterase inhibitor, now it can't inhibit kallikrein. So what happens? Well, now kallikrein can go unregulated, right? It can go unregulated, and it can just stimulate this process to a very high degree. And so what are you going to get? You're going to get very high levels of bradykinin. You're going to get a lot of vasodilation, right? And this can also cause vascular permeability to increase, and you can end up with edema. Okay, so you can end up with increases in vascular permeability, and you can end up with edema. And these patients can also have a lot of pain because of these really high levels of bradykinin in the setting of a C1 esterase inhibitor deficiency. So these patients, typically, this will be autosomal dominant. Okay, remember, we always try and remember the autosomal dominant diseases, the X-linked recessive and X-linked dominants, and then anything that doesn't fall in those categories, that's going to be autosomal recessive. Okay, that's kind of my way of organizing it. And again, we have increased levels of kallikrein. We already talked about that. The kallikrein is going to basically go unregulated, and that's going to lead to increases in bradykinin. Now, the presentation typically, and there's more detail on this, we're just going over the high yield stuff here. Typically, these patients will have recurring angioedema. They might have facial edema. They might have abdominal edema where they have abdominal pain and nausea from edema that's happening there, or even edema in the extremities. Okay, the concern here is we don't want these patients to get laryngeal edema, where we start to close off the airway. Okay, so this is going to kind of present almost looking like this patient is, potentially going into anaphylaxis, or this patient had some allergen exposure. But one thing that's different when you're talking about C1 esterase inhibitor deficiency from something like a type 1 hypersensitivity is that in this situation, there's really no urticaria. Okay, especially in a board question. There's no urticaria. So that's one way that you can try to tease out some type of type 1 hypersensitivity leading to anaphylaxis versus a C1 esterase inhibitor deficiency, because they're treated differently, right? Because if I have a patient that has anaphylaxis, I might be thinking epinephrine. If I have a patient that has C1 esterase inhibitor deficiency, I can try and get these patients C1 esterase inhibitor because that's what they're missing. That's going to slow this pathway down. If I give them concentrated C1 inhibitor, that will inhibit this kallikrein and we can get the bradykinin levels under control. So they're treated differently. So it's important to distinguish them. One thing they'll say is that the patient recently received an ACE inhibitor or was started on an ACE inhibitor. So we talked a little bit in the cardiology section about this, about how the ACE enzyme, it has a few different functions in the RAS cascade. But one thing that it does is it actually inhibits bradykinin. Okay, so if we had a patient that had an underlying C1 esterase inhibitor deficiency and we started them on an ACE inhibitor recently, okay, so if we just started them on an ACE inhibitor and they already have low levels of C1 esterase inhibitor, look what's going to happen. If I put somebody on an ACE inhibitor, I'm going to inhibit this enzyme, right? And so now if I inhibit this enzyme, I'm not able to regulate my bradykinin. So not only will my kallikrein be, stimulating bradykinin, so there's more and more bradykinin being produced potentially, but I can't even inhibit the bradykinin with the ACE enzyme to try and keep things under control. So it's kind of like double trouble here, because I have an ACE inhibitor that's inhibiting one thing that's regulating bradykinin, and then I don't have my inhibitor to control kallikrein, so I have even more bradykinin. And so that's typically how this will come up. So these patients should avoid ACE inhibitors, but a lot of times in a board question, that's how it's presented. They were started on an ACE inhibitor for high blood pressure or whatever, and now they're presenting a few days later, potentially with new facial edema or abdominal pain, recurrent abdominal pain with new edema, etc. Okay, so that's usually going to be the trigger. The trigger can also be trauma, stress, right? There are a lot of different things, but that's one classic way that this comes up. All right, PNH, paroxysmal nocturnal hemoglobinuria. So this is classically going to be a hemolytic anemia. You can have effects on some of the other cell lines, but essentially what's happening here, if I just draw in a red blood cell here, I'm going to have certain proteins on this red blood cell. We're going to call them GPI. And so these are going to be membrane-bound glycerol, phosphatidylinositol proteins. Okay, so GPI proteins. And these proteins are going to be things like CD55, right? We already talked about what CD55 does. This is your decay accelerating factor. It's going to inhibit the C3 convertase that we talked about when we went through the complement cascade in the last video. Okay, you're also going to have other GPI proteins on here, like CD59, which is going to inhibit the membrane attack complex, right? And that's going to be the membrane inhibitor of reactive lysis. Okay, so we already talked about those. So these are going to be on the cell surface of my red blood cell. Okay, so this is my red blood cell. So in a way, I kind of want these things on my red blood cell because I don't want my red blood cell to get destroyed by complement that's floating by. I don't want complement to get activated on my red blood cells. Now, if for whatever reason, though, I didn't have these proteins, okay, let's just say I didn't have these proteins on the surface of my cell. Well, if I didn't have them here, it might be more likely that I potentially could have complement activated on my red blood cell. And that complement cascade that eventually leads to a membrane attack complex forming, right, would destroy my red blood cell. And that's essentially what PNH is. So it's complement destruction of red blood cells due to loss of these GPI proteins, specifically CD55, right? We talked about that. That's a decay accelerating factor, and CD59. Okay, so those are the two that you really want to associate here with this paroxysmal nocturnal hemoglobinuria. We're inhibiting the inhibitor again, or we don't have the inhibitor, so to speak. So we have overactivation on our own cells. It doesn't just have to be on red blood cells. It could be on white blood cells. It could be on platelets. You could have a pancytopenia with this potentially. So again, in general, and you'll see this a lot when you're talking about hemolytic anemias, you see this in lupus, these patients will be very fatigued, right? They're going to have much lower oxygen carrying capacity in general. Systemically, they're going to have pallor, intermittent jaundice. Where's the jaundice coming from? We're going to have all of these red blood cells, right? We're going to have bilirubin that's being released, that's causing some of this jaundice. And then we'll have some hemoglobinuria, potentially with kidney injury, because of all of the red blood cell destruction. Now, the very classic thing, though, that you'll sometimes see with PNH is going to be this venous thrombus in atypical locations. So the idea here is as you're destroying these red blood cells, like we just said, you're going to have breakdown that eventually leads to high levels of bilirubin in the blood, but you're also going to have hemoglobin. And hemoglobin can cause oxidative stresses onto the endothelial walls. So this hemoglobin can exert oxidative stresses, right? Oxidative stresses, oxidative radicals can start to damage some of the walls here, particularly in areas where there's a little bit more venous stasis, okay, where there's blood not necessarily moving as fast, and that's going to be more on the venous side. And this can eventually lead to clots forming, right? We can have venous thrombus that form. And again, the classic thing is you typically aren't going to see venous thrombus in the hepatic veins, for example, right? The hepatic veins, renal veins, or the cerebral veins, right? So you're going to start to see kind of these very unique locations, not the typical, deep venous thrombus in the leg, right? These are going to be atypical locations in board questions as kind of a call out. So if you see patients that have intermittent jaundice, pallor, fatigue, hemoglobinuria, particularly hemoglobinuria that's worse in the morning, very classic for PNH, okay? And why I say worse in the morning is because if a patient is, gets up to have their first void in the morning, the urine's typically going to be more concentrated because they were sleeping and they weren't consuming fluids. So a more concentrated urine plus the fact that you're spilling hemoglobin, that's going to tend to be the darkest urine, where you're going to have very dark red appearing urine, okay? Very classic for PNH, dark urine in the morning. When you have this venous thrombus in atypical locations, particularly in the hepatic veins, that's sometimes referred to as Budd-Chiari syndrome. We'll go into way more detail on this when we get to the GI section, but when you start to block off the blood leaving the liver, right? All that blood is going to start to sit in the liver. You're going to end up with this congested liver that sometimes starts to form what's called a nutmeg liver, okay? And we'll get into more detail with that, but eventually that leads to a liver failure. And you're going to get a backup of a lot of that venous blood. You're going to get things like ascites, peripheral edema. One thing you won't get usually is going to be JVD, because the backup on the venous side is proximal to the jugular veins, right? If you had JVD, you'd be thinking more about something like CHF, okay, which we went through a whole bunch of detail on this in the cardiology section too, but you just have to think about this anatomically speaking, right? The hepatic veins are going to drain eventually into the inferior vena cava, and the blockage, if you had a hepatic vein thrombus or Budd-Chiari syndrome, would be before the hepatic veins reach the inferior vena cava. So you wouldn't expect, for all those reasons, jugular venous distension, okay? But you would expect things like ascites, peripheral edema, for that reason. Okay, now if you're going to diagnose this, the Coombs test is negative. And I don't want to get too off track and go down this rabbit hole just yet, but we will talk in great detail about the Coombs test. This has more to do with antibodies on the surface of these cells. Again, the point here is not that we have antibodies that are destroying the cells. The point here is that we're missing our own inhibitory, regulators of complement on our cells. All right, and the last thing here is there are certain drugs that you do want to be familiar with. Now, step one isn't as big on testing medications, but this drug in particular, the eculizumab, is an anti-C5 antibody. Okay, and so the idea here is if I'm destroying my own cells, right? If I'm destroying my own cells because I don't have my CD59 and my CD55 to regulate things, to inhibit complement from attacking my cells, I can try to attack the complement that's attacking my cells, okay? As crazy as that sounds. So if I had an anti-C5 antibody, okay, so here's some antibody, and let's just say, right, that I have, let's go back to my red, let's clean this up and go back to this red blood cell here. So here's my red blood cell again. It doesn't have the CD55 or 59 on it. And let's just say that for whatever reason, right, complement starts to get activated here. And again, it's probably going to start with C1 complex or C1-like complex. That's eventually going to lead to the formation of a C3 convertase. And eventually, it might have some C5 that binds, right, when I get to my C5 convertase. What these anti-C5 antibodies do is, as this is happening, right, as this is kind of going through the complement cascade, these antibodies can then bind to that C5, right? So here's some C5. It can bind to this and destroy it, so that we never really get to a point where I form C5b and then form my membrane attack complex. I can't get to that next step to actually destroy the red blood cell, all right? And that's what this drug is doing. It's a monoclonal antibody, right, that ends in mob, eculizumab. And there's also another one on here, not as high yield. But the point is if I use this medication, right, which may work very well, the issue is that if I can't form membrane attack complexes in this patient anymore because I'm inhibiting C5, what would that predispose this patient to? That would predispose them to Neisseria infections, because I essentially am giving this patient a terminal complement deficiency so I don't destroy their red blood cells, right? That's essentially what we're doing. And so because of that, now these patients are at increased risks of Neisseria infections. So if you give a patient eculizumab, you have to know that this patient is going to be at increased risk. So you're going to have to make sure they're vaccinated from Neisseria, and in some cases, they might even be on prophylactic antibiotics to prevent certain infections, particularly, again, Neisseria being the big one. And that's something where you have to, that would be a great board question, because you're integrating so many components of your knowledge here. So that's the way you have to kind of think at some of these multi-level questions, especially when you go on to step 2, when you have to have a little bit more wider of a knowledge base in terms of what's going on. Take 15 seconds to pause the video, read the question, and then we will go through the answer. All right, so we have a 37-year-old female who's presenting to the emergency department with a 3-day history of worsening severe left lower quadrant abdominal pain. As you get more kind of into the clinical realm of things, right when you see this first sentence, you want to start kind of jogging a differential in your mind, right? So when you see severe left lower quadrant abdominal pain, again, how old is she? She's 37 years old. Of course, you want to start to think a little bit about things. I mean, for me, ectopic pregnancy is definitely up here. What other things would you be thinking about potentially? You could be thinking about a UTI, maybe pyelonephritis potentially, if she has a fever and they say she has CVA tenderness or that sort of thing. Then also diverticulitis would be pretty atypical. Usually in a board question, if they're asking about diverticulitis, there usually is left lower quadrant abdominal pain, but it's usually in an older patient typically. But again, there could be a variety of things. Kidney stone would be another one. We could just put nephrolithiasis. So, as you kind of get more comfortable with these clinical vignettes and, especially when you get into the clinical world, right when you hear a sentence like this, immediately you kind of have a set of differentials that you're starting with, right? And so this is kind of one way to think about it. All right, so let's keep going here. So the patient states that she ordered a hamburger from a fast food restaurant for dinner the day prior to onset of symptoms. Okay, so that might be relevant potentially. E. coli potentially as like an infectious cause. The patient's past medical history includes allergies to dust, pollen, and numerous medications. Okay, so they're kind of giving us a lot of information from some different areas here. Additionally, the patient was started on lisinopril by her primary care physician 1 week prior for essential hypertension. Okay, vital signs are stable. Physical exam reveals significant edema in the bilateral upper extremities. Okay, that is interesting. Let's keep reading here just to get a little bit more information. When questioned regarding the swelling, the patient appears unconcerned and states, "Everyone in my family has this happen from time to time." So this is definitely a big piece of information here. A lot of the time when they put what the patient says in quotes or anything like that, especially for clinical vignettes, board questions and that sort of thing, it tends to be relevant. So we'll come back to this in a second. We'll finish here. Abdominal CT scan reveals significant diffuse bowel wall edema. Okay, so this would explain a little bit about where this abdominal pain is coming from. Which of the following sets of laboratory data are most consistent with this patient's presentation? Just putting the pieces together here. So this patient was recently started on lisinopril for essential hypertension about 1 week ago. Okay, so lisinopril, so this is where you have to, put the pieces together. You have to understand lisinopril is an ACE inhibitor, right? So it's an ACE inhibitor. And the other key piece of information here is that this patient seems to have a family history of frequent swelling or edema, right? When questioned regarding her swelling, she says she's probably unconcerned about it and everyone in her family has this happen. So that would suggest potentially that there's some family history of swelling or edema. So just kind of putting these pieces together, we're probably dealing with a patient that has hereditary angioedema. A lot of times in board questions, they'll present this more with like lip swelling or facial swelling, but it can happen in the extremities. It can happen in the bowel too. And in this case, this is probably what's contributing to her severe left lower quadrant abdominal pain. So she was already kind of predisposed to this angioedema, and then you gave the patient lisinopril, and that kind of tipped her over the edge. So let's just kind of review that process really quickly. So just remember the key player here is going to be bradykinin, right? So bradykinin, and this is exactly what they're asking about here. They're really asking about this pathway. And this is why I tell you for step one, you got to understand the pathways. If you know the pathways, you can kind of rule in and out different things. You just have to make sure that you're solid on your mechanisms and your pathways. Okay, bradykinin is formed from high molecular weight kininogen. And then this bradykinin, just remember the functions of bradykinin, right? So some of the functions, one big one is vasodilation. So this can lead to edema, interstitial edema, right? As we start to vasodilate and we increase the permeability of capillaries and that sort of thing, that can definitely lead to edema. And with this vasodilation, like we said, there's increased, I'll just put perm here for permeability, right? This is all contributing to the edema. And sometimes we can also get pain, right, from bradykinin. So these patients can complain of painful edema, or in this case, this patient has abdominal pain, likely secondary to the elevations in bradykinin and this diffuse bowel wall edema. What is really regulating this step here is kallikrein. It's kind of stimulating the conversion of high molecular weight kininogen to bradykinin. Notice on here, when we're looking at this lab data, they also included, the C2 level, the C4 level, C1 inhibitor functions. Let's just talk about that too, because this is all kind of interrelated here. So also remember, and we talked about this a little bit in the video lessons if you've been following along, but remember that C2 and C4 can get converted to their subcomponents here, C2b, C2a, and C4a, and C4b. And this all happens by C1, right? C1 is going to allow for a lot of these processes to happen. Now, remember that there's a C1 inhibitor that regulates this process. So I'm just going to kind of draw this here. There's a C1 inhibitor that can regulate this process. So essentially, to put this all together, what happens here in this hereditary angioedema is that we have some dysfunction in the C1 inhibitor. Okay, so the C1 inhibitor has some kind of dysfunction. Now, there's different types of hereditary angioedema. A lot of this is beyond the scope of step one. In some cases, you can have low C1 inhibitor. I'll just put an I for inhibitor. But in all the cases, you have dysfunction of the C1 inhibitor. And so that's the thing that everyone should remember, right? So the C1 inhibitor is not going to be functional. It could be low if it's a certain form of hereditary angioedema. But in general, whether it's low or whether it's normal values, in both forms, the C1 inhibitor has some form of dysfunction. Now, you can imagine if the C1 inhibitor had some dysfunction, right? So if I knocked out the C1 inhibitor here, what's going to happen? Well, now this complement, the C1, is going to kind of be over stimulated, right? Because there's nothing to regulate it. There's nothing to keep it in check. And so you're going to get a lot of C2 and a lot of C4 getting converted because there's nothing inhibiting this C1, right? And so what happens is the levels of C2 are going to drop and the levels of C4 are going to drop because they're getting converted pretty rapidly here. And there's nothing to inhibit this process because we have a dysfunction or deficiency of this C1 inhibitor. That's the point. So with that being said, we know from this fact that we should have low levels of C2 and C4. Right? So if we're just kind of scanning this thing here, there's really only two options where we have low C2 or C4 levels, which actually is kind of nice. It simplifies this quite a bit. You can see that there is an option here where one is low and one is high, but again, we would expect both of them to be low in this situation, right? If we just kind of understand the mechanism. The other thing here is you can actually solve this problem just by knowing this and knowing that, hey, the C1 inhibitor function is going to be impaired, right? C1 inhibitor function is going to be impaired. We pretty much know that F is the right answer, right? Just based off of that information, we can solve this problem. But let's just explain why the kallikrein and the bradykinin are also elevated really quickly, okay? Because you may be in a situation in the board question where it's not quite this simple, right? You might have to literally go through every single arrow. So kallikrein and bradykinin are elevated. Why is that? Remember that the C1 inhibitor can also inhibit kallikrein, right? So if it inhibits kallikrein here, what's going to happen? So if kallikrein is inhibited, that's going to regulate this process, this conversion of high molecular weight kininogen to bradykinin. If I have a patient that has hereditary angioedema and they don't have C1 inhibitor or they have a deficiency or dysfunction of the C1 inhibitor, then what happens? Well, if we don't have that C1 inhibitor functioning correctly, right, the kallikrein is going to kind of be overregulated, just like we saw down here. So the kallikrein is going to be more stimulated, right, because there's nothing to kind of keep it in check. There's nothing to inhibit it. And so we're going to get more high molecular weight kininogen converted to bradykinin, which means that we're going to have higher levels of bradykinin, right? And with higher levels of bradykinin, we get more vasodilation, more vascular permeability, more pain, more edema, which is exactly what we see here. Also, the last kind of layer here is to remember that ACE inhibitors run into this pathway also. So remember, this patient was given lisinopril, which is an ACE inhibitor. So to integrate ACE inhibitors here, remember that the ACE enzyme normally inhibits bradykinin. Okay, so the ACE enzyme, again, as a regulatory step, inhibits bradykinin. When you start somebody on an ACE inhibitor, right, you're going to inhibit this ACE enzyme. Okay, so if I start somebody on an ACE inhibitor like lisinopril, what's going to happen is I'm going to inhibit that ACE enzyme. If I inhibit that ACE enzyme, that's only going to further potentiate or stimulate this bradykinin, right? I'm going to get more and more of this bradykinin or more functioning bradykinin because I'm now inhibiting this enzyme. This was kind of like the last checkpoint. This patient at baseline probably didn't have a C1 inhibitor, so they already had kind of high levels of bradykinin, but now we added an ACE inhibitor and we actually made that problem even worse. And so again, the key is you can sit in a textbook and you can memorize, oh yeah, hereditary angioedema, so it's associated with edema, and ACE inhibitors make it worse. But the hard part is seeing that in a board question and just saying, hey, this is an ACE inhibitor, this patient has bowel wall edema, right? They have a family history, boom, you're thinking hereditary angioedema. Now you just have to understand the mechanisms to apply that knowledge. And so for those reasons that we just mentioned, again, the kallikrein should be elevated, right? We just said that. And the bradykinin should also certainly be elevated. So F here would be the best answer. Hey everybody, Dr. Roviso here. In this video, we're going to talk about vaccinations. We're going to build a little bit on some of the other concepts that we already talked about with humoral response, cell-mediated immunity, and then how does that translate to some of these different vaccine types. So if you kind of know the rules of the game, if you're sharp on that B and T cell video lectures, then I think this is going to make a lot of sense. So before we get too far into it though, let's just go back to active versus passive immunity, and let's make sure that we really kind of nail this down. So when we're talking about active immunity, remember this is when we're going to have a host generating antibodies in an immune response. Okay, so the host is generating the antibodies, and it tends to be a more delayed humoral response. Remember, whenever you see humoral response, you want to think about antibodies in general. Okay, so we're thinking about plasma cells releasing antibodies. So in this situation, let's just say that this is our patient, right? This is our host. So in this patient in particular, it's going to be the patient or the host that is going to be producing the antibodies. Okay, so that's kind of the key with active immunity. And the thing to understand here is that this is going to take more time, right? It's going to take time to produce those antibodies because those B cells might have to undergo class switching, for example, or have to generate a memory response. But on repeated exposures, there's going to be a higher antibody response over time. This is really what we talked about when we looked at the IgG over time, right? We looked at a graph where we kind of said, okay, look, the first time that you're exposed, right? If this is your first exposure here, right? Your IgG response might be something like this. Okay, this is going to be IgG. But then later on, you might have a second exposure. Okay, so you might have a second exposure where you're going to have a lot larger IgG response, right? You might have a lot larger IgG response. But the thing that we also talked about when we looked at this graph is that both times we'll typically get an IgM response first, right, before we get the IgG response. And the IgM response shouldn't really change very much. Okay, so that was the important thing that we talked about when we looked at these graphs over time. But the point is that the antibody response in general, if we're just kind of looking at all of our antibodies, in general, that response should increase over time because we have active immunity, because we're generating memory cells. Okay, now when you're looking at each of these active and passive immunity, there's two kind of subcategories to be familiar with. And the two categories here are going to be natural and artificial. What kind of active immunity did we generate? You know, naturally, what would happen? How would I end up generating antibodies? Well, that's because I had an infection, right? So an infection would cause me to generate antibodies versus that pathogen. Okay, that would be natural. Artificial, on the other hand, would be if I perhaps was immunized, right? So if I was giving my patient a vaccination, I might be giving my patient some antigen potentially, or even a virus, which we'll talk about in a second. But in any of these situations, it's still the host generating antibodies. That's going to take some time, but it was an artificial mechanism in which we generated that response. It wasn't naturally occurring. Okay, we had to give that patient an immunization or vaccination. So in passive immunity, it's not necessarily the host producing antibodies. Instead, we're literally just giving our patient antibodies that have already been produced in some other fashion. Okay, so again, if this is my patient, so now it's not necessarily the patient that's producing antibodies, it's antibodies that are being given to the patient. Okay, so it's kind of the other way around. So you're thinking antibodies to the patient. These have already been preformed. It's not the host that's producing them. Okay, so that's why it's passive. It's right. When I think passive, I think of, there's not a lot of activity going on. Active, there is a lot of activity. It's the host producing antibodies. In passive immunity, we're just giving them, right? And so this is going to be very rapid humoral response. If I give you an antibody to an antigen, these antibodies can start binding. There's nothing to stop this antibody from binding to a pathogen right away. Right? Where with active immunity, it's going to take me some time to get to repeated exposures to have really strong responses. Or it might even just take time in general to make certain antibodies like IgG. That's not the case. With preformed antibodies, I give them, they can start working right away. Okay, now the downside to this, though, is when we talked about active immunity, we made this huge response over time, right? We have a much larger IgG response on repeated exposures. The difference here is if I just give you antibodies, I'm not letting this host produce antibodies, right? I'm just giving them. Over time, these antibodies will eventually kind of wear down. Every antibody is going to have a half-life, right? In general, around 3 to 4 weeks, that antibody response is going to start to come down and it's going to decrease over time. And this is exactly what we see when we talk about mothers giving IgG to newborns, right? Or to the fetus potentially. Because remember, IgG can cross the placenta, whereas the other immunoglobulins are going to have some difficulty doing that, right? IgM way too big to be crossing the placenta, but IgG does in fact cross the placenta. And so this is an example of natural passive immunity, right? Mom's essentially going to be giving these antibodies through the placenta to the fetus, right? And that's exactly what's happening with natural passive immunity. It's a natural occurring mechanism that is allowing mom to give some of her antibodies from exposure she's had throughout her life to the fetus. But once that fetus is delivered, they're no longer going to be receiving those antibodies, right? Once this baby's delivered, now baby's not getting these preformed antibodies. Baby has some of them from mom from before, but over time, those antibodies are going to start to wear down. And that's where vaccinations will start to come into play, right, at certain times. Now, there's also artificial examples of passive immunity. So one of the artificial examples here would be giving a patient something like a tetanus immunoglobulin. So this is an antibody that's targeting a very specific pathogen, for example, or toxin, for example, and that's precisely what this tetanus immunoglobulin is. So you're giving the patient, again, antibodies into the serum that are targeting something very specific, okay? So that's the tetanus immunoglobulin. And you'll see this for diseases like rabies, and we'll go into more detail on this, especially for step 2, but it's very similar in the sense that, again, we're giving a preformed antibody to a patient that has likely not been vaccinated or doesn't have these antibodies, presumably, to help fight off an infection or destroy a toxin potentially. Okay, so this is a big slide. So this is where we're going to talk about all of these different vaccine types. And the thing that you want to understand here is you want to know which type of vaccine falls into which category. And there's a lot of different mnemonics here on to try to understand, okay, well, where does varicella fall, or where does, the BCG or smallpox vaccine fall? And the thing that I want to call your attention to, though, when you start to go through some of these mnemonics, it's really easy to get the different vaccines confused. So what I like to do is I like to look at some of the examples where there's only one or two major examples to understand. And you'll see when you look at the live attenuated, there's a lot more examples just in general that tend to fall in this category. So I try not to necessarily, like if I'm just trying to memorize these, I try not to necessarily start here memorizing all of these. I'll start with something like my subunit, polysaccharide conjugated activated, and just know, okay, these are the big 3 here. This is the big polysaccharide, etc. And then, anything that doesn't fall in these kind of smaller example buckets, then you'll know that that's probably going to be in the live attenuated. But even what's more important than that is understanding the comparisons, right? So you have to know intranasal influenza versus intramuscular. You have to know Sabin versus Salk. These are the really big things that you absolutely want to be familiar with. And we'll talk about all of this as we go through it, but we're going to do this in building blocks. So I like having everything on one slide so you can just quickly compare it, but we'll do this in separate videos because it's a lot of material. So without further ado, let's start talking about the live attenuated vaccines. When we're talking about live attenuated vaccines, we're basically talking about taking a live pathogen, right? So if you want to use the example of a virus, okay, or you can say a bacteria, let's just say a virus, okay, so I'm just going to draw some virus here. We're actually taking this virus, right, and we're putting this virus into our patient. Okay, so we're taking a virus and we're putting it into our patient. And you might say, well, that sounds really bad. We're basically just kind of infecting this patient. Now, the thing that's different though, if the virus normally uses, some factor to get into the cells, okay, so we'll just say this is its, this is related to its pathogenicity. Okay, so if it has something that's related to its pathogenicity that allows it to replicate, that allows it to infect cells potentially, what we're going to try to do is we're going to try to knock out the things that are really increasing the pathogenicity of this organism. Now, that's not to say that it can't replicate, right? They're live pathogens. They can still replicate. They're just less pathogenic, okay, and tend not to cause disease. But they're still going to have the antigens on their surface that we need to generate antibodies, right? So once we're given this live pathogen that just doesn't tend to be as pathogenic because we've made some modifications to it, then this patient will then have that live pathogen replicating and then will produce antibodies against this pathogen. Now, the key thing here is, remember, you're adding in here a live pathogen. And what step 1 likes you to know is to know what kind of response are you going to generate. And this is where you really have to think about your pathways here. So just going back to what we've been talking about this whole time, right? So here's our dendritic cell. Okay, and we've gone through this a few times now. Now remember, a dendritic cell is going to have an MHC1 receptor on it, right? It's going to have an MHC1, and it's also going to have an MHC2. Okay, now most cells in our body, like we talked about, are going to have MHC1, most of the nucleated cells, if not all of them, but the MHC2 receptor is only going to be present on antigen-presenting cells. Since a dendritic cell is an antigen-presenting cell, it's going to have both of these receptors, right? Now, if I have some live pathogen that I just put in the body, a couple things can happen. The first thing that can happen is this dendritic cell can digest this pathogen. Okay, so you can have phagocytosis of this pathogen. Now, if that happens, the dendritic cell is going to present this pathogen that we just digested, it's going to present it on MHC2, right? It's going to present that pathogen or that antigen from the pathogen on MHC2. And we already know what this is going to do. MHC2 is going to trigger my T helper 1 cells, right? My CD4 positive cells, right? Rule of eights. So CD4 positive cells are then going to bind to that MHC2 receptor using their T cell receptor and their CD4 positive co-receptor. And this whole process is going to lead to these T cells eventually activating B cells using CD40 ligand, right? We talked about all of this in the previous video. So if you're not familiar with this, go back, watch those videos. We go into this in great detail. And then we're going to have the CD40 ligand binding also. That's going to allow for class switching. And then these B cells will then become activated, right? And they'll go on to become plasma cells. Okay, so they'll go on to become plasma cells. And a plasma cell is essentially an antibody factory. And so now we're going to produce a bunch of antibodies to this antigen. Okay, that's pretty much the whole process. And that's going to be very consistent with what we see across the board. Now, remember what I said here. There's something really important. We're going to have CD40 ligand class switching occurring when this T cell uses this binding to a B cell. Okay, so remember, that's important. That causes class switching. Now, when you say class switching, what am I talking about when I say class switching? When I say class switching, I'm talking about taking IgM antibodies and turning them into a different heavy chain, right? So either IgG, IgA, IgE. Now, when we're talking about a memory response, we're primarily talking about IgG antibodies, especially in these simple kind of straightforward board questions. So when I say that there's T cells, right, these helper T cells go on to activate these B cells and they have class switching, what we would expect to see, right, is a strong immune response from this pathogen because we're going to generate IgG antibodies because we had class switching. That's an important piece to remember here, okay? So that's the first thing. You're going to get a good immune response because you're generating humoral IgG antibodies. You're going to have a memory response because you're involving T cells that are activating B cells, and those B cells are going to go on to have some memory B cells and also some memory T cells, and you're going to have these plasma cells pumping out IgG antibodies. The other part of this, let's go back a second. We said, okay, we went down this MHC2 pathway, and that MHC2 pathway allowed me to generate a very strong humoral response that involved class switching because we had T cell activation. What about if we go down the other road? Is it possible that this dendritic cell would present this antigen on MHC class 1? Okay, is it possible? Well, what would have to happen? Well, instead of the dendritic cell phagocytosing this pathogen, let's say this is a virus, right? Instead, maybe this virus infects this dendritic cell. Okay, so maybe instead of the dendritic cell phagocytosing it, the virus actually infects the dendritic cell. Now, if it does that, right, if this virus starts to put its viral material in this dendritic cell, we talked about this when we talked about these MHC receptors, this material is going to get broken down, put in the rough endoplasmic reticulum, and it's going to get sent up to this MHC1 receptor, okay? So now this is on MHC1. So what's MHC1 going to bind to? Well, if it's going to bind to anything, it's going to bind to cytotoxic CD8 positive killer T cells, right? So these again are T cells, but they're CD8 positive T cells. And again, the T cell receptor and the CD8 positive co-receptor are going to bind to this MHC1, and then this cell, realizing that there's something not normal here, right? Something that's not a self-antigen here, there's going to be perforins and other enzymes that are released to destroy this dendritic cell. And we're going to start to get some memory response from the T cells. Okay, so you're going to get a cellular mediated response. Remember, when you have these CD8 positive T cells destroying these dendritic cells or any cells in the body, that's going to be a cell mediated process. And so we say there's a cellular response or a cell mediated response and a humoral response. You can actually get both from a dendritic cell, right? Because the dendritic cell can phagocytose this, presented in MHC class 2, or the dendritic cell can actually get infected with this and then presented on MHC1 like a normal cell would. And because of this, we can get a cellular or cell-mediated response. Okay, so you can get a cellular response, and we can also get a humoral response. So we can get both because we gave this patient a vaccine that had a live pathogen. This patient shouldn't get sick, right, when they get a varicella vaccine or when they get a yellow fever vaccine, but they can get sick, right, because some of these pathogens can actually alter their virulence factors, right? This pathogen can alter some of these virulence factors, and it can actually then become pathogenic. Okay, so it can become pathogenic potentially, but that's not extremely likely. Now, where are we concerned about these pathogens potentially increasing their pathogenicity? We're primarily concerned about that in patients that are immunocompromised, right? Patients that don't have a good immune system are going to have a tough time responding to organisms that have acquisition of new virulence factors. Okay, now what patients are we going to be really concerned about in this category of immunocompromised states? Number one is infants. Now, most infants, and these are children younger than a year of age, most of them are not going to be getting these live attenuated vaccines. There's one exception to that, and that's the rotavirus vaccine. So the rotavirus vaccine is actually designed to be given usually around the first 6 weeks of life. Okay, there are some contraindications to the rotavirus vaccine, things like intussusception or history of GI tract malformations like a microdiverticulum. And this is more of a step 2 thing, but the reason for that is because you can have lymphoid hyperplasia in the Peyer's patches and you can end up with intussusception, right? Because this is generating an immune response, and so you can get lymphoid hyperplasia in infants. The point is, though, is that if you're going to remember, there's one exception to live attenuated vaccines. It's the rotavirus vaccine in infants. In the elderly population, we also will tend to start to avoid some of the more live attenuated vaccines. Pregnant females, same thing. These are kind of your big 3. And then always remember transplant patients that we're giving them immunosuppressive medications, or patients that have AIDS. Okay, so a patient that has HIV, this comes up pretty frequently. Now, let's say that this patient, you have to decide, hey, I have a patient here that has HIV. Do I give them their, varicella vaccine, for example, if they haven't had it? And how do you make that decision? Well, you have to look at the CD4 count. So if the CD4 count is greater than 200, right, which is usually the cutoff here, when we're talking about, an opportunistic pneumonia versus a normal pneumonia, we're going to look at the CD4 count, right? If you have a low CD4 count, you're significantly predisposed to opportunistic infections. If you have a normal CD4 count, even though you have HIV, it doesn't necessarily mean that you would have an opportunistic infection. The same is true here. You're not really considered to be extremely immunocompromised if you have a CD4 count greater than 200. However, if the CD4 count is less than 200, especially if it's significantly less than 200, these patients should not be getting live attenuated vaccines. However, the patients that have CD4 counts greater than 200, that's usually going to be okay to give them, especially in a board question. Okay, and the big vaccines here, like I said, you do have to commit some of these to memory. Varicella and MMR are probably the 2 highest yield, but you do frequently get questions where you have to distinguish different types of vaccines. So I would be familiar with the fact that the intranasal influenza vaccine is a live attenuated vaccine, whereas the intramuscular influenza vaccine is an inactivated or killed vaccine. In one case, you're giving them a live influenza strain. In the other case, it's a killed influenza strain. And we'll talk about that in a moment. And you're not really going to see intranasal influenza being given much in the United States. You'll primarily see the intramuscular variant. And then also remember that polio vaccines, there's 2 types. So you have Sabin and Salk. Okay, remember the Sabin is the live attenuated form, and the killed form is the Salk. And the way that I kind of remember that, okay, so the last letter is K, and these are going to be completely inactivated vaccines. And we'll talk about this in a minute. And so I remember that K for killed. So this is going to be a killed organism that we're giving the patient. And I always look at that last letter to distinguish the 2. So K for killed. That's my easy way of remembering that. But you do have to distinguish these very frequently, so I would be familiar with them. And then BCG for tuberculosis, we'll talk about that probably in a future video. And then we also have smallpox here as well. But the big one here, I would say, especially for the US, know your varicella, MMR, rotavirus. It's going to be the exception in infants. And then for travelers, you'll see yellow fever occasionally. Not really going to give a whole lot of intranasal influenza in the US. Or the polio Sabin for that matter. And in the next video, we'll talk about some of the other variants here. All right, so moving right along, let's talk about the whole inactivated vaccines. And so this is going to be a non-replicating, as opposed to the live attenuated, non-pathogenic, again, as opposed to the live attenuated, virus, bacteria, or some type of pathogen potentially. And again, the idea here is that in the previous example, right, I gave this pathogen to this patient essentially. I just kind of decreased its pathogenicity in some way. In this situation, I'm going to just kill this organism and then give it to the patient. That's essentially the difference. So this organism cannot replicate. It cannot infect cells. And you might be saying, okay, well, how does that differ when you start to talk about some of these different pathways in the immune response? Well, let's think of it this way, right? If I just gave this patient a killed organism, can the dendritic cell still present a killed organism's antigens on MHC2? And the answer to that question is absolutely, right? This dendritic cell can still find this killed organism that's floating around there in the blood or the lymphoid tissue, and it can go up to it and it can phagocytose it, right? And so this dendritic cell can phagocytose this pathogen, and in doing so can present it on MHC2. And so that answers kind of the first question. If I can put it on MHC2, I know that I can get CD4 positive T cells to bind to that, right? And that can cause eventually B cell activation, CD40 ligand binding, class switching, and I can generate IgG antibodies to this pathogen. So I can generate humoral IgG antibodies to that pathogen, right? And that's what we also saw with live attenuated, right? We saw we could get a humoral response there with IgG antibodies, memory response, right? From the class switching from the CD40 ligand binding. The question here is, well, I don't see cellular on this side. Why is that? Well, let's think about this for a second. So again, if I kill this organism, okay, so remember now I'm killing it, can a killed organism infect a dendritic cell? Probably not, right? If this organism's killed, it's not going to be going around infecting dendritic cells. So can I present it on MHC1 on this dendritic cell? Probably not, right? Because it's not infecting the dendritic cell. For it to get onto MHC1, it's got to infect the dendritic cell. And in doing so, when a cell is infected, when any normal nucleated cell is infected, it's going to present that antigen saying, hey, this is a virus inside of me, or this is a cancer. This is not normal. It's not a self-antigen. I need to get basically this cell as a suicide cell, or a cell that needs to self-destruct and destroy itself because that cell is infected. Now you have cytotoxic T cells that come in and destroy those cells. If this can infect a dendritic cell, it's not going to get presented on MHC1. So because of that, you're not going to get a memory cell-mediated response, which is going to decrease the efficacy / immune response that you're going to get from a killed vaccine. So that's why I put on here, you're going to get a stronger immune response in general from a live attenuated vaccine. Now, what's the upside to these killed vaccines then? Well, a big upside is you don't have to worry as much about acquisition of virulence factors causing higher pathogenicity because the organism's killed, right? We're not worrying about the organism getting stronger and causing an infection in an immunocompromised host. These organisms are killed, so it's very unlikely for that to happen. And the flu vaccine, which we're all probably somewhat familiar with at this point, and especially in the United States, you're going to see this given intramuscularly. And this is exactly what kind of vaccine this is, right? It's a killed inactivated vaccine. We're taking the influenza virus, we're killing it, and then we're giving it to the patient. And that's essentially what we're looking at. And so they should generate a humoral IgG response. However, over time, some of that IgG, if we're not exposed to it, we might lose some of that memory response over time. We might lose some of those memory cells. And so for some of these vaccines, especially as we go down, you'll see there will be boosters that are involved. You might be saying, oh, is that why I get a influenza shot every year? Not quite. The reason you get an influenza shot every year is because proteins on the virus are kind of mutating or changing. And essentially, we're trying to predict every year what those proteins might be. And that's when that's what your flu shot is for. But in general, as we start to go this way, right, particularly when we get down to this polysaccharide inactivated vaccine, we're going to start to talk about why boosters become so important, okay? And you'll see hepatitis A, also whole inactivated. And again, knowing the differences here, right? Hepatitis A is a killed vaccine, but hepatitis B in particular is going to be a subunit protein that we're going to be giving the patient, particularly that Hep B surface antigen. And then again, we talked about the polio vaccine, right? So you have the Salk and the Sabin. Remember the K at the end for killed here, and then the Sabin is the active, and then also Salmonella typhi is in this conversation as well. But essentially, that's the big difference, right? The big difference is you're not getting a cellular response because the virus is killed. It's not infecting the dendritic cells to then have it be presented on MHC1. So that's the concept. So let's talk about these subunit protein inactivated vaccines. And so essentially what we're doing here is going back to our pathogen. We're saying, okay, look, we know that there's specific proteins on some of these pathogens that we can isolate. Instead of giving this patient the whole organism, let's just give them maybe a couple of those proteins. Okay, so maybe we just give them a couple of those proteins. And these proteins, we can then target these proteins and make antibodies against them. Okay, so we can take these antigens from this species, right, whatever it is that was on the cell surface, and we can make antibodies from that. All right, and so that's the concept. So we're just giving the protein components of the pathogen. So we wouldn't expect there to be any issues with, a replicating live pathogen or anything like that, because I'm just giving the proteins off of that virus's cell surface, for example, or from that bacteria. And again, you might be saying, okay, well, what kind of immune response are we going to generate here? When we can see it's humoral IgG. Why is that? Well, remember, if I have this antigen floating around in the blood, I can have a dendritic cell come up to that antigen. It can digest that antigen. Okay, so it can digest that antigen, and then that antigen can get displayed in MHC class 2 because I phagocytosed it with my antigen-presenting cell, and then eventually lead to the formation of antibodies, IgG antibodies from class switching. It's the same process we keep talking about. And again, you might say, well, was there a cell-mediated response from this? And the answer is no, right? There's not going to be one for the same reason we talked about when we talked about the whole inactivated vaccines, because this antigen is not a live organism infecting cells, right? It's not going to infect a dendritic cell. It's just a protein component floating around in the serum that we're generating antibodies to and phagocytosing. Okay, so for that reason, you're not going to get any cell-mediated response, again, with a subunit protein inactivated vaccine, right? You're just giving this patient a protein or an antigen from that pathogen. So you're only going to get humoral IgG response. If we're stratifying this is going to be in the middle somewhere in terms of its immune response. Pertussis is very classic. And then we also have hepatitis B, right? We talked about that a little bit in the last video. Hep B surface antigen, and we'll talk about this in greater detail when we talk about the microbiology section, but the Hep B surface antigen is going to be what we're targeting. So again, it's just like it says, right? If I have some virus here, if this is my Hep B virus, okay, I'll just put HB here for my Hep B virus, and on that Hep B virus, there's going to be certain surface antigens, okay? And instead of giving the patient a vaccine that has the whole Hep B virus, I might just give them the antigen, right? I might just give them what the antibody targets, for example. Okay, and then we can also see HPV is on here, and then toxoid vaccines. And what we're doing is we're essentially giving the patient this toxin, but its pathogenicity has been wiped, right? So it's not going to be causing disease, but it still has immunogenicity. Okay, so I can still make antibodies to it. So pathogenicity down, immunogenicity, we can still generate antibodies to, and that's the concept. Okay, so that's what we'll see with tetanus and diphtheria. And sometimes you'll see this vaccine, right? This is going to be a very classic vaccine, especially when you get to step 2. You'll see the Tdap vaccine, right? Tdap. So what does this stand for? So the T is for tetanus, right? That we just saw. Okay, so that uses a toxoid. Then we saw the D here. This is for diphtheria. Okay, and what is this AP? AP is what we have right here, right? AP is acellular pertussis. Acellular pertussis. Why does it say acellular? Because the organism is not being given. We're just giving the subunit protein with 2 toxoids. Let's start talking about the subunit polysaccharide inactivated vaccines. How does this polysaccharide differ from the protein variant? Well, to answer that question, let's start with a bacteria here. So we're just going to take some bacteria, and maybe this bacteria has a capsule. Okay, maybe this bacteria has a capsule, all right? And let's just say that this is a polysaccharide capsule. When I say polysaccharide, what I'm basically saying is that the capsule around the bacteria is made up of carbohydrates. It's not made up of proteins. Remember, proteins are peptides. Polysaccharides are carbohydrates, okay? These are different substances, different macromolecules. So what I'm saying here is, you know, if I'm thinking about making a vaccine for this bacteria, do I want to make a vaccine where I give the patient the whole bacteria? Maybe, right? That might be, you know, an option, giving them a live attenuated vaccine, but maybe I don't want to give them the whole bacteria, right? I don't want to worry about this thing potentially infecting my patient. So I just say, look, I'm just going to give them the polysaccharide. Okay, so if I just give this patient part of this polysaccharide capsule, maybe that can generate an immune response to produce some antibodies. Okay, so let's think about this. Can the dendritic cell see this polysaccharide as an antigen and then present it on MHC2? Well, here's the problem, right? A dendritic cell that may recognize this polysaccharide, you know, for example, it's not going to be able to put it on MHC2. And you might be saying, well, why is that? Why can't it just display it there? Because remember, MHC only displays protein antigens. Okay, that's something we talked about. It only displays protein antigens. This is not a protein. This is a polysaccharide. So I cannot display this on MHC2, which means if I cannot display this on MHC2, I cannot activate the T cells. I can't generate a memory T cell response, which means I can't then cause class switching to occur, which then means that I will only have IgM antibodies responding to this polysaccharide capsule. Now, in real life, it's a little bit more complicated than that. But remember, if you have B cells around that recognize this polysaccharide capsule, they can still make IgM antibodies, right? They can still do that. However, you might get an inflammatory response potentially, but it's not going to be a strong one. It's not going to be a super strong memory response, because if there's only polysaccharides around in this capsule, then this is going to be a T helper independent response. And we talked about this. This is only going to generate a humoral IgM response, not the IgG responses that we generated with all of these other vaccines. So this is going to be the weakest immune response that we've seen thus far among our vaccines, just from a general perspective. And the classic example of this is going to be the strep pneumo vaccine PPSV23. And this vaccine is also sometimes called Pneumovax. Okay, so this is sometimes called Pneumovax. And the reason that it's given, you might be saying, well, why do we even give this thing at all if it's so weak? Well, it covers a lot of different variants and strains of strep pneumo, okay, 23 of them to be specific here. And so that's why Pneumovax is sometimes given. There's 23 different serotypes that we can target. But the big thing is you start to get levels that decline after 4 to 5 years, depending on how robust your immune response is. And so you need very frequent boosters. And so that's kind of the catch. Because you're generating this IgM response only, you're going to need even more frequent boosters, even more frequent than you might need for some of these other vaccines. Okay, so that's something to keep in mind. There is a way kind of around this for certain vaccines where what we can do is we can take this polysaccharide and we can say, look, I can maybe attach this polysaccharide to something that might be able to get through this pathway. I might be able to attach this polysaccharide to a protein. Okay, because if I can attach this polysaccharide to a protein, then I can get this whole thing potentially presented to an MHC2 receptor. Okay, because then we have a protein component with it, right? And this thing here is essentially going to be my protein. Okay, so the protein, I can pick any protein that I can bind this polysaccharide to, and this whole thing together is going to be called a conjugate. Okay, so this whole thing, when I combine these two, this is going to be called my conjugate. Okay, so I'm essentially conjugating, I guess you could say, a protein to a polysaccharide. Okay, so that's essentially what we see down here, the polysaccharide plus the protein. And the idea is, now that I have this protein and this polysaccharide here, I can put that on my MHC2 because my MHC2 can certainly display the protein. Okay, and then I have my polysaccharide here. And now these T cells can essentially bind to this MHC2 and we can still generate antibodies with class switching, right? Because now I can go down this pathway and I can get IgG antibodies. So I can get a humoral IgG antibody because I have a protein component now that this dendritic cell can display. And again, will I generate a cellular immune response? The answer is no, right? This thing, which is part of a bacterial wall attached to a protein, dendritic cells will phagocytose it, but the dendritic cells will not be infected by it per se. And so the classic example of the vaccine here is going to be the PCV13 vaccine. And the PCV13 vaccine, this is sometimes known as the Prevnar vaccine. The easy way to understand these vaccines that fall into the polysaccharide / conjugate category is just remember, if you have a patient and they have a splenectomy, what are the organisms you vaccinate for, right? It's these organisms because they all have capsules, polysaccharide capsules. Okay, so you can see strep pneumo, meningococcal vaccine, right? Haemophilus influenza type B, right? And again, strep pneumo for patients that don't have spleens. And we already kind of talked about that, so I won't go into too much detail on that. The last thing I want to talk about here, just really briefly, just be familiar with, some of the RNA vaccines, specifically the mRNA vaccines. We're essentially taking, a strip of code, putting that in our host. Okay, so let me kind of illustrate this here. So instead of putting in a polysaccharide or a live bacteria or virus, what we're doing is we're putting in a strip of code. So I'm just going to kind of put this out here. So this is just some strip of mRNA. Okay, and so this strip of mRNA is going to have a specific code on it. And we're going to put that in the host. The host will have cells that take up that mRNA. And our cells will then generate specific proteins from that mRNA. Now, in the example of COVID-19, quite simply, we'll generate spike proteins. Okay, so our own cells are making the spike protein from this code of mRNA that was given to the host, right? Now our own cells take up that mRNA and we start translating that mRNA and start making these proteins here. So we start to make these spike proteins and then we make the spike proteins, right? Our own cells make them and then we make antibodies to the spike proteins that our own cells made. So that, I know it's kind of confusing, but again, this is not super high yield at the time of this recording, although I do think that it will start to become asked about a bit more frequently as this is certainly a global phenomenon right now. And again, the classic example for this would be the SARS-CoV-2 virus or COVID-19. The last thing I want to say is that for some of these vaccines, especially the polysaccharide vaccines, you can give things like adjuvants. Okay, so you can give things like adjuvants. And an adjuvant, essentially what this is is it's something that will allow for there to be a higher, stronger, more robust immune response. And we don't have to go into a ton of the details on this because it's kind of in that medium low yield rating. I just thought I'd bring it up. But the big one to be familiar with when you're talking about adjuvants is aluminum. Okay, so aluminum is the one, if you're going to remember any, you give the patient aluminum inside of that vaccine or as a component of that vaccine, it can tend to boost the immune response under specific situations. So just something to be familiar with. But hopefully now you have a little bit of an understanding of these different vaccines. And I always just go back to the simple pathway. If you're ever in doubt, right, is it a protein? If it's a protein, you know it's going to go on MHC2, right? If it's not a protein, it's not going to go on MHC2. If it doesn't go on MHC2, you're not going to get class switching, right? That's the concept. If it's live and it's infecting cells, you're also going to get a cellular response. Because if this dendritic cell gets infected, CD8 positive T cells will also be activated. So that's the concept. Remember which vaccine goes where. Remember polysaccharide, just think, what are the things you vaccinate against if you have a patient that has a splenectomy? Those are the vaccines we're talking about. And then I think you can pretty much, I just remember the subunit protein here as pretty much Tdap with hepatitis B in there. And then the whole inactivated versus the live attenuated. I think a lot of these make a lot of sense because we don't give live attenuated influenza vaccines. And then I already talked about identifying polio, right? Remember the K in Salk for killed vaccine or whole inactivated versus Sabin, right? And so I think some of these will make a lot of sense once you go through this once or twice. Take 15 seconds to pause the video, read the question, and then we will go through the answer. Okay, so we have a research group attempting to identify the effectiveness of SSVK, a vaccination against Shigella sonnei bacteria. All right, isolated Shigella sonnei were grown in broth containing deoxycholate. Formalin was added to the vaccination sample for complete inactivation of pathogenicity. In preclinical trials, the vaccine demonstrated immunogenicity against various strains of Shigella sonnei infected mice. Okay, great. Response per participant was recorded as strong or poor using cutoff serum values of specific immunoglobulins. Data collected is shown below, which the following most likely describes the SSVK vaccine. Okay, so I think we're trying to figure out what type of vaccine this is. You know, there's definitely some clues here off the bat. You know, just from reading this line, there was complete inactivation of pathogenicity. So remember, you know, there's two different terms being thrown around here. There's pathogenicity and then there's immunogenicity. You got to kind of keep these things straight, right? So pathogenicity, remember when we talk about pathogenicity, I'm primarily talking about, you know, the infectivity of this, you know, organism or of the vaccine, right? So if I give somebody like a live attenuated vaccine, it's not a very pathogenic vaccine, but it still can become more pathogenic, right? There could be spontaneous mutations or alterations that can make it more pathogenic, which is why, you know, if you give a patient, you know, especially an immunocompromised patient, a live attenuated vaccine, these patients are at higher risk of developing an infection, right, from that vaccine. So the point is you can have some, you know, inactivation of pathogenicity, but the fact that they're adding this formalin and there's complete inactivation of pathogenicity already kind of takes me kind of out of the realm of the live attenuated. Now remember, this is different though than immunogenicity. It's referring to our ability to generate an immune response, right, from that vaccine or from that antigen, whatever it is. So we can have a really high immunogenicity. We can generate a really strong immune response from something that's not very pathogenic. Conversely, right, you can have a pathogen that has really high pathogenicity. It can cause really harmful disease, but it's not very immunogenic. It's difficult to destroy, right? So, or at least difficult to generate an immune response against. We're looking at specific immunoglobulins, right? So they have the specific idiotypes to SSVK here. So let's see if we see anything significant. So they said that response per participant was recorded as strong or poor, which is what we see here, using cutoff serum values of specific immunoglobulins. And I can see that all the participants here were accounted for. So there's 73 participants in each of these specific diagnostic buckets here. So again, SSVK specific serum IgG. Okay, so it looks like overall, these patients that were inoculated developed a pretty strong response, generally speaking. A couple people did not. Serum IgA, same thing. Pretty strong response throughout. Fecal IgA, again, pretty strong response. So this is significant because we know that this vaccine allows for class switching, right? So that's the significance of these, because in each of these situations, right, we would need class switching to occur. Okay, we would need class switching to get this robust response of immunoglobulins that are not IgM. SSVK specific CD8 positive cytotoxic T lymphocyte assay. Okay, so they're telling us these are essentially looking at the amount of CD8 positive T cells that are responding to this antigen, I suppose. And the strong response here is 0. So this is interesting. So, I mean, this is basically telling us that, look, we have humoral immunity, right? So we have humoral immunity, okay? So we have humoral immunity. And we know that the antigens are T helper dependent antigens. And you might be saying, where are you getting all this information from? Okay, I'll kind of walk you through this in a second. We talked a lot about this, by the way, in the vaccine videos, if you haven't watched those already. But the thing that I know that that's not happening here is we don't have cellular immunity. Okay, we don't have cellular immunity. And how do I know that? The fact that this CD8 positive assay to SSVK specific CD8 positive T cells, we pretty much don't have any T cells that are responding with cellular immunity to this antigen. What does that mean? That means that this antigen from Shigella sonnei is not invading our host cells, right? It's not invading antigen presenting cells. Remember, if I have an antigen presenting cell here, right? Just going back to the basics. And again, we go into way more detail in the vaccine video, but all of the nucleated cells in the body should have an MHC1 receptor. If I had a virus that was invading a host cell, right? Let's just say it invaded, epithelial cells, invaded, tissue throughout the body, but it also can invade antigen presenting cells, right? This virus can essentially get into this antigen presenting cell, and then these viral particles that we end up producing in our host tissue can get presented on MHC1. And these MHC1 receptors containing the antigen can then present this to a CD8 positive T cell, and this whole thing can go on to produce cellular immunity, right? Eventually, what we probably do, we would probably end up destroying this antigen presenting cell using perforins and granzymes and that sort of thing. But the key thing that you had to understand here is that we had to either infect this antigen presenting cell using a live strain of bacteria, right, that had some pathogenicity, right? It has to have some pathogenicity to do this. Or the other option is I could have given this patient a DNA or an RNA sequence, and instead of there being a virus that infected the cell, I could have just given this patient some RNA or DNA that goes into the antigen presenting cell and then codes for all of these different receptors, right? Or all of these different antigens that then get presented to MHC1 and then goes on to activate a CD8 positive T cell. And again, this is not just happening in antigen presenting cells. I'm just using antigen presenting cells so I can juxtapose it to humoral immunity, but this can happen in any cell, right? Because all nucleated cells should have MHC1 receptor. So the point is, again, I either had to infect this cell, right, with an intracellular pathogen, or I had to inject DNA or RNA so that the host cell can produce viral particles that get presented on MHC1 receptors to CD8 positive T cells. I can tell you off the bat, just reading this line here, complete inactivation of pathogenicity, that if there's complete inactivation of pathogenicity, then we know we're not going to get cellular immunity. This is probably not a live attenuated vaccine just for that reason. If I look at this specific CD8 positive cytotoxic T lymphocyte assay, I can see there's no response really at all here. In general, there's a poor response. So I would assume that there's not very good cellular immunity. Now, live attenuated vaccines, the big difference between a live attenuated, a whole inactivated, and a subunit polysaccharide is the live attenuated has cellular immunity. And I know that there's probably not any cellular immunity going on, at least that's what's suggested in multiple ways by the question. So it's probably not live attenuated. DNA sequence vaccines are not very high yield in general. Again, this involves kind of injecting DNA in so that we can produce an antigen. Same thing with RNA sequences. We talked a little bit about them in the vaccine video, but essentially it involves kind of like injecting the code to produce the antigen by our own cells, which is what you see with some of the early, novel coronavirus vaccines. But in both these situations, because we're producing these antigens, they can get by host tissue, they can get displayed on MHC1. And so these can induce cellular immunity. Okay, now this is another situation where you might not have necessarily known that specific fact, but there are other clues in the question to kind of get you to a more reasonable answer, which is the whole inactivated vaccine. Okay, so the key thing here to understand between the whole inactivated and the subunit polysaccharide is both of these can allow for humoral immunity. So essentially what's happening here, again, we're going to take our same kind of antigen presenting cell here. The difference here is, right, so these antigen presenting cells, they're going to have the MHC1 receptor, just like the MHC2 receptor, right? So they have their MHC1 receptor. I'll just put 1 here, and they're going to have their MHC2 receptor. Okay, so this MHC2 receptor is going to basically allow us to present extracellular pathogens or antigens from those pathogens. Because what happens is, right, if I have a bacteria like Shigella, right, if I have this bacteria around and I phagocytose this bacteria, now I can take components of this bacteria like an antigen and display it on an MHC2. The MHC2, right, 2 times 4 is 8, right, rule of 8s. This can bind to a CD4 positive T cell, and then this can stimulate humoral immunity. And you might be saying, well, can't you do that with live attenuated vaccines too? Yeah, absolutely. You can still go through that same process with a live attenuated vaccine also. This is why live attenuated vaccines, will allow for cellular immunity and humoral immunity, right? And we go through like all this, like I said, in the vaccine video. But the whole inactivated vaccines, these don't allow for cellular immunity because the pathogen is dead, right? We've completely inactivated it. They said here, they put it in formalin, it's completely inactivated, and you can see that there's no cellular immune response. So a whole inactivated vaccine does not have cellular immunity. It does have humoral immunity though. It has humoral immunity because we can still produce antibodies to this. This antigen presenting cell can still present this to CD4 positive T cells, right? And we can eventually undergo class switching as this binds to a B cell, right? CD40 ligand, and that can allow for humoral immunity, right? Antibodies being generated. Now you might be saying, well, what's the difference between the subunit polysaccharide vaccine? The difference is, in the case of a subunit polysaccharide vaccine, this is a T helper independent response. So in the case we just saw here, where I gave the patient the whole inactivated vaccine, in that situation, we were able to display the antigen on MHC2 to get the CD4 positive T cell activated, and B cells can do the same thing. They can bind to CD4 positive T cells or T helper cells and then cause antibody production through class switching. What happens here, if you have a subunit polysaccharide, you don't have a protein antigen, right? So all of this binding here, these antigens, they're all peptides. They're protein antigens. The difference here with the subunit polysaccharide is, again, it's polysaccharide. It's not a peptide. So this might activate a B cell. A B cell might phagocytose a pathogen, right, a capsule or something of that nature, and then produce IgM antibodies. But it's T helper independent. For you to get the T cells involved, you need peptide antigens, right? These are peptide antigens. Okay, in both situations, these are peptides. If you don't have peptides, right, you're not going to get a T helper dependent response. So the difference between a whole inactivated vaccine and a subunit polysaccharide is the T helper response. And a whole inactivated, it's a T helper dependent response, right? You can get class switching, which means that you can get IgG, IgA, right? If you have a T helper independent response, the only thing you're going to have is IgM. Right, you're only going to have IgM. So that's why it's probably not a subunit polysaccharide, because we can see a strong response from the participants with both IgG and IgA. Hey everybody, Dr. Roviso here. In this video, we're going to talk about immunodeficiency syndromes. And the easiest way for me to kind of organize these is going to be to put these into categories like B and T cell variants, immunoglobulin variants, and then we're going to have some additional diseases that don't quite fit as neatly into these buckets. And there's a lot of different ways that you can organize this information. Again, we're going to focus on the high yield, and we're going to talk about what can we use from kind of the basics that we talked about before to distinguish some of these different diseases. We're going to start off with severe combined immunodeficiency. Now, this is probably one of the highest yield overall. When we're talking about SCID, or severe combined immunodeficiency, we're talking about involvement of both B and T cells. And so in your mind, when you're thinking about these different pathologies, you want to ask yourself, are there T cells involved and are there B cells involved? And if there's T cells involved, we know it's going to have some impact on cell-mediated immunity. Okay, because we need T cells, cytotoxic T cells, to destroy cells displaying antigens on MHC1. And when we're displaying an antigen on MHC1, a lot of times that's going to be a virus, right? An intracellular pathogen that's infecting that cell. And we talked about all of this in the last few videos, so I won't go through all the details on it here, but check out the last few videos. If you're a little confused by any of this, we go through all of the basics there. If I knock out my T cells, I'm going to knock out cell-mediated immunity. So things like viruses, for example, will actually favor this. Viruses are going to have a really easy time infecting our cells if we have poor cell-mediated immunity, right? If I knocked out my T cells, for example, because then I don't have cytotoxic T cells to then go and destroy cells that are displaying the virus antigens on MHC class 1. The other thing I need these T cells for is I need T cells and B cells to come together, right? So that I can generate class switching. Okay, so I can change the heavy chain on my immunoglobulins. Remember, most immunoglobulins are going to be IgM. But if I want to generate a memory response with immunoglobulins like IgG, for example, right? If I want to use IgG, I'm going to need to have class switching. Okay, so memory response can also be impacted if I knock out my T cells or my B cells, right? And the same concept is true when we talk about antibodies like IgA. I need IgM to class switch to IgA so that I can fight off things like certain parasites, right, that are going to be in the GI mucosa, where I'm going to have a lot of IgA. Things like Giardia, for example, are going to flourish in patients that have some problem producing IgA. And then, of course, we also talked about IgE being in this category. And in general, if I knock out my B cells altogether, I might also impact some of my humoral immunity just in general. So when I think about IgM, IgG, IgA, IgE, all of these might have some impact. I might have a pan-hypogammaglobulinemia. In other words, I might have a decrease in all of these immunoglobulins if I knock out my B cells altogether. And so the point of this is just from looking at this, right, you can kind of say, okay, look, I went through all of the physiology, I understand the mechanisms here, so all I have to do is figure out, okay, what's the problem? If I know what the problem is, right, if I knock out this T cell, well, guess what? I'm not going to have great cell-mediated immunity. I'm not going to have T helper-dependent antigens because I don't have B cells to bind to T cells with CD40 ligand because my T cells are knocked out, right? Even if I have functional B cells, that might be a problem with class switching and generating a good memory response. Because remember, not only do these B cells undergo class switching, but these B cells will also undergo affinity maturation as soon as they bind to these T cells and then get activated. And let's talk about some of these different pathologies. So again, going back to severe combined immunodeficiency, the thing that you want to know here is there's really a couple different, reasons that this disease comes across. And this is the big thing. When you're talking about step one, you got to know your pathophys. What's causing each of these diseases? So with severe combined immunodeficiency, the classic defect is in the interleukin-2 receptor. Now, this should make some sense to you, right? We talked about interleukin-2 in the cytokines video. You can go back and check that out. But the point there is that interleukin-2 receptor is very involved with growth of lymphocytes, right? It's very involved. You can even have autocrine signaling with interleukin-2. If you remember from that video, we talked about that. That's kind of the high yield thing to remember. You can have all different types of signaling, autocrine, paracrine, endocrine signaling from interleukin-2. And this allows proliferation of lymphocytes. So guess what? If this is defective, if those receptors are defective, I'm going to have a tough time mounting a strong immune response and generating the necessary T and potentially B cells. And this is the most common mutation that you'll see in SCID. And the classic inheritance pattern here is X-linked recessive. Now, you have to kind of juxtapose that to adenosine deaminase deficiency, which is autosomal recessive. And the difference here, the pathophys is completely different, right? Because interleukin-2 is responsible for T cell growth, right? So the interleukin-2 we talked about, this is primarily responsible for the growth of lymphocytes, right? So we're thinking lymphocyte growth. And so that's why if I knock it out, I'm going to have a very tough time mounting a strong immune response, or at least having lymphocytes that are going to be able to fight off my infections. Now, with adenosine deaminase deficiency, the difference here is that, remember, what adenosine deaminase does. So let's just say I have some adenosine, okay, maybe some deoxyadenosine here. So these substances can get converted to hypoxanthine, okay, this is going back to your biochem, as well as uric acid by adenosine deaminase, right? ADA, I'll just put for adenosine deaminase. So adenosine deaminase converts these substances to hypoxanthine and uric acid. And the whole point of this is so that we can eventually just excrete these substances in the urine, right? Kind of as waste products. So these can just get excreted from the body, okay? So this is part of your purine metabolism, purine breakdown. Now the thing here is, if I don't have adenosine deaminase, for whatever reason, let's just say I don't have adenosine deaminase, now I'm gonna have a buildup of deoxyadenosine and I'll have a buildup of adenosine. So why is a buildup of this deoxyadenosine and adenosine a problem? Well, if we go kind of backtrack a little bit, so remember you have your ribonucleotide reductase, which essentially is gonna take ribonucleotides and convert them to deoxynucleotides. The point of this is essentially we want to take our ribonucleotides that we might use for RNA, for example, and we can convert the sugar group that we can use these structures in DNA. That's the point. So ribonucleotide reductase is going to generate deoxynucleotides. Now, deoxyadenosine is an example of a deoxynucleotide. So if I have a whole big buildup of this deoxyadenosine, for whatever reason, let's just say adenosine, right? If I have a whole bunch of this deoxyadenosine, what's going to happen is this is actually a product of ribonucleotide reductase. So it's going to have negative feedback on ribonucleotide reductase. Okay, and so this buildup of adenosine is going to inhibit the conversion of ribonucleotides to deoxynucleotides, which is a problem because then I can't use all of these ribonucleotides for DNA synthesis, right? I can't make deoxycytosine, I can't make deoxythymine, right? I can't make the other deoxynucleotides because I have this massive buildup of deoxyadenosine because I couldn't convert it because I don't have adenosine deaminase. And so we see a precipitous drop overall in the deoxynucleotides because of the buildup of deoxyadenosine. That's the point. If you think about lymphocytes in a newborn, for example, we're producing a lot of lymphocytes in that time period, and there's a lot of DNA that's required. And if I don't have the tools to make that DNA because I have low deoxynucleotides overall, right, then I'm not going to be able to make enough immune cells. And so adenosine deaminase is very classic for having a low B cell and T cell in the serum. Both of these are going to be extremely low in the setting of adenosine deaminase deficiency. Okay, so you can imagine if you knock out T cells and you knock out B cells because you can't make enough DNA to correctly make these cells, then there's going to be a whole host of problems, right? Everything under the sink, so to speak, is going to be involved. So that's adenosine deaminase deficiency. So completely different mechanisms, but they're both causing a similar variant in that we're affecting multiple cell lines and that we're affecting T cells and B cells potentially. That's the point here, that we can affect T cells and B cells. Now, the last thing on here is RAG mutations. I'm not going to go into too much detail on this, but remember we talked about what the RAG gene does. It's the recombinase gene that allows you to kind of shuffle some of the information in the cell so that we can produce different types of cells, right? All of that variation that we talked about. And we talked about this already in some detail. But again, these are the three classic causes. The two in particular to remember are going to be a defective interleukin-2 receptor, right? The lymphocyte growth receptor, and adenosine deaminase deficiency. Now, how does this present? Normally, in a lot of these different pathologies, we're going to have a normal newborn. Why is that? Because remember, the IgG antibodies can cross the placenta. So you can actually still have mom's antibodies as a newborn. And so you can still fight off some of the infections because of what you have from mom. But over time, what's going to happen is those antibodies have a half-life, and those are eventually going to start to come down. And so these children will often have failure to thrive, recurrent infections. Typically, this is going to be a younger patient, around 6 months to 12 months of age when this initially gets diagnosed. You can also see absent lymphoid tissue. Now, the point here is you want to be kind of sharp on, what in the lymphoid tissue is involved. Let's say I biopsy a lymph node. Okay, let's say I biopsy a lymph node and I tell you that, hey, this lymph node has little to no follicles or very small follicles or very small germinal centers, for example. What am I basically telling you? I'm telling you that the B cells are primarily involved, right? Because that's where the B cells are going to live. There's going to be dormant in primary follicles, active in some of the pale staining areas of the germinal centers, right? And so this would suggest potentially that B cells were probably involved, right? Now, on the other hand, if I told you that, hey, the paracortex is absent or hypertrophied, for example, a very small paracortex, we might be talking about T cells. This all goes back to the first video where we had to understand where do the B cells come from? Where do the T cells come from? And so it's kind of integrating that information. So you can get this information. You can get them telling you that they biopsied a lymph node and there's, very small follicles, low paracortex, the absent lymphoid tissue. This is all very classic, pushing you in the direction of a B and T cell disorder. And conversely, you can have a normal paracortex with very small follicles. And in that situation, you might be thinking maybe this is more of an isolated B cell scenario. Okay, so we'll talk more about that. But again, I don't want to get too off track. So in terms of the diagnostics here, the big one to remember are these Tregs. And so the Treg stands for T cell receptor excision circles. And I'm not going to go into, all of the detail on this. This is one of those things I would just remember specifically for severe combined immunodeficiency is that you can test for this using Tregs. And this is actually frequently done in the newborn screening. So they'll do, an assessment to look for SCID by trying to measure these T receptor excision circles. And they're going to tend to be very low. And part of that makes a lot of sense, right? You know that the T cell count is going to be low. And so this being some surrogate. The other thing you can classically see here is an absent thymic shadow. And this is not just something that you see in severe combined immunodeficiency. You can also see thymic hypoplasia or thymic aplasia in general when you're talking about DeGeorge syndrome, for example. Point here being when you see absent lymphoid tissue, right, paracortex, follicles, right, you're also expecting your thymus, which we already said is part of the lymphoid tissue. It's where the T cells mature. That's going to probably be absent if I don't have T cells, right? And so if you did flow cytometry, you would see very low numbers of T cells. And we already kind of showed that flow cytometry graph kind of earlier in the series where you can kind of have two lines going each way, and sometimes you'll see a bunch of dots on there representing certain cells. And so sometimes you'll see, a CD marker, it'll be CD, and then some number here that would represent that this CD marker is present in your flow cytometry sample. And then you'll have another one here, right? And so this one, you might see no dots here, or you might see dots up here, meaning that it has a combination of the two, for example. But the point is you have to know these CD markers to understand these flow cytometry graphs. So for T cells, right, what's the classic CD marker that you want to be familiar with? You really want to be familiar with CD3. Okay, so CD3 is going to be pretty much on all of your T cells. So if I gave you one of these graphs, for example, right, and I said that, okay, this person's CD3 is here, maybe they only have a dot here or a dot here. They have very little CD3 detected in that sample. Well, that will tell you that the T cells are very low. That's something we would expect in severe combined immunodeficiency. You can also see extremely low levels of serum immunoglobulins of all isotypes. And the point here is remember, if I don't have functional B cells or I don't have T cells that can allow activation of those B cells to undergo class switching, in those situations, I'm going to have low IgG, IgA, and IgE. And because, especially in adenosine deaminase deficiency, right, we're not going to have any B cells either. And so I'm not even going to get IgM. So all of these are going to be knocked out. So all of my immunoglobulins, all isotypes are going to be low. Let's say that you had a newborn and you're testing your immunoglobulins after the first couple of days of life. Well, sure, you would expect the IgG levels to be relatively normal at that point, because remember, you still have mom's antibodies. But if we're talking 7 or 8 months out, then in a patient that has SCID, you would expect the serum immunoglobulins generally to be very low. Okay, let's talk a little bit about Bruton X-linked A-gamma globulinemia. How does this differ from severe combined immunodeficiency? The point here is, normally when we're talking about SCID, we said that there's probably going to be involvement of T cells, and in certain variants, we can also have involvement of B cells. But the difference between the two diseases here is that with Bruton's, we're just talking about B cell involvement. So our cell-mediated immunity should actually be functional in these patients. The issue here is primarily going to be with B cells. And if I don't have B cells, we're going to have major issues with our immunoglobulins. Okay, so B cells are going to be very, very low. And that's because this step, this BTK gene, allows for our B cells to essentially get out there into the circulation. So if I don't have this gene working, my B cells are not going to be able to get into the blood and eventually into the lymphoid tissue. And so my B cells, essentially, if I had some bone marrow here, right, so here's my bone marrow, my B cells are going to just be kind of sitting here in the bone marrow as pre-B cells. Okay, they're never going to make it out into the bloodstream, right? If here's my bloodstream, and then eventually maybe I have some lymph node, right, that these blood vessels are eventually going to kind of go into, right? I'm never going to be able to get these B cells out into the blood because I don't have this functional BTK gene. And so all of these pre-B cells are basically going to stay here, and in the blood, I'm not really going to have any B cells. And if I don't have any B cells, right, I'm going to have a hard time making IgM. I'm going to have a really hard time making any other immunoglobulins in general because I can't class switch, right? I'm not going to have B cells to bind to T cells to get activated to become antibody factories or plasma cells. Okay, so if I did flow cytometry on these patients, I'd see very low levels of CD19, 20, and 21. So what would that look like, right? So if I did flow cytometry on one of these patients, for example, right, and let's just say that this was CD21 and this was CD3, I might have, some level of CD3 that is normal, right? I might see a lot of dots representing CD3. And maybe I don't have any, dots at CD21, for example. And there's a lot of different ways they can show you this. But the point being, Bruton X-linked A-gamma globulinemia would be in my differential. And again, if you go back to the name, remember we said that combined and SCID kind of makes me think of B and T cells combined, right? But when I'm thinking of this name, right, I'm looking at A-gamma globulinemia. It pretty much tells you what's going on. A meaning without immunoglobulins in the blood, right? I don't have immunoglobulins, and why don't I have them? Because I can't get these pre-B cells into the bloodstream. Okay, and so that's why, again, if you know your CD markers, you can see a flow cytometry question, and you can say, look, I know there's no CD19, I know there's no CD20 or CD21, I know that my B cell levels are very low, but in some way, the T cells will be functional, right? They can show you CD3 on here, they can show you a lymph node and show you that the paracortex is completely normal, but there's, follicle atrophy, for example. Again, just putting all the pieces together with T cells and B cells like we talked about, you can distinguish these two different diseases with that information. And again, we just talked about this, all isotypes should be affected in Bruton's X-linked A-gamma globulinemia. I also want to talk about common variable immunodeficiency because it often gets confused with Bruton's X-linked A-gamma globulinemia because they're similar in that they both affect B cells, but they affect the B cells differently. Now, for most of these different pathologies, the presentation, it's going to be tough to just use the presentation to just say, okay, I'm at this disease or this disease. Usually, you're going to have to know a little bit about the diagnostics, the CD markers, the flow cytometry, what's affected, right? The pathophys. That's going to get you a lot of the answers on step one. But when you're talking about Bruton's and common variable immunodeficiency, the presentation actually can be relevant in that with common variable immunodeficiency, it tends to be less severe. And so these patients will typically present a little bit later in life. usually post-puberty. The classic age range for questions is like between 20 years old and 40 years old. So if you have a patient that has recurring infections at 20 to 40 years old, and then they start giving you some clues that there's potentially very low immunoglobulins, right? You might be saying, well, could this be Bruton's? Well, probably not, right? Bruton's is going to be no B cells. And so these patients, as soon as they lose mom's IgG, they're going to start to present with symptoms. Whereas with common variable immunodeficiency, these patients will tend to present much later in life with low immunoglobulins and plasma cells. Okay, and the pathophys here is also a little bit different. With Bruton's, we were basically saying, look, we can't get any of those B cells out of the bone marrow, right? So we effectively have no B cells. The difference here is that in common variable immunodeficiency, we actually have B cells. We have normal levels of B cells. So on flow cytometry, we wouldn't expect to have no CD19 or 20 or 21 markers. We would see them. However, the issue is that we have B cells, but they don't work correctly. So the issue here is that we do have B cells here in the bloodstream, right? These are my B cells. So I have B cells, okay? I have B cells, but the issue is that they don't work. My B cells don't work correctly. So they can't produce the antibodies. They can't turn into plasma cells in these patients. Okay, so that's the big difference between these two. One of them, we have no B cells. One, we do have B cells. They just don't work correctly. One of the things to kind of remember here, medium low yield, is that common variable immunodeficiency is sometimes associated with increased risk of certain lymphomas, autoimmune disease, rheumatoid arthritis. And again, the same concept when we talked about the lymph node is going to be true here. Because we have B cells, but they're not functioning correctly, we're not going to see germinal centers. We're not going to see follicles that are going to be very active in general in these patients. We would expect to have very small follicles or absent follicles in a lymph node. But again, the paracortex should be untouched because paracortex is referring primarily to our T cells. And we'll talk about thymic aplasia here. I won't go into, all of the details here. I think it's just important to distinguish these. So let's just talk about how thymic aplasia is different from some of the other pathologies here. Now with thymic aplasia, we're primarily going to be talking not so much about the B cells, but the T cells in particular. And the reason we're talking about T cells is because the T cells are going to be maturing in the thymus, right? We talked about that. Now, the issue here, again, you can see by the name, thymic aplasia, right? We're not really going to have a thymus. So if I don't have a thymus, I'm going to have a problem generating mature T cells, right? Because this is where pre-T cells, right, we're going to go. Remember that whole physiology we talked about, the whole mechanism of negative selection, positive selection, all occurring in the thymus from the pre-T cells. So if I don't have a thymus, we're going to have some major issues with making functional T cells. Okay, and why does this happen? Why don't I have a thymus? The issue is that we're going to have defective third and fourth pharyngeal pouch development. So this goes back to some of the embryology that we've talked about before. Third and fourth pharyngeal pouch are going to be very much involved with thymus development as well as the development of the parathyroid gland. And remember, the parathyroid gland is primarily responsible for calcium and phosphate regulation, okay? And we'll talk about this in more detail in the endocrine section. Again, I don't want to get kind of too off track. But the point here is if I have a patient that has very low T cells, but completely normal B cells, I might be going straight to thymic aplasia here. Now you might be saying, well, okay, well in SCID though, you can have very low T cells. And again, that's true, but the difference in thymic aplasia is they're going to kind of go on a little bit about this issue with the parathyroid, because remember, this pharyngeal pouch development is not only for the thymus, but also for the parathyroid. So if you have a patient that has hypocalcemia in the setting of extremely low T cell numbers, now you might really be pushed in the direction of thymic aplasia. And the way that some people remember this is catch 22, okay? So 22 is referring to the chromosome deletion that's involved, okay? So this is the deletion that causes this issue with the pharyngeal pouches. So that's chromosome 22, and then each one of these is a very specific kind of category of pathology. So the C, you can think of this as cardiac defects, specifically conotruncal defects. And we talked all about this in the cardiology videos when we talked about tetralogy of Fallot, we talked about truncus arteriosus, and those two are very classic. So if you have a patient that has tetralogy of Fallot, really low T cells, hypocalcemia, very classic for this thymic aplasia. The A stands for abnormal facies, and there's actually a variant of this. That's the velocardiofacial syndrome. And then the T, we've already talked about, that's going to be the thymic hypoplasia. The C is cleft palate, and the H here is going to be the hypocalcemia. And again, some of these questions, you have to integrate a couple concepts, but your radar should go up. We have two diseases now that we've talked about with T cell deficiencies. And they're quite different, right, between SCID and thymic aplasia. There's some very classic findings we would expect to see with thymic aplasia. And remember, they're not always just going to tell you the patient has hypocalcemia. Maybe they'll say they tapped the patient's cheek and, they saw some twitching, for example, or, they're testing for Trousseau sign using a manual blood pressure cuff, whatever it is. There's going to be some clue that tells you that, this patient potentially has this electrolyte disturbance, but they might not come out and say it for a lot of these different things. So you have to be prepared for that as well. All right. And again, for the diagnostics, low T cells, like we talked about, this is going to be pretty similar to what we talked about with SCID. The difference is we're going to have some defect in the parathyroid hormone, the calcium, also some of the classic findings we talked about. There could be a heart murmur, abnormal facies, cleft palate, all would be more classic for thymic aplasia. And the other point is, if in SCID, you might see the B cells might also be very low, right? You might have absent CD19, 20, 21 on flow cytometry with absent CD3. That would be very classic for SCID. Not classic for thymic aplasia. The B cells should be working in thymic aplasia, which helps differentiate it from Bruton's common variable immunodeficiency, as well as some of the forms of SCID. So now that we kind of have some idea about the T cells and the B cells, let's talk specifically about the immunoglobulins. And I like having this organized in this way because remember, in the last video, when we had defects with the BTK gene in Bruton's A-gamma globulinemia, we had pretty much wiped out all of our immunoglobulins. And we also saw that in combined variable immunodeficiency, where we had defective B cell development, and we just wiped out all of our immunoglobulins. But here, the difference is we're not wiping out everything in a lot of these cases. We're just focusing on one or two immunoglobulins that are going to call our attention to this specific disease. So we have to be able to kind of distinguish these. Remember, if we have a global phenomena of immunoglobulins being very low, we are going to start to think more so about the B cells being involved, as that's going to be upstream from this whole process if we go back to the diagram on the last video. But let's focus on these immunoglobulins here. Let's start with IgA. So the big IgA pathology here is going to be selective IgA deficiency. And this is going to come up very classically in board questions when they try to transfuse a patient. They start to transfuse the patient, and all of a sudden the patient goes into anaphylactic shock, and they're thinking, well, what's going on? We just gave this patient some blood. Why are they kind of having this kind of reaction? And the idea here is these patients will have very low levels of IgA in the blood. And the reason they might have those low levels of IgA in the blood is because they have antibodies essentially against the IgA. And so if you go back to talking about your type 1 hypersensitivities here and talking about IgE, let's just say that I have some mast cell or some basophil here. We'll just say it's a mast cell. And again, my patient might have antibodies against their own IgA. Okay, and so if that's the case, then we're marking our own IgA for destruction. So this patient might have very low levels of IgA. Maybe our body destroyed all of the IgA because we have antibodies against it. Some of those antibodies might be an IgE antibody against IgA. So let's go back to kind of the basics here for a second and just explain what's going on. So let's just say, we have some mast cell, and remember, we also have IgE antibodies in our blood, right? So IgE antibodies, and we talked about, having like an anaphylactic reaction. So here's my IgE antibody. I have an FC portion that's kind of docked up against that mast cell, and then I have a Fab portion out here, and that Fab portion is essentially binding to an antigen. So let's just say there's some, something we're allergic to. It could be, maybe it's an antigen from a bee sting or from a drug that we took, potentially that, that we have an allergy to, or maybe it's even something like peanuts, for example, right? Or it's something, a shellfish. And anyway, the point is that antigen binds to this Fab portion and can cause cross-linking of the IgE here with other IgEs that are on the mast cell. And the big thing that we have to remember here is that these mast cells, in response to the binding of this antigen, they can degranulate. So they can drop all of the granules out into the blood, and this process can set off a very strong immunoresponse, particularly using things like histamine, right? And then this can cause anaphylaxis, right? Anaphylactic shock from this massive widespread vasodilation. What's different here is that instead of this antigen here causing this whole problem, maybe, like we said, it's something this patient's allergic to. Instead of this antigen here, the thing that's causing these mast cells to degranulate is actually going to be an IgA antibody. If this patient's given blood that has IgA antibodies in it, this IgA antibody will bind to this IgE antibody in the host, and that binding will cause degranulation of the mast cell. So that's why we say that this patient here, the host that's receiving the blood, has anti-IgA IgE. Now read this carefully. Anti-IgA. This antibody is anti-IgA. It's against IgA. It's an anti-IgA antibody. And what type of antibody is it? It's IgE. So it's an anti-IgA IgE antibody, okay? And again, these patients are essentially allergic to IgA antibodies. So that's why it's called selective IgA deficiency. So again, if you have a board question, they transfuse a patient, they go into anaphylactic shock. There's a lot of different transfusion reactions. This is the classic one that you want to think about in that scenario, when you have an immediate reaction. Now that's pretty severe, but if we're just talking about, illnesses that can come from this, the illnesses in and of themselves are not so severe, okay? The anaphylaxis obviously is very severe if we transfuse this patient blood with IgA antibodies, but in general, just from an infection perspective, remember IgA is primarily going to be in the mucosal lining. So whenever you see IgA, you could develop respiratory illnesses, diarrhea. The classic thing to remember though is Giardia. When you have IgA deficiency, test writers love to ask about Giardia because IgA is very involved with preventing infections, or at least fighting infections with Giardia. The other thing that you can sometimes see here is celiac disease being very classically associated with IgA deficiency. Now remember, this is again where this gets tricky, where you want to know your isotypes. Sometimes when you test for celiac disease, there's different types of tissue transglutaminase antibodies. Okay, so this is the tissue transglutaminase. Okay, so when you suspect a patient has IgA, sometimes you test them for this antibody. Now, there's different types of the antibody you can test for. If you test a patient, right, a patient that has selective IgA deficiency, which is very much associated with celiac disease, if you test them for celiac disease using a tissue transglutaminase IgA antibody, well, guess what? That might come back negative, but maybe this patient actually has celiac disease. And the reason for that, remember, if this patient doesn't make IgA antibodies, right, they don't have any IgA antibodies, they're not going to have an IgA variant of tissue transglutaminase, right? It's going to come back negative no matter what, whether they have celiac disease or not. Okay, so that's going to be a false negative because that patient, we might think that they might not have tissue transglutaminase IgA antibodies because they don't have celiac disease, but in reality they do have it. They just don't have IgA because they also have selective IgA deficiency, which is very much associated with celiac disease. So just something to keep in mind. Now, in terms of the diagnostics here, again, of course, the big point is serum IgA is going to be low. Should your other antibodies be low? No, right? This is going to help you differentiate this from some of the other B cell disorders. Remember, if I knock out B cells, I'm going to essentially knock out all of my immunoglobulins like we talked about in the last video. But here, the other immunoglobulins are just fine. We're really just talking about IgA. All right, moving right along here to discuss hyper-IgM syndrome. So hyper-IgM syndrome actually makes a lot of sense. And the way to kind of just quickly get your mind around this is, remember, IgM is the only isotype of an immunoglobulin that does not require us to go through the class switching pathway. It helps you get to this pathology very quickly and the pathophys. Okay, so the classic defect is going to be the CD40 ligand receptor defect. So again, just going back to this here, in a healthy adult, we can see this T cell here, we see CD40 ligand, CD40, right? Remember, the CD40 ligand is usually going to be on the T cell, and the CD40 is usually going to be on the B cell. And so this is a co-receptor when we're going through activation of the B cell. By having that co-receptor there, we can get this patient to not only generate IgM antibodies, but also to generate IgG, IgA, IgE, IgD, right? So that's the concept. I need this CD40 ligand to undergo class switching. That's the point. Now, if I don't have that, then I have nothing for this B cell to bind to, and so I only make IgM because I can't get class switching. Remember, once that CD40 ligand binding occurs, the T cell can send over certain interleukins to determine what type of class switching we're going to undergo. But again, if I don't have this, right, I don't have class switching. That's the point. No CD40 ligand, no class switching. Now, I said before, how do I remember the different inheritance patterns here? Well, I don't remember anything that's autosomal recessive, but if something's X-linked recessive, X-linked dominant, or autosomal dominant, I want to know about it, right? So this is going to be one of those scenarios where you do want to remember that hyper-IgM syndrome is X-linked recessive, and this is going to fit right into the category with things like severe combined immunodeficiency. If we're talking about a defective interleukin-2 receptor, that's also X-linked recessive, as well as Bruton's 8-gamma globulinemia, which is also X-linked recessive. And childhood opportunistic affections, right? Opportunistic being infections we normally wouldn't expect to see, right? Pneumocystis is very classic, histoplasma, cryptosporidium. The other big one here that you want to remember is also going to be CMV. Okay, so these four are all going to be very classic in hyper-IgM syndrome. But the biggest thing is when they show you the diagnostics, you're going to see the IgM levels can be high, normal, but all of your other immunoglobulins are going to be pretty much deficient. Okay, and again, how do you differentiate this from common variable immunodeficiency and Bruton X-linked 8-gamma globulinemia? Well, again, you just look at the immunoglobulins. If all of the immunoglobulins are low, including IgM, well, then you're thinking more about a Bruton's or a combined variable immunodeficiency. But if the IgM is high or normal, now you're thinking more about a hyper-IgM. The issue is just class switching. It's that CD40 ligand binding that we're concerned about. So I just brought this table back from the last slide. So just a couple things here. If I have a T cell deficiency, right? So if I knock out my T cells, again, we're thinking it could be SCID and it could be thymic aplasia, right? This would be very classic, particularly if I had both B and T cells knocked out. I definitely want to start to think about SCID. Now, what about if I just have B cells knocked out? If I just knock out B cells, I might be thinking combined variable immunodeficiency or Bruton's X-linked 8-gamma globulinemia. Okay, so both of these would fall into this category. Now notice when I knock out this upstream, everything downstream is affected, right? Now on here, I just told you that if we have selective IgA deficiency, we would just be knocking out the IgA here. So the only thing we're primarily going to be getting, and it's not just to say Giardia, but Giardia is the big one, but the point is we don't have IgA, so we're going to get mucosal infections. We're not going to have issues with IgM, IgE, or IgG if we just knock out IgA. So this is going to be selective IgA deficiency. Okay, so selective IgA deficiency. Now, in hyper-IgM syndrome, the issue is over here. It's class switching, right? So in hyper-IgM syndrome, the issue is just class switching. So I don't have IgG, I don't have IgE, I don't have IgA, but I do have IgM. Because the issue is here, everything upstream should be okay, right? And so that's kind of how you got to think about this. You got to see how upstream is my lesion, so to speak, even though it's not a lesion, but how upstream is the defect from what's actually going on, okay? And that's how you can kind of make sense of this. Okay, the last two on here, not quite as high yield. Hyper-IgE syndrome is sometimes gets confused with hyper-IgM. In hyper-IgE syndrome, sometimes called JOP syndrome, the issue is that we don't really have our T helper 17 cells. And remember, these cells are very much involved with getting neutrophils and macrophages to the site of chemotaxis. If we go back, initially when we talked about acute inflammation, we talked a lot about this. And the T helper 17 cells are very critical with that. So you do want to remember T helper 17 cells and impaired neutrophil chemotaxis. And again, this is going to be one of those situations where if I don't have neutrophils, right, when we talked about acute inflammatory response, we need our neutrophils to help generate that response as well as our macrophages. And so if I can't get them to the site of the infection, we're going to have, walled off infections, abscesses, but we're not going to have inflammation because I can't get the neutrophils to the site of infection. This sounds kind of similar to what we talked about with leukocyte adhesion deficiency, where I couldn't get neutrophils to the site of infection because they couldn't adhere, they couldn't bind to the site. In this situation, I just can't kind of get the signal to them to get them over to the site of an infection or whatever it might be. But the point is we don't have inflammation here. Kind of similar to leukocyte adhesion deficiency in the sense that in that situation we didn't have pus, which is pretty much what we're talking about here. We can't get the neutrophils and the macrophages to the site of infection. And the way this is sometimes differentiated, and you can see there's other features here, coarse facies, eczema, but the way that you want to differentiate this is, again, you want to look at the labs. In leukocyte adhesion deficiency, we talked about some classic presentations, okay, and I won't go into all the details here, but there are certain markers that you're looking for, like CD18 in leukocyte adhesion deficiency. here, the diagnostics you're looking for are elevated IgE and eosinophils, which are very classic for this hyper IgE syndrome. And you can also see very low levels of interferon gamma. Now, there's really only two major diseases where you're going to see low levels of interferon gamma. This is going to be one of them. The second big one is going to be interleukin 12 receptor deficiency. Okay, that's going to be the other classic pathology. But I think for the purposes of hyper IgE syndrome, that's really what you have to know. It looks kind of similar to a leukocyte adhesion deficiency in some ways, but the key is that you're going to have high levels of IgE, high levels of eosinophils, and again, because I can't get macrophages to the site of infection, those macrophages need to bind to T cells at some point when they present their antigens, and to get activated, those macrophages often will have binding that will lead to interleukin 12 and interferon gamma being released. If I don't have those macrophages getting to the site of infection because of impaired chemotaxis, I'm going to have lower levels, I would expect, of interferon gamma. Okay, and this is all, again, remember, because I have low T helper 17 cells. And why does this occur? This occurs because there's a STAT3 mutation. Now, STAT3 is one of those genes that's going to help regulate cell growth. Okay, and you don't need to really know any more than that. You do want to know that this is autosomal dominant. Remember, you want to remember the diseases that have the kind of more unusual inheritance patterns. So remember, hyper IgM, X-linked recessive, hyper IgE, autosomal dominant. Now, the last one on here is going to be Wiskott-Eldridge syndrome. This disease in particular, we'll talk more about when we talk about the hematology oncology, because it relates to that section in that there's an involvement of the platelets. But when we're talking about just comparing some of these different diseases, this one comes up because it can be easily confused for some of the other ones on here. So Wiskott-Eldridge syndrome classic mutation is the WASP mutation. Again, another X-linked recessive, a lot of very unusual inheritance patterns here, most of which, when in doubt, are X-linked recessive with a couple exceptions. This mutation is essentially causing some defect in the cytoskeleton. Okay, so you also want to remember that there's a defect in the cytoskeleton. Like I said, we'll talk about this in greater detail, probably in the hem-onc section. But because there's some defect in the cytoskeleton, when cells don't have the correct cytoskeleton and they try to kind of bind to each other to communicate, right? They have receptors here, but if the cytoskeleton isn't correct, right? If there's some defect in it, then when these cells try to communicate with each other, they're going to have some difficulty in doing so because the cytoskeleton isn't structured accordingly. So cell-to-cell interactions will be impaired. And the big thing that this calls our attention in immunology is impaired antigen presentation, right? We have so much communication between cells because we have to present antigens, right? We talked about that in pretty great detail. MHC1, MHC2, these are all used to present antigens. If I have impaired antigen presentation, now I'm going to have a really hard time generating immune responses. So these patients in general, because of the impaired antigen presentation, they'll classically have infections with encapsulated organisms, opportunistic infections, and a lot of this isn't really news compared to some of the other pathologies we talked about. This won't completely distinguish this disease for you. The thing that you really want to look for here is going to be the other classic findings here, and that's going to be eczema and purpura. Now, the purpura specifically is going to be classic because these patients have thrombocytopenia. This puts Wiskott-Eldridge syndrome in the category of these thrombocytopenic disorders like TTP, HUS, ITP, for example, and it makes you distinguish between them. If you're just thinking about this in immunology, if you have answer choices like the ones shown here, the way that you distinguish this is based on the thrombocytopenia, though, because this is kind of the outlier. If you look at the immunoglobulins, the IgA and IgE will tend to be high, but the IgG and IgM will tend to be on the low side. So again, what I want you to focus on here when you're asked about Wiskott-Eldridge syndrome and they're giving you, immunoglobulin levels and that type of thing, look for the purpura and potentially the eczema. Okay, and the purpura is because of the thrombocytopenia. These patients are going to be higher bleeding risk, and the low platelets can also cause things like epistaxis, for example. These patients might have recurrent nosebleeds, again, in the setting of this eczema and these recurrent infections. That's going to be very classic for Wiskott-Eldridge syndrome. And also notice here the platelets, not only do we have thrombocytopenia, meaning we have low levels of platelets, but the platelets are going to be unusually small. The whole point of that, again, is because I have these defects in the cytoskeleton. And one of the classic infections you'll also see here when we're talking about these recurring infections is these patients will tend to have recurrent otitis media. Okay, that's also very classic for these patients. Now, again, if you just look at the immunoglobulins here, this is kind of the one situation where I would say the immunoglobulins are somewhat non-specific. They don't tell you a lot of information, but you usually do see an elevation in IgE and potentially IgA also in the setting of Wiskott-Eldridge syndrome. So now let's take a couple minutes to talk about some of these additional variants. And again, if you understand what we've been talking about this whole time in terms of, the physiology going on with the immune system, then a lot of this is going to make sense. So going to interleukin 12 receptor deficiency, we kind of already hit on this when we talked about antigen presenting cells activating macrophages. And so you can see here, again, we have our antigen presenting cell. Okay, so this is our antigen presenting cell. And remember, this antigen presenting cell, it can present its antigens to T cells, right? So we have a T cell here that it's presenting its antigens to. And remember that this T cell here is typically going to be a naive T cell when this presentation happens. In other words, this T cell has never been exposed to this antigen. This antigen presenting cell brings this antigen into the T cell, again, because it's an antigen presenting cell. And the reason that I'm going through all of this is because if you understand this process, then you can understand what happens in interleukin 12 receptor deficiency. So the macrophage now is going to release interleukin 12, right? We talked about this before. So this macrophage releases interleukin 12 when this binding occurs. So interleukin 12 goes over to the T cell, and then the T cell, of course, if you're going to release interleukin 12, right, there's got to be a receptor here. So this T cell can bind this interleukin 12. Then what does the T cell do? Then the T cell says, okay, macrophage, I see what's going on. You want me to go down the T helper 1 pathway, right? You're basically telling me, this antigen presenting cell is telling this T cell, hey, I want you to become a T helper 1 cell. Why would it do that? Well, it's probably concerned about an intracellular type of organism. What is a classic bacteria that's an intracellular organism? That's going to be Mycobacteria tuberculosis, right? We've talked about this, a few times now. And so this macrophage is essentially saying, look, I want you to become a T helper 1 cell. Okay, so that's why it's releasing interleukin 12. Now, again, we have to have the interleukin 12 receptor, right? That receptor, the interleukin 12 receptor, so that we can even get this process to happen at all. Now, typically what the T cell will do in response to that is it will activate this macrophage and say, hey, you're doing a really good job here. Let's activate this macrophage so we can kick things off to fight off this pathogen. Okay, so it's going to activate this macrophage, which is what we see in tuberculosis, and it's going to do that primarily through the release of interferon gamma. Okay, again, and this is the whole process. If you understand this process, this should all make sense to you. So now what happens is, in this interleukin 12 receptor deficiency, if I knock out my receptor, right, I can't get this interleukin 12 to bind to the T cell. I can't get a T helper 1 response because I don't have this binding to stimulate the response, and I don't get interferon gamma released because this T cell never got that signal from the macrophage or from the antigen presenting cell, right? And so that's the whole concept. So again, if we look at this, interleukin 12 receptor deficiency, right? No interleukin 12 receptor. What do you see in these patients? Typically, there's going to be younger patients, typically, 2 to 3 months of age that present and they have disseminated TB. You can also see this, especially if it's in older patients, you can see this too with Pott's disease, right? Where you have the TB essentially kind of infiltrating the spine. But the idea is these patients are predisposed to intracellular infections that normally would have been fought off with the T helper 1 response, going back to our T cell video. And the classic one here is going to be Mycobacteria. And again, how would you diagnose this? Well, look, interferon gamma is going to be low. This should make sense to you. Interferon gamma is low because we can't stimulate this process to occur. The mechanism is essentially broken pretty early on here at this initial step. Okay, let's talk a little bit about chronic mucocutaneous candidiasis. And there's actually a lot we could talk about for this, but I don't want to get off of the road too much in terms of what we really want to focus on. What we really want to focus on is in board questions, what are the things that we're going to see that are going to call our attention to this? And it's pretty straightforward here. We're going to see recurring or refractory candidal infections, particularly mucocutaneous infections. What does that mean? I'm not talking about infections of the bloodstream, right? If you have endocarditis with it from Candida, for example, that's more of an issue with neutrophils. When Candida gets into the blood, that's a neutrophil issue. Okay, then you're thinking more of a neutropenia. That's going to be more of a hemonc thing, right, in general, but that's the way to think about it. If Candida's in the blood, that's a neutrophil problem. If Candida is infiltrating the skin or the oral mucosa or the esophagus, that's going to be more of an issue with the T cells themselves. And I'll explain this in a second when we look at this test here on the bottom. Normally in a board question, if they're asking about this disease, they're talking about very low levels of the RE protein. And I think we talked about this a little bit in the T cell video. Also, you want to remember this is going to be due to a defective interleukin 17 or interleukin 17 receptor. Some associations are made with this as well. And I'm not going to go through all the pathophys here to explain it because, like I said, it's just not as high yield. But the point is that we have a lower response to candidal antigens. Now, the way that this is sometimes diagnosed is we can inject candidal antigens into the skin, and what we're looking for is some kind of response. It's kind of similar to what we do when we do the TB skin test. And just to give you an idea of what we're talking about here, so when I inject these candidal antigens, I might get some of these antigens binding to T cell receptors. I might get some of them even potentially binding to macrophages. And the idea here is when there's this binding, we already talked about this whole process here, right? The antigen presenting cell can present the antigen. This T cell may or may not already be activated. And the point is these T cells will start to release interferon gamma, like we just talked about out here, the same mechanism where they're going to release interferon gamma, and then this interferon gamma is going to activate this resting macrophage. Like we just talked about here, that interferon gamma is going to get released, stimulate this macrophage to become activated, and that macrophage is then going to release cytokines that will eventually result in some induration here, right? Some bump on the skin. And that shows that this patient is able to essentially identify candidal infections, and we're able to make an immune response to that candidal infection. Now, if a patient has this test done and there's no induration, then we would be more concerned that this patient potentially is more susceptible to a candidal infection. So that's what happens here in chronic mucocutaneous candidiasis. Again, we would have an absent cutaneous reaction to candidal antigens because our body is not well equipped to fight candidal infections. And that's exactly the problem here. So let me ask you, just to add some layers to this, now that we know kind of some of the players involved, right? We have T cells involved that are going to be involved with activating macrophages. Let's just say that we had a patient that had SCID, right? So we talked about this already, severe combined immunodeficiency. So if I had a patient that had SCID and I gave them an injection with the candidal antigen test, what do you think would happen? Do you think this patient would get an induration of the skin? Right? And so the answer to that is no, right? These patients should not get indurations of the skin because these patients don't have T cells. So they are not able to initially bind the antigen to the T cell receptor to then get that T cell to eventually bind to a macrophage and then release interferon gamma to activate the macrophage so that we can get a localized inflammatory response and an induration of the skin. They don't have T cells, so this process breaks down very early. What about now if I had a patient with HIV? Okay, so if I had a patient with HIV, let's say they had a CD4 count of 700. Okay, I'm just making up a number. If I had a patient with HIV that has a CD4 count of 700, do you think that they would develop an induration of the skin? And the answer is they should, right? Because they have an adequate number of CD4 cells, right? 700. And so they are able to produce this response. So barring any other defects, right? They have CD4 cells that are able to help get this initial process going. Now, if I had a HIV patient, on the other hand, that let's say had a CD4 count of, 50, okay, so if I had a patient that had a CD4 count of 50, on the other hand, this patient would not be able to generate the appropriate induration or any induration at all because they have very few CD4 cells. So the cutoff, like we always say, CD4 count less than 200 is when you start to think about more of the immunocompromised state of an HIV patient. And that goes hand in hand with some of these tests as well. Now, last question. What about a patient that has Bruton's X-linked agammaglobulinemia? Okay, so I'm just going to put Bruton's up here. What about this patient? Will this patient have an induration? And again, you have to just think about it. And when you're answering these questions, these are all questions that are integrating a lot of the knowledge that you have, right? And so you think about, okay, what's the problem with SCID? No T cells. What's the problem with HIV? No T cells, unless I have a high CD4 count, right? If I have a CD4 count less than 200, then I have very low T cells. That's the same problem with SCID, low T cells. If I have HIV, but I have normal T cells, maybe I'm being treated adequately, or I don't have severe disease, in that situation, I should have a normal response. In Bruton's, what's the problem? The problem is I don't have B cells. Okay, if I don't have B cells, will that prevent this process from happening? The answer is no, right? Because there's no B cells here, right? We have T cells that are binding to macrophages to have a localized inflammatory reaction to get an induration in the skin. There's no B cells anywhere. Now, B cells will be helpful for immunoglobulins, right? Things that we've already talked about, class switching, memory responses. But in this particular situation, it shouldn't have an effect. You should expect to have some induration with Bruton's as well, right? Because the T cells technically should be functioning in Bruton's X-linked agammaglobulinemia. Okay, last one, IPEX syndrome. So IPEX syndrome is due to a mutation in the FOXP3 gene. Now remember, we talked about this when we went through the T cell video. We said there's these certain cells, these are the regulatory T cells. Okay, so the regulatory T cells. And these regulatory T cells are going to kind of be the opposite of the inflammatory response. Essentially, these cells are trying to keep things under control. They don't want things to get out of control, is another way to think about it, right? They want to keep the inflammatory response in check. And so the way that they do this, these regulatory T cells, is they're going to release things like TGF-beta. Remember, TGF-beta is going to help kind of either cause chronic inflammation or kind of just slow the overall process of inflammation from happening. And the other substance they're going to release is interleukin 10. So both of these are going to kind of quiet down the immune response. And regulatory T cells are particularly effective in this if we have a response to our own cells, our own self-antigens. This is why we went through the process of negative selection to begin with. And these regulatory T cells are marked, right? So they're CD4 positive, CD25 positive, okay, that's particularly high yield, and they're FOXP3 positive. Okay, so this is kind of the classic markers. Now you can see CD4 positive on a lot of different cells, right? CD4 positive cells can turn into T helper 1, T helper 2 cells, but you can also get regulatory T cells from CD4 positive cells. That's the point. They're coming from that cell line. And the thing that distinguishes them really is going to be the CD25 positive and FOXP3 positive, which is actually all up here. So the point is, if you have a mutation in the FOXP3 gene, you might see a pretty significant drop off of those T cells. In other words, those three markers telling you that this is regulatory T cells. The point here is other T cell lines should be intact. So if I did a candidal antigen test on a patient that has IPEX syndrome, we would expect to see an induration because other cell lines are intact. It's the regulatory T cells that are affected. What is the presentation like in IPEX syndrome? And I didn't put a ton on here because I wanted to kind of talk about it. But the first thing is it typically is going to present very early. Some of these different pathologies we talk about, it doesn't really present until, 6 months after we kind of lose mom's antibodies. But with IPEX syndrome, things are going to start off very early on because the issue isn't that we don't have antibodies, right? We have antibodies. We're able to make new antibodies. The issue is that our own T cells are not regulating the immune response. So we can actually have, T cells in our body attacking our own cells, and there's no one in to kind of stop things and prevent it from getting any further. And that's the point here. So if we're attacking our own cells, we're thinking more of an autoimmune phenomena. And if you just remember IPEX syndrome with autoimmune conditions, that can simplify this dramatically, right? Because you know that the regulatory T cells are defective because of this mutation. Now, the classic things that you'll see are things like type 1 diabetes, right? And that's, again, our own cells attacking the beta cells in the pancreas. You can think about things like thyroid disease. So it could be hyperthyroidism, hypothyroidism, right? Thyroid disease. And these patients can have things like autoimmune hemolytic anemia. They can have ITP, which we'll talk about all of this in the hemonc section. You can see these patients with neutropenia as well. And that's because we're attacking our own cells. And like I said, no one is there to kind of keep things under control. And so in these infants, what you'll see is they might have failure to thrive. Okay, so these infants might have failure to thrive because our own cells are kind of doing a lot of the damage early on, and this can be dramatic in these early stages of organ development. So this was a really large chapter. What we have here is a table just to kind of review everything in one place so that it's a little bit more organized. But again, it's not so much about kind of memorizing a lot of the details. Sure, there are certain things that you have to understand, you have to just commit to memory, but overall, if you understand the processes that we talked about, you just have to know what is the problem, and then you can kind of make sense at the diagnostics and some of the associations too. So let's take a look at the first one. We talked about SCID, right? So SCID, remember the problem. What's the problem? That's the first thing, absent T cells. Okay, so if I have absent T cells, there's going to be certain markers I would see. For example, if I was testing this in flow cytometry, the big one would be CD3 positive, right? If I don't have CD3 positive, that's pretty much universal among T cells. I might also see very low CD4. I might see very low CD8 potentially, right? So those are other markers, but the big marker to know is CD3. And again, if I don't have T cells, I'm going to have an absent thymus, right? Or a very involuted thymus potentially in these younger patients that are going to be presenting with this. And the classic newborn screening that we talked about is testing for these T cell receptor excision circles. Okay, so classically in SCID, if you see low Tregs, you want to start to think that this potentially is the disease that they're hinting towards. And if we also have concomitant B cell dysfunction or absent B cells, we would also see drops in our serum immunoglobulins. Now, there are certain diseases in general that you really want to know the presentation for. It's going to kind of call your attention to it. In SCID, it's usually going to be at that 3 to 6 month mark, which is going to be pretty classic among a lot of these different diseases, where they'll start to show symptoms. And eventually they'll have failure to thrive, recurring opportunistic infections. Opportunistic infections, we talked about things like Candida, pneumocystis, CMV, CD would all be very classic in these patients. But again, this alone is not always going to get you to the answer of SCID. You're going to really have to understand the diagnostics and understand the problem. And then they might ask, what is the cause of this patient's problem? It could potentially be a interleukin 2 receptor, which we talked about. Interleukin 2 being that growth receptor that's going to help immune cell growth, right? And that's going to be X-linked recessive. Or adenosine deaminase deficiency, which would be more autosomal recessive. And then we also talked about RAG mutations, not as high yield. All right, and then we talked about Bruton A-gamma globulinemia. Again, this is going to be absent mature B cells. So if I don't have B cells in the bloodstream, right, I'm going to have very low levels of my B cell markers on flow cytometry, 19, 20, and 21. And because of that, I have low serum immunoglobulins. And the other key point here is that your T cells should be normal, right? The T cells should be normal. I shouldn't have low CD3 in Bruton's. Combined variable immunodeficiency, what's the difference between these two, right? The difference is here I have absent mature B cells. Here they're present, they're just dysfunctional B cells. Okay, so I have B cells in the blood, so I should have CD19, CD20, CD21 markers on flow cytometry, but the problem is they're dysfunctional. So I still will have a decrease in all of my immunoglobulins and a decrease in my plasma cells because I can't get these B cells to actually become activated to become plasma cells. And so the classic presentation here, this is one situation where you really want to know that the presentation is going to be in an older patient. Now, it doesn't have to be between 20 and 40 years old. It could be a 10-year-old and 8-year-old, but the point is these patients are going to have less severe disease because they have B cells. They just don't work quite right as opposed to not having any. And so these patients will just tend to present later because the disease is less severe than these patients in Bruton's and SCID, which will present a lot earlier, around that 3 to 6 month mark usually. Selective IgA deficiency, again, what's the problem? It's right there in the name. We don't have IgA. That's the selective, meaning it's just IgA, right? That's the only thing that's going to be low here. When we have low IgA, I want you to think about Giardia, mucosal infections, but the big thing, the highest yield thing to remember for this, and this is usually how it presents, is going to be an anaphylaxis to a blood transfusion. Okay, so a patient that just got a blood transfusion for whatever reason, all of a sudden immediately goes into anaphylaxis. That's a classic patient for this. Again, that's due to that anti-IgA IgE antibody that's causing that to happen. Also remember that these patients are going to have a false negative TTG IgA in the setting of celiac disease, which is often associated with selective IgA deficiency. And that's because they don't have IgA antibodies. So that test is going to appear negative. They could still have celiac disease. It's negative because they also have selective IgA deficiency, meaning they don't have any IgA antibody. Hyper-IgM syndrome, again, what's the problem? Impaired class switching. If I can't do class switching, right, which comes from that CD40 ligand binding, if I can't do this, then I'm not going to make any of the antibodies or the isotypes that come from class switching. I might still have IgM. I might be making more IgM because my body is trying to figure out what's going on, right? So it's just going to keep generating a response with IgM, but I'm not going to have any of the IgA, IgE, or IgG antibodies because I can't class switch. In hyper-IgE syndrome, the issue here is impaired neutrophil macrophage chemotaxis. So this is kind of like what we talked about with leukocyte adhesion deficiency. We're going to have lack of inflammation because the neutrophils are not getting the signal to come to a certain part of an infection or an area that should be having some level of acute inflammation. And because of that, we're not going to have a lot of inflammation, and we're also going to have some classic features here, coarse facies we talked about, eczema. And when we look at the labs, IgE is typically going to be elevated in hyper-IgE syndrome. IgE elevation, very concomitant with eosinophils being very high. Now, the other thing to remember here is the interferon gamma is often low. Now, don't confuse that with interleukin 12 receptor deficiency, which is typically going to present a little bit differently. Interleukin 12 receptor deficiency is going to present with disseminated tuberculosis in a very young patient usually, okay? And that's because of the reasons we already talked about. You're not going to get interferon gamma release if you don't have interleukin 12 receptors on your T cells, okay? Because they can't then stimulate and do that next step of activating the macrophages. And so we're kind of jumping around a little bit, but that's your interleukin 12 receptor deficiency. But I just want you to remember that when you're comparing these two. So when you see low interferon gamma, it could mean either one. You got to take, if they're giving you information about IgE and eosinophils and, lack of pus or abscess without inflammation, you might be thinking more hyper-IgE syndrome. If they're telling you that this patient has recurring TB infections, for example, and they potentially are, not responding to a TB skin test, something like that, you might think more interleukin 12 receptor deficiency. All right, Wiskott-Eldridge syndrome, we'll talk about this one a little bit more in the hemonc section, but again, you have to remember, what's the problem? The problem is impaired antigen presentation. That's because we have cytoskeletal defects that are going to kind of inhibit our cell signaling. Okay, and so if we have impaired antigen presentation, the classic things you'll see are some deviation in the immunoglobulins, but that's not what I'm really looking at. I might see see that, okay, the IgM, the IgG is low, but that's kind of, in some ways non-specific when you're comparing these diseases. The thing that I'm really looking for with this disease is I'm looking for this patient to have thrombocytopenia and unusually small platelets. Now, you can see thrombocytopenia in diseases like IPEX syndrome, where you have some component of autoimmune disease, okay, where you start to kind of attack your platelets, and that's called immune thrombocytopenic purpura. We'll talk about that in the hemonc section, but the thing that stands out here, though, in Wiskott-Eldridge syndrome is that the platelets are really, really small. And they're really small because we have cytoskeletal defects and impaired communication between cells. So it makes these very unusually small platelets. Okay, so that's what I'm looking for. Now, if you have low platelets and they have some kind of defect, potentially, the thing that you're looking for here is going to be purpura, easy bleeding. These patients might have epistaxis, recurring nosebleeds, very classic, or bleeding for a really long time after a cut, requiring them to go to the emergency room or something like that. That would be very classic for this Wiskott-Eldridge syndrome. Now, the other things you can see with it, you can see recurring infections, you can see eczema. Again, these are more non-specific in the setting of these diseases that we're talking about, though. Chronic mucocutaneous candidiasis, again, we already talked about this one being a poor response to candidal antigens. That's the point. So you can get these recurring infections, recurring mucocutaneous candidal infections. Again, they shouldn't be in the blood, right? You shouldn't have a candidal endocarditis unless we're talking about a neutropenic patient. And we're going to diagnose this by having an absent cutaneous reaction to candidal antigens. And we have IPEX syndrome here. And IPEX syndrome, remember, this is going to be your regulatory T cells, FOXP3, low levels of regulatory T cells. And so we kind of hit on this a little bit. And I didn't want to add too much in. Remember, this is going to present in infancy very early. And the polyendocrinopathy is really the big thing I want you to remember. I'll put that in red here. So polyendocrinopathy, because, that's going to make this stand out. So we're talking about things like hypothyroidism, hyperthyroidism. It could be either one very early in life. It could be pancreatic disease. These patients could have type 1 diabetes, all very classic. They also can have enteropathy, skin lesions, which are more, non-specific, especially the skin lesions. But again, the thing that just zooms you in on IPEX syndrome is going to be the low FOXP3, CD4, CD25 cells on flow cytometry. They're talking about T cells. The other T cells are working just fine, though. You still have a T cell response. It's just that the regulatory T cells are not functioning the way that they should. So hopefully this simplifies things. Again, first thing you always remember is what's the problem? Are they giving you any diagnostics? And then are there any key pieces of information in the presentation? And I think I highlighted most of the key things in red and in pink here in terms of what you really want to know in the presentation that's going to kind of zoom you in to that disease process. You have 15 seconds to pause the video, read the question, and then we'll go through the answer. You want to try to skim this thing one time and then really focus in on what you know. What are the key things that you know, and what are they asking in the question, right? This is going to be the most important sentence. What are they asking in the question? Okay, so let's read through this. I'll walk you through it and kind of tell you, what are the big things that really should have jumped out at you here. So we got a 21-year-old male who's presenting to his primary care physician to establish care. He states that he has been suffering from rhinorrhea, intermittent headaches, and cough for the past 2 weeks. He reports that this is his 7th illness this year and states that he recently recovered from a prolonged course of watery diarrhea. So when you see something like this, again, 7th illness this year, kind of unusual, had a prolonged course of diarrhea, has these symptoms for 2 weeks, right? So a lot of different kind of recurring illnesses, right? Which is pretty consistent with potentially an immunocompromised state. This doesn't really help us because if you look at the answer options, they're all patients that have some immune dysfunction, right? Some immune deficiency. Okay, he states that he has recently had multiple episodes of prolonged nosebleeds. Okay, that's kind of interesting. Now we're kind of going in another direction. Which one of these is associated with epistaxis? Not any of them really, right? Or at least off the top of your head. You probably don't make that association, but we'll talk about that in a minute. Vaccinations are up to date. Now, this is another one that's kind of funny because sometimes they'll put in here, vaccinations are up to date. It's highly likely at some point somebody's going to test you on the fact that these patients, their vaccinations are up to date, but guess what? They're literally telling you they're immunocompromised. So does that really mean their vaccinations are up to date from, an immunogenicity perspective, right? Are they generating a good antibody response? They might not be, right? Because they're immunocompromised. So just because the vaccinations are up to date doesn't mean that this patient is completely vaccinated versus all the pathogens we would expect them to be vaccinated against. Okay, the patient denies any sick contacts. Past medical history and birth history are insignificant. Physical examination. This is actually pretty important. Past medical history and birth history are insignificant. I'll tell you why that is just because I've kind of skimmed these options already. We'll come back to this. Physical exam reveals increased nasal mucus secretions and maxillary sinus pressure to percussion. Kind of sounds like an episode of sinusitis here. Okay, it's kind of what this reminds me of. Multiple ecchymoses are noted on the upper and lower extremities. Okay, so this is going back to this prolonged nosebleeds. Now I'm kind of thinking, okay, is there a coagulopathy going on here, or is it a platelet disorder? The patient is subsequently referred to a hematologist and an immunologist for further evaluation. Diagnostic serum studies and flow cytometry results are shown below. Lymph node biopsy reveals reactive follicular hyperplasia. Anytime in a board question they give you a biopsy, especially for step 1, make sure that you really take the time to make sure you make it a point of emphasis, right? Because biopsies are usually confirmatory things, and there's a major reason they're telling you that most of the time. So reactive follicular hyperplasia. So this means that we have a lot of B cell action going on in the lymph nodes. Okay, which we would expect if we had certain, infections and that sort of thing. Which of the following immunologic disorders is most consistent with this patient's presentation and diagnostic evaluation? All right, the hemoglobin looks okay. The leukocyte count, it's actually not super elevated, which is fine. I mean, patients can have sinusitis and not have a significant leukocytosis. Oh, but here we go. The platelet count, on the other hand, is actually quite low, 61,000, which is very consistent with some of the presentation findings of the ecchymoses, the prolonged nosebleeds, and the bleeding time is also prolonged. But the PT and PTT are normal. So we're going to talk a lot about all of this in the platelet section in hematology. This is pretty interesting, so we'll come back to this in a second. The immunoglobulin A level is also quite low here. So IgA level is pretty low. It's 4. The reference range 76 to 390. IgG level is also very low. IgM level is also very low. CD3 positive. So remember, CD3 positive is your T cells. So the T cells look okay. Or CD3, CD4 positive. Okay, so remember, CD3 is just like T cells, right? So CD3, CD4, these are specifically talking about the T cells that are CD4 positive, or usually things like the T helper cells, for example. Okay, so CD4 positive cells are also within the reference range, which is good. And our CD19 positive cells, which is going to be our B cells, are actually a bit low here. Okay, so just to kind of organize ourselves here, we've got a couple things going on. We've got a platelet problem. Okay, so we've got a platelet problem evidenced by we have an increased bleeding time and we have a low platelet count. So the bleeding time can go up if there's platelet dysfunction, or if there's an issue with the platelet count, like a quantitative issue where we don't have enough platelets, or both. The platelet count is probably explaining why the bleeding time is elevated, which would explain the prolonged nosebleeds and the ecchymoses. Now, that doesn't seem directly related, at least not on first glance, to some of these other things. The T cells, okay, so the T cells are okay, right? The T cells are good. We know the CD3 positive and the CD4 positive cells, they're within the normal range. And the B cells, on the other hand, are low. Okay, so our B cells are also low, okay, which is interesting because remember the lymph node biopsy, reactive follicular hyperplasia. What is going on here? We can see the answer is common variable immunodeficiency. So let's kind of just peel the layers back here really quickly. One of the most underrated things also is just looking at the age here when you're talking about these immunodeficiency syndromes, right? And we talked about this past medical birth history were insignificant. So, if they came at this question and they said that, this was a 6-month-old or a 3-month-old or a child with a really complicated, first year of life where they had a lot of recurring infections. Now I might be thinking about one of these two in my differential, right? I might be thinking about SCID, I might be thinking of, which is severe combined immunodeficiency, I might be thinking about X-linked A-gamma globulinemia. So remember, the issue in severe combined immunodeficiency, which in my opinion is probably the highest yield of these 5 on the list, maybe up there with option B, but the point is with severe combined immunodeficiency, you're going to have low T cells, you're going to have low B cells. We can see here that the T cells are actually within the normal range, and usually severe combined immunodeficiency, it tends to present around 3 to 7 months of age, right? When we start to lose mom's immunoglobulins, we really start to see some of these infections take hold. Now, you can still get this one to present in adulthood, though, right? This could still present in adulthood, but the fact that the T cells are normal here, that pretty much just argues against this. It's probably not the best option because remember, the T and the B cells are generally affected in severe combined immunodeficiency, right? Combined meaning T and B cells. Okay, the X-linked A-gamma globulinemia, on the other hand, is really tough to differentiate from common variable immunodeficiency because they're very similar, right? The issue with the X-linked A-gamma globulinemia is we literally can't get these B cells out into the blood, right? Because we have that BTK gene defect. So in X-linked A-gamma globulinemia, the T cells are often normal, like we see here, but we have some low levels of B cells. Now, in general, X-linked A-gamma globulinemia will tend to have lower B cells than a patient with common variable immunodeficiency, but that's not like something you can hang your hat on. But what you can say is, look, this patient, for one, X-linked A-gamma globulinemia is probably going to be in an infant or, like I said, 3 to 7 months of age, not as likely presenting in a 21-year-old, right? Just now, a patient that's never really had B cells. It would be pretty unusual, especially with no other past medical history. But the other thing to consider is that this patient had a lymph node biopsy showing reactive follicular hyperplasia. Now remember, if you can't get B cells out into the blood, right, how are you going to get all these B cells to the lymph node? They're developed in the bone marrow. So usually, if you did a lymph node, I'll just do lymph node biopsy on a patient with X-linked A-gamma globulinemia, you would usually see absent germinal centers, right? So secondary follicle, remember the germinal centers, the pale staining portion. You might even see absent primary follicles, because the issue is you literally don't have B cells in your systemic circulation or even in the lymphatics. And that's different from common variable immunodeficiency. The issue in common variable immunodeficiency, there's some defect that happens usually between 20 to 40 years of age where patients start to have, just defective B cells that aren't quite working the way that they should, and their plasma cell levels then drop because those B cells aren't being able to convert themselves back into plasma cells. And so in general, your plasma cell levels, right, are going to start to drop a little bit because your B cells just aren't working the way that they should. They may have worked normally, up until 21 years of age, as is the case with this patient, or even longer potentially, right? Common variable immunodeficiency usually presents between 20 to 40 years of age. Classically in board questions, it presents between 20 to 40 years of age, but it can present earlier, right? Notice that X-linked A-gamma globulinemia in a board question, it's almost always going to present a lot younger, and the lymph node biopsy should show absent tissue in these areas because absent germinal centers and absent primary follicles, because you can't get the B cells out into the blood. Common variable immunodeficiency, the B cells are out there working for, some part of your life, but then they kind of get defective, and because of that, they can't convert to plasma cells. Now, plasma cells are also, just like your general B cells, a lot of plasma cells are also CD19 positive, right? Just like a lot of your naive B cells. And so because you have this lower level of plasma cells, because they're both CD19 positive, you can actually get the CD19 positive cells, or the B cells, to be a little bit lower in common variable immunodeficiency. But that's why I tell you that usually in X-linked A-gamma globulinemia, the B cell count will be a lot lower because literally all of the B cells aren't working. Whereas in the case of common variable immunodeficiency, it's mostly the plasma cells that are the cells that aren't accounted for, so to speak. In any case, though, in common variable immunodeficiency, much like X-linked A-gamma globulinemia, T cells should be normal, and the B cells can be lower. They could also be normal, though, right? They could be normal also for the reasons that we kind of just mentioned. Now, another thing we would do these lymph node biopsies for, if you saw some of the data that we see here, you might be a little concerned about lymphoma also. And so that's another reason why, a patient that has common variable immunodeficiency, we'd probably be doing a lymph node biopsy. All right, let's just walk through the other options here. Interleukin-12 receptor deficiency, from start to finish, doesn't really sound like a patient with interleukin-12 receptor deficiency. If we had a patient that just got a BCG vaccine, right? It's a live attenuated vaccine, and then the patient develops systemic mycobacterial tuberculosis or something like that. That would be very classic for interleukin-12 receptor deficiency. So just remember, the whole idea with this is you have some antigen presenting cells, say it's a macrophage here, and, let's just say it interacts with the pathogen like Mycobacteria tuberculosis, for example. It presents that pathogen to T cell. And then essentially what happens is the macrophage says, hey, based on the type of pathogen I'm seeing here, I'm going to release interleukin-12. And remember, interleukin-12 will then stimulate this T cell, right? It'll stimulate this T cell to become a T helper 1 cell. And then the T helper 1 cell will then release interferon gamma, kind of stimulate that macrophage to help destroy the pathogen, or at least to wall off the pathogen, depending on what we're talking about. But in any case, the point is that you need this interleukin-12 to bind to an interleukin-12 receptor here on the T cell to make it a T helper 1 cell. Well, if you don't have that receptor, then you can release interleukin-12 all day, but those T cells are not going to become T helper 1 cells. And so remember, that's the point. And so again, it's usually pathogens that require this T helper 1 response that these patients will typically have a problem fighting off. But we don't really see enough detail to mention that. In fact, the derangements in the immunoglobulin levels would suggest otherwise, right? Especially there's a lot better answers and options here. Okay. Acquired immunodeficiency syndrome. So we're talking about AIDS with option B. Remember, AIDS has a couple defining features. Remember, this is the human immunodeficiency virus, right? HIV, which is a retroactive virus, and preferentially infects CD4 positive target CD4 positive T cells. Okay, so eventually what happens is, right, these CD4 positive T cells are going to kind of get destroyed gradually, and then eventually we're going to end up with a very low CD4 positive T cell count, which becomes particularly problematic. And we start to get things like opportunistic infections, right? So what are some of the opportunistic infections we're talking about? Cryptosporidium, POC, sarcoma, cystis, cerebral toxoplasmosis, for example. You know, we can make a long list. We'll talk about this more in the infectious disease section, but the point is there's certain AIDS-defining opportunistic infections. And the other thing here is you can look at the CD4 count, right? If it's less than 200, that's also suggestive of acquired immunodeficiency syndrome. But if we look at the CD4 count here, it actually looks like it's within the normal reference range. It seems unlikely that they'd be asking us about acquired immunodeficiency syndrome, although this can present certainly in this age group and can present with recurring infections. But there's really not enough evidence here in the STEM, in my opinion, and certainly not in the labs here to suggest this disease process. Now, the last thing I want to say is what was going on with this patient's platelets, the prolonged nosebleeds, the multiple ecchymoses. One major thing to remember when you're talking about common variable immunodeficiency is that this presents very frequently with autoimmune phenomena. Particularly, the big one is ITP, which is immune thrombocytopenic purpura. We talk about this a lot in the heme section, right? And that's exactly what's going on here, most likely, right? This patient also, a lot of these patients with common variable immunodeficiency will present with like ITP, or another big one is autoimmune hemolytic anemia, right? They'll present with these symptoms, and then this will get treated by hematologists, and then this will kind of be incidentally discovered later on that they have common variable immunodeficiency. So just kind of keep that in mind. Very frequently in board questions, they'll kind of integrate these different concepts to try to throw you off. But as long as you kind of understand the big picture, what's going on, you can read through some of this lab data, then you'll probably be okay. This is a very high yield section where a lot of the different questions are going to stem from. So what's really important here is that we get down the differences in the mechanisms and then some of the very classic disease processes that present with each of these 4 different hypersensitivities. So we'll start at the top and work our way down through the different types. So when we're talking about the type 1 hypersensitivity, we're typically going to be talking about more of an allergic type of reaction. And you can see, allergic contact dermatitis, for example, with type 4 hypersensitivities. But in general, when we're talking about allergies, allergens, we're talking primarily about type 1 hypersensitivity. Okay. Now, in this category, the classic causes are going to be patients that are allergic, again, to certain foods, right? So again, we're talking about allergic. So patients that are allergic potentially to certain foods, to certain medications, or a history of some type of insect sting, all very classic for this kind of allergic reaction. And the concern when you have these allergic reactions is that this allergic reaction can kind of tip the patient over into anaphylaxis, okay, specifically anaphylactic shock. So that's what we're worried about in these patients. We don't want them to get to the point where their blood pressure drops and we don't have organ perfusion, right? Because of this massive widespread reaction. And that's where the name comes from, right? We're hypersensitive to something, whether that's, peanuts, shellfish, certain medications. The classic one, when you're talking about medications, these patients can be allergic to penicillins, they can be allergic to cephalosporins. But for each of these categories, there's usually like a classic drug that fits into that type of hypersensitivity. You'll see what I mean as we go through this. Sulfa drugs are going to be very classic for the type 1 hypersensitivity. That's not to say that you can't get certain other types of hypersensitivity reactions with sulfa drugs, but kind of the classic one, when in doubt, is going to be more of the type 1 hypersensitivity. And then insect stings, certain foods, very, very classic for causing these kind of allergic reactions, these type 1 hypersensitivities. So what exactly is happening when you have a type 1 hypersensitivity reaction? So let's go through that really quickly. So the thing that you really want to understand here is that there's 2 kind of steps to this. There's the initial exposure, and then there's the subsequent exposure. Okay, so let's start off with an initial exposure. Okay, so the initial exposure, we're going to kind of just do in this green color here. So we're going to start off with some allergen. Okay, now an allergen, you might be saying, what's that? An allergen is essentially just an antigen. And we've talked a lot about antigens up to this point. So you can essentially think of the allergen as an antigen, just to keep things simple, because that's really what it is. Okay, so it's some antigen that's floating around in the blood. Now let's just make things simple here. So we can just say that we had a patient potentially here that just got, some insect sting for the first time, right? They got a bee sting, and our patient with the bee sting, when they had this inoculation of the sting, there was some allergen from that sting potentially that eventually got into the body. Now, this allergen is going to get recognized by the antigen presenting cells. And this could be antigen presenting cells in the skin if we're talking about, inoculation from a sting. It could be antigen presenting cells in the blood if we're talking about a reaction to a sulfa drug. In any case, we have an antigen presenting cell. It's going to recognize this allergen and it's going to bind it, right? So it's going to bind it. It's the unique fit on its receptor to bind this allergen. This antigen presenting cell is then going to go on to bind to some naive T cells and say, hey, look what I found. And remember, this T cell receptor is going to be complementary in terms of its binding to this antigen. And what type of receptors are we talking about specifically here? So we have our MHC2 receptor. Okay, now you might be saying, well, how did you know that was MHC2 receptor? It's an antigen presenting cell, right? Antigen presenting cells will display MHC2 to bind to antigens. Remember, all nucleated cells also have MHC1, but for this antigen presenting cell to display the antigen on MHC1, that antigen presenting cell would have had to have been infected, or we might have something going on inside the cell that would cause it to present it on MHC1 through the endoplasmic reticulum, right? And those are all things that we've already talked about, so I won't go into too much detail on that, just kind of bringing it full circle here. But again, because this antigen presenting cell recognized this extracellular allergen, it presented it on MHC2. And if it's presenting it on MHC2, then this naive T cell that recognizes it must recognize it on a T cell receptor that has a CD4 positive co-receptor. How did I know it was CD4 positive? Remember your rule of eights. 2 times 4 is 8, right? MHC2 times 4, that's 8. This is a CD4 positive T cell. And this is where I want you to just stop for a second, because this is where test writers can trick you very easily, right? Because they can say, look, type 1 hypersensitivities, what are you thinking about? You're thinking about antibodies. In general, when we're talking about hypersensitivities, the first 3 types of hypersensitivities are all going to primarily involve antibodies, okay, immunoglobulins. But when we get to type 4, the type 4 hypersensitivity, we're going to be talking more about T cells. Okay, so the question is are T cells involved in a type 1 hypersensitivity? The answer is actually yes, T cells are involved. This whole process is going to be primarily antibody mediated, but to get to that point, to get IgE antibodies, which you'll see in a second, we need T cells. Okay, so don't be fooled. You still need T cells to make IgE antibodies. You can't class switch, right, without T cells. We've gone through all of this a few times, in the video series so far. So again, I don't want to talk too much about that. You can go back and check out the other videos, but that's the concept. Okay, so we still have T cells involved in some way. All right, so let's recap. So we have some allergen bound to this antigen presenting cell, now presented to this naive T cell. Okay, and now once we have that presentation occurring, that T cell then becomes activated. That T cell, what it will do is it will find a B cell, again, with the same kind of receptor binding to that allergen or antigen. And we have our T cell receptor here, right? So we have our T cell receptor again, T cell receptor, and then here you can see this immunoglobulin on the B cell. Now, what's this thing down here? This is going to be a very important CD40 ligand, right? So here's your CD40 ligand, and here's your CD40. And again, we talked about all of this in the previous videos. This is going to be responsible for that co-stimulatory signal so we can get class switching to occur. We get this signal, interleukin 4 and interleukin 13. Now remember, these are high-yield cytokines that are responsible for class switching from IgM to IgE antibodies. Okay, so now you kind of see where this is all coming full circle, why IgE is so important in this type 1 hypersensitivity. In fact, I would go as far as to say that IgE in general is probably the single most high yield thing to remember when you're thinking about type 1 hypersensitivity. Okay, so we make these IgE antibodies from interleukin 4 and interleukin 13 from class switching, right? Now, those IgE antibodies, what are they going to do? These IgE antibodies can then bind to the surface of our mast cells and our basophils. So it doesn't just have to be a mast cell, it could be a basophil here too. But the point is that these IgE antibodies are going to bind to the mast cell and basophil. And you can see what portion is binding to the mast cell and basophil. This is where the devil's in the details kind of thing, right? So these receptors here that you can see, this red-orange receptor, that's going to be the Fc epsilon receptor, okay? And it kind of sounds complicated, but the way that you can kind of think about this is Fc, right, is just talking about this portion of the antibody. Remember, you have your antibody, and remember, this portion is your Fc, your constant region, and then you have your Fab region out here. Okay, so this Fc is just saying that, hey, this receptor binds to the Fc portion of the IgE antibody. That's really all it's saying. And then the epsilon, I just remember epsilon with IgE, right? Epsilon receptor. Okay, so that receptor is on the mast cell. That's this structure right here. Okay, so that receptor is going to bind to, again, the Fc portion of the IgE antibody, meaning that the Fab portion of the IgE antibody is going to be sitting out on the top of the cell. So when an allergen or antigen comes around in the future, it will bind to this Fab region, and when it does that, these IgE antibodies can cross-link, causing degranulation of your mast cell. Okay, so all of this stuff in green was the initial exposure, right? We got these antibodies put on the surface of our mast cells, of our basophils, all because of this process, because we were, stung by a bee, for example, or we took a medication that we were allergic to, right? And the antigen presenting cell presented it to the naive T cell and caused this cascade to happen that ultimately resulted in sensitized, that's the key word, mast cells and basophils. Sensitized because now they're sensitive to this allergen. So if this allergen were to come in the body again, if I got stung by a bee a year later, right, or if I took that medication a year later, I'm going to have a much worse reaction because now all of these IgE antibodies that I created are sitting on the surface of my mast cell and basophil. So this is going to be the re-exposure. We'll do this in purple. Okay, so this is the re-exposure. So now I'm being re-exposed to this antigen, right? This is a second time, or maybe a third time or fourth time, but you can see now these mast cells are already prepared. They already have the IgE antibodies that we formed from class switching on their surface, causing degranulation. And what are we degranulating here? This is going to be primarily histamine, okay? That's going to be the big one to remember. And you have to kind of remember, what are the effects of histamine? So histamine can cause bronchoconstriction, bronchospasms, vasodilation. It can cause increased permeability in the capillaries, so you can get some edema, right? And those are some of the features that we see clinically. The big, presentation thing to look for is going to be urticaria in general. Okay, so urticaria is very classic for type 1 hypersensitivities in particular, or some kind of allergic reaction that's kind of disseminating throughout the body. Now, urticaria is also sometimes called this wheal and flare type presentation. So that's another kind of term you can see is wheal and flare. And the wheal is going to be kind of these areas of central pallor, where we get whitening essentially. That's the wheal. The flare, right? You think fire, flare. The flare is the red area around the wheal. So it's all of this red area, right? That's going to be around those areas of pallor, those wheals. Okay, so that's the wheal and flare. And this lesion is actually going to be raised a little bit. And that's because we're getting a lot of fluid in the superficial dermis, right? So as we have increases in vascular permeability and vasodilation, we're getting fluid leaking essentially into the superficial dermis. So that's what urticaria is. Now just be careful here too, because there's also angioedema, which you can also see here because of the vasodilation and vascular permeability. One technical kind of aspect to this is, remember, urticaria is going to be, we have fluid in the superficial dermis, where when we're talking about angioedema, we're talking about fluid deeper, usually in the dermis, usually in the subcutaneous tissues. Okay, so just a little thing to remember, when you're talking about the two of these. Now, like we said, the concern is that this can eventually lead to anaphylaxis, anaphylactic shock. Okay, so that's why this is taken extremely seriously. The even more concerning part is that it happens so quickly. So remember what I said, right? If you have a re-exposure, you already have everything set up for this patient to just degranulate their mast cells and their basophils, because you already have all these IgE antibodies set on the top of your mast cells and basophils. As soon as that allergen comes in, they're going to degranulate. So it happens immediately. So that's why sometimes the type 1 hypersensitivity reaction is sometimes called the immediate hypersensitivity reaction, because it happens so quickly. Everything's already set up. You put the allergen back in and you get instant degranulation. And then again, like we said, the concern is that can go straight into anaphylaxis. So that's why this is taken very seriously. All right, let's just recap the mechanism here. So pretty much what we talked about in the early stages of this happening, again, there's going to be some previous sensitization, which is all of this kind of initial mechanism that we talked about. And then what happens is you have the IgE Fc portion bound on your mast cells and basophils. That's exactly what we saw right here. That IgE Fab portion is going to bind to the allergen like we see here. And then eventually we'll have some cross-linking, right? We have some cross-linking that we talked about, and we degranulate and we release histamine. So we can see the degranulation here right after we have our cross-linking. Now, there's also going to be some release of tryptase. And you might be saying, well, what is that? do exactly? Well, the thing that I want you to remember about tryptase is that we can actually do a serum sample for tryptase. Let's say that we have a patient that comes in, right? Maybe they were exposed to something they think they're allergic to, and you might be concerned that this patient is kind of moving quickly towards anaphylaxis. What you can do is you can draw serum tryptase on them, and this will give you an indication as to if they're in fact at risk of anaphylaxis. So that's just one thing to remember in terms of the diagnostics. In general, though, when you're talking about things like anaphylaxis, it's usually more of a clinical diagnosis. You're looking for things like urticaria, difficulty breathing, shortness of breath, edema, etc. Now, the thing that is a little bit less high yield than what we talked about here, but has come up occasionally, is the kind of what happens in the later stages. What happens hours after you're exposed to this antigen? Because remember, the early phase are things that are happening immediately, right? We already have everything we need to degranulate. But later on, we do get some release of prostaglandins, leukotrienes from the arachidonic acid pathway, and a lot of this is potentiated through eosinophils. Okay, now you can see when we went through this mechanism, I kind of skipped this step here where the B cell can go on to release interleukin 5. And remember, interleukin 5 is very classic for stimulating eosinophils and eosinophil growth. And that's exactly what happens. These eosinophils are just a little late to the party though. Okay, so when you get questions on type 1 hypersensitivities, remember, you might have an eosinophilia, but classically the eosinophils are going to be the late stage players in the game. Okay, so they're not going to be things that are happening in the early phase mechanism. That's probably the highest yield thing to take away from this. And these all eventually also contribute to inflammation. And I think we already kind of talked about the presentation here. Again, generally the more mild presentation, which can potentially lead to this severe anaphylaxis if not treated. And typically when we treat these patients, it's usually going to be with something immediate like epinephrine. Now, if it's more mild, you can think about things like antihistamines, right? Because the problem is that you're releasing histamine, right? So if you give somebody an antihistamine, that should have some effect into kind of minimizing some of these more mild symptoms. And again, this sometimes will take a little bit of time to kind of kick in, and there's different antihistamines, there's different classes. Just know that a lot of what we're targeting here is primarily going to be at the H1 receptor, okay? And we don't have to go into too much more detail than that. Step 1 isn't very heavy on the management, but for step 2, we'll definitely go into more detail. But if we're talking about anaphylaxis, we need something that's going to work immediately. And so in those situations, we're talking about epinephrine. Now, the other thing in the diagnostics, remember, you can also do skin testing in these patients. If somebody comes in and they say, "Doc, I'm just allergic to something, I don't know what it is," you can test all different types of allergens on the skin, and essentially you're looking for these kind of reactions, right? You're looking for urticaria, edema, swelling, etc. Now, the last thing on here I just want you to remember, because this has been coming up more and more in questions, are these non-IgE mediated histaminergic reactions. So it's just like it says. It means in some way, we're stimulating mast cells and basophils to release histamine, but we're not doing it through IgE. That's the important point. So is it truly a type 1 hypersensitivity? The answer is no, but you should be familiar with these. You just should know that they're not using IgE to cause this type of reaction, because again, everything is really based on mechanisms for step 1. So the first one here is vancomycin. This is going to be very classic for causing the quote-unquote red man syndrome, which is usually due to a rapid infusion. If a patient gets a lot of vancomycin really quickly, you can get direct activation of mast cells, basophils, and get degranulation. Okay, but again, not mediated through IgE. There's no IgE. It's direct stimulation from the antibiotic in some way or another beyond the scope of step 1. The other thing on here is radioiodine contrast is also very classic for this. And then very kind of low potency opioids can sometimes do this. And again, the presentation for all of these, it can pretty much appear identical to, what we're talking about here. It's just not IgE mediated. So when you see a question with vanc, radioiodine contrast, low potency opioids, and all of a sudden that patient looks like they're having a type 1 hypersensitivity or maybe anaphylaxis even, right? Just remember that these are non-IgE mediated, because that's where the questions come in. Type 2 hypersensitivities, we're talking about basically an antibody in the serum essentially binding to host cells, and they're binding to the host cells through this antigen that's going to be on our host cell. So just walking through this mechanism, let's just say in this situation, our host cell is going to be our red blood cells, right? And we'll say that, there's some antigen on the red blood cell. Now, this could be because we have a certain pathology like autoimmune hemolytic anemia, for example, right? This AIHA, or this could be secondary to, a drug that we took. Maybe we took a drug that bound to the surface of our red blood cells and now is causing us to target our red blood cells. Okay, so let's just say for simplicity's sake that we took took some drug, right? We took some drug, let's just call it penicillin, for example. So let's just say that we took some penicillin, and that penicillin had an antigen, okay? That's kind of what you see here. So that's this antigen, and it bound to the surface of our red blood cells. Now, this antigen from the drug is going to be foreign to our body, and so we can generate antibodies against that antigen. And you might be saying, well, which antibodies are we talking about? Classically, when we're talking about type 2 hypersensitivities, we're usually talking about IgG or IgM. And again, you want to juxtapose that to what we talked about with type 1 hypersensitivities, where that was primarily IgE. Okay, so usually this antibody that's doing the work here, it's usually going to be IgG, but in some cases, it can also be IgM, although that would be a little bit less common. And so again, it's also important to know what's binding to what, right? So when I have an antigen, my epitope is usually going to get bound to the Fab portion of my antibody, right? My Fab portion, and then here you can see this is going to be your Fc portion. Okay, so again, I'm going to bind to this antigen on a surface of one of my cells. In this case, it's the red blood cell. And you can see, here's the antibody, right? There's the Fab portion. There's the Fc portion bound to this red blood cell, bound to the antigens. Now, what happens is when I start binding antibodies to host tissue, the body can think potentially that this structure is foreign. Similar to what happens if you have a bacteria, right? If you just think about, okay, if you had some bacteria here, right? You had some bacteria here and you wanted to target this bacteria. Well, on this bacteria, there would be antigens, right? We would target these antigens and then we would have antibodies that would come in, similar to what you see here. And these antibodies would come in and attach to these antigens and essentially stimulate complement, neutrophil chemotaxis, etc. So all the things that we talked about in the last videos, the only difference is instead of targeting this bacteria, we're targeting our own cells because our own cells have some antigen on them, either from a drug we took, from some genetic pathology potentially, right? Or some other things that we'll talk about. But that's the point. So the point is now we have this antibody bound to this antigen, bound to this host cell. And the questions come in where you have to know, well, what are the things that can potentially happen to this host cell? Okay, so there's really 4 major things. So let's go through those really quickly. So the first thing is we can go straight down that complement pathway. You can go back to the complement video, check that out. But essentially what we have here is we have complement binding. Remember, it's going to bind to the Fc portion of the IgG antibody here. And that can essentially lead to cell lysis, right? Eventually, if we get to the MAC complex, which is the terminal complement cascade, we can essentially use this MAC complex to essentially punch holes into this red blood cell and destroy it. Okay, so that's one option. So by having these antibodies attached, we can have complement cascade stimulated, and the terminal endpoint of that would be the membrane attack complex, C5b to C9. Now, the other option here is, remember, as I'm stimulating complement, I can also end up with opsonization, right? So instead of going to the terminal component of this membrane attack complex, I can stimulate C3b specifically. And C3b can then kind of drag in some of these phagocytic cells to essentially opsonize this red blood cell. And the end result is pretty much the same thing, right? We're going to destroy our own host cell that has this antigen bound, only it's a little bit different pathway. It's through C3b. Remember, that's particularly high yield. Remember, C3b associated with opsonization. And you can also remember that we talked about IgG is also associated with this pathway. And guess what's bound to the surface of these cells? IgG in most cases, right? IgG. And so IgG, like we said, is also very much associated with opsonization, and that's where this all comes together. C3b, opsonization, IgG, opsonization. Third thing on here is chemotaxis. Okay, so remember, again, going back to your complement cascade, C5a is going to be a very important chemotactic factor in conjunction with LTB4, interleukin 8, right? Those are really important neutrophil chemotactics, and those cytokines can essentially stimulate neutrophils to come to the site of wherever this antibody might be, right, with this complement, right? You might have chemokines getting released to these red blood cells. And these neutrophils, when they get to these red blood cells, they're just going to dump peroxidase and a lot of these really toxic chemicals on the red blood cells to destroy them. Now remember, we're targeting, in this situation, one red blood cell. When we talk about type 3 hypersensitivities, we're talking about like an entire region of the body or entire organ potentially that's going to get targeted. And so you can imagine that chemotaxis and complement-mediated C5a release is going to generally be much higher when you're targeting a whole organ, for example, like the kidney. In this situation, if we're just targeting red blood cells, you're not going to get as many neutrophils to the scene because these red blood cells are always moving around. So these neutrophils will play a little bit bigger role when we talk about type 3 hypersensitivities in terms of the damage that they can cause. And the last one on here is the natural killer cell. Now, this ADCC, antibody-dependent cell-mediated cytotoxicity. And this is largely driven by natural killer cells. And what this essentially means is, the name kind of gives it away in a sense. Antibody-dependent, right? We need this antibody here. This antibody will essentially bind to this receptor on the natural killer cell. So it's dependent on an antibody, and it's cell-mediated cytotoxicity, meaning the natural killer cells are going to mediate the destruction of this cell. Kind of similar to what happens with the neutrophil, but not exactly the same, because there's not chemokines necessarily that are stimulating this natural killer cell to come over here. This natural killer cell is binding to the IgG receptor here and then releasing perforins and granzymes to essentially destroy the red blood cell. Okay, so just remember, these are your 4 kind of major pathways, and a lot of this is really complement mediated. I mean, if you're just looking, just trying to remember this, you can really remember that this is a large portion of the cell destruction that's happening because we're binding to our own cells is mediated by complement. You just have to be familiar with your complement cascade. This all goes back to the complement video. We're just kind of adding a layer to that, and then also be familiar with antibody-dependent cell cytotoxicity that's largely driven by antibodies that are bound to cells, and then remember that it's the natural killer cells that are going to come and bind to those cells and then destroy them. The other thing that natural killer cells are very notorious for is binding to cells that don't have MHC1. Remember, all of our nucleated cells should have MHC1. So when cells are downregulating MHC1, that could indicate potentially that there's a cancerous process or something wrong with that cell, and natural killer cells step in and then destroy host tissue in situations where those MHC1 complexes are downregulated. So the 2 big things to remember, again, for natural killer cells, 2 big things to remember is that they're going to target cells through antibody-dependent cell cytotoxicity, and then also they're out there searching for MHC1. And if they find a cell that doesn't have it, then they're going to destroy it. Okay, so those are the big things. Let me clear this up here. Those are the big things for natural killer cells to remember, if you had to remember anything. Okay, so let's run through this really quickly. So again, this is sometimes referred to as a cytotoxic process, right? A cytotoxic hypersensitivity. Why is it cytotoxic? Because we're destroying cells, right? Cytotoxic, cell toxic, we're destroying cells. And the way this happens, like we said, we're going to have an antibody. That antibody is going to bind to our own host cell surface through an antigen, okay? Or there'll be graft tissue, which we'll talk a lot more about in the transplant rejection video. Again, 4 processes. A lot of this, like we said, really just mediated by complement. So if you're familiar with your complement cascade, I think this will make a lot of sense. So C3b, C5a, ADCC, we all kind of talked about that. Now, you should also know kind of what pathology falls into, each category of hypersensitivity. So autoimmune hemolytic anemia, very classic for this type 2 hypersensitivity, where you have antibodies that are binding to your red blood cells and eventually causing complement-mediated lysis and ADCC of those cells. The same thing is true with your platelets. You can have immune thrombocytopenic purpura, right, ITP, acute hemolytic transfusion reactions. So this is very classic if you have a patient that receives blood from somebody else and they're not matched, right? If you have mismatched blood being donated, right, and then given to a patient, right? So this is going to be mismatched blood. Is very classic for this. Obviously, we do a type and screen whenever we donate blood. I mean, emergent situations, they'll sometimes use O negative, but in general, we're trying to match the blood so we don't run into the situation. Like I said, I'll talk about this one in more detail when we come to it. But remember, the concept is the host has antibodies to certain markers on red blood cells. Depending on what the person's blood group is, they could have antibodies to other types of red blood cells, right? And so when you give those red blood cells, those antibodies then, what do? They can bind to this donated red blood cell, right, that has these different markers on it, and then can target it for destruction, and you can end up with a transfusion reaction. The other thing on here is erythroblastosis fetalis, and this is sometimes referred to as the hemolytic disease of the newborn. Okay, so we'll talk about this probably in its own video, but just to give you a high-level overview, essentially what we're talking about here is, and let's clean this up a little bit. So essentially what we're talking about here is certain red blood cells in mom. So I'm just going to put mom here. Okay, so certain red blood cells in mom can have markers on it. Okay, so we'll call this an RH marker. Okay, so we'll say RH positive, and then we have fetus over here. So we have mom and then we have fetus. Now, if mom's RH positive, generally she won't have antibodies against this factor, because if she did, she would then be destroying her own cells. Okay, so usually if mom's RH positive and baby's RH positive, everything's okay. But let's imagine that instead of mom being RH positive, if mom's RH negative, on the other hand, what that means is mom doesn't have this antigen on her red blood cells, but baby has it, right? And so what mom might do is mom might say, hey, mom's body might recognize this antigen as foreign, okay? Because mom doesn't have that on her cells, but baby does. And so what mom would do in this type of situation, potentially, is mom might start to generate antibodies against this RH factor. Now remember, in the placenta, we talked about this, there's only really one major antibody you need to remember that crosses the placenta, and that antibody is going to be IgG. And what are we talking about right now? What's the major antibody antibody here? We already said IgG, right? If this is the first baby, right, this is fetus number 1 that's Rh negative, it's going to take mom a little bit of time to go through class switching to generate IgG antibodies. Remember, her IgM antibodies aren't going to do a really good job of trying to get through the placenta because they're so big, right? They're pentameric, at least a lot of them are. Okay, so this first baby is not really going to get affected. But what's going to happen is mom's going to start to generate antibodies. There's going to start to be class switching against these antigens. They're going to get presented essentially to mom. Okay, and you're going to start to get T cell activation, memory response, all those things we talked about in the previous videos. And so mom, from this first fetus, will start to make antibodies. For baby number 2 though, okay, so baby number 2, let's say mom has a second baby, okay, let's say this baby is Rh negative. So if this baby is Rh negative, it's unlikely that mom would target this baby with antibodies, right? Because there's nothing to target. This antigen isn't there. There's nothing for the antibody to bind to. Mom's Rh negative, baby's Rh negative. So if fetus number 2 is Rh negative, we wouldn't have anything to worry about. However, if fetus number 2 is Rh positive, right, just like baby number 1, now we have that antigen on here again. And now mom's antibodies are ready to go. Mom already class switched. She already has a memory response. These IgG antibodies are going to go right through the placenta and right to fetus number 2 and start to bind to this antigen. And it's going to look just like what we saw here. This would be your Rh positive antigen, right? That's what's in yellow here. And then here's your IgG antibody. And we would go through all of the same process that we talked about right here. We'd have baby cells getting targeted and getting destroyed. And this is obviously a very serious situation. Okay, and we won't go into any more detail than that for this video, but that's really the mechanism, the idea of what you want to have when you think about erythroblastosis fetalis. Now, there's other examples here that are more inflammatory in nature. When I say more inflammatory in nature, I'm talking about more involvement of kind of a general tissue, but we don't have complex formation. The thing that defines type 3 hypersensitivity is that we start to make these complexes with the antigen and antibody. In type 2 hypersensitivity, most of the stuff we're just targeting single cells. But here, if we're targeting kind of an overall structure, for example, in Goodpasture syndrome, we're going to target type 4 collagen in the lungs and the kidneys. Okay, and so because there's not complexes, though, it actually goes into this type 2 hypersensitivity category. Okay, so again, you want to categorize these diseases into these different hypersensitivities. The same thing is true with rheumatic fever. Hyperacute transplant rejection is actually quite similar to the hemolytic reaction. Remember, when you start to transplant tissue, everybody has different HLA markers. You have to match up your HLA phenotypes. If you have a different HLA phenotype, when I put a graft in another patient, right? So here's my host or my recipient, right? You can call it either one, my host or my recipient. And then you have your donor, right? You have your host and your donor, okay? And the donor is going to give the host something, right? They're going to give them some kind of transplant. Let's just say, you know, the donor, we're doing a renal transplant, right? So the donor is going to give their kidney to the host, okay? So now the host is going to have the donor kidney, okay? But remember, the host is going to have different HLA markers, right? So the host might have one HLA marker. Let's just call this person HLA-A just for simplicity's sake, and let's just say that this person is HLA-B, okay? So if they have different HLA markers, those markers on the cells, right, this HLA-B marker on this kidney tissue might be foreign to this host who only has HLA-A. And so for that reason, this host might already have some antibodies against HLA-B, right? They don't have an HLA-B in their tissue. This is foreign to them. And so they already have these antibodies. They can bind to this tissue and essentially mark it for destruction. And again, this can lead to complement activation. We can have thrombosis of these vessels because of the infiltration from all this tissue and the inflammatory response. And that can also be problematic. And we'll talk about that more, like I said, when we go through the transplant rejection. So in the first few examples, we're talking about cells that are essentially marked for destruction. But now you can imagine these antibodies, instead of necessarily marking things for destruction, antibodies can also act to bind to things. They can bind to receptors or they can block receptors. So if we're talking about something like myasthenia gravis, for example, with myasthenia, you can see these receptors, these IgG antibodies are essentially binding to the acetylcholine receptor here in the neuromuscular junction. So you can see here, these are all going to be your acetylcholine receptors. And here you have your acetylcholine, right? It's traversing the synaptic cleft, trying to make its way to the receptor. But guess what? All of these antibodies are blocking the receptor, which can eventually lead to that muscle fatigue that we talked about in the neurology section, where these patients will typically, especially with the cranial nerves, these patients will tend to have difficult time after repeated motor stimulation. In Graves' disease, this is another classic one where the antibodies not necessarily destroying or marking a tissue for destruction, but instead stimulating a receptor. So with myasthenia, we're blocking the receptor, so we can't stimulate it. Here, we're actually stimulating the receptor using antibodies. So you can see TSH can bind to some of the receptors in the thyroid follicle and cause thyroid hormone production. But we can also make antibodies that bind to the receptor as well and also stimulate the receptor to make thyroid hormone production. And if we make too much of this thyroid hormone production, we end up in a situation with hyperthyroidism. That's essentially what Graves' disease is, right? Because we're overstimulating the TSH receptor. Just to be familiar with, again, you want to know you have to understand the mechanisms and where these mechanisms fall into these different hypersensitivities. And again, their relevancy. Finally, the last two things on here, we have our diagnostics. So the direct Coombs test. It's very confusing for a lot of different people. So let me just kind of try to explain this. Okay, so you have to understand for each of these tests. So let's just write direct here. So this is going to be the direct Coombs test. So you have to understand for each of these tests what's going on with your host, right? This is going to be your patient. And then what are you adding essentially? Okay, so what's the lab thing that you're adding? Okay, so here's the host and what are you adding? So in this situation, in the direct Coombs test, we're testing for the antibody bound to host cells. So we have a host, let's just say we have our red blood cell here. Let's use the example we talked about. We have some antigen bound to that red blood cell. Okay, and that antigen, these antigens that are on our red blood cell, we have antibodies that are binding to those antigens, right? This is what we just talked about, right? So we have these antibodies all here that are bound to the antigens. Now, this is what we're going to have from the host. What we're adding to the host sample is going to be antibodies to the antibody. So we're adding some kind of anti-antibody. Okay, kind of what we talked about before. And so what this looks like is, so when I add these two things together, these anti-antibodies are going to bind to the Fc portion of the antibodies that are bound to my red blood cells. Okay, and what happens is when I get a bunch of these added antibodies binding, it's going to cause this whole solution to agglutinate, because you can imagine there's going to be other red blood cells here. They're all going to agglutinate, and that's going to indicate a positive test. In other words, we're testing to see if the host has antibodies bound to the surface of the red blood cells. If the host didn't have antibodies bound to the surface of the red blood cells, these blue antibodies, these anti-antibodies, they'd have nothing to bind to, and so we wouldn't get agglutination. So agglutination is going to be a positive test, right? What does that mean? What does it mean that it's a positive test? It means that the host cells have antibodies bound to them, and the anti-antibodies that we added bound to those antibodies. And where do they bind? To the Fc portion of the antibodies bound to the host cells via the anti-antibodies Fab portion. Okay, so I know it's a little confusing, but again, the important thing is in the details. That's what you have to pay attention to. What does the host have, right? What's in the host sample, and what are we adding? So the host, we're just going to add the host's serum. And the idea here is if the host has antibodies in their serum, we can add red blood cells potentially with some antigen to see if the host cells will bind to that antigen. Okay, so here's my red blood cell with the antigen. And again, it's not the host's red blood cell. We're adding some external red blood cell with the host's serum. And what happens if I put these together, right? If I put these together, these antibodies are going to bind to these antigens. And what would I expect? I would expect agglutination, right? If there were antibodies in my host serum, which again would be a positive test. And you can imagine the classic antigen that's going to be on red blood cells that we add for doing this agglutination, we might be testing to see if we have red blood cell transfusion compatibility, right? Because different hosts, right, different people will have different markers on their red blood cells, right? If you're type A or type AB, positive, negative, right? And so we might be testing to see if the person that we're going to give this blood to has antibodies to the donor. So we might be seeing if the person that's going to receive the blood, right, that being the host, has antibodies to the donor's red blood cells. That's the solution that we're essentially going to be adding to the host's serum. Okay, so that would be a red blood cell transfusion reaction we would be testing for. We can also do this for hemolytic disease of the newborn or erythroblastosis fetalis, right? We can test mom serum, right? In this situation, this would be mom serum for the antibodies to the Rh factor. Okay, and we can add in red blood cells that are Rh positive, right? So we can use this test, the indirect Coombs test, for things like this specifically. And if you're getting questions on, well, what is this test looking for? Again, we're testing for if the antibody is present in the host serum. If it's present, we add something that we suspect has that antigen. If we get agglutination, we're confirming that the host has the antibodies in the serum. With the direct Coombs test, remember, it's a little bit different. We're looking to see if there's antibodies already bound to the surface of the host cells. So we have to use an anti-antibody that binds to that Fc portion of whatever we think this pink antibody might be. So I know that's a little confusing, but again, understanding the details is critical to getting a lot of these questions right. So just kind of go through this a couple times if you're a little unsure. And a lot of this builds on the previous videos. So if it's a little confusing, go back, check out the previous videos, and I think it will probably make more sense. All right, so type 3 hypersensitivity. So how does this compare to what we just talked about with type 2 hypersensitivity? Remember, in type 2 hypersensitivity, we have antibodies that are binding to the antigens on the surface of cells, primarily. When we're talking about type 3 hypersensitivity, though, these antibodies are binding to these kind of free-floating antigens or soluble antigens in the bloodstream. So the key word here is soluble. So we have antibodies that are binding to these soluble antigens. In other words, they're kind of just free-floating, and you can see these antibodies binding to them. Now, in a type 2 hypersensitivity, we talked about these antibodies binding to antigens that were on the surface of cells, and the cell that we use as an example was a red blood cell. So instead of this antigen kind of free-floating, that antigen would have been on the surface of this red blood cell, and then our antibody would have bound to that specifically. Okay, and then that would have marked this red blood cell essentially for destruction. And that was what we talked about with the type 2 hypersensitivity. And again, type 3, these antigens are kind of free floating in the blood. And so, what's kind of the repercussions of that? Well, there's a couple things. You can imagine that if you have a bunch of these antibodies and antigens kind of getting stuck together, so to speak, and kind of forming that snowball effect where, that it's just going to get bigger and bigger and bigger and then get deposited into tissues, what happens here is you kind of see this arrow pointing down as this gets deposited into the endothelium here. As more and more of these antigen-antibody complexes get together, you're going to start to get complement activation on all of these FC portions of these antibodies. So complement is going to start to get activated, and we just kind of talked about that in the last video. What are the repercussions of that? Well, if it was a single cell, you'll see a lot of the membrane attack complex being released. But one thing you'll see, especially in the bloodstream here, when you have these immune complexes, is you'll get a lot of the C3, C4, C5a getting released. And when you think about type 3 hypersensitivity, think of this as being even a stronger level of complement response than you typically see in a type 2 hypersensitivity. And you might be saying, well, why is that? The reason is because you have all of these antigen antibody complexes together and all of these FC portions getting complement activation in this one location. So what happens with that? Well, remember, C3a, C4a, and C5a are all going to work to increase vascular permeability. That can lead to edema. So this is something that we've already kind of touched on, but the even more important thing is, remember, C5a specifically, we just talked about this in the last video, is responsible for neutrophil chemotaxis. That's particularly high yield, along with LTB4 and interleukin 8. So neutrophil chemotaxis to this site, you're going to get a whole bunch of neutrophils, right, from all of this complement activation. You're going to have all of this C5a. So you can see all of this kind of C5a, we'll just call it here, kind of getting released down into the bloodstream. And that's a chemokine. It's attracting all of these neutrophils to the scene, right? So these neutrophils are coming to the scene. And when these neutrophils get here, what are they going to do? They're going to dump tons of myeloperoxidase and peroxidase and just damage all of this tissue where these immune complexes are getting deposited. And this is on a pretty large scale in a lot of situations. So that you're going to have lysosomal destruction of that tissue. So this is essentially explaining the inflammation you get, right? When you talk about something like vasculitis, right? If I say, okay, this patient has, vasculitis secondary to type 3 hypersensitivity. What am I saying? Well, itis, right? We're just saying inflammation of the vessels. Where's that inflammation coming from? The neutrophils. Where's the neutrophils coming from? C5a. Where's the C5a coming from? Complement. And where's that complement binding to? They're binding to all of these antigen immune complexes. If you can kind of go through this in your mind, it's hard to get questions wrong because you understand the process, right? If you understand the process, you know how to play the rules of the game. You just have to apply that knowledge, just to apply the foundations. And that's essentially what we're talking about. So that's what vasculitis essentially comes from, right? So you have inflammation in the blood vessels secondary to this immune complex formation, right? And so the classic example of that would be polyarteritis nodosa, okay? And this is very classic for patients that have had hepatitis B infection in particular, and that's particularly high yield. And we'll talk about that more in the room section. Another classic one is post-strep glomerulonephritis, which is actually the most common cause of nephritis syndrome in children, okay? So it tends to get asked about very frequently. These patients will have all of this happening essentially in the kidney, and so they'll present with hematuria, edema, high blood pressure at some time after a strep infection. Usually 2 to 4 weeks is the normal range, right? 2 to 4 weeks after some kind of strep infection is very classic for causing this. And the classic strep infection that you should be familiar with is strep pyogenes, right? That's going to be very, very high yield to remember. And we'll talk about this more in the renal section. But again, it's applying that knowledge to understand the pathophysiology. That's where a lot of the questions come in. Lupus, it's the same thing. Again, we're targeting the kidneys in this situation. That's our tissue, IgA nephropathy, all of these being kind of that same category. And then hypersensitivity pneumonitis is also in here. Okay, and again, the point of this video, though, is not so much to go through each of these diseases, but more so to understand this mechanism. Again, antigens are binding to immunoglobulins, soluble antigens, floating around in the blood, not on any tissue at this point. Then they're forming these immune complexes like we see here. Those immune complexes are then getting deposited into tissues. If it deposits in a blood vessel, I get a vasculitis. If it deposits in a joint, I get an arthritis, right? If it deposits in a kidney, I get a nephritis. Now, the thing that I said earlier is the complement activation is quite extreme, especially compared to the type 2 hypersensitivity. And the thing that you want to remember about that is the neutrophils are really mediating a lot of the damage here, okay? Because there's so much immune complex formation, there's so many FC portions kind of localized in that one location, you're getting a lot of neutrophils to one spot, and they're all kind of just dumping their myeloperoxidase, peroxidase, all these toxic substances onto the host tissue. Okay, so we kind of already touched on this, correlating with the tissue involved. Now, one image that I think is relatively high yield is just understanding, when you get a patient that has vasculitis, as this is kind of the classic type 3 hypersensitivity along with some of these nephritic syndromes, it's important to understand kind of what you're looking at. Okay, so when you're looking at this slide here, I can see that this is a blood vessel, right? So I can see that I have a blood vessel here. I can see it's got kind of a muscular outer wall here, right? So probably arterial. And then you can see all of these red blood cells in the middle here. So that tells me this is some vessel. And if we go zoom in a little bit, we can see kind of the outside of that vessel. You can see all of your red blood cells are here, right? You have all of your red blood cells, okay? And then you can see there's also a bunch of neutrophils in here. So we have a lot of inflammatory cells that look like they're inside this vessel. And then you can kind of see that here too, right? In this vessel, here's your muscular lumen, right? You see your red blood cells here, and you can see that there's a huge inflammatory infiltrate here. And so when you see something kind of similar to this, where you see a lot of, and the easiest thing to do is just to look for inflammatory cells. The inflammatory cells everywhere is going to be significant in patients that have some type of inflammation ongoing. A lot of times you'll see the inflammation in vasculitis described when they're looking at the blood vessels as a fibrinoid necrosis. This vasculitis in particular, the other thing to know is, again, because it's mediated primarily by leukocytes, right? It's mediated by white blood cells like neutrophils. Sometimes this vasculitis in particular, when we're talking about this, is called a leukocytoclastic vasculitis. So what they're essentially saying is it's a vasculitis that's primarily mediated by leukocytes, right? And so that's the concept. So that's when you see leukocytoclastic vasculitis, fibrinoid necrosis. These are all kind of big words, kind of scary words if you don't know what they mean, but they're really just talking about a vasculitis induced by the leukocytes because of the complement activation, right? And then also you have a huge inflammatory infiltrate. You have necrosis of this tissue because you're dumping all this toxic substance onto the lumen, essentially, right? Or the blood vessel wall, and that's causing you to have some necrosis. So serum sickness is also very classically talked about with type 3 hypersensitivity. Now, let me just kind of clean this up a little bit so I can tell you a little bit about this. Okay, so when we're talking about serum sickness, the classic kind of way this is going to get asked about is usually with antitoxin or antivenom. So let's just say that we have a patient that gets bitten by, and this is supposed to be a rattlesnake, okay? So this rattlesnake is essentially going to, inject some type of antigen, right, into this patient that's essentially going to cause an inflammatory response. Okay, and we want to give this patient an antitoxin to that antigen, right? So what this patient does is they come to the emergency room and they have symptoms, etc., and then we give them the antitoxin to that rattlesnake, for example. Okay, so we give them the antitoxin, and this antitoxin is essentially going to be binding up to these antigens, right? And in some way, depending on what we're talking about specifically, if it's rattlesnake or tetanus, it's essentially going to eliminate that antigen from causing disease. And it could do this in a variety of ways. Again, this is gross oversimplification. But the concept is we give them an antitoxin. Now, the patient may, in some situations, create antibodies to the antitoxin. So the patient might say, look, this antitoxin is foreign to me. I don't recognize this antitoxin. So the body might start to make antibodies, right? So the plasma cells eventually will get wind of this and they'll start pumping out antibodies to the antitoxin. So these antibodies will try to bind to the FC portion of the antitoxin. So again, this is where you have to kind of be sharp on the name here. We're making antitoxin antibodies. essentially, right? For the plasma cells to start pumping out IgG antibodies, for example, to the antitoxin, we have to go through class switching, right? There's a lot of steps in the pathway, right? The antigen presenting cell goes to a T cell binds CD40 ligand, class switching, etc. All the things that we talked about already. So this process takes some time. Now we have a whole bunch of these antibodies around to bind up these antitoxins. And so what does that do? Well, now you have, if you can imagine this, you have an antitoxin that's bound to the antigen, and you also have the antitoxin antibody all bound in one structure. And so, of course, these are going to start to kind of congregate, and you get what? You get immune complex formation, which is the classic thing that we're talking about with type 3 hypersensitivity. And this can happen throughout the body. Okay, so again, just reading through this, we have antitoxin, antivenom antibodies, and the other ones that are very classic for this are the monoclonal antibodies. These are going to be very classically recognized as foreign. Remember, these are going to end in MOB, right? Those are the monoclonal antibodies. A board question in some situation can ask you about a patient that recently received one of these and now has immune complex formation, or now has vasculitis, or arthritis, or glomerulonephritis potentially from exposure to either monoclonal antibodies or antitoxin antivenom. Now, what can you test for? And this goes for all of type 3 hypersensitivity. What you can test for is you can test for C3, C4 levels. And you might be saying, well, why is that? The whole crux behind this type 3 hypersensitivity is that you have widespread, massive amounts of complement activation. And if you have massive complement activation, significantly higher than a type 2 hypersensitivity, you would expect your complement levels to be low in the serum because you're using up a lot of that complement. Now, of course, you might be saying, well, what am I going to look for on pathology, for example, if I have a patient with serum sickness? Well, we already talked about it. You're going to look for vasculitis. You're going to look for arthritis, glomerulonephritis. You're going to look for tissues generally that have immune complex formation that are getting damaged, some kind of inflammation. And a lot of times this could be systemic because these antibodies are traveling everywhere in the bloodstream, depositing everywhere. The thing that you have to be careful about is serum sickness-like reaction, because occasionally this gets distinguished from serum sickness, and this is not the same thing. The big thing to remember is that serum sickness-like reaction is not considered to be a type 3 hypersensitivity. Okay, so it is not in this category. Serum sickness is considered to be a type 3 hypersensitivity. Serum sickness-like reaction is not. And there is no immune complex formation, which is essentially why it's not considered to be type 3 hypersensitivity. And the idea here is that this presents similarly to serum sickness, but because there's no immune complex formation, generally the symptoms are much milder and the complement levels are normal because complement is not causing the symptoms per se. This just has a similar presentation. So it's a different mechanism, different pathophysiology. It just presents similarly, less severe, normal complement. Classically, penicillins and cephalosporins are kind of notorious for kind of getting in this category. Now, of course, you can take penicillin and have a type 2 hypersensitivity, right? We kind of already touched on that. This isn't saying that penicillin only causes serum sickness-like reactions. This is just a very classic presentation. So if you start to get a patient that has a little bit of arthropathy, maybe they have some hematuria, but they have normal complement levels, no immune complex formation, and they're bringing up penicillin or cephalosporins that the patient was recently started on, it would be a tougher question, but you would probably want to start to think about serum sickness-like reaction, especially if they did some biopsy and there wasn't really an inflammatory infiltrate, right? All right, the last one on here is going to be the Arthus reaction, and this is probably the least high yield of the ones above, but it is something that comes up occasionally, very classic as a complication of the Tdap vaccine. And this is essentially talking about a more local immune complex formation. So remember, with serum sickness, this is everywhere. This is in the blood. We gave that antitoxin, right, systemically into the bloodstream. Whereas with an Arthus reaction, you're injecting usually in one area, and so you have a local reaction just in that area where you have immune complex formation. And what happens is, initially, again, just like with the antitoxin, the first time you give the vaccine, the body might make some antibodies to it. And with Tdap, right, or DTaP, starting in the younger population, what happens is over time, you're constantly exposed to that vaccine because you need a lot of boosters, right? And so over time, you make antibodies, right, to those Tdap antigens. And so eventually, as you get the vaccine, right, what's going to happen is you get this kind of local reaction. You might get local, swelling. You might have a little bit of complement activation in that one area, a little bit of inflammation in that one area, but overall, significantly less severe than what we're talking about with something like serum sickness. And again, this is going to be very classic as a complication of a vaccine that requires a lot of boosters. Tdap tends to be the classic All right, congratulations. We have made it to the type 4 hypersensitivity. If you've been following this video series, so far, this is actually probably going to be one of the easiest hypersensitivities to understand because we've talked about this mechanism so many times that at this point, it should be pretty much review in terms of T cell activation component. And again, the thing is that I'm kind of referring to here is, when we talked about type 1 hypersensitivity, we were talking about IgE antibodies. When we talked about type 2, we were talking about, IgG, maybe IgM binding to the surface of cells. Type 3, we're talking about immune complex formation, IgG being very classic. But you can see in all these situations, we're talking about an antibody. We're talking about some kind of humoral response, right? But in type 4, it's kind of in its own world over here, in the sense that this is primarily going to be T cell mediated, and it's going to be more, like we said, cell mediated response because we have T cells involved. So it's a little bit different in that sense. It's not necessarily humoral. There's no antibody that's classically going to be kind of potentiating this pathway. Okay, just to clean things up here a little bit, let's just go through an example of this. So allergic contact dermatitis is kind of like the poster child for this. And when we're talking about this, there's a few different causes, right? Poison ivy is one, latex, nickel. Let's just go with poison ivy here and we can kind of go through a demonstration. So, poison ivy, our patient, this is the surface of their skin, right? And they're having some exposure to poison ivy. Maybe they were outdoor camping, which would be very classic. Whatever the case may be, this patient was exposed to poison ivy. Okay, so this patient was exposed, and this chemical that's released here, this is urushiol. Okay, and this chemical is very classic for causing some of these symptoms. Now, urushiol is actually a hapten. It is referred to as a hapten, and essentially what that means is it can bind to proteins and then have that protein with the hapten presented to these antigen presenting cells that we see here. And so, if we're talking about the skin, what kind of antigen presenting cell we're going to have here? Well, primarily probably Langerhans cells. And those cells will find these antigens and bind to them, right? So they'll bind to their corresponding receptor, binding to the epitope. And of course, this is the same thing that we've been talking about, from day one, watching these videos, right? So the antigen presenting cell is going to present that antigen on MHC2 to a CD4 positive T cell, right? And then that CD4 positive T cell with the matching T cell receptor, CD4 positive co-receptor, will bind to that antigen. It will get activated, right? And then this antigen presenting cell will activate it using interleukin 12, right? Interleukin 12 will be used to activate the CD4 positive T cell. And then this CD4 positive T cell will then form a T helper 1 cell, again, because it was stimulated with interleukin 12. And then that T helper 1 T cell will then go on to release interferon gamma to activate antigen presenting cells, particularly macrophages, to release chemicals at the site of the urushiol. That's where that inflammation is going to be. So again, same concept we talked about. It's literally just the T helper 1 response that I'm referring to here. The important point though is you have to know, is this the first exposure or re-exposure? This is something that we keep kind of going back to. On initial exposure to this antigen hapten complex, the antigen presenting cell, like we said, will present to the CD4 positive T cell, binding via MHC2. Interleukin 12 stimulates differentiation to a T helper 1 cell, and then that T helper 1 cell will release interferon gamma. That interferon gamma will essentially stimulate macrophages. However, on that initial exposure, this isn't going to tend to be as dramatic as subsequent exposures, right? The memory response is going to be much greater. So if I'm exposed to this again down the road, I'm going to have preformed T cells that are ready to go in this tissue the next time I get exposed to urushiol. And in that situation, I'm going to have a lot more interferon gamma released from those T helper 1 cells, meaning there's going to be a lot more macrophage activation, meaning that this inflammation is going to be a lot worse, right? That's the idea. I'm going to have more interferon gamma release because I have more preformed T cells, because I generated a memory response, right? Because I generated a memory response. That's the key. So subsequent exposures will be worse. It's kind of like what we talked about with the type 1 hypersensitivity, different pathway though, right? And so again, we'll generate an inflammatory response. And the other thing is, remember, these antigen presenting cells, right? So let's just kind of clear some of this up. These antigen presenting cells here that are binding to these proteins, these haptens, if they're binding them up or if they're phagocytosing something to present them, then they're going to be on MHC2, right? Remember that. So if you're phagocytosing something, if it's an extracellular antigen, it's going to be on MHC2. However, remember that all of our nucleated cells have MHC1, including the antigen presenting cell. Now, the antigen presenting cell will usually only display antigens on MHC1 if it's infected with them. Like if there was a virus, for example, a virus could infect an antigen presenting cell, cause it to then be presented on MHC1. And remember, if you present on MHC1, the cytotoxic CD8 positive T cell can then get activated and destroy it. In this situation, urushiol isn't necessarily infecting the antigen presenting cell. So pretty much the antigen presenting cells will just present on MHC2. However, there is urushiol that's going to be in close contact with some of this epithelial tissue. These epithelial cells can potentially present on MHC1. That MHC1 presentation would cause activation of CD8 positive T cells, eventually cytotoxic killer CD8 positive T cells that would then release perforins, granzymes to cause inflammation to the tissue here. In fact, a lot of the inflammation and tissue damage you see here on subsequent exposures is because of the CD8 positive T cells that are ready to go from this memory response to wreak havoc and damage at these sites that are exposed to the urushiol. Okay, so again, key points here. Number one, it's a T cell response. Memory response is a much higher on subsequent exposures, similar to what we talked about with type 1 hypersensitivity, even though this is a different mechanism, right? It has to do not necessarily with the class switching of antibodies, it has more to do with a memory response of preformed T cells that are ready to go in response to these antigens, generating larger quantities of interferon gamma, more macrophage activation, more cytotoxic killer T cells that are ready to go. And again, also remember, all this interferon gamma is going to cause your acute inflammatory response. The key 3 cytokines to remember for that were TNF-alpha, interleukin 1, interleukin 6, right? So that's where you can get fever potentially from this. You can get some edema in this area, right, as you get fluid leaving this area because of this inflammatory cascade. And remember, kind of 2 divisions here, right? You have your T helper 1 response, you have your cytotoxic CD8 positive T cells, all of this being cell mediated. And that's why before I kind of said that the T helper 1 response is in some ways part of that cell mediated cascade. Okay, and the only thing I think I skipped on here was this interleukin 2. Just remember, these T cells that when they get activated, interleukin 2, remember what it's responsible for. It's basically responsible for T cell growth. It can be autocrine, paracrine, endocrine, right? It can stimulate T cells anywhere. Even the T cell that releases interleukin 2 can then get stimulated by the interleukin 2 it released. With that being said, CD8 positive cytotoxicity is a big factor in a lot of these situations. Like I just said here, right? CD8 positive T cells can wreak a lot of havoc and cause a lot of damage simply from releasing perforins and granzymes on subsequent exposures. In situations like MS, we're targeting oligodendrocytes, right? Inflammatory bowel disease, type 1 diabetes, we're targeting the pancreatic cells. Hashimoto's thyroiditis. Remember, Graves' disease, if you're comparing the two, Hashimoto's being hypothyroidism, Graves, you're thinking hyperthyroidism. Graves' disease is a completely different mechanism, right? We're not using CD8 positive T cells to destroy thyroid tissue in Graves' disease. In Graves' disease, we're essentially going to be taking antibodies to bind to the TSH receptor to stimulate it to cause more thyroid hormone to be released. So again, that you have to understand the mechanisms here. If you understand the mechanisms and how all of this works, you're going to get a lot more questions right than if you're just trying to memorize where things fall, right? You have to kind of understand what's happening. In this situation, we're literally just destroying thyroid tissue as opposed to stimulating a receptor that causes more thyroid hormone to potentially be released. And again, CD8 positive T cells primarily will be binding to MHC1. Remember, almost all of our nucleated cells are going to be displaying this. If T cells recognize something on MHC1 that's foreign, they'll destroy it, right? If it's on oligodendrocytes, if oligodendrocytes are foreign to our T cells, if our self-tolerance isn't preserved, so to speak, through those initial steps in negative selection, right? If that wasn't effective, or if we have a poor T regulator response, we might be targeting our own tissues. Okay, and these are all things that we've talked about already. And how are we doing that? We're doing that by having CD8 positive T cells bind MHC1 on our nucleated cells, particularly in the case of MS, oligodendrocytes, pancreatic tissue, thyroid, whatever it may be. I put a little bit of skin differential on here. The only thing, I really want you to take away from this is going back just because we're talking about the skin. I don't want to make this like a derm lecture or anything, but just know allergic contact dermatitis. We talked about the big 3 on here. Dress syndrome is drug rash and eosinophilia with systemic symptoms syndrome. I know it's a mouthful. Really, the big thing for this is a patient that was just started on allopurinol. That's like the classic drug. It doesn't have to be allopurinol, and allopurinol can be seen in hypersensitivity reactions, etc. But the point is with Dress syndrome, when you're comparing it to some of these other pathologies, Dress syndrome is very classic for happening, 1 to 7, 8 weeks after you start the drug. So it's going to be sometime after you start the drug, a few weeks after, and the patients will have eosinophilia, just like the name says, right? You have the E for eosinophilia. They'll also have variations in the platelets and the lymphocytes, right? I don't want to go into all the details on that, but just something to be familiar with. We're talking about the different medications here. So allopurinol for Dress syndrome. And then when you're thinking about SJS and TEN, which you can also see allopurinol with, but the big 2 drugs I want you to remember are going to be lamotrigine for SJS and TEN. And by the way, this is Stevens-Johnson syndrome and toxic epidermal necrolysis. And you can check out our derm videos for, a really good explanation on this, but I don't want to get too off track. But lamotrigine is one big one. And then the other one is trimethoprim sulfamethoxazole. So these 2 are going to be very classic for causing this syndrome in particular, or at least putting patients at some degree of risk. I also put phenytoin and carbamazepine on here just because, like lamotrigine, it's kind of like that whole anti-epileptic category. It can get plugged into that SJS-TEN profile. So just something to keep in mind. But particularly if you see a question about lamotrigine or trimethoprim or sulfamethoxazole, just keep that on your radar. Okay, the last thing I want to talk about on here is going to be the tuberculin skin test and the Candida skin test. And so just remember what we're talking about here is we're talking about injecting some antigen, right? So we're injecting some antigen. And if I've had exposure to this antigen before in the past, then I'm going to generate a response, right? I'm going to have antigen presenting cells, the same pathway we talked about, activating our T cells. You know, if I've been exposed to this before, I'm going to have pre-formed T cells that are pretty much ready to go, okay? In fact, there could be T cells that recognize this antigen directly in certain situations, but a lot of times there'll be an antigen presenting cell initially kind of surveying this area, presents it to a T cell, and these T cells are ready to go. We're going to have a memory response. So we're able to generate, a relatively fast response within, 48 hours or so, where these T cells can then cause, right, cytotoxic T cells, CD4 positive T cells with activating macrophages can cause there to be some induration that forms here. So we're just going to call this an induration. And this basically shows that we had been exposed to whatever antigen we injected into this patient, right? It shows that we've had a previous exposure. We were previously exposed to that antigen. And this, again, is very gross oversimplification. I think we went through the pathway a little bit more when we talked about the Candida skin test, but it's the same pathway that we've been going over this whole time with T cell activation, T helper 1 response. Okay, the point is it's a cell-mediated pathway, okay, and you need T cells. You need T cells for you to generate this induration. You can imagine if I took out these T cells, I wouldn't get the induration here. Okay, that's the point. All right, so you need T cells. So let's just go through this. So the first thing, I'm gonna start here with the Candida skin test. If I gave a patient a Candida skin test, what would I expect to happen? So let's just say that here's a healthy patient, okay? Here's a healthy patient. We'll just draw a smiley face here. So this patient's healthy. This patient, if I did the Candida skin test on them, okay, I'm just going to put C test here for Candida skin test. If I did the Candida test, what would I expect to happen in a healthy patient? Would you expect to get an induration of some size, right? The answer to that is yes. You would expect there to be an induration because the patient should have been exposed to Candida. That's number one. They should have been exposed. You might be saying, well, how do I know this patient was exposed to Candida? Well, almost everybody is exposed to Candida at some point, right? It's a superficial skin infection. We just don't see candidal infections because our body's able to fight it off. Okay, so but most people have been exposed to Candida. And so in a healthy patient, you would expect there to be an induration. Now, what about a patient, on the other hand, that's not healthy? Okay, so maybe a patient specifically, let's say this patient has SCID. Okay, so this patient has very low levels, if any, T cells, or maybe it's an AIDS patient, right? So this patient, we're gonna put no smiley face right now. So this patient is not happy, right? And so if I did the Candida skin test on this patient, would I expect to get an induration? And the answer to that is no. You wouldn't, because you don't have functioning T cells. If you don't have functioning T cells, because you can't go through a T helper 1 response, you can't have CD8 positive T cells attacking that area to cause there to be some inflammation to get the induration. Okay, so that's the point. Let's add a layer to that. Now let's talk about the tuberculin skin test. So now if I did a tuberculin skin test on a healthy patient who does not have TB, okay, would I expect an induration? And the answer to this is no, right? You wouldn't expect an induration if my patient was healthy and my patient did not have TB. Now let's say that I had a patient that is not healthy, right? And this patient also does not have TB. So this patient's not healthy, but they don't have TB right now. Okay, now let's say in our patient that's not healthy, this patient has SCID, for example, right? But this patient also does not have TB. Let's say I do the tuberculin skin test in this patient. Would I expect this patient to have an induration? And the answer is no, right? It's for the same reasons as the Candida skin test. It doesn't matter what T cell tests I do. In any case, this patient will not have a induration because they don't have T cells. Okay, not because they don't have TB, but because they don't have T cells. Okay, now what if these patients actually had TB? Okay, so let's do T test and then we'll put yes, TB. What if we did the T test and my healthy patient actually had TB? what would happen? So try and think about that. So if you had a healthy patient that has TB, what should happen on this test? Well, the T cells are working, right? And this patient has been exposed to TB. And when I put yes TB, I'm saying the patient's been exposed to TB at some point, right? They're previously exposed. That could mean that they have a current infection, they've been previously infected, right? Or maybe they even got a vaccine, like a BCG vaccine in the past. So they've had this antigen exposure in the past, right? So in this situation, if this patient had been exposed in the past, what would happen if I did the tuberculin skin test? Would I expect an induration? And the answer is yes, you would, right? Because you've been exposed to the antigen in the past and you have T cells here that are essentially functioning, right? So in this situation, we would expect there to be some response in my healthy patient, even though this patient's healthy in the sense that they have T cells, they are infected with TB or had previously been exposed, right? It could be either one, but they would generate an induration in that situation. Now, what about my not healthy patient? So again, we do the T test and we're saying, yes, this person has been exposed to TB. It could be an active infection, could be a previous exposure. Would I expect this patient to have a sizable positive test, right? A positive induration? And the answer is no, right? It doesn't matter what this patient actually has, what exposure they have. And why does it not matter? Because they don't have T cells. If you don't have T cells, no matter what, you can't generate the induration, right? If you have SCID, if you have AIDS, you're going to have a problem in these situations, okay? So that's why they have to sometimes change the parameters of what is a positive test in patients that are immunocompromised. In a healthy patient, we would expect whatever this patient has in terms of exposure should be semi-accurate. And so what you can do in these patients, right, if you're not sure what the patient's T cells are like, you don't know if there's any anergy, right, in this patient, you can do a Candida skin test and a tuberculin skin test. So the Candida skin test, right, will just tell you if this patient has functioning T cells. You are expecting an induration, right? Are the T cells functioning? That's the question that the Candida skin test is going to answer, because everyone, more or less, should have been exposed to Candida. The tuberculin skin test, on the other hand, is going to answer, does this patient actually have TB? Okay, but you have to look at these together, right? So if you have a negative TB test, but you also have a negative candidal antigen test, well, that's not very helpful. That tells you that this patient might just be immunocompromised. That doesn't tell us if this patient has TB or not, right? It just tells us that this patient is probably immunocompromised. And so you're essentially using the Candida skin test as a control, okay? So this is where a lot of these questions come in, where you have to understand what's going on. You can't just sit back and memorize all this stuff. It'll be pretty difficult. If you understand the principle behind each of these tests, the point is, if you've previously been exposed to an antigen, you generate an induration here. The key of that is that you need to know that you need T cells to generate that response. So you have to weigh in, has this patient been exposed, and do they have functioning T cells? And all of that has implications into your results. All right, so we just included this table here to recap some of the information. There's a ton of information on hypersensitivities, but again, we'll just go through the big stuff here. Remember, type 1 hypersensitivity, the classic term we use to describe this is immediate, because we have the preformed IgE antibodies on the mast cells and on the basophils. Remember, you have to have a second exposure, though, to get to that point, because we had to class switch to get those antibodies onto the mast cells and the basophils. The early phase is the phase that's classically asked about. Probably the most important thing to remember here is that we have mast cells and basophils along with preformed IgE that will cross-link when antigens bind, degranulation, histamine release. Remember, tryptase also, you can measure the serum for that. And then the late phase, remember eosinophils, but not quite as high yield. Urticaria, very classic initial symptom. What are we worried about? Anaphylaxis. If we're testing for it, we can test tryptase, which also gets released in the granules. We talked about that. You can do skin testing to look to see what exposure potentially this patient has had before. We talked about the key components here, and then some of the key examples: food allergies, insect stings, even certain medications being very classic for that. Remember that type 2 hypersensitivity, we kind of broke it down in a few different categories. Really, cytotoxic and inflammatory are similar. Inflammatory I just put on here because you have certain tissues that will have effects as opposed to just like one cell. The key between type 2 inflammatory and type 3 hypersensitivities is that type 3 involves immune complex formation, whereas type 2 does not. Okay, so that's particularly high yield. Type 2 cytotoxic, we're talking about cell destruction, tissue destruction, and then we can bind to receptors, essentially block receptors or stimulate receptors. Okay, and so we kind of talked about all that here. The complement cascade, intricately involved with the effects that we're going to see when antibodies bind to host surface cells via some antigen. And remember also, you have natural killer cells involved with antibody-dependent cell cytotoxicity. autoimmune hemolytic anemia was very classic. We talked about the direct Coombs test to look for antibodies actually on the cell, and then the indirect Coombs test to look for antibodies in the serum. Okay, and you can also just simply measure a serum antibody. And then here's your classic examples. Talked about all of this in pretty great detail in the video already, so I won't go into too much detail here. Type 3, again, remember the key thing here, immune complex formation. Okay, immune complexes are getting deposited kind of systemically. And the big thing is you're going to have much more significant amount of complement release on average here when you're talking about type 3 hypersensitivities. Vasculitis, arthritis, glomerulonephritis are very classic. You can measure the complement levels because of that extreme amount of complement activation. Finally, we talked about the type 4, very classically called the delayed or cell-mediated. Remember, these are all humoral. Type 4 are primarily going to be talking about T cells that are causing most of the havoc here. And the big one is the CD8 positive T cells activated via MHC1, but we can also see a T helper 1 response, largely driven by interleukin 12, interferon gamma. Okay, we talked about the tuberculin skin test, Candida skin test being more so used as a control to see if there's actual T cell function, as most people are exposed to Candida, tuberculin, then testing for tuberculosis, right? And then we talked about some of these different cell lines involved and some classic examples here. So a lot of information in this video. Hopefully you found some of this helpful, and I think the table does a pretty good job of just summing up the big key points. Take 15 seconds to pause the video, read the question, and then we will go through the answer. All right, so we have a 44-year-old African-American female with a past medical history of childhood asthma who's presenting to the emergency department with worsening dyspnea over the past 4 days. She states that she was initially treated for a presumed asthma exacerbation with an oral steroid medication. She also reports difficulty sleeping at night due to night sweats and worsening anxiety. Okay, she has approximately 9.1 kilograms or 20 pounds of unintentional weight loss. So now the night sweats and the unintentional weight loss, you know, the first thing that you start to think about when you see these signs is you usually start to think about some form of malignancy. Typically, at least that's what I'm thinking about. This is happening over the past month. Additionally, she reports cramping, nonspecific abdominal and diffuse joint pain that started insidiously months earlier. Chest CT imaging reveals a large left lower lobe mass. Okay, so now I'm definitely thinking potentially lung cancer. We'll have to go back. It didn't mention any history of like breast cancer that can metastasize to the lungs. But yeah, large left lower lobe mass and significant hilar lymphadenopathy. Subsequent biopsy of a hilar lymph node is conducted and shown below. Bronchoscopy revealed granulomatous inflammation without evidence of malignancy or infectious etiology. Okay. A regimen of high-dose prednisone is initiated, and here is the biopsy of that hilar lymph node. Okay, so a couple things. So initially, you know, again, even though this isn't a question on malignancy, I mean, they clearly state, right, the bronchoscopy that they did here, right, to look at that mass that was in the lung, there was not any evidence of malignancy or infectious etiology. Now, you know, again, there are certain features here, though, that initially kind of called our attention to that. So it's important to kind of take that away from this question number one, is when you see unintentional weight loss, when you see night sweats, those are symptoms typically where initially I'm thinking, right, this could be lung cancer, right? Because she has this dyspnea, right, in a 44-year-old female. If she had a history of breast cancer and she had radiation in the past, that would put her at higher risk of lung cancer. So those were kind of the thoughts that were going through my head. Now, the fact that we know now that there is no evidence of malignancy here, what's going on with this patient? When you look at the question, there was one line here that kind of gave things away a little bit. There was significant hilar lymphadenopathy. When you see hilar lymphadenopathy in general, especially for a step 1 or complex level 1 exam, the first thing that I want you to just kind of think about, you know, obviously lung cancer, you know, is definitely something we're concerned about in this patient. But usually when they use this kind of terminology, they're usually talking about sarcoidosis. Typically, in general, sarcoidosis tends to affect African-American females. And this is usually kind of like the classic way this is asked about. It doesn't have to be, but it's the classic patient that you're going to see this in. Usually middle-aged patients also. Okay, so this is very classic for sarcoidosis. And the other thing, besides the significant hilar lymphadenopathy that I'm looking at, is this lymph node biopsy. Okay, so this lymph node biopsy, the hilar lymph node, is showing something that's very classic here, and that's going to be these non-caseating granulomas. Okay, non-caseating granulomas are also very classic. And what we're basically looking at here in simple terms, you don't have to be a pathologist here, but basically we have this dense inflammatory infiltrate here. And we'll kind of talk about that in a second. A lot of these epithelioid cells that are going to be releasing things like 1-alpha hydroxylase, for example, right? They're going to be stimulating the conversion of vitamin D to its active form, causing hypercalcemia in sarcoidosis. So that's one thing that's going on. You're going to see these kind of multinucleated giant cells. And it's kind of hard to see. We're kind of in a low mag view here, but if you had a higher magnification view, you'd see these cells that have kind of multiple nuclei that basically represent these multinucleated giant cells. Okay, and again, remember in non-caseating granulomas, right? When we're talking about non-caseating granulomas, like we see in sarcoidosis, right? Like we see in beryllium exposure or leprosy, for example, in these situations, right, you're going to expect there to be no necrosis, right? There's not going to be necrosis in the center of this granuloma. Now, this is juxtaposed to a case-eating granuloma like you would see in tuberculosis, where you would expect to see necrosis in the center. Okay, and again, this is kind of a classic image, so I would be familiar with the appearance of granulomas on histology. But again, you have multiple clues here to tell you this is sarcoidosis. Now, the key here is to figure out what type of hypersensitivity reaction is related to sarcoidosis. So again, the first step, right, we had identified that this is sarcoidosis. And again, we have some key clues here, right? We have the significant hilar lymphadenopathy. They're literally telling you here it's granuloma, right? We can look at it. We can see it's a non-caseating granuloma. Okay, so these are the clues to kind of point us in the direction of sarcoidosis. But then the next step is what is exactly going on in sarcoidosis? Okay, so let's kind of talk about that. And how is that related to a hypersensitivity reaction? Well, remember, in sarcoidosis, we kind of go back to our T helper 1 response, right? If I'm going to form a granuloma, for example, even if I didn't know the pathophysiology of sarcoidosis, if I understand what's happening from an immunologic perspective, right, by understanding the hypersensitivity reactions and granuloma formation, I can answer this question. The concept here is, right, just kind of going back to this, if I have some antigen presenting cell, I'm just going to say this is a macrophage. That's what this denotes here is macrophage. So this macrophage, right, it's going to digest a pathogen normally, right? And let's just say we're talking about tuberculosis. Now remember, tuberculosis causes case-eating granulomas, but I just want to kind of start here with this example, and then I'll tell you what's happening in sarcoidosis. But again, if we're taking tuberculosis, right, so this macrophage is going to present this antigen after it kind of phagocytoses it, right? And in the case of tuberculosis, we might not know what to do with it, so we start to wall it off, right? But anyway, we're going to present this antigen to a T cell. Okay, so this is usually going to be a naive T cell. Okay, so this naive T cell is going to see this antigen, right? This is its specific antigen. It's going to match up its epitope. It's going to bind to the epitope. And then this T cell becomes activated. And how does that happen? Well, that's because this macrophage tells this T cell, hey, I want you to become a T helper 1 cell. And how does it do that? It sends a signal using interleukin 12, right? We talked about this a few times. And then there's an interleukin 12 receptor on this T cell that allows for this interleukin 12 to bind. And that allows this T cell to become a T helper 1 cell. And then that T helper 1 cell can also stimulate this macrophage by releasing interferon gamma. Now that we have this T helper 1 cell, it can go on to release interferon gamma to this macrophage to activate this macrophage. And this activation can allow these macrophages, right, to become epithelioid cells or multinucleated giant cells. And then just like we said, these epithelioid cells would be present here around the granuloma, as well as these multinucleated giant cells. And so this is basically what's happening in the case, like we said, of TB. Now in sarcoidosis, what's happening in sarcoidosis is that we have kind of a dysfunctional T cell response. So we have a lot of these T helper 1 cells becoming activated, even though we might not necessarily be presenting a infectious pathogen to them, right? So there's some dysregulation in this T helper 1 response to the point where this might be potentially overactivated and then stimulating too much interferon gamma to cause these macrophages to then become activated and become epithelioid cells and multinucleated giant cells. Okay, so in sarcoidosis, the pathophysiology has to do with granuloma formation, meaning that it must involve T helper 1 responses with interferon gamma, right? And we can tell that just from looking at, if you just looked at this image and recognized, hey, this is a granuloma, or you saw that, hey, this is a granuloma, right? How do granulomas form? Well, typically, this is going to be from a T helper 1 response mediated through interferon gamma release. Okay, so again, understanding the mechanisms is really the key for step 1. You don't necessarily have to clinically know exactly what to do next or what the next best test is, right? That's more of a step 2 thing. But the key here is understanding the mechanism. Now remember, this is going to be more related to a type 4 hypersensitivity because this is more of a T cell mediated process. Now let's just go through the other options here really quickly. So option A, FC receptor mediated immune cell activation. So typically what this is talking about, like if I had let's just say I had an autoimmune hemolytic anemia, right? So in the case of autoimmune hemolytic anemia, I might be targeting an antigen on the surface of my red blood cells, right? Maybe there's some antigen here, and my antibodies, let's just say I have some IgG antibody here that's going to target this antigen. So this IgG antibody is going to bind, right, using its Fab portion here to this antigen. And then out here I have my Fc portion. So this Fc portion can then bind to an immune cell, can activate complement potentially, right? And that can lead to activation of immune cells to destroy this red blood cell. So this would be very classic for a type 2 hypersensitivity reaction, right? So this would be classic for a type 2 hypersensitivity reaction in that we're causing immune cell activation using the Fc portion of our antibody, right, to activate some immune cell to destroy, this target. In this case, it's the red blood cell in autoimmune hemolytic anemia. It could be a platelet in immune thrombocytopenic purpura, for example. And in both of those cases, that would be a type 2 hypersensitivity reaction. And again, just going back to option D here, remember we said this is usually going to be type 4 hypersensitivity reaction. All right, let's just go through the other ones here. Option B, IgG-mediated inhibition of signaling pathways. So you can imagine, right, if I had, let's just say I had a synaptic cleft here. So here's my postsynaptic membrane, here's my presynaptic membrane, right? I have these acetylcholine receptors. If I have a condition like myasthenia gravis, right, I can actually have antibodies that literally physically bind here on these acetylcholine receptors. These are anti-acetylcholine receptor antibodies. They can physically bind here and block acetylcholine from binding to this receptor, right? Because this antibody is physically sitting on the receptor. This is also an example of a type 2 hypersensitivity reaction that we've talked about in this chapter. IgE-mediated mast cell degranulation, right? So again, we have IgE receptors on the surface of our mast cells, and we've kind of gone through this a few times, so I won't go through it again here. But essentially, this is going to be classic for a type 1 hypersensitivity reaction. These all really are not completely relevant to the formation of a granuloma, right? We've talked about that before. So a lot of these other options are kind of out of the scope of what you would expect to see in a patient with sarcoidosis. The final one on here, you can probably guess, is a type 3 hypersensitivity reaction. This is where we get deposition of antigen-antibody complexes. Again, not very classic for sarcoidosis, right? This is something you might see, classically in a patient that has something like a post-strep glomerulonephritis. So just to recap the big point here, a lot of times test writers are going to make you think a little bit. Okay, so sometimes you got to think outside of the box to figure out what's going on. If you didn't memorize that sarcoidosis is a type 4 hypersensitivity reaction, just kind of think about what's going on, right? If I know the mechanisms, I go back to the mechanisms. That's what I do when I'm in a situation where I really don't know where I'm supposed to go with the right answer here. And the fact that I know there's a granuloma, I have to think about how granulomas are formed to get to the right answer. And again, like we've kind of talked about in some of the other videos, there's going to be things in here that are going to try to distract you. Well, why does this patient have, worsening anxiety? And why does she have weight loss and this cramping, nonspecific abdominal pain and then diffuse joint pain? What's that all about? And a lot of this stuff, sometimes test writers will put this in here to throw you off, but the thing you have to understand is there's usually a reason for it, right? For example, this patient has sarcoidosis. Why does the patient have anxiety? Why does the patient have bone pain? Why do they have abdominal pain? Well, remember what we said, right? In sarcoidosis, and we'll talk about this more in the room section, but in sarcoidosis, the problem here is that once I get these epithelioid cells and these multinucleated giant cells, the problem is we start upregulating 1-alpha hydroxylase. Remember what we're talking about here, right? We start with cholesterol, right? And we eventually get this cholesterol through the liver, which turns it to 70-hydrocholesterol, UV light, et cetera, et cetera. Eventually, the liver turns this cholesterol into 25-hydroxyl D3 for vitamin D, right? And it does this using 25-hydroxylase. Now, this form of vitamin D is more of a storage form. It's not the active form of vitamin D. In other words, it doesn't exert the effects where we can increase calcium absorption and phosphate absorption, for example. So what we can do is we can store some of this, 25-hydroxyl D3 in the adipose tissue, for example. But then what we can do, if we wanted to activate this, normally this 25-OHD3 can then go to the kidney, right? And in the kidney, we normally have this 1-alpha hydroxylase, and this can turn it into 125 vitamin D. Okay, so the point is this form here, this 125, this is the active form. This allows for increased calcium, right? So this vitamin D is going to allow me to have calcium reabsorption. And again, the point here is with sarcoidosis, remember we said these T helper 1 cells are going to have some dysregulation, right? I'm going to have too much activation of my macrophages getting converted to epithelioid cells. And then all of these epithelioid cells are going to start to release too much 1-alpha hydroxylase. And all that 1-alpha hydroxylase, guess what that's going to do? That's going to cause more conversion of all this stored 25-OHD3 into the active form of vitamin D. And if I have too much of this getting turned into the active form, well, guess what's going to happen to my calcium? It's going to go way up. And what happens when you have really high calcium levels? Well, when you have really high calcium levels, usually, and the mnemonic that's classically remembered is going to be bones, stones, groans, and then I'm just going to put POT for psychiatric overtones. Okay, so the bones is usually talking about bone pain from the hypercalcemia, stones, so nephrolithiasis, right? Groans, usually abdominal pain from the hypercalcemia, and then psychiatric overtones, that might be, right here we see some of that anxiety. And so we can see a lot of these symptoms, right? The abdominal pain being the groans, the diffuse joint pain potentially being the bones. So there's other symptoms here that we can actually correlate to the hypercalcemia, secondary to the activation of vitamin D, secondary to these epithelioid cells, right, that are classic for sarcoidosis. So again, there's going to be things in the question that sometimes you might not make all these connections with right away. But as I always say, the most important thing to read is usually going to be the very last line, which is where the question is at, and then working back. What is going on, everybody? In this video, we're going to talk a little bit about transfusion reactions. Again, this is kind of like the hypersensitivity syndromes, the immunodeficiencies, the transplant rejections. There's kind of just a bunch of different categories of pathology that you should be familiar with. And a lot of these can be distinguished based on some very unique things, either in the presentation, the diagnostics, or the management. And so we'll start here with the acute hemolytic reaction. Now, the acute hemolytic reaction is probably the highest yield of the group. And so that's why I think it's a good one to start with. But not only that, I think this is a great opportunity to just kind of talk about these red blood cells and review what antigens are typically going to be on the surface of our red blood cells. And when we talk about the different red blood cell types, right, we have different groups. So we have group A, group B, we have a combination A, B, and group O. And what this is referring to, what this A is referring to, is just this antigen here on the surface of the red blood cell. So these red blood cells have an antigen that we'll just call the A antigen, which means, again, if this is an antigen, right, potentially, if I had an anti-A antibody, right, an anti-A antibody, that antibody could potentially bind to these antigens and then mark them for destruction. And this is exactly what we talked about when we talked about type 2 hypersensitivity reactions. We had antigens that were on the surface of cells that antibodies bound to and then marked those red blood cells for destruction, primarily mediated by complement. And so that's the concept here. So these red blood cells, this group A, has A antigens on their surface. So anti-A antibodies could target these antigens potentially. Okay, so that's the concept. Now, if we go to group B, right, group B is the same kind of thing. So group B is going to have these green antigens you see here, right? Those are the B antigens. And then we can have a combination where we have an AB group. So the AB group, right, is going to have A antigens as well as B antigens. So they have the A and they have the B antigen on the surface of their cells. Then there's the group O, right? Group O is going to have no antigens on their surface. So group O, we can see here, no antigens on the surface of the red blood cell. Okay, so with that being said, the point here is if I have a patient that has a group A blood type, in other words, if they have these A antigens on their surface, these patients will likely have anti-B antibodies. Okay, so they're going to have antibodies against the B antigens, but this works out because these patients have all of this A-type blood, so their blood should not be targeted by the B antigens. Now, on the flip side of that, if I were to give this patient with group A blood, if I was to give them some blood that had the B antigens on them, now these anti-B antibodies would go after those cells, right? They would target these cells and mark them for destruction via type 2 hypersensitivity reactions. Now, notice the structure here of these antibodies, of these anti-B antibodies. Notice that these are pentameric, right? And this pentameric structure, remember, this is very classic for an IgM antibody, right? So this is very classic for an IgM antibody. And it's going to be pentameric, okay, but it's going to have 10 binding sites, right? Each one of these that I'm kind of making a circle over is a binding site, okay? So when we're talking about antibodies in the plasma here, we're mostly talking about IgM. That's going to be doing a lot of the damage here. That's going to be mediating this process. And again, the point being, if I have a patient that has a group A type blood, and I give that patient some blood from another person, potentially that's group B, that person's group B antigens will be targeted by the anti-B antibodies in that group A type blood. That's the big point you want to take home here. Now, conversely, right, if I had a patient that had a group B type blood, right, if I had a patient that had a group B type blood, and then I gave that patient group A type blood, okay, so if I gave this patient some blood from a patient that has the group A antigen, then those anti-A antibodies that would be present in this patient would then target these cells
for destruction. Once again, so it's kind of the same concept. Now, where it gets a little tricky is what if I have a patient that has group AB type blood? Okay, so they have the A and the B antigens. Well, the point is, if the patient has A and B antigens on their red blood cells, they're probably not going to have any antibodies in their plasma against these cells, right? Otherwise, these antibodies would have already targeted their red blood cells for destruction. So these patients will usually not have any antibodies in the plasma. So the point here is, if I were to give this patient some group B type blood, or if I was to give this patient some group A type blood, in both of these situations, these donors' red blood cells shouldn't really be targeted for destruction because there's no antibodies to target them for destruction. So that's why we say in general, type AB blood is classified in the category as the universal recipient. So type AB blood, universal recipient, because I can give blood from group A or group B and not have to worry about those red blood cells being marked for destruction. Now, on the other hand, what about if I had a patient that had a group O type blood? So if I have a patient with group O type blood, this patient doesn't have any antigens on their surface. Okay, so type O, you can think of this as a 0, if that helps you remember it, that there's no antigens on the surface of the red blood cell. If there's no antigens here, then I might have anti-A and anti-B antibodies. In other words, if I gave this patient blood that had the B antigen, those cells would be marked for destruction by my anti-B antibodies. And along that same length, same thing for group A, right? If I give them group A blood that has the A antigen, this patient will likely have anti-A antibodies that will target these cells for destruction. So the group O patients will really only be able to receive blood from other group O type patients. I can give these red blood cells to any of these other patients, right, and not have to worry about antibodies targeting the group O type blood because there's no antigens on the surface of the group O type blood. There's nothing for these antibodies to target. And when I say there's no antigens, I'm just referring to, group A, group B, right, just for simplicity's sake here. But the point is I can give this group O type blood to a group AB patient, to a group B, to a group A, and not have to worry about antibodies targeting it. Like there's no A antigens, there's no B antigens to destroy these cells. So that's why we say type O is the universal donor. But remember, if I was going to donate blood to a patient that had type O, I can only use type O because otherwise I would have these antibodies targeting those red blood cells. Students will understand the concept here with type O, type AB, right? Type O being the universal donor, type AB being the universal recipient. But where it gets tricky is when you start adding in things like fresh frozen plasma transfusions. This is where test writers build on this concept and make you think a little bit. Okay, so the easy way to remember this is if you remember the red blood cell transfusions being type O as the universal donor, type AB as the universal recipient, you just have to flip those to understand who's the universal donor with fresh frozen plasma and who's the universal recipient. So let me explain this though, because I think it actually makes a lot of sense here. So remember, the first things first, if I take a sample of some patient's blood and I spin it in a centrifuge, right, the erythrocytes are typically going to be on the bottom here. And the erythrocytes are going to be these red blood cells that we're talking about here, right? And then I have some buffy coat that's going to be my leukocytes, my platelets, and then I have all of this plasma, right? So this is all plasma up here that's going to kind of sit on the top of the centrifuge, okay? And that plasma is what we're talking about here. The antibodies, right? The antibodies are going to be in this section, most likely, of the plasma, okay? So if I'm giving somebody plasma, right? If I'm giving them this portion here, I'm not giving them the red blood cells. I'm just giving them the plasma now. That's what we're talking about, right? Fresh, frozen plasma transfusions, not red blood cell transfusions. Okay, so if I give the patient this portion here, the plasma with the antibodies in it, let's say that I have a patient that's group A and I give them group B plasma, right? What's going to happen? If I give a patient that's group A, group B plasma, these anti-A antibodies are essentially being given to this patient, right? And so the donor's pentameric IgM antibodies are going to target the recipient's red blood cells, okay, and they'll mark them for destruction. Okay, so that's the concept. So we wouldn't want to do that, right? Because we're taking this box now and moving it into our patient. And the same is true if I had a group B patient and I gave them some group A plasma, right? If I gave them these antibodies, that would mark my red blood cell with the B antigens for destruction. Okay, so that would not be what we want to do. You might be saying, okay, well, wouldn't it be simple if we just didn't give any antibodies to the red blood cells in the sample? And that's exactly what group AB blood has. It has no antibodies to A or B, right? So the antigens are already on all these red blood cells. So like we said, we don't really have any antibodies in the plasma. So that's why group AB are going to be the universal donors for plasma because they don't have any of these red blood cell antibodies to target cells for destruction. So I can give group AB blood to someone that has group B blood, to someone who has group A blood, to someone who has group O. And I don't have to worry about the antibodies targeting the cells for destruction. And so that's why type AB blood is going to be the universal donor. Again, just the opposite of what we saw with red blood cell transfusions. Now, type O in this situation is going to be the universal recipient. And the reason for that is because type O blood doesn't have any antigens on its surface to mark it for destruction, right? There's no A or B antigens here to mark it for destruction. And so I can give this patient plasma from a group A patient, right, that has anti-B antibodies and not have to worry about them targeting the cell because there's no antigens to target. The same thing is true from group B plasma. The same thing is true, obviously, from the universal donor group AB because there's no antibodies at all in this patient's plasma. Okay, so that's why type O blood is the universal recipient. Okay, again, just the opposite of what we talked about with red blood cell transfusion. So that's where it gets a little tricky. If you're in a rush and you're not sure, go back to your red blood cell transfusion concepts and just flip it. And that's the easy way to understand that. But a lot of times, test writers will try to test your critical thinking of this concept, and you might actually have to understand some of what we just talked about to get the question right. Now, the acute hemolytic reaction is essentially saying that we have some incompatibility in these red blood cell antigens. Okay, and incompatibility is just referring to what we talked about. It's a situation where we have an antibody and we have an antigen on the red blood cell, leading to the destruction of that red blood cell. Okay, so that's essentially what I'm talking about with incompatibility. Now, if we did a red blood cell transfusion, right, that's going to be this top box. We're giving this top box to another patient. Okay, so that would be a red blood cell transfusion. Let's just say that I take this patient and I give this patient group B blood, right? So if I have a patient that's group A and I give them group B blood, I'm giving them the red blood cell, right? I'm giving them this box right here with the group B antigen on the surface. And this patient has anti-B antibodies. So this is going to be my donor. So the donor is giving group B blood, and the recipient is going to be group A. So the recipient's group A, the donor is group B. And so what we're talking about here with incompatibility is going to be destruction of the donor's red blood cell, right? It's these red blood cells that are being donated that are going to be marked for destruction by the recipient's preformed anti-B antibody. Okay, so that's if I did a red blood cell transfusion. Now let's say I did a transfusion of fresh frozen plasma. Let's say I do the same thing. Let's say I have a patient that's group A blood type, and I give this patient fresh frozen plasma from a group B type patient, right? So I'm going to give the plasma, which is this box here, right? I'm going to give the plasma to this group A patient. Okay, so I'm going to give them this plasma, and I have anti-A antibodies in that plasma that's going to target these A antigens and mark the recipient cell for destruction. So in this situation, the donor had the preformed antibodies, and the recipient's red blood cell, right, the host, those red blood cells were marked for destruction. So it's kind of flipped. In this situation, it's the recipient's red blood cells that are being marked for destruction in the setting of a fresh frozen plasma transfusion. Okay, and in all of these situations, this is a type 2 hypersensitivity. We have antibodies that are binding to the surface of the red blood cell to mark them for destruction. In a lot of these different reactions, the reaction could happen at different times. It can happen during the transfusion, it can happen after the transfusion, right? So it's variable. However, in board questions, there's always classic ways that things are presented. And this is not an exception. In acute hemolytic reaction, it's very classic that the reaction will happen during the transfusion. Okay, so there are going to be other types of type 2 hypersensitivity transfusion reactions, but this is the primary one that's going to happen during the transfusion. So as the transfusion is happening, these patients might present with pain at the IV site as they're getting the transfusion. They might start to have some jaundice, scleral icterus, right? These are all classic for bilirubin, particularly indirect bilirubin from the red blood cell breakdown. Okay, they can have chills, hemoglobinuria from the red blood cell breakdown, right? All that hemoglobin in the blood, that can potentially also cause kidney damage, right? And so you can see dark urine as a very classic presenting sign to indicate that these patients might be having an acute hemolytic reaction. And then if it's really severe, these patients might develop hypertension, tachycardia, right? This can be very serious. And for that reason, in general, the thing that you'll see as a recurring theme across all of these different transfusion reactions is you want to stop the transfusion, right? If you're in a situation, the patient starts to become symptomatic during transfusion, the first answer choice every time is going to be immediate cessation of that transfusion. And then obviously monitoring or treating that patient. A following step to that would be to investigate exactly what happened, right? And so that would include something like a direct Coombs test. So just to kind of build on this direct Coombs test, because we've talked about this in great detail, this is a particularly high yield thing to focus on when we're talking about hemolytic reactions. So let's just take a look here. So this first column here is going to be our donor. this is going to be our recipient. Now, in these situations, let's just say that, like we said, we have a type O donor. No matter what type of antibodies are in the recipient's bloodstream, right? So let's just say that these blue ones are going to be anti-B antibodies. Okay, these will be anti-B, and then these red ones here will be anti-A. Okay, so we have anti-B and anti-A antibodies, okay? And not every patient's going to have, both of these, right? Some might have one or the other, some might not have any. But the point is, just for an extreme example, you can see that when I give type O blood, there's nothing for these antibodies to bind to. If I give type A blood, right, there's a possibility that this patient might have anti-A antigens, and the same is true for type B. They might have anti-B antigens. And if I have AB, if they have either one, they're going to get targeted, right? These are all the same things that we kind of talked about. But the point is, what I'm essentially doing with a Coombs test is I'm giving this patient anti-A or anti-B antibodies, okay? So this is the original antibody that we talked about, and I'm making another antibody to that, right? So I'm making another antibody to this, essentially, is what I'm trying to do. And I'm trying to get this thing to bind here to cause agglutination, okay? If that happens, that tells me that on the surface of these red blood cells, there are antibodies bound, okay? So if I have a positive direct Coombs test, that tells me that there's antibodies bound to the surface of the red blood cells. Which antibodies? Well, it depends. Did I give them anti-A or did I give them anti-B antibodies, if that makes sense, right? So I'm making an antibody against the antibody on the cell surface, and if that antibody is present on the cell surface, my anti-A antibody in this situation will bind, or if it's an anti-B antibody, it will bind, right? And it will bind, causing agglutination. And agglutination would be a positive test, and it tells you that this red blood cell is essentially marked for destruction. And you'll see that this is not the only hemolytic reaction that has a positive direct Coombs test. The delayed hemolytic reaction, which is a very similar mechanism, also presents the same way. It just takes a lot longer to get that presentation. You're not going to have a patient that's in the middle of a transfusion that has symptoms with a delayed hemolytic reaction, at least not in a classic board question. Okay, and then the diagnostics, you'll see a lot of these are just, going to be synonymous with red blood cell breakdown, hemolysis in particular. So an increase in your LDH, right, your lactate dehydrogenase, bilirubin usually will be elevated, causing some of the jaundice. And then haptoglobin, when red blood cells are destroyed, and we have hemoglobin that enters the bloodstream, right? So we have red blood cell destroyed, we have hemoglobin that enters the bloodstream, right? This hemoglobin can then bind to haptoglobin. Okay, so this hemoglobin and haptoglobin will bind together, and what will happen is your levels of haptoglobin, because they're all getting bound up by hemoglobin, they'll come down. Okay, so the levels of haptoglobin will go down because they're getting bound up from all the hemoglobin that's kind of being released essentially from these red blood cells that are being destroyed. That's the general concept. These are essentially giving you some indication that there's red blood cell breakdown. Now, when we're talking about the delayed hemolytic reaction, this is actually, one way to think about it is it's going to present very similarly to the acute hemolytic reaction in the sense that the mechanism in many ways is the same with some slight variation. The classic thing that's going to help you distinguish these two is really going to be the timeline and the severity of disease. Okay, so let me explain a little bit. You can see that the etiology is going to be incompatibility with red blood cell antigens, essentially the same thing as the acute hemolytic reaction. The antigens that we're talking about are not your classic antigens being A, B, right? AB type blood, type O blood. We're not talking about that. We're talking about some of these other antigens that in general are sometimes considered to just be more minor blood group antigens. They're not like the major ones we typically talk about. So the KIT antigen, the D antigen, remember this D antigen is essentially going to be the RH antigen that we talk about a lot when we talk about Rh positivity in an Rh negative mother, right? An Rh positive fetus to an Rh negative mother that then causes on re-exposure hemolytic disease of the newborn, which we've kind of touched on already and we'll talk about in greater detail in the future. But the point here is that we'll have some incompatibility again with the recipient and the donor. Now, in these situations, because you think about this, these antigens, when you think about them, like I said, you kind of think about them as being more of a minor antigen. You don't think about them in the same way as the ones that we talked about. And so when I think about minor antigens, I'm thinking that it's going to take a lot more exposure to get a strong reaction because the antigens are minor. Okay, so that's kind of the way that I'm thinking about this when I think about delayed hemolytic reactions, when I think about board questions with delayed hemolytic reactions. Now, I'm not talking about, I want you to separate here hemolytic disease of the newborn from this. And the reason I say that is because it just presents differently. Usually, if they're asking a board question about hemolytic disease of the newborn, it's going to be asked about in a very different way than a question that asks about a delayed hemolytic reaction, like you'll see here. Okay, so I want you to separate those two. Even though the RhD antigen is here, we're not talking about hemolytic disease of the newborn in this example. I'm more so talking about a patient that gets repeated transfusions and then has antibodies that essentially form against an Rh positive donor. Okay, that's what I'm talking about here. Not hemolytic disease of the newborn, which is fatal to the fetus. Very different in terms of severity. Okay, so I just want you to make sure you're sharp on that. Now, when we're talking about the mechanism, like we said, it's going to be very similar. Donor red blood cells are going to be destroyed, right? The person that's giving the blood, their red blood cells are going to be destroyed. Why are they destroyed? Well, the recipient is going to have preformed antibodies. Okay, so let me explain. So if I have a red blood cell here, okay, so I'm going to take some red blood cell, and again, we're going to exclude the major antigens. So we're just going to look at these minor antigens. Let's just say that this red blood cell has an Rh antigen. Okay, so we can say that this is essentially an Rh positive donor. Okay, we can also use the KIT antigen. We're just using this as an example. And this red blood cell is going to be in my donor. Okay, so this is going to be in my donor. Now again, this donor, right, is going to donate this blood to a patient. And this patient, let's just say, for example, this patient doesn't have an Rh antigen. Okay, so we would say that this patient is going to be Rh negative, right? Patient doesn't have that antigen. So the donor would give their red blood cells to the recipient, right? To the recipient. And the recipient might say, hey, this is foreign. This Rh antigen is foreign, but it's a minor antigen, right? It's minor. So what I might do is I might just make, a couple B or T cells against that antigen. Maybe I'll make a couple antibodies against that antigen for future exposure, right? And if this happens frequently or over some extended period of time, I might get some class switching potentially, right? I might get some IgG antigens, etc. And I might also, over some period of time, generate a memory response with B cells, T cells, right? Plasma cell factories generating antibodies. But the thing is, for this stuff to happen, especially against a minor antigen, I'm going to need repeated exposure, right? I'm going to need to have more and more exposure to this Rh antigen to really generate a strong response. That's the point that we're making here, and that's what you have to think about. And so this is going to be the anamnestic response. Essentially, what we're saying here is after you've had repeat exposure, right, repeated blood donations from Rh positive antigens, in this example, we would eventually start to generate some pretty significant responses, but it's going to take a while because, again, like I said, these antigens are minor when we're talking about delayed hemolytic reaction. Again, different from the hemolytic disease in the newborn, right? We're not saying this is necessarily the same exact thing. It's not in terms of severity. And the concept here is if I had an antigen on this donor cells, it's again going to be the recipient's antibodies that will go and bind to that Rh antigen on the donor. Okay, so that's what we're saying. And so we're marking the donor's red blood cell, right? Destruction of the donor's red blood cells, right? We're marking the donor's red blood cells for destruction on repeated exposures. So what do you think is going to be the classic patient that has a delayed hemolytic reaction? Well, I just told you, right? It's going to be patients that have multiple blood transfusions. What's another way they could ask this? How about a patient that frequently uses IV drugs or shares needles potentially, right? So a patient with IV drug use would also be very classic. And you might be saying, well, why is that? Well, if the patient is constantly exposed to other blood types that have these minor antigens, when they get transfused, they might have a reaction because they've had repeated exposures to other blood types that have these minor antigens. And again, type 2 hypersensitivity, we talked about this, right? Antibody binding to the surface of the red blood cell, marking it for destruction, classically complement mediated, right? We talked about that in the hypersensitivity video. And the key thing here, the important thing, is that this is going to take a little bit longer to get symptomatic from because, again, we're saying minor, right? Just think of this as kind of a weaker response overall. So usually it's going to take a while to get the symptoms to present. And when they do present, they're mild, they're self-limited. We're not going to necessarily stop a transfusion in a patient with a delayed hemolytic reaction because the transfusion has been over for weeks, right? This is going to present much later on. Now, if you did the same tests, though, that we talked about previously with acute hemolytic reactions, you'd get similar results. You get a positive Coombs test usually, right? Because you have antibodies bound to the surface of these red blood cells. So if I gave an anti-Rh antibody, I should get agglutination for the reasons we mentioned in the previous videos. Okay, and the same thing is true with some of these markers here. But again, because this is minor, right, this is going to, especially in real life, this is going to be variable. But this is the kind of things that you want to think about. You want to think about what's happening, and that will help you cipher through the diagnostics. And we've talked about all of this already in previous videos. So if you're not familiar with some of this, go back, check out the previous videos. I think they would really help you kind of understand this if you're having any trouble here. This transfusion reaction in general isn't quite as high yield as the other ones that we talked about because it's actually pretty simple. There's not a lot they can really ask you, but let's make sure we go through it just in case you get, something on it. The concept here is pretty straightforward. So we're saying that this is a non-hemolytic reaction. It's right there in the name. And I don't want to jump too far ahead, but you can see right here, non-hemolytic, right? We're going to have normal labs. We're not going to have hemolysis labs that indicate that we have red blood cells being broken down. It's in the name, right? Febrile, non-hemolytic reaction. How does the patient present? Well, they're probably going to present with a fever. All right. And in general, the symptoms tend to be much milder in this reaction. So let's backtrack a little bit. What is even causing this to happen? The concept here is have some sample of blood that, is just kind of sitting there on the shelf. And let's just say it's a sample of red blood cells, right? So this is going to be 1 unit or 2 units, whatever it is, of red blood cells. All right. And these red blood cells in that sample are going to have some white blood cells. Probably not a lot, but there might be some that are mixed in with that sample. Okay. So we have some white blood cells here, but again, not usually going to be very many. Now, these white blood cells over time, as they're sitting here over a long period of time, they might start to leak out some of their cytokines. Okay. So over a long period of time, some of those cytokines might leak out into the sample, okay, which is exactly what you see here, right? So these cytokines are kind of leaking out over a long period of time. And then when I go to give this to a patient, right? So if this is all kind of going on inside of my sample, and now I go to give this sample to my recipient, right? And now I have all of these cytokines floating around in the sample. And that's going to cause kind of an immediate reaction in this patient. All those cytokines, things like we talked about, like interleukin 1, interleukin 6, TNF, right? What are these going to do? They're going to increase the temperature set point. These are the things that make us have a fever when we have an infection, right? They're acute inflammatory mediators. That explains why these patients will have a fever potentially after they get this transfusion, right? It's because these cytokines are leaking out. Now, that's the classic high yield thing to remember when we're talking about this mechanism. There is another portion of this where in some situations, the recipient actually has antibodies against antigens on the donor white blood cells. The actual pathophysiology of this is beyond the scope of step 1. In fact, this doesn't get asked about as frequently, but it's important to know that this can also happen. If I did have antibodies against my donor's white blood cells, then I might mark these for destruction, and when I destroy them, I might get a cytokine leak. Okay, so it's a similar concept, but the thing that would be different if they asked a question about this, which I don't think they would, in these situations, you may actually get a positive Coombs test if you're looking for that specific antibody that bound to the white blood cell. Okay, again, pretty much beyond the scope of step 1. So what you see on this slide, I think more or less will get you the right answer. Okay, but there is some variability here. That's just why I bring that up. But in general, you would expect there to be a negative Coombs test, especially if you're doing a Coombs test using anti-A, anti-B, anti-RH, right? Anti-KID, antibodies in the sample, right? If you're testing for those, you're looking for red blood cell breakdown, that's going to be negative, okay, in these patients. And again, majority of these cases, especially when they're asked about in board questions, are going to be like we talked about, due to this white blood cell cytokine leak. The timeline is usually going to be hours after the transfusion, which doesn't really distinguish this from some of the other diseases. But what we can get from this is that, in general, we don't have red blood cell breakdown, which helps you kind of zero in on what we're talking about. Now, what would you normally do if this patient had symptoms, if they got a fever potentially during the transfusion? We already said the answer is always going to be immediate cessation of the transfusion. But on future occurrences, you would give them blood products that have less white blood cells. Leuko-reduced, right? Leuko meaning white blood cells, reduced white blood cells in the blood products because you're afraid of the cytokine leak potential. So you might be saying, okay, well, what can I look for to really kind of narrow me in on this, besides some of these little things that we mentioned? Well, the key vignette is usually going to be about a pediatric patient. That's classically how these are asked about. So look for, younger age patient in general that ends up having a fever, but has relatively normal labs. That will be very classic for this presentation. So just kind of keep that in mind. A little bit different from what we talked about previously. All right, let's talk about the transfusion-related acute lung injury, commonly called trolley. Okay, so for the trolley in general, and that's kind of how I'll refer to it here, it's another one of those situations where we're looking for something really particular to kind of call our attention to this disease process. So let's just kind of go through it really quick, and then I'll circle back and kind of tell you what to look for. The concept here is, remember, if you have a patient, for example, that you start on some steroids, you are very frequently going to see an elevation in their white blood cell count in the blood, in the serum, right? And the reason for that is because you've now activated some of the neutrophils that are going to be residing in the lungs, where you're going to have quite a bit of your neutrophils in the pulmonary vasculature. Just think of it, again, we're using simple terms here. Just think of them hanging out essentially. What we're doing is we're activating pulmonary endothelium that's causing neutrophil sequestration into the blood, priming and activating these neutrophils. And again, when these neutrophils get activated, we're going to have pro-inflammatory cytokine release. What is causing this whole process to happen? The actual pathophysiology, there's a lot of different articles and that kind of thing on it. For step 1 purposes, the thing that you have to know is that there are certain risk factors that patients can have for TRALI, but again, most of the pathophysiology is beyond the scope of step 1. The thing that you have to do for TRALI is know that you have neutrophils that are primed in the pulmonary vasculature with activation of the pulmonary endothelium, and you have to know that these neutrophils are going to start to release a lot of those pro-inflammatory cytokines that we just talked about with febrile non-hemolytic reactions. And those cytokines being released, and if you think about where they're being released, a lot of these are going to be released in the lungs. So if I kind of go, take a snapshot here, way deep into the lung parenchyma here, I'm just going to take some pulmonary blood vessel here. Okay, so I have some blood vessel running here, and then I'm going to have all of these neutrophils that are going to have released all of these cytokines into the pulmonary vessel. And these cytokines, right, they're acute inflammatory cytokines. They're going to cause me to have vasodilation of these pulmonary vessels. And when I vasodilate these pulmonary vessels, remember, I have my endothelium kind of sitting here on the surface. And as I vasodilate, I'm going to start to get some gaps here, right, into this endothelium. And so what's going to happen? Well, a lot of the fluid is going to move through those endothelial cells and make its way into the interstitium. And so I'm going to get interstitial edema, right? Interstitial edema from the dilation of those pulmonary vessels and the increase in vascular permeability that's going to occur in the setting of this pro-inflammatory response, which is actually very similar to something that we'll talk about in the pulmonary videos, but that's going to be ARDS, right? We're going to have a very similar presentation to what we're talking about here, and I don't want to go into too much detail on that. But you can imagine, like I said, you'll have interstitial edema, right? Pulmonary edema that's non-cardiogenic in nature. What does that mean? Well, that means it's not originating from the heart. It's not like the pump is broken and things are backing up into the lungs, like we talked about quite frequently with heart failure, right, in the cardiology section. That's not what's happening here. What's happening here is almost like a tip over the edge in terms of pro-inflammatory response that's now causing this widespread increase in pulmonary vascular permeability, dilation, etc. Now, again, non-specific on the timeline, right? Could be during or hours after the transfusion, but what is the presentation? That's the key here. Remember, there's always something that you have to kind of tease out of the question that's going to distinguish it from the others. And the key here is that these patients will be very short of breath. They might have increasing oxygen requirements, right? They become tachypnic, for example. And the classic vignette is going to be a patient that's receiving fresh frozen plasma or a platelet transfusion. Okay, so again, the other situations we talked about, a lot of them were referring directly to red blood cells. We're not saying that you can't have this happen with a red blood cell transfusion, but again, what's the classic vignette? What are the things I'm looking for? Shortness of breath, increasing oxygen requirements, interstitial edema, right? And you can also see that here on the chest x-ray. You can see all of this haze in the lung fields, and the patient will classically have received fresh frozen plasma or a platelet transfusion. Okay, we already said interstitial infiltrates on the chest x-ray. Key here is that it's transient, and a lot of these will resolve spontaneously. And so you can see here, this was the initial chest x-ray of this patient here that had TRALI, right? So you can see kind of this haziness throughout the lung field. And then you can see the repeat chest x-ray here, right? This is largely resolved. We don't have to go into all the details on reading the chest x-rays and that kind of thing. This is going to be an option along with things like a febrile non-hemolytic reaction, or they might be teasing this out versus like a cardiac cause, for example. But again, classically, fresh frozen plasma, platelet transfusion is very classic. And then remember your pathophysiology. Pro-inflammatory cytokine release largely driven by priming and activation of neutrophils. Again, do you expect there to be a positive Coombs test? Not really, right? Because the whole concept with the Coombs test is we have an antibody that's binding usually to a red blood cell that's targeting it for destruction. There's really no red blood cell hemolysis here, so we wouldn't expect these to be elevated either. Again, if you understand the pathophysiology, they can throw lab values at you all day. You don't have to memorize these. You just have to think about it, right? You have to think about, what is the lab value telling me? Is that something that's happening in this disease process, right? So again, the key is if it's happening during the transfusion, like we said, we stop the transfusion. And because the patients largely are having some almost like an acute episode of respiratory distress, we're going to provide respiratory support. That's going to be the key, but usually will resolve spontaneously.
All right, the anaphylactic transfusion reaction is actually something that, if you've been watching the video series so far, we've actually talked about this already. And so, I'll go through this a little bit more quickly, but we did hit on this when we talked about the immunodeficiency syndromes. But it fits in really nicely here, and it's something that you sometimes have to tease out from the other transfusion reactions. And so let's just go through it one more time because this is particularly high yield. The concept here is again, we have a recipient that's getting blood from a donor, okay? And in this situation, this blood here, let's just say that this blood here is the donor blood, okay? So again, this is gonna be the donor, okay? So the donor is giving some blood, and in that blood sample, potentially, there might be some antibodies. So again, we have our donor here, and this donor is donating some type of blood, right? Could be whole blood, potentially red blood cells that might have antibodies, could be plasma, whatever it is. But we're donating some blood. In a board question, they're probably not gonna go into all the specifics. They're just gonna say this patient was transfused with some blood. But the concept here is that the donor, right, is gonna give this blood, and most patients will probably have IgA antibodies, okay? And so this is gonna be the IgA antibody. Now, when that blood is donated, normally this wouldn't be a problem, right? Because most patients have IgA antibodies. However, what we're talking about specifically here is a patient that does not have IgA antibodies, okay? So this is a patient that has IgA deficiency. This is the recipient, has IgA deficiency. What does that mean? That means that they don't have IgA antibodies. Because they don't have IgA antibodies, their basophils and their mast cells, right? You can see them here, right? Here's a mast cell. Their basophils and their mast cells are going to have anti-IgA, IgE antibodies bound to the surface of those mast cells. If I give this patient IgA antibodies in one way or another, these IgA antibodies can then bind at the IgA Fc portion to the Fab portion of the IgE antibodies. When these cross-link, these mast cells will degranulate, okay, and release all of this histamine and substances like we talked about, like tryptase, into the serum. This can cause an anaphylactic reaction and will typically be worse on repeated exposures like any other type 1 hypersensitivity, okay? And so this is something that we've touched on when we talked about type 1 hypersensitivities, but we've really talked about this in great detail in the immunodeficiency videos. And it's the same concept that we talked about before. We're just integrating that concept into the transfusion reactions here. So again, the classic cause is going to be a recipient that has IgA deficiency, right? They don't have IgA antibodies. Instead, they have anti-IgA antibodies. In other words, they have antibodies that will mark IgA for destruction. Or in this situation, they've already class switched and they have IgE on the surface of their mast cells and their basophils, and so they're ready to degranulate. These are preformed. As soon as you give this donation of blood with IgA, it's going to bind. You're going to get instant degranulation. So again, this is going to be more immediate, right? We already said, what's type 1 hypersensitivity? What kind of hypersensitivity? It's immediate, right? So again, all of this stuff is interconnected. It's not separate pathologies. So if you've been following the video series so far, a lot of what we're discussing here is just review at this point, right? So IgE-mediated degranulation, we already said, with histamine. Okay, and again, it's the recipient that has the anti-IgA, IgE antibodies on the surface of mast cells and basophils, and it's the donor, IgA, in the blood sample. So these patients, if you think about it, how does a type 1 hypersensitivity present? Hypotension, tachycardia, urticaria is very classic, wheezing, all the things we talked about in the type 1 hypersensitivity video. Now, if I do a Coombs test, what's going to happen? Well, I'm not marking red blood cells for destruction per se, especially if I'm using anti-A antibodies or anti-B antibodies against the red blood cell surface antigens, right? That's going to be negative. I'm not getting red blood cells being destroyed here. I'm getting histamine release. I'm getting an anaphylactic reaction from this histaminergic response, from the degranulation. So again, red blood cells aren't being destroyed. You know that red blood cells aren't being destroyed, so you shouldn't have elevations in bilirubin and LDH. You shouldn't have decreases in haptoglobin. The classic hemolysis lab should not be present for the reasons we just mentioned. You just have to kind of think about it. You have to think about what this means, and is that actually happening? It's not happening here, right? We're just getting degranulation. We're getting a type 1 hypersensitivity reaction. And so what do I do? Again, every situation, if they're symptomatic during the transfusion, you just stop it. Now, if it's an anaphylactic reaction, you just have to take that one step further. What did we say? For type 1 hypersensitivity, what was the treatment? Well, an immediate treatment would be epinephrine, right? If the patient is going into anaphylactic shock, we would do epinephrine as an initial treatment. And we'll talk more about that for step 2, but just something you should kind of have an idea with. Management isn't, a huge thing on step 1, but it's something that you should be familiar with
just at a high level, okay? Because they can ask you about a drug that was given and then ask you what the mechanism of that drug was, okay? That's still fair game, and so you have to know that, okay? And so respiratory support, again, if the patient needs it. And then on future occurrences, this is the big thing. You want to make sure that these patients are given IgA deficient blood products. You want to make sure if they need blood products, there is no IgA in those blood products, because that is precisely what caused the problem to begin with. All right, so let's recap all of this on one slide. And what I'm going to try and do is I'm going to try and put the really big stuff in red here so that at least you can kind of focus in on that. But a lot of the stuff on here is relatively high yield. You have to make these associations. Okay, so first off, acute hemolytic reaction. Again, what's the mechanism? We already said it's going to be, usually it's going to be the donor red blood cells destroyed by the recipient antibodies. Now that's going to be a little bit different if we're talking about plasma transfusions, right? If we're talking about a classic red blood cell transfusion, right, this is going to be the presentation. If you want all of the details on that, you can go back to the slide and watch that video. But in general, it's usually going to be the donor red blood cells that are destroyed. And again, this is going to be a type 2 hypersensitivity. Classically is going to be happening during the transfusion. It's going to kind of make this stand out. You can see there's really only one other classic presentation that happens during the transfusion. Again, symptoms of hemolysis are going to be present. Things like jaundice, sclerolicterus, pain at the IV site, right? Hypotension, tachycardia are all going to be very classic. And when you do the labs on this patient, these patients will typically have a positive Coombs test, okay, and they'll have the classic hemolysis lab markers, right? Elevation, LDH, bilirubin. When we're talking about step 1, we already said, number one thing every time, immediate cessation of the transfusion. That's going to be the first thing that you want to do. You want to stop the transfusion if it's happening, if the patient's having symptoms while we're transfusing them. And then you can do things like a type and screen. Specifically on step 1, they usually refer to this as more just saying like, hey, would you do a Coombs test, right? A direct Coombs test is what we're trying to do. We're trying to see if there's antibodies on the surface of the red blood cell that are marking them for destruction. And the key cause of this, right, the key association is going to be ABO incompatibility of the blood antigens, right, of the major antigens. When we're talking about delayed hemolytic reactions, we're usually talking about the minor antigens that are going to be causing a lot of the responses. And for that reason, we think of this as having more of the mild symptoms. Again, an anamnestic response is very classic. It's going to take repeated exposures to generate that response. It's also a type 2 hypersensitivity, right? Very similar, just pathophysiology to the acute hemolytic reaction. The big differentiating factor here is the timeline, right? It's going to be weeks, right? We could be 6 weeks out and the patient might start to have symptoms. None of these other reactions really present that way. So that makes it stand out. If you did a Coombs test, right, it would be positive because you have antibodies bound to the surface of the red blood cells. You have red blood cell lysis, right? You'd have these markers elevated if it was severe. But in general, self-limited. And the classic presentation, again, frequent blood transfusions, because it takes time to generate that anamnestic response, right? Same thing, IV drug use, we already kind of talked about that also for the same reasons, right? You're exposed to that minor antigen repeatedly, right? From, using needles that may have been contaminated from previous use, for example. Okay, febrile non-hemolytic reaction, right? Classic mechanism is this donor white blood cell cytokine leak, usually hours after the transfusion. Symptoms tend to be mild overall. The classic thing in this patient, like we talked about, very classic to present in a pediatric patient, and in future occurrences, right, you want to make sure you use the leukoreduced blood products. So trolley, transfusion-related acute lung injury, very similar presentation to like an ARDS, right, pulmonary edema from the neutrophil priming and activation. These patients, like we said, classically dyspnea, increasing oxygen requirements, and I'm actually going to highlight those in red because that's particularly high yield. It actually kind of makes this stand out a little bit. That, along with the chest x-ray findings that we talked about, you have pulmonary edema, that being very classic for this presentation. Okay, and again, this resolves spontaneously. Also remember, fresh frozen plasma or platelet transfusions tend to be very classic for precipitating this transfusion reaction in particular. And then finally, the anaphylactic reaction. We already kind of talked about the pathophysiology here. It's really these recipient anti-IgA, IgE antibodies that are causing most of the problems here. And again, this is a type 1 hypersensitivity, and the classic presentation is going to present with things like urticaria and wheezing, okay, which is very classic for a type 1 hypersensitivity reaction, and you want to avoid IgA in the blood on future occurrences. Very classically presented with the IgA deficiency. So hopefully this helps simplify this a little bit for you. I think there's some key things to look for with each of these different pathologies. Once you find that key thing, though, they might ask you about something else specific with the disease. So that's where it helps to kind of understand the whole picture of what's going on so that you don't miss anything. Even if you recognize the pathology, you might still have to know a little bit more to get the question right.
Take 15 seconds to pause the video, read the question, and then we will go through the answer. All right, so kind of a more challenging question here. So let's go through this step by step. So 34-month-old male with no significant past medical history presents to a pediatric hospital for difficulty standing for the past 3 days. Okay, 2 weeks prior, he was noted to have diarrhea and a mild fever and was treated with a short course of trimethoprim sulfamethoxazole. Okay, so this was 2 weeks prior. So I'm seeing that there's kind of like an antecedent infection potentially here. And this is already very classic to me for Guillain-Barré syndrome. Child can't stand, antecedent infection, right? Short course of antibiotics. Very, very classic for that. So that's the first thing I'm kind of thinking about here. Remember that, Guillain-Barré syndrome, we talk about this in the neuro section. This is going to be more of an ascending, kind of flaccid, usually symmetric paralysis. Okay, typically ascending, flaccid, paralysis, usually symmetric in the bilateral lower extremities. All right, so his parents reported first noticing difficulty with toe clearing, right? So this might be, again, because we said it's more ascending. So, there might be some deficits potentially in dorsiflexion, right? We need dorsiflexion to kind of clear the floor, right? So that might have been what happened. And then that started approximately 1 day after completing the antibiotic medication. Birth history reveals that the patient was born at 39 weeks gestation via C-section without complications. According to his parents, the patient has also achieved normal motor milestones. So again, a lot of this information, right, isn't super relevant. Vaccinations are currently up to date. Certainly if there was something going on here, if there was something abnormal that we can potentially contribute this to, that would be notable. But again, sometimes they just kind of fill some of this fluff, so to speak, in the question. Physical examination reveals distal flaccid weakness of the lower extremities and areflexia at L4-S1 bilaterally, right? This is all very classic, right? So typically in Guillain-Barré syndrome, we see, either reduced reflexes or areflexia, especially in the lower extremities here where this usually starts, right? We said it's an ascending process. Again, distal is typically affected first, right? We said flaccid paralysis, flaccid weakness at the lower extremities. These are really kind of classic terms to describe this. So they end up doing a lumbar puncture, right? And what do you expect to see on a lumbar puncture if you have a patient with GBS? Classically, it's the albuminocytologic dissociation, right? So significantly elevated protein in the setting of a normal cell count. Now, what's interesting here is they don't mention if there's any infectious things on the LP. Now, I would presume there's probably not, but that's definitely something you would be thinking about too, right? Is there an infection potentially going on, right? Like a meningitis, or was there a really high opening pressure, right? Other things that would be interesting to see, in real life especially. But again, in a board question, if they don't mention it, usually it's not relevant, right? So in this case, they're primarily just kind of pushing us in the direction of Guillain-Barré syndrome. So one of the things we can do for this, right? Initial dose of intravenous immunoglobulin is administered. Again, the idea here is that we don't want the molecular mimicry that's happening from GBS to be occurring on the myelinated Schwann cells, right? And so the idea here is that we're giving them a bunch of IVIG to essentially attenuate that process. Okay, so IVIG is administered, which is very classically used for this, by the way. Within seconds, the patient begins wheezing and demonstrating increased work of breathing. So the first thing that's really important is the timeline here. Within seconds, this happened. Wheezing, increased work of breathing. Okay, the patient quickly becomes hypotensive and intramuscular epinephrine is administered. Which of the following pathophysiologic mechanisms most likely describes the cause of this patient's reaction to treatment? Let's just start with C, because this is probably the most relevant to Guillain-Barré syndrome, just to kind of talk about this. So remember, and again, we're just going to kind of try and simplify this a little bit. So let's just say that we have some nerve here. I'm just going to say that this nerve is, there's some myelin around this nerve. So this is going to be a nerve, right? Usually in the peripheral nervous system, right? If we're talking about Guillain-Barré syndrome. If we're talking about demyelination in the central nervous system, we're thinking more of something like a multiple sclerosis potentially. But again, in the peripheral nervous system, right, we're talking primarily about our Schwann cells, right? The Schwann cells are going to be myelinating these nerves. And the concept here is, if you have some previous infections, all right, so let's just say that, and again, this is gross oversimplification, but let's just say that I had a previous infection with some bacteria that was causing this patient to have, diarrhea, I think they said, right? The patient had diarrhea and a mild fever, right? So maybe this patient had some infection, right? This is some bacteria. And what we did was we created antibodies to that bacteria. Okay, so here's my antibodies to this bacteria. We eventually targeted this bacteria for destruction. But let's just say that underwent affinity maturation, right? Somatic hypermutations, made some adjustments to that Fab region. Well, what could have potentially ended up happening was these antibodies then, right, when they went through that process, could potentially now be cross-reacting with antigens on my nerves, right? Of course, this isn't a super common thing, right? But it can happen. So I can have antigens on these nerves. One of these antigens is going to be GM1, and another antigen that we sometimes see is GD1A, right? So these are just antigens that are on these myelinated and this myelinated tissue. And so these antibodies now, if they're cross-reacting with these antigens right now, if this can bind here, well, what can happen is, just like we destroyed this bacteria, we can destroy the myelinated segments of these nerves, and even the axons can be damaged potentially. In any case, though, this is kind of the general hypothesis really of what's happening in these patients. And so when we test these patients, what we're looking for are things like anti-GM1 antibodies. If we were to test this patient for this, right, we'd be looking for anti-GM1 antibodies, right? Antibodies that would be targeting GM1 or GD1A, for example. So that's the general concept of what we're talking about, happening in this patient. Now, if you look at option C, you might be saying, well, isn't that the right answer then? Anti-GM1 antibody-mediated demyelination, that's what's happening. Now, remember, this is the process of what's happening in the pathophysiology of Guillain-Barré syndrome, right, which very well could be happening in this patient. However, what the question is asking us, and this is where you have to be really careful into, kind of deciphering what the question is asking you. The question is asking you which mechanism describes the cause of this patient's reaction to treatment, right? Not the cause of the patient's Guillain-Barré syndrome or inability to stand, right? This might be a reasonable option in that scenario. But if we're talking about what is most likely describing the reaction to treatment, this is not the best answer, right? This doesn't tell us why the patient all of a sudden started wheezing, became hypotensive, and then went on to receive epinephrine. This doesn't really tell us that much. So let's just go through the wrong ones first for a change here. So anti-A IgG mediated response. Now, when we're saying anti-A, the antigen we're usually talking about is the A antigen on a red blood cell. Okay, so typically if a patient has like a blood transfusion reaction and, that patient gets an A antigen and they have anti-A IgG antibodies, right? So, if this was the donor red blood cell and my host has anti-A IgG antibodies, these IgG antibodies could target that A antigen and destroy it. And this is very classic for an acute hemolytic reaction. These patients might have jaundice, right? We sclerolicterus, we kind of talked about this in the videos. The thing here, you might be saying, well, doesn't that make sense? Because, this happened within seconds and the acute hemolytic reaction happens pretty quickly. That's true. You could totally have an acute hemolytic reaction happen pretty, very rapidly. And you would usually stop the transfusion in that case. But the difference here is there's kind of some unusual features, right? This patient started wheezing within seconds, increased work of breathing. We're not talking about jaundice or pain at the IV site. These are kind of different findings. And we have hypotension here, and the patient gets intramuscular epinephrine. This looks more like anaphylaxis, right? This whole process that's being described here looks like anaphylaxis. This is more of an anaphylactic transfusion reaction, not an acute hemolytic reaction. Okay, these are two different things. Typically, an acute hemolytic reaction, this is going to be something we see more often when we're doing blood transfusion. Not really as classic for a patient that's receiving intravenous immunoglobulin. Remember, this patient isn't getting a blood transfusion, they're getting IVIG. So even though the timeline checks out, really not the best answer because it doesn't really fit with a clinical picture of what's happening, right? The anti-KIT IgG mediated response, this is referring to the delayed hemolytic reaction. So this is more of a delayed hemolytic reaction. And the reason that I know it's a delayed hemolytic reaction is because I can see the KIT antigen. Remember, the KIT antigen, just like the D antigen, these are minor antigens. Usually these are patients that have, recurrent exposure to blood transfusions. And then, 10 days later or 20 days later, they're going to develop some symptoms potentially. And usually pretty mild in nature. It's not wheezing and increased work of breathing and hypotension, especially not seconds after they got this transfusion. So again, this would not be very classic for a delayed reaction. Okay, going to option D here. Now, I would probably say that option D is the most commonly picked wrong answer and maybe even the most commonly picked answer here. And the reason is because you see IgA and you kind of just jump, right? You kind of just jump to D. Now let's talk about this for a second. So, what's going on with this patient? How do I know it's D or E? The reason for that is because, remember, this patient is having an anaphylactic transfusion reaction, okay? Now, when you have an anaphylactic, transfusion reaction, whether that's to IVIG, whether that's to blood products, typically the reason for this, the high yield reason that I really want to kind of ingrain in your mind here is usually going to be due to IgA deficiency. Okay, usually IgA deficiency, right? In this case, we're giving immunoglobulins, which are mostly probably IgG, but there's probably some IgA in there, right? Or if you give blood products, right, there's usually some IgA in there. And our patients that have IgA deficiency, they have IgA deficiency because they have anti-IgA, IgE antibodies. What does that mean, right? So we kind of talked about this already in the videos, but again, just to jog your memory here, right? Let's just say this is some mast cell, okay? And on that mast cell, I'm going to have these IgE antibodies, right? So I have IgE antibodies here on this mast cell, and I might also have some IgG antibodies in this patient, right? IgG, and all of these antibodies that I'm pointing out here, they're all going to be against IgA in these patients that have IgA deficiency, okay? So if I gave a patient an IgA antibody, okay? So if I gave a patient an IgA antibody, okay, so let's just say I give this IgA antibody. Now what these IgG antibodies can do, right? These are going to be anti-IgA, IgG antibodies. They can target this IgA antibody for destruction. Conversely, this IgA antibody that I just got from either blood products or from the IVIG, it can also bind to these mast cells. Okay, it can also bind to this Fab portion of IgE and cause cross-linking of these IgE receptors, and this can lead to mast cell degranulation, right? This can lead to mast cell degranulation, and that degranulation can cause anaphylaxis. Okay, so this mast cell degranulation can eventually cause anaphylaxis. And when I say eventually, I mean in the order of like microseconds, right? Because this can happen so fast. So the whole idea is because this patient already is predisposed to having destruction of their IgA antibodies, they also potentially can have anti-IgA, IgE antibodies. Bottom line, when you give a patient a transfusion and they go into anaphylactic shock, start to think in a board question, especially about IgA deficiency. Very, very classic for this, right? Now that we kind of went through that, this is why I say that option D is probably going to be picked pretty frequently because you see IgA and you might jump to this, right? IgA-mediated enzymatic destruction. But this is not the right answer, right? The whole problem here, like we just said, is that you have anti-IgA, IgE antibodies that are causing degranulation, leading to anaphylaxis. That is why E is the right answer, right? That's why E is the right answer because we just talked about it, right? These anti-IgA, anti-IgE antibodies are causing this degranulation process to happen, leading to anaphylaxis, which is exactly what's happening in our patient here. And that would explain the patient's reaction to the treatment. Let's just go through a little bit more about why D is not incorrect, though. I just want to clarify this. So IgA-mediated enzymatic destruction, what's this talking about? You know, what really comes to mind here for me, and I like talking about this with patients with IgA deficiency, is celiac disease. So the first thing is, you know, even before we talk about celiac disease, it's not IgA that's causing the problem here, right? It's the other antibodies that are destroying the IgA or basically using the IgA as an antigen to then degranulate the mast cells, right? Which is what we see with the IgE. If you have IgA-mediated destruction, first of all, that would imply that you have IgA, not an IgA deficiency, right? Because then IgA is mediating the destruction of antibodies. But one thing we sometimes do in celiac disease is we use specific markers like in IgA tissue transglutaminase, okay? Now, what this is essentially an antibody that's targeting an enzyme, right? The tissue transglutaminase, which is responsible then potentially for causing the celiac disease. Now, the first thing you might say, if you're kind of familiar with this, is you might say, okay, well, you have celiac disease here, and aren't patients with IgA deficiency at higher risk of developing celiac disease, right? Is there an association there? And you'll find that patients with IgA deficiency certainly have a higher risk of atopic disease, right? And potentially celiac disease as well. Celiac disease is also kind of in that category. Patients that have IgA deficiency have a higher predilection for celiac disease. Okay, so that's true. Normally, we can test celiac disease. We can test patients for celiac disease by looking for an IgA tissue transglutaminase antibody, which we know is causing IgA-mediated destruction of the tissue transglutaminase, right? The antibody is destroying the enzyme. But the exception would be if I had a patient that had celiac disease and they had IgA deficiency. There's a higher predilection for celiac disease in these patients that have IgA deficiency, right? So if this patient had both, if I tested the IgA tissue transglutaminase in this patient that I suspect celiac disease in, well, guess what? I'm not going to see it. It's going to be normal. It's going to be a false negative reading. And you might be saying, well, why would it be false negative? Because a patient that has celiac disease and IgA deficiency isn't going to have IgA antibodies to tissue transglutaminase. They don't have any IgA antibodies, right? They have very few IgA antibodies. So when I test them, the levels are going to be normal, right? It's going to be a false negative. So that's why you would be more inclined to test maybe an IgG variant of the tissue transglutaminase antibody in a patient with celiac disease and IgA deficiency, just for example. Okay, so that's the concept. So that's why there is potential here for false negatives. Okay, so kind of a circuitous full circle here, but bottom line is the reason why D is not the right answer is because, again, it's not the IgA that's mediating the enzymatic destruction. This is something that you might see in a celiac disease patient, but not in a patient that's undergoing anaphylactic shock, especially because the anaphylactic shock is due to IgA deficiency. You don't have IgA antibodies, so IgA can't be mediating enzymatic destruction, if that makes sense. Okay, all right. Kind of a complicated video, but a lot of really key concepts here that you should be familiar with. Hey everybody, Dr. Roviso here. In this video, we're going to talk about transplant rejection, and this is a pretty big video. A lot of topics integrated here, so we'll talk with just some basic principles of transplantations to start. We'll go through the different types of transplantations, talk a little bit about graft versus host disease, and then we'll recap this all kind of like we've been doing with some of the last chapters. And finally, we'll talk a little bit about some of the immunosuppressants that can be particularly high yield, as well as some of the biologic immunotherapy. Just to get things started, starting off pretty simple here, when we're talking about the principles of transplantation, all of these different terms have to do with where a donation is happening from. Okay, so let me show you what I mean. So in general, we have a donor. Okay, we have a donor and we have a recipient. And if you've been following along from the previous videos where we talked about red blood cell transfusions, for example, we talked about the same terminology, right? It's a donor and a recipient. The only difference was we were talking about transfusing blood or platelets. Here we're talking about transplanting an organ, essentially. And so a lot of the times we're going to talk about this transfer, whether it's a kidney or skin or whatever it is, we're going to say that it is a graft. Okay, so essentially the donor is going to be giving a graft to the recipient. Now, who the donor is, who the recipient is, that's where all of this terminology comes into play. So let me show you what I mean. So for example, let's just say that, we have a patient that has a really bad sacral wound ulcer, okay? And sometimes what we do is we would put a flap over that sacral ulcer, right? Because we don't want it to get infected. We don't want that patient to get osteomyelitis, right? So we can take skin from the same patient and put it over the ulcer. So what I'm essentially saying here is the same patient is the donor and the recipient. The patient is simply donating skin, maybe from their thigh or their leg, and that skin is then going to their sacral wound ulcer. Okay, so in this situation, the donor is the recipient. And so the term for that is an autologous transplant. Okay, so it's the donor is the recipient. So it's donor to self. And what I would call this type of graft, would be an autograft. And again, that means that the donor graft is going to themselves, maybe just a different part of the body potentially. All right, so the next situation, let's say that I have a patient that's donating a kidney to another patient. Okay, so here's my patient one. They're donating a kidney to another patient. Okay, so here's a different patient and they're donating their kidney, right? That's the graft. It's going to this patient. Okay, now because we have two different patients here, unless they're genetically identical, there's going to be some differences in their HLA antigens, which I'll talk about in a second. Okay, but the point is that these are two genetically distinct individuals. And so this type of transplantation is called an allogeneic transplantation. Okay, so that's an allogeneic transplantation. We're donating an organ, in this situation, to a non-genetically identical individual. All right, and so again, going with this prefix here, auto, right? Previously, this would be allo, right? This is an allograft. Okay, so this would be an allograft. Okay, so this is the type of graft would be an allograft when it goes from one person to another if they're not genetically identical. Now, in a situation if they were genetically identical, okay, that would be if you had, for example, two patients potentially that were twins, right? Particularly monozygotic twins, right? So if you had two patients that were monozygotic twins and you had one patient donate some tissue to another, then we would call this an isograft. Okay, iso meaning same. They're genetically the same. Okay, so that would be isotransplantation, donation to a genetically identical recipient. Now you're not going to see, the isograft mentioned quite as frequently because again, an isograft, it has to be between genetically identical individuals, and it's really only going to be the case in a board question where they're talking about monozygotic twins. So most commonly in a board question, you're talking about allografts. In general, when you talk about transplant rejection, you're not really going to be talking about rejection in these first two categories, right? So the autologous transplantation, the isotransplantation,
there's not any differences in the genetics between these individuals. So we don't expect there to really be much rejection. Rejection comes because either the donor or the host is sensitized to some new antigens. Those antigens are going to be the HLA molecules on the cells that are being transplanted, or it could be on the host cells as well, which I'll talk about as we go through this. Now, the last one I just want to put on here before we wrap this up, because occasionally you'll see this come up. Let's just say that we're transferring tissue from a different species to a human, okay? So to some patient. So this happens a lot when you talk about certain types of heart valve transplants that aren't necessarily allogeneic, right? They're not coming from human to human. It's coming from a different species, usually bovine heart valves you'll see occasionally. But when you see this terminology for the graft here would be a xenograft. Okay, so xenograft is when we're talking about donor grafts to a different species. Okay, so that's a xenograft. And again, the biggest one on here is going to be the allogeneic, right? The allogeneic is the big one because that's how the majority of these transplant rejections are going to occur. They're going to occur because there wasn't complete matching between the donor and the recipient. Okay, so this is the majority of what we're going to be talking about. Now, how do these antigens even cause a rejection to begin with? Well, remember, the HLA genes will code for our MHC molecules, okay? And we talked a little bit about MHC being on the surface of all nucleated cells, particularly MHC1, right? MHC1 is on the surface of all of our nucleated cells. And the thing that we talked about earlier too is MHC1 can be remembered by remembering that it's just one letter after the HLA molecule, whereas MHC2 can be remembered because there's two letters after the HLA molecule. And these are all different variants of these HLA molecules. And so there's a lot of diversity and distinction between them. The point being though, let's just say that, we did donate some organ from one patient to another. There's a couple different things that can happen, right? So let's just say that this recipient here, right? This recipient might recognize MHC molecules on that transplanted kidney, for example, right? They might recognize MHC1 and say, hey, this MHC1 has a different HLA than the HLA that we have, right? I'm doing gross oversimplification here, but they might have slightly different HLA molecules. And so the T cells in this patient, particularly, right, what's going to bind MHC1? It's going to be CD8 positive T cells, right? Rule of eights. So the CD8 positive T cells in this patient could attack this graft. And it can attack this graft, this allograft, right? It can attack it at these HLA antigens, at the MHC1 antigens. Now, the other thing that can happen is we can also have antigen-presenting cells that say, hey, look, these HLA molecules that have the two letters after the HLA, these HLA antigens are different from our HLA antigens. Again, but this is now at MHC2, right? This is going to be antigen-presenting cells. And again, if you're not familiar with some of this, go back and watch some of the videos on T cells that we've talked about. We're really building on the knowledge from this whole video series to get through this concept. But the idea here is you can have antigen-presenting cells bind this MHC2, present this to CD4 positive T cells, right? CD4 positive T cells can then get activate B cells through CD40 ligand, and you can generate antibodies against these antigens, okay, via MHC2. Okay, so this could be potentially more of a humoral response. But we'll get into all of the details on this as we proceed, but that's the concept. That's essentially what we're talking about. So the big take-home points here, remember, allogeneic is what we're primarily talking about. Two genetically non-identical recipients, right? They're both humans, same species, that we're having one organ donated to another. If the patient was genetically identical, very unlikely for this to happen because they're going to have all of the same HLAs, right? So you're not really going to see a significant reaction there. And if it's autologous, it's going from the donor to self, essentially. So it's the same person. So generally, we're talking about allograft transplantations. And again, it could technically happen here with the xenografts as well. They just don't tend to come up as much in terms of the board questions. All right, so we're going to talk about our first type of transplant rejection here. So this is going to be the hyperacute rejection. Now, before we go any further though, I want you to just kind of organize this in your brain a little bit because we just talked about the acute blood transfusions not too long ago. And remember, the acute hemolytic reaction, okay, so we kind of just talked about this. The acute hemolytic reaction primarily had to do with this, red blood cell major antigen incompatibility, right? That was the concept. The concept was there was some mismatch in the A, B, and O antigens. And you can go back and check that video out. We go into that in great detail. But that was the concept of an acute hemolytic reaction. Now there's acute hemolytic reactions, there's delayed hemolytic reactions, right? But there's also acute transplant rejection there's chronic transplant rejection, there's hyperacute transplant rejection. And so you have to kind of organize these in your mind and understand that in the hyperacute transplant rejection, you can see our red blood cell incompatibility, and we'll explain why that is in a second. This is essentially going to be very similar to the acute hemolytic reaction, though, that we talked about, if it presents this way. The pathophysiology isn't very different from what we talked about with acute hemolytic reactions. The only difference is we're transplanting some tissue, right? Allogeneic transplant usually. And with that, there might be some HLA incompatibility and potentially some incompatibility in the red blood cells and the red blood cell antigens. Now, of course, what we would normally do to prevent this is we would do a type and screen or direct Coombs test, testing to make sure we're not going to end up having an acute hemolytic reaction or a hyperacute rejection. But the point that I want to make is that you see this with both hyperacute rejections and acute hemolytic reactions. It's the same pathophysiology. This tissue that we donated, we didn't type and screen those red blood cells to see if they had markers on them the recipient might already have antibodies against. Okay, and again, we talked about this in great detail in the acute hemolytic reaction. I don't want to belabor the point here, but the reason I bring this up is because there's also an acute transplant rejection. Okay, so there's also an acute transplant rejection. And the acute transplant rejection is not the same as these two. Okay, so this is not the same as these two. This is a completely different pathophysiology, and it happens on a completely different timeline. Okay, so my point is, I don't want you to confuse acute hemolytic reactions with acute transplant rejection. That's the big point. So it's just kind of noting these things so that you're aware of them, noting them in your mind so that when you come into those situations, you don't get confused or tripped up by it. Okay, but the hyperacute rejection is very similar to the acute blood transfusion reaction. The concept here is, when we talked about transfusion reactions, so again, I have my donor, I have my recipient, right? And essentially in a blood transfusion, right, I would be donating this blood, and this recipient might already have anti-A antibodies, right? Especially if this patient didn't have A antigens on their red blood cell surface. So if this patient was, blood type B, for example, this patient might not have A antigens on their red blood cells, so they'll probably have anti-A antibodies. And so when this donor red blood cell comes in here, right, what's going to happen? Well, it's going to get marked for destruction by preformed antibodies. These antibodies already exist. We don't have to wait to undergo class switching to form them. So these antibodies are going to bind immediately to the surface of this cell, mark it for destruction, and then we're going to end up with most likely complement-mediated destruction of these red blood cells. And because we'll have an antibody here sitting on the surface of this cell, right? If I draw it in here, I'll have an antibody sitting on the surface of this cell, right? This is going to be a type 2 hypersensitivity reaction, right? I'm marking those red blood cells for destruction. And so this is essentially what's happening with a graft, right? When I donate tissue, it's the same concept. So if you can imagine, instead of this being a red blood cell, let's just say that this is some tissue, okay? So maybe I'm donating, I'm just gonna draw a kidney in here, right? We draw some kidney in here, and on this kidney, there's antigens. There's HLA antigens. There might also be some blood in that kidney, potentially, or when that transfusion happens, there might be some blood that's transferred with it. Okay, so you have your HLA antigens, you have your red blood cell antigens, right, that are all gonna be on this tissue, right? And so when I donate that tissue, the same thing can happen, right? I can have antibodies that are preformed against these HLA antigens. Instead of it being anti-A antibodies, I might have anti-HLA antibodies to specific HLA molecules that are going to be on this donor's graft, right? This is why we have to perform HLA matching, just like we have to cross-match red blood cell antigens, right? Because if we don't match the HLA markers and we start donating tissue, that host might already have antibodies to that graft. And so what's going to happen here? Well, it's the same thing as what we talked about with the red blood cells, right? These antibodies are then going to bind to the surface of the donor's graft, and this is going to lead to complement-mediated destruction. So let's just talk about this here. So again, it's destruction of the donor graft, and this is where you have to be careful. Again, destruction of the donor graft by recipient preformed antibodies, right? By recipient preformed antibodies. Again, this is a type 2 hypersensitivity because I'm putting antibodies on tissue, right? I'm putting it on the red blood cells, or I'm putting it on the kidney parenchymal tissue, or whatever it is that I'm donating. Because these antibodies are preformed, in other words, right, we didn't really do a good job of matching the HLA antigens or matching the red blood cell antigens. This is going to lead to a very rapid onset, which is why it's called hyperacute. Now, in a board question, the way that they'll ask you about this is they'll say that, a surgeon just transplanted this kidney and as soon as there was, for example, an anastomosis created or the blood from the recipient was then sent to that organ, what will happen is an immediate edema to the graft of the tissues. Okay, so there's an immediate reaction. As soon as this recipient's antibodies get to that kidney, it's marking it for destruction. Complement cascade is set off. So we're talking about something that's happening, again, within minutes of the graft placement. It's going to happen in the operating room. Okay, here, let's write that down. It's going to happen in the OR. Okay, so this is going to be classically presenting as they literally put that organ in the patient, it's immediately being rejected. And not only is it being rejected, this complement-mediated destruction, right? If I zoom into this kidney, okay, if I zoom in and I look at a blood vessel going through this kidney, okay, and I establish perfusion, right? This is all the recipient's blood now going through this blood vessel to supply this kidney. The antibodies here are immediately going to start to bind, right? The antibodies are going to start to bind and recognize this HLA mismatch all around this kidney tissue. And what's going to happen is we're going to get complement-mediated destruction. So complement is going to start destroying the tissue around here. We can get a little bit of an inflammatory reaction potentially, but eventually what's going to happen is from all of this endothelial cell destruction, it's eventually going to block off this vessel. Okay, so now blood can't get through this kidney tissue, and we know that if we can't get perfusion to an organ, what happens? Well, we end up with ischemia. Okay, so we end up with ischemia because we can't get blood through this organ. And this whole thing here is going to clot, right? This blood here isn't really moving, so it's going to clot. You can get thrombosis of these vessels. Okay, and so what is that going to look like when you see a blood vessel that has dying tissue around it, right? Particularly these smaller vessels that have smaller luminal diameter, they're going to have fibrinoid necrosis, right? So you're going to see thrombosis, fibrinoid necrosis of this vessel. The tissues will have ischemia. You're going to get necrosis immediately of the graft, and that graft has to go, has to come out. And again, the way that we minimize this is we make sure that the HLA antigens in the donor match the HLA antigens in the recipient, just like we do with red blood cell transfusions. It's the same thing as we talked about with ABO incompatibility. It's just with HLA antigens. And it can also happen with ABO incompatibility here as well. It can be multifactorial, right? But the big thing is going to be the HLA antigens. We want to make sure that those are matched up. All right, let's talk a little bit about acute rejection. Now, the first thing I want to say here is, again, we just talked about this in the last video. Don't confuse acute rejection with acute hemolytic reactions with blood transfusions, right? They're two different things. The acute hemolytic reactions with blood transfusions are type 2 hypersensitivity. Pretty much they're caused because of preformed antibodies. They're going to happen a lot faster, and they're more synonymous with the hyperacute transplant rejections. Okay, so that's number one. Number two, in all reality, hyperacute transplant rejections are pretty rare because usually we're going to be looking to match HLA antigens right before we go putting an organ in somebody. So you don't really see them a lot. However, the acute transplant rejection is actually quite a bit more common. It still results from HLA incompatibility, but maybe not to the same extent as the hyperacute rejection. The difference here is, remember, with hyperacute rejection, we're talking about preformed antibodies. We already have those antibodies, we just weren't matched really well. And so immediately those antibodies started attacking that graft, right? And caused, within minutes, it caused thrombosis of the vessels around it. It caused ischemia and necrosis of the graft. Now, an acute rejection is going to happen on a longer period of time. It's going to be a rejection that happens within weeks to months. And because of this, it's not because of preformed antibodies, right? If it was preformed antibodies, just like we see with type 1 hypersensitivity reactions, happens immediately when that IgE is on the mast cell. Just like with acute hemolytic reactions, right? We had antibodies preformed, things start getting destroyed right away, possibly even during the transfusion. Here, though, it's going to take time for that reaction to happen. So let's just look at a couple scenarios to kind of get an idea of what we're talking about. So again, we have some donor. Okay, so here's my donor. And I'm just going to draw, we'll just do a kidney again, right? We did a kidney last time. So the donor is going to give a kidney to the recipient. And here's my recipient. Now this time, I don't have preformed antibodies to the HLA antigens here. But what can happen is, after this recipient gets this kidney, okay, after that comes in here, initially we might have some antigen presenting cells in this recipient. Okay, so I'm just going to put antigen presenting cells. And again, I'm going to go through this a little bit fast. And the reason is because we actually talked about this probably 5 or 6 times during the immuno section. So like I said, go back, check out some of those previous videos. But essentially what we're talking about here is this antigen presenting cell is coming from the recipient now. Okay, remember, this kidney came from the donor. I'm trying to keep it color coded for you. And so what can happen is this antigen presenting cell can say, hey, look, there's some HLA antigens on here. And then it can take a piece of this HLA antigen, and then it can present it to a T cell, right? So it can present this HLA antigen to a T cell. Again, the recipient's T cells
can recognize this. Now, of course, this can go a couple different ways, and we talked about this in great detail already in the video series. But again, when this antigen presenting cell presents this HLA antigen, it can release certain substances, right? It can release interleukin 12. And if it releases interleukin 12, it's going to cause this T cell to become a T helper 1 cell. And then what's that T helper 1 cell going to do? It's going to release interferon gamma, right? And that interferon gamma is going to cause macrophage activation. And these macrophages, and what are they going to do? They're going to go and they're going to attack that tissue, okay? But again, this whole process takes time, right? This T cell response takes time. This process here, right? This process here, along with potentially CD8 positive T cells, right? If you factor in some CD8 positive T cells here, so we're just going to put T cell, CD8, right? So you might have some CD8 positive T cells that also recognize these antigens and also start destroying the tissue here. And this whole process here really is going to be largely driven by destruction of this graft by macrophages, right? From a T helper 1 response and CD8 positive T cell activation. And we talk about this very frequently as a cell-mediated response. When we have cell-mediated responses, that's very similar to a type 4 hypersensitivity, okay? So that's a cell-mediated response. That's one possibility of something that can happen with this graft. Now, if this happened, what would you expect to see on histopathology? Well, you'd expect to see a whole bunch of T cells at the site of the graft, right? So CD8 positive T cells, potentially these are CD4 positive, talked about that, T helper 1 cells. You'd expect to see a whole bunch of these, and macrophages too, all around the graft. And so a good image of that is depicted here. You can see this is really a significant lymphocytic mononuclear infiltrate, right? It's infiltrating, in this case, the lungs, right? You can see these are all your alveoli, your alveolar tissues here. And when you see a bunch of lymphocytes in the tissue here, that's very consistent with either an acute or potentially a chronic transplant rejection. You might be saying, well, how do I tell the difference? Well, you look at the timeline, right? So acute rejections are going to be usually less than 6 months, weeks to months. If you're talking about a chronic rejection, it's going to be like a year out at least. Okay, but they'll look similar on histopathology. There are a couple differences we'll talk about. Things like fibrosis or more chronic inflammation is going to be more consistent with chronic rejection, right? The acute rejection is going to be more consistent with things like vasculitis. But again, if it's cell-mediated, it's very classic to see this lymphocytic infiltrate. Again, when I say cell-mediated, I'm talking about this process that we've gone through a few times now, but essentially macrophage and CD8 positive T cell destruction of the graft. And that's what you're seeing here. All of these blue dots that you're seeing throughout here, this is this dense lymphocytic infiltrate. And you can also see here, and you can see here, these are all red blood cells. Right? And so you also have some intraalveolar hemorrhage, probably from the parenchymal destruction of the lung here. Okay. And so, but again, what are you looking for? You don't have to be a pathologist. You're just looking for a dense lymphocytic infiltrate. Look for a whole bunch of lymphocytes everywhere, and then ask yourself, what's the timeline? Is it weeks to months, or is it, a year plus, right? Usually, like I said, less than 6 months is almost always going to be acute rejection. If it's like 10 to 11 months, you'd lean more towards chronic, or look for additional findings like fibrosis or vascular, smooth muscle proliferation, which I'll talk about in the next slide. Okay. But that's what we're talking about here with acute rejection. Now, the thing about acute rejection that's a little tricky is that this can be a cell-mediated response, but it can also be a humoral response. But it's usually not both, okay? So it's kind of like it's one or the other. Now, this is the cell-mediated response like we just talked about. Now, a humoral response would be a little bit different. So let's do the humoral response here on the bottom. Okay, again, we have our donor donating a kidney to our recipient. Okay, now the difference here is, again, there might be some antigens on here, some HLA antigens that are recognized by the antigen presenting cells. Okay, so the antigen presenting cells will recognize these. One good question here is, if the antigen presenting cells recognize these, what type of HLA are they recognizing? Well, it's probably going to be HLA-2, right? If it's an antigen presenting cell, it's probably going to present this to CD4 positive T cells. And if it does, we know that it's going to be MHC class 2, which means it'll be an HLA antigen that has 2 letters after the name, right? So these are all like the little intricacies of putting this all together. But again, the antigen presenting cell will identify this HLA antigen. It's going to take that HLA antigen and present it probably to a T cell again. Okay, probably to a T cell, probably a CD4 positive T cell, right? Especially if this is MHC2, right? According to our rule of 8s. And so then this T cell, if we're going down a humoral pathway, would probably become a T helper 2 cell, right? A T helper 2 cell can then go on to bind with B cells and activate B cells to undergo class switching. Okay, and we talked about all of this in the previous videos, right, driven by CD40 ligand, and these B cells will then convert into plasma cells and start making a bunch of antibodies, right? They'll be turned into antibody factories. And this whole pathway here is going to be the humoral response. And a humoral response is going to be more consistent with a type 2 hypersensitivity. Why is that? Well, because we're making these antibodies. Where are these antibodies going to bind to? They're going to bind right to these antigens on the graft, right? So similar in some ways to the hyperacute rejection where we had preformed antibodies that bound to the graft. In this case, the difference is the antibodies are not preformed, right? We're going to have to take some time to form these antibodies and then have them bind to the graft because of potentially some HLA incompatibility or mismatch. But again, it takes time for that to happen. It takes time for the T cells to become T helper 2s, to then bind to B cells, activate them, undergo class switching, and eventually make IgG antibodies against the graft, as opposed to having preformed antibodies. So that's the major difference. But again, it's kind of the same mechanism after that point, right? It's really just type 2 hypersensitivity, complement-mediated destruction of the graft, largely driven by complement. Now, would you see, if we went down just a humoral response, what are some things that can help you distinguish that from the cell-mediated response? One of the big ones is we can look for complement in the graft. Remember, when we're talking about a humoral response, we're talking primarily about complement-mediated destruction. So, right, if I tag something for destruction and then I start having complement bind to this, right, eventually leading to a membrane attack complex to destroy the graft, well, that's going to be a little bit different than if I just destroy the graft using CD8 positive T cells and macrophages. Okay, so what we would do is we can look for complement markers. So if you use specific complement markers, one classic one is C4D. Okay, so if they tell you they use a complement marker on a histo slide, right, or immunofluorescence with a complement marker, and it's lighting up and it's positive, well, then we think more about humoral rejection. However, if that complement marker is negative, right, if I'm not really getting anything when I use the complement markers, in other words, it's saying there's really not a lot of complement here, it's probably more cell-mediated destruction. Remember, with acute rejection, it's usually one or the other. Okay, it's usually not going to be both. So you're going to have destruction from one or the other classically, and that's particularly important to remember here. What's this going to present with? Well, edema to the graft tissues, so all the swelling, all of the inflammation, and eventually you'll have some deterioration of the function of that organ. In our case, we're talking about a kidney. What are some things you would see in a board question that would make you think, or even in real life, that would make you think that this patient potentially has some rejection of a kidney? Well, you would probably see an increase in their creatinine, right? The filtration, the GFR would be decreasing or declining. You probably see an elevation in the BUN as well. You probably have decreased urine output, for example, right? These are all things you want to look for in a board question. Again, it depends on the organ being transferred. And again, the classic thing here is we want to make sure we're matched from an HLA perspective, and we also can add in some immunosuppression. Now, if you have an acute transplant rejection, what you can do in these patients is you can kind of quote unquote blast them with high dose glucocorticoids and try to basically eliminate this immune response acutely. Okay, that's one option. It might not always necessarily work, but you can also have these patients on maintenance immunosuppression therapy, hoping that this doesn't happen. All right, so what about chronic transplant rejection? So the big difference here between the acute transplant rejection is going to come in a couple different places, but it's not significantly different. Okay, so the first thing is, again, we're talking about HLA incompatibility, right, which is pretty consistent with what we've said so far. The timeline is a little different here, though. It's going to be more months to years. Usually 6 months and on is a good way to kind of go about thinking about chronic rejection. So I would say when you start to get greater than 6 months, and now this patient is starting to present with some signs of transplant rejection, then we think more about chronic rejection. Now, what's the difference? Again, we said there's a couple key differences. One is the timeline here. The other one is this word right here, and, right? So you can sometimes see cell-mediated and humoral responses kind of integrated together in the chronic rejection. Whereas when we talked about acute rejection, we're saying usually it's one or the other. Okay, and again, this is the same thing that we talked about in the last slide. So I won't go through it all again, but again, you can have a cell-mediated response, humoral response. Remember, your cell-mediated is primarily type 4 hypersensitivity, humoral is type 2 hypersensitivity. And again, the idea is there's some cytotoxic destruction to the graft related to macrophages, CD8 positive T cells, and then eventually antibody production post-class switching, where you're going to have IgG antibodies inducing complement-mediated destruction of the graft. Okay, talked about this all in the video on acute rejection. And again, the presentation is pretty much the same, right? It's not a huge difference from acute rejection. Really, we have to just focus on the timeline, and then remember, mechanism can involve both the cell-mediated and humoral responses. Now, in terms of the histopathology, this can be a little different. There's a couple key words I want you to look for. Okay, the first one here is fibrosis. When you see fibrosis, just in general, okay, it's almost always chronic inflammation, right? Fibrosis, TGF-beta, a lot of these things that we've talked about already are very classic terms to call your attention immediately to something like a chronic disease process or a chronic rejection. It's been happening over a long period of time. There's chronic inflammation there. Eventually, what will happen is if we're not acutely cutting off the entire blood supply to an organ, we'll start to have some VEGF, right? We'll have some vascular endothelial growth factor potentially being released. We'll have some vascular smooth muscle proliferation to try to reestablish blood flow to this tissue. But by this time, it's already atrophic. It's not necessarily completely ischemic, but it's on its way down. It's not an acute destruction of the organ. It's just that the recipient's immune system is just like hacking away at that organ. Okay, that's one way to think about it. Now, in terms of the management, in these situations, usually when you catch chronic rejection, you just have to take it out. We try to prevent it, again, using things like immunosuppression, all the things that we talked about in the last video. But again, the big things to distinguish acute versus chronic rejection, because this is what you'll typically have to do. Number one, remember the timeline, usually greater than 6 months. If you start getting into the years in terms of how long this patient has had this transplanted tissue, in those situations, usually you're talking about chronic. The key word, number one, is going to be fibrosis, right? Usually interstitial, right? Some vascular smooth muscle proliferation that's going to take, time to happen as there's worsening perfusion potentially to this organ. And it's going to be atrophic, right? It's going to be shrink in size, and usually we'll have to remove the graft in these patients. But that's what we're looking for. And remember that you can get humoral and cell-mediated responses in the chronic form of transplant rejection. All right, let's talk a little bit about graft versus host disease. Now, this is probably one of the highest yield slides of this chapter, and so I really think it's one of the ones that we're going to spend a little bit of time on to make sure we're sharp on this, because some of this can get a little confusing, but if you understand the last few slides, it might make a little bit more sense here. So let's just go back to our basics here. So let's just say we have some donor, and let's just say that we're doing a stem cell transplant from this donor's tissue. Okay, so we're going to do a hematopoietic stem cell transplant, potentially from the bone marrow here of this donor, and we're going to give it to the recipient. Okay, so that's the idea. Now remember that when you do a hematopoietic stem cell transplant, okay, when you do this, a lot of these cells are going to be very rich in lymphocytes. Okay, so we'll just put rich in lymphocytes in this region. So when this donor gives this tissue that's rich in lymphocytes to the recipient, these lymphocytes might start, floating around the blood and eventually might recognize some of the tissues here in the recipient. Okay, so let's just say that here's my recipient, and I'm just going to draw my GI tract here in the recipient, and maybe these lymphocytes are, in the blood vessels around the intestines, for example, and they might recognize some of the HLA antigens on the recipient as foreign. Okay, so here's all these lymphocytes that are coming in here from the donor, and they might be floating around in the blood vessels and recognize some of these HLA antigens, particularly the CD8 positive T cells. Okay, so the CD8 positive T cells are the killer cells, again, coming from the donor, coming from this hematopoietic stem cell transplantation, right? These lymphocytes might recognize the tissues in the recipient, right? So we said in the intestines, potentially in the skin of the recipient, right? So in the skin. So these lymphocytes are going to start to recognize some of this tissue as foreign. Again, probably because there could be some, sensitization or HLA incompatibility that's causing this. But again, these lymphocytes, usually going to be CD8 positive, are recognizing these cells. Now, if they're recognizing all of these cells in the recipient, they're probably recognizing MHC1, right? Especially if they're CD8 positive. Because remember, all nucleated cells are going to have MHC1 on them, okay? And so the MHC1 on these recipient cells are getting recognized and eventually getting destroyed by this donor's T cells, essentially. And there's a lot of these T cells that are being transferred, right? We already said that the bone marrow is going to be very rich in lymphocytes. And so again, the big difference here from what we talked about before is in this situation, it's the donor's T cells, not the recipient's cells. It's the donor's T cells that are damaging the host tissue. Okay, before when we said acute rejection, hyperacute rejection, chronic rejection, everything was flipped. It was the host, right? It was the recipient that was damaging the donor graft. In this situation, it's the graft that has the T cells in it that then kind of come out and destroy the recipient's tissues. And so this is going to be a cell-mediated response, again, because it's driven by the T cells. not the T cells of the recipient, again, the T cells of the donor. And because of that, it's going to be a type 4 hypersensitivity reaction. We're primarily talking about CD8 positive T cells. Now, the onset for this is completely variable, okay? It's not particularly high yield to know that, but it is high yield to know that when you see a board question, they say this patient got a hematopoietic stem cell transplantation, you immediately should think about graft versus host disease. Now, if they said that this patient had a kidney transplant or renal transplant, I wouldn't jump to this, right? I wouldn't think of this necessarily. But when I see hematopoietic stem cell transplantation, that's my first clue. That's my first clue that says, hey, we're probably dealing with graft versus host disease. I don't know for sure yet, but I'm going to look for some other clues in the question, which we'll talk about in a second. Before we talk about that, though, there is another situation that can kind of go either way. Liver transplants. Now, livers are also kind of rich in the lymphocytes. Okay, so if they tell you that the patient had a liver transplantation, this is also very classic for causing graft versus host disease. Kind of one of the classic things you'll see here, and this is your way to distinguish this, and this might also be getting into a bit of the details here. But let's just imagine if you're trying to say, hey, is this graft versus host disease, or am I dealing with something like an acute or chronic rejection potentially? Well, you have to look at the liver function. Okay, so you have to look at the liver function. Now, if we think about this, right, if the donor gave the liver to the recipient, and the recipient is rejecting it, right, from either acute rejection or chronic rejection, the recipient starts making antibodies against it, marking it for destruction. What's going to happen to that liver that the donor gave the recipient? It's going to get marked for destruction. It's going to get destroyed. We already said it's going to have either fibrosis, right? It's going to become atrophic. It's going to have a decline in function, all the things that we talked about, right? That liver is going to get damaged. If I put that in the recipient marks it for destruction and destroys it, that liver that was donated, that graft is going to get destroyed. We might have to remove that graft. So if we're talking about an acute rejection or chronic rejection, like we talked about before, where the recipient or the host damages the donor graft, in these situations, we would expect to have a decline in the liver function, right? We'd have a decline in that liver function because it's getting damaged. So we'd see elevations in the AST, in the ALT, we'd see jaundice, scleral icterus, right? Signs that this liver is not working, right? Now, the other situation is, let's say that this donor, again, donates the liver, and let's say this liver is really rich in these lymphocytes, right? And these lymphocytes are going to recognize the recipient essentially as foreign, right? They're going to recognize the tissue potentially in the intestines, potentially in the skin as foreign, and they're going to start to destroy those tissues. In that situation, okay, in the situation of graft versus host disease, right? I'm going to put graft versus host disease, which is what we're talking about here. What would happen to the liver function? It's going to be normal because the liver's not getting attacked. The liver came from the donor. The lymphocytes in the liver come from the donor. The lymphocytes in the liver from the donor are not going to attack their tissues that they're genetically identical to. They're going to attack the recipient's tissues in which they're not identical to. So in graft versus host disease, that liver function, it should be normal, right? It should be normal. What's not going to be normal is the rest of the presentation. The host tissues are getting attacked. The recipient's tissues are getting attacked. So the recipient is going to have things, if our skin's getting attacked, we're going to see a rash. A classic rash that we'll see in graft versus host disease is a maculopapular rash. It might be diffuse, right? Normally, if you have transplant rejection of a graft, it's usually local to that area, right? But if you see diffuse issues in this patient, diffuse pathology, right? Maculopapular rash. If you see this patient has abdominal pain, nausea, emesis, diarrhea, these are all things that might signify potentially this is more of a graft versus host disease. Again, if I transplanted the liver and the liver caused this, the liver function would be normal. Now, again, like I said earlier, though, the classic pathology is a hematopoietic stem cell transplantation. So you can see all of this, again, in a hematopoietic stem cell transplantation. And in that situation, you might see jaundice and an increase in the ALK-Phos or an increase in the liver enzymes. Because if I do a hematopoietic stem cell transplant, the liver's fair game, right? But if I transfer the liver, then I know that the donor lymphocytes aren't going to attack their own tissue. That's the point I'm making, okay? So the point is, if you have a hematopoietic stem cell transplant, liver's fair game, right? If you transfer the liver, though, these cells are not going to attack where they came from. And that's the point. They're already genetically identical. So just remember that. So you would only really see this if the patient had a hematopoietic stem cell transplantation. That's the point I'm trying to make. Again, pancytopenia, this is also possible, right? The recipient cells can get destroyed by these lymphocytes. Okay, so it's a diffuse presentation. That's the point. We're attacking tissues all throughout the recipient. The classic ones are going to be dermatologic and intestinal. All right, and again, we're going to see lymphocytic infiltration of the host specimen. Now, there's something in here that's subtle that's important.
Okay, we already said you can see lymphocytic infiltrate in acute rejection, chronic rejection, but the key is the host specimen. So let's just say this patient has a maculopapular rash. You do a biopsy of the skin. You see a lymphocytic infiltrate. Well, that's classic, in the right vignette for graft-versus-host disease. And you might be saying, okay, well, how does that compare to the acute rejection, chronic rejection? Well, it's the host specimen. It's the recipient's skin you're biopsying. You're not biopsying the graft. If I biopsy the graft in graft-versus-host disease, right, the graft isn't getting attacked. The graft isn't abnormal. Whereas with acute and chronic transplant rejection, it's the graft that has this lymphocytic infiltrate. Here, the graft is just fine. It's the host tissues you're biopsying that have lymphocytic infiltration. So again, you have to pay attention, right? What are they biopsying? Are they biopsying, this recipient's intestines because they have inflammation potentially, or the skin because they have a rash? In those situations, now we're thinking more about graft-versus-host disease. If I'm biopsying the graft and I see a lymphocytic infiltrate, I'm thinking more acute or chronic rejection. You might see immunosuppression, in a lot of these patients because, right, we don't want the host to destroy the graft. But here's the problem. If you start immunosuppressing this recipient's going to have a harder and harder time fighting off these T cells that are attacking its tissues, right? And so the concept is, right, as you immunosuppress this recipient, this reaction can actually get worse. So as you start to increase your immunosuppression, right, you can actually make the graft-versus-host disease worse. Potentially, right? Because now the recipient has less of an opportunity to sustain the damage from all of these T cells. The other thing is you can see this graft versus tumor effect that sometimes comes up. And so the concept here is, let's just say that you had a patient that had leukemia or a patient that has myeloma, for example. What ends up happening is, especially with leukemia, is you kind of have this crowding of all of these white blood cells that are being produced. If we take leukemia, for example, right? And all of these white blood cells are essentially crowding out all of the other cell lines, okay? And a lot of these white blood cells are going to be genetically similar in some way, and they're, in many cases, not functional, okay? And so they're really just taking up space and causing things like pancytopenia from the cells that actually work, okay? Because they crowd everything out, right? They're crowding. And so what you can do here, if you do a transplantation of hematopoietic stem cells to try and fix this problem, you can actually get these patients immunosuppressed enough to increase potentially this graft-versus-host disease. But instead of thinking about the graft attacking the host, you want the graft to attack all of these kind of non-functional crowded leukemic cells, right? And so we call this the graft versus tumor effect, right? You want it to kind of target these tumor cells or the cancer cells. And so these T cells that are coming from the graft, right, they can go over here and recognize that, hey, these cells don't have the correct HLA antigens, right? So these CD8 positive T cells can start destroying all of these abnormal crowded cells, right, or tumor cells. Now you can imagine that these CD8 positive T cells aren't selective for just the tumor, right? They're also going to destroy the host tissue. So as you increase the immunosuppression, right, you're also going to potentially increase the side effects that these patients might have with graft-versus-host disease, but you're doing that to try and get the graft cells to essentially attack the tumor or the underlying pathology as well. So anything beyond that is really beyond the scope of step one. It's just something that you want to be familiar with. And again, remember, all of this is really happening in allogeneic transplantations, again, where there's some potential for HLA incompatibility. We have our hyperacute, acute, and chronic rejection. And remember, in all of these three situations, we're talking about donor graft destruction. Okay, so everything is against the graft. Okay, so we're attacking the graft with hyperacute, acute, and chronic. In graft-versus-host disease, it's just like it says. The graft is doing the attacking, okay? It's the donor graft that's attacking the host or the recipient, okay? So that's how we kind of distinguish these. Now, these three are distinguished based on the timeline. Is it happening in the operating room? Then it's hyperacute. Is it happening around, less than 6 months or so? Then we'd say acute. Greater than 6 months to years out, we're thinking more chronic. What type of response are we getting? Well, remember, the hyperacute is very similar to the acute blood transfusion reactions, right, in the sense that it's humoral. The acute can be either or, okay, and the chronic is both. Okay, so that's your kind of way of remembering this, humoral or and. And remember, graft-versus-host disease is cell-mediated. And if you're ever in a situation where you're getting really worried because you're saying, well, I don't remember what it is, think about what's happening, right? If something happens immediately, it has to be preformed antibodies, right? It has to be, in most of these situations. So it has to be humoral because there has to be something already there to immediately cause a reaction. Whereas if you're in a situation where it takes a lot of time for the reaction to happen, well, now it could be cell-mediated. If you're looking at a histology slide and the complement is positive on the histology slide, right? They did, a complement marker or immunofluorescence, right? And there's complement everywhere. Well, it might probably humoral, right? Because
because it takes antibodies to activate that complement. If you're seeing lymphocytes everywhere, maybe it's cell-mediated. Okay, so that's kind of the way to think about it. Now, if it's graft versus host disease, it's cell-mediated. It's going to be probably CD8 positive T cells that were transplanted from a bone marrow transplantation or hematopoietic stem cell transplantation or potentially a liver transplantation. Okay, so kind of all those things that we talked about. Now, again, hyperacute, we said preformed antibodies. What does that make it? A type 2 hypersensitivity, just like the acute blood transfusion reactions. If it's cell-mediated, it's type 4. Again, humoral's type 2. So it just depends. You have to take this and just apply that to the type of hypersensitivity that you're going to get. Okay, remember, in hyperacute, we're in the OR, and we're seeing that this graft is turning white or it's becoming ischemic. We're looking for thrombosis of the vessels, fibrinoid necrosis of the graft. Acute and chronic, it's really about the timeline, but in general, whatever that graft was that was transplanted, there's some decrease in function. There's some edema to that graft tissue. Graft versus host disease, the host is going to have symptoms all over the place, right? They're going to have, we said classically, dermatologic manifestations are very classic. Maculopapular rash, diffusely is very classic. Abdominal pain, nausea, emesis. You can get a pancytopenia, potentially liver involvement with hematopoietic stem cell transplants. And then the histopathology we also talked about here. So just going over that again, thrombosis, fibrinoid necrosis of the graft. Again, right away, lymphocytic infiltrate is classic for cell-mediated responses. You can also see vasculitis. And then when you're thinking things like fibrosis, you're thinking chronic, right? When you're thinking vascular smooth muscle proliferation, it takes time for that to happen. It doesn't happen, in a week, right? It takes time for you to have the mediators to eventually allow proliferation of blood vessels. And then atrophy is very classic too. It's kind of this very slow decline in the function of that tissue. Okay, and again, if you see lymphocytic infiltrate on the host specimen, right? If they do a biopsy of the skin, for example, that would be more classic for graft versus host disease. Again, where is the lymphocytic infiltrate? Is it in the graft itself, meaning that the graft is getting attacked, or is it in the recipient, right? Is the recipient's tissues getting attacked? So that's important to know. Now, the immunosuppressants in general can be somewhat overwhelming because, there's a lot of information, but I think of the immunosuppressants really, at least the high yield ones, into, two kind of separate categories. Okay, so we're going to do category 1 here. So category 1 is just about a pathway. Okay, it's a pretty straightforward pathway. There's only 4 or 5 steps to it. So going back to kind of the pathophys we've talked about before. So again, this is going to be an antigen presenting cell, and this is going to be a T cell. Okay, now we already said antigen presenting cells can present antigens, right, via MHC2 to the T cell receptors. Usually this will be a CD4 positive T cell, right? And so the antigen presenting cell binding here will then activate this T cell, right? So this T cell now has the matching antigen. This T cell receptor gets activated, right? It gets activated, and the process here involves this calcineurin. Okay, so calcineurin will help activate nuclear factor of activated T cells. Essentially what this thing does is it just increases the transcription of interleukin 2. That interleukin 2, remember we said when we talked about cytokines, interleukin 2 can, have paracrine effects at nearby cells. It can have endocrine effects at distant cells, and it can also have effects at that same T cell, right? Autocrine effects. And so the concept is, right, interleukin 2, remember, we're stimulating pretty much a lymphocyte response with interleukin 2. Everybody's going to have lymphocyte growth when I have interleukin 2 released. And this interleukin 2, like I said, can go back to this T cell for the simplicity of this diagram and bind to the interleukin 2 receptor, okay? And the interleukin 2 receptor, and we don't need to go into all the details on this, but this can eventually lead to activation of the mTOR kinase and mTOR. And again, like I said, we don't need to go into all the details, but essentially stimulating T cell growth. Okay, as well as growth of lymphocytes in general. But that's the bottom line. So the pathway started with the presenting of an antigen, right? So we presented an antigen, that's where we started, and we ended with some increase in T cell growth. Now, if you look at this, there's really 4 points that you want to be familiar with. Things aren't as bad as they may initially seem. All right, let's clear this up and talk about it. Okay, so the first one on here is the calcineurin inhibitors. Now, we already said this antigen presenting cell is going to bind to the T cell, right? It's going to do so via this MHC2 typically, and the calcineurin here is then going to be one of these mediators that's essentially going to act to increase interleukin 2 transcription. Now, if I inhibit calcineurin, right, if I inhibit this step, then I'm going to have a decrease in my interleukin 2 released. Therefore, right, I'm going to have less interleukin 2 binding to the receptors, less T cell growth. That's why these are immunosuppressants. They're essentially suppressing in this particular diagram, the responsive T cells. But remember, interleukin-2 acts on B cells, natural killer cells, etc. Classic drugs here that you want to be familiar with. The first one is cyclosporine, right? Cyclosporine. And cyclosporine can bind to cyclophilin. Okay, so by binding to this molecule, it can help eliminate some of the calcineurin here, right? So it can inhibit it. The other one is tacrolimus. Commonly see on the words as people just say tacro, right? So tacrolimus can also inhibit, but it binds to a different protein, FK506 BP, or binding protein. The point here is, you might be saying, do I have to know this? Well, sometimes they ask questions about these calcineurin inhibitors, which is what they're doing here, right? They're calcineurin inhibitors. And you sometimes have to know the protein they bind to. Okay, and I'll kind of explain how they tee this up in a second. But the point is, the bottom line is that at the end of the day, we're decreasing interleukin-2, right? Why are we decreasing it? Because we never really activate this nuclear factor of activated T cells to increase interleukin-2 transcription. Okay, so we're kind of blocking this pathway upstream here. And so for that reason, we have less interleukin-2 released. Now, when would you use this? Well, if you wanted to do some kind of immunosuppression, right? So immunosuppression being transplant rejection prophylaxis, preventing transplant rejection. You can also see it used in psoriasis. These are the big two. Now, I want to say that, this is not an exhaustive list of immunosuppressants, and it's not an exhaustive list of indications or adverse effects. It's really just the high yield stuff, right? This is the big stuff that you want to know. The really important thing about calcineurin inhibitors, where this kind of gets paradoxical, is that they can cause nephrotoxicity and neurotoxicity, right? They can damage the kidney, they can damage the nerves. Now, the biggest thing is the nephrotoxicity, and the reason for that is because the mTOR inhibitors, which I'll talk about in a second, there is no nephrotoxicity with those. Okay, so this is where you have to distinguish these. What's really interesting is that a lot of times, when we're using these for transplant rejection prophylaxis, the calcineurin inhibitors actually are used for transplant rejection prophylaxis for patients that are getting renal transplants, right? When they're getting kidney transplants. You'll see these patients after they've gotten their kidney transplant, they're on cyclosporine, they're on tacro, and the thing is that they can actually cause nephrotoxicity because the cyclosporine inhibitors, or I should say the calcineurin inhibitors, can cause decreases in renal blood flow, leading to decreased perfusion of the kidney, right? That transplanted kidney, and that can cause direct endothelial damage to the kidney, right? AKI, CKD, etc. So there is a component of nephrotoxicity, and that's the particularly high yield side effect. Now, the way that you distinguish, you might be saying, okay, well, these two sound exactly the same. Am I going to have to distinguish the two? Well, if you did have to distinguish the two, it's important to know that only cyclosporine can cause the gingival hyperplasia and hirsutism, right? So cyclosporine in general, if you're in a board question and you're trying to distinguish cyclosporine from tacro, that's what you're looking for. When I see gingival hyperplasia, by the way, in a board question, I'm usually thinking about phenytoin, okay? So there's certain, unique side effects in board questions that you'll see from medications that really make you just kind of jump to something. So when I see gingival hyperplasia, I jump to phenytoin. If phenytoin is not related to the question, the next thing I'm thinking about is distinguishing cyclosporine from tacro. Okay, so that's what I would remember there, because again, they both have similar effects overall. Now, the way a board question can do that is they can give you a patient that has gingival hyperplasia and then ask you, what is this? Because again, not a lot of this is on management. It's more about mechanisms for step one. So they can say, yeah, this patient's got gingival hyperplasia, right? They're post-renal transplant. Maybe they have a little bump in their creatinine. And they say, well, what medication or what's the mechanism of action of the immunosuppressive medication this patient's on? And one option might be binding to cyclophilin. Another option might be binding to FK506, right? And so that's where you have to distinguish that. If they have gingival hyperplasia, it's binding cyclophilin, right? So all right, so that's calcineurin inhibitors. All right, we're going to jump kind of to the mTOR pathway. So we talked about calcineurin. Now let's talk about this mTOR. Again, after this interleukin-2 receptor is activated, right, there's going to be this mediator mTOR that's going to kind of assist with the growth. It's like the last step that we're going to focus on in this pathway. Now, the mTOR in general can be inhibited by sirolimus. Now, the difference with sirolimus, as you can imagine, because this is more downstream, right? This mTOR is more downstream. It shouldn't necessarily have the same effects on interleukin-2 that we talked about with the calcineurin inhibitors, right? Because it's downstream. We should still be able to make interleukin-2. It's just that the interleukin-2 receptor, after it gets activated, it's not really going to do too much, right? Because we're blocking downstream from that. Sirolimus can also bind to some of these FK binding proteins, similar to tacrolimus. So that's why you have some similarity in the name, but again, it's primarily going to be inhibiting mTOR. And again, classically used for renal transplant prophylaxis, and the high yield adverse effect here is pancytopenia. The important thing, the really important thing, is that there's no nephrotoxicity, right? So when we're using sirolimus, we're not usually talking about direct damage to the kidney, right? So that's going to be very different from the calcineurin inhibitor. So that's particularly high yield. One big thing to distinguish these two that you want to remember. Now, when we're talking about these last two drugs on here, we have one that's targeting the interleukin-2 receptor. So you can imagine, we just talked about blocking mTOR downstream. If you block the interleukin-2 receptor, right, you're essentially accomplishing the same task. You shouldn't really have any effects on interleukin-2, right, because this is all kind of before this step in the pathway. The problem is now interleukin-2 won't be able to bind the receptor because I stick this antibody on the receptor. And we've actually seen this before. If you remember in type 2 hypersensitivity reactions, we have cytotoxicity when we bind antibodies, right? When we talk about diseases like autoimmune hemolytic anemia, for example. But when you think about diseases like myasthenia gravis, right, where you have antibodies, anti-acetylcholine antibodies, for example, that bind to the acetylcholine receptor and essentially block it. Right? That's a receptor binding, type 2 hypersensitivity. That's what this antibody is doing, right? This basiliximab is binding essentially to the interleukin-2 receptor, and it's blocking interleukin-2 from binding to it. Okay, and so this is the chimeric version. The daclizumab is essentially the humanized version of it, but in both situations, they're blocking the interleukin-2 receptor. If I block this receptor, I don't actually get the effects of interleukin-2 in these T cells, right? I might be releasing some interleukin-2, but I'm not actually going to be able to stimulate the interleukin-2 receptor with interleukin-2 because I block it. Okay, so again, also transplant rejection prophylaxis. You can see hypertension and edema, kind of more nonspecific. The important thing here, remembering that this is a type 2 hypersensitivity reaction because we're blocking the receptor. Okay, the last one on here is recombinant interleukin-2. And I don't want to confuse you. Recombinant interleukin-2 is actually not an immunosuppressant. Okay, so it's not an immunosuppressant. So you might be saying, well, Dr. R, why would you include it on this slide if it's not an immunosuppressant? The reason I include it here is because it's just a really good place to see this whole mechanism and see where this drug acts. What does this drug do? So essentially, recombinant interleukin-2, it's interleukin-2, right? I'm giving this patient interleukin-2. So let's just say that I give this patient interleukin-2. Okay, so I give them interleukin-2, which is this drug L-dysleukin. And so what's interleukin-2 going to do? Well, we already know interleukin-2 is essentially going to bind to the interleukin-2 receptor, and it's going to activate it, and it's going to cause these T cells to grow. It's going to cause natural killer cells to grow. It's going to cause B cells to grow, right? We're going to activate lymphoid cells. And so that's what recombinant interleukin-2 is doing. So you can imagine, this is the opposite of immunosuppressant. This is going to increase my immune response. Why would I want to give it? Well, again, if I have a patient that has malignancy, right? And we talked about this a little bit with graft versus tumor effect. We can have our lymphoid cells target those malignant cells by recognizing those cells on MHC1, right? We can recognize cells on MHC1 that have improper antigens or no antigens at all potentially and mark those cells for destruction. So if I have a more robust immune response, I'm better able to do that. This is particularly useful in renal cell carcinoma and metastatic melanoma. Distinguish this in the sense that this is not an immunosuppressant, but it does come up in these conversations where you have to kind of go through this mechanism because it's right in the middle of this mechanism that we're talking about. Now, the second kind of category of immunosuppressants are going to be the glucocorticoids and the purine inhibitors. Again, this is in my mind how I'm organizing these pathways. Let's start with glucocorticoids because I think we've talked about this quite a bit already. So glucocorticoids, we've already went through the NF-κB pathway. And again, the NF-κB pathway is really essential for kind of kicking off the inflammatory response. We're trying to get an inflammatory response that essentially generates, acute inflammatory reactants, things like interleukin-1, interleukin-6, and TNF, right? That's what we're trying to do with NF-κB. As it enters the nucleus here, impacts transcription potentially and causes an increase in transcription of interleukin-1, 6, and TNF. So that's what NF-κB is essentially doing. Now, glucocorticoids are trying to basically eliminate that process from happening. So they're going to inhibit NF-κB and the inflammatory cytokine gene. So a glucocorticoid, remember, we're talking about a steroid, so it can usually freely diffuse through the membrane here. It'll bind to a glucocorticoid receptor in the cytosol, essentially block off this NF-κB, essentially inhibit it. Okay, and so that's what you see here. The glucocorticoid bound to the glucocorticoid receptor, inhibiting NF-κB and the inflammatory cytokine genes. That's really the extent of what you have to know here, right? You just have to remember that's the primary mediator that we're inhibiting. And again, these can be used for a lot of different things. Adrenal insufficiency, we'll talk about this in the endocrinology section. Asthma, especially acute exacerbations, or even chronic maintenance therapy with inhalers, acute inflammatory states. The big thing you'll see glucocorticoids used when we're talking about transplant rejection is, like I said, when you have an acute rejection, okay, you can usually do high-dose glucocorticoids to try to eliminate that acute rejection from happening or at least damaging the graft any further. But glucocorticoids in general, you'll see in all different types of board questions. In terms of the adverse effects, we can make a really, really long list here, okay? So osteoporosis, Cushing syndrome, hyperglycemia, amenorrhea, avascular necrosis of the femoral head, also very classic. And we'll go through this all in a lot greater detail in its respective video. I'm just including it here so that we can see this in completeness sake. Now, the two big things to remember, though, is when you give a patient glucocorticoids, you're going to essentially lead to a lot of those white blood cells, like we talked about with trolley, getting released into the bloodstream. Okay, so you're going to immediately see, some people call this an artificial leukocytosis. It's basically showing that a lot of those white blood cells that were sequestered in the pulmonary vasculature are going to get released systemically. Okay, so you're going to have an elevation in the white count. You know, especially when you go on the wards and that kind of thing, you see a patient, you see a big jump in their white count, or they have an elevated white count. The first question always should be, are they on steroids, right? The other thing is, if a patient's on glucocorticoids for a long time and you just suddenly take them off, well, you've been suppressing their ability to produce glucocorticoids for so long because you're giving them glucocorticoids, right? Everything wants to stay in some level of homeostasis. And when you have really high dose glucocorticoids being given over a long period of time and you suddenly take them away, now the patient is going from having potentially more glucocorticoids than they would normally have, right, based on homeostasis, right? But now you take that away, and now they're having way too little glucocorticoids, and you can send those patients into adrenal insufficiency, which is actually one of the most common causes of adrenal insufficiency. Again, we won't have to go through all the details on that. Big ones, though: prednisone, dexamethasone, methylprednisolone, right? We can make a long list here, but that's the concept for glucocorticoids. Again, we're just going high level here. Now, when we're talking about purine inhibitors, okay, so purine inhibitors, we're talking primarily about things like azathioprine and 6-mercaptopurine. So azathioprine and then 6-mercaptopurine are the big ones that I want you to remember. So essentially what's happening here is azathioprine goes on to form 6-mercaptopurine. 6-mercaptopurine actually can compete with some of the other purine derivatives like hypoxanthine, guanine, and by doing that, by competing with them, it'll actually inhibit some of your de novo purine synthesis, okay? And we'll go into this in more detail in the biochemistry. But the enzyme here is PRPP aminotransferase, right? This is the rate-limiting step in de novo purine synthesis. Again, when I'm saying purine synthesis, I'm talking about the synthesis of the building blocks of DNA. That's what we're talking about. Now, if I inhibit that step right early on, I'm going to have a decrease in the number of purines being produced, right? If I'm using something that kind of looks like a reactant here essentially, but isn't quite doing what it's supposed to do, right? It's not actually going to be a building block of DNA. That's going to kind of tie up this enzyme, right? And inhibit this process. And so I'm going to get less formation of IMP, which would be the downstream step, less guanine, less adenine essentially being formed, less nucleotides, less DNA production. Therefore, the cells that rely on high levels of nucleotides for very frequent replication, right, responding to pathogens, foreign invaders, generating a robust lymphocytic response, those cells, the lymphocytes, are going to be in a lot of trouble, right? When I give drugs like this and I block the formation of new purines, right, the synthesis of new purines and the formation of DNA, that's going to be a big problem, but it's going to be a big problem for the cells that have to replicate the most, right? If a person is fighting off an infection, these cells are going to be replicating. They're going to be going through, maturation affinity with the B cells. The B and T cells will need to generate a memory response. You're talking about things like affinity maturation with B cells. It's a lot of replication going on and a lot of transcription also going on. So when you start to take out any building block of DNA, you're going to feel the effects of it, particularly in the lymphocytes. And that's essentially what's happening here. Now, mycophenolate and then ribavirin, which I won't talk about too much here, these are both going to have a similar effect, but we're mostly going to be inhibiting the enzyme inositol monophosphate dehydrogenase, IMPDH here. And again, we'll go through this the whole pathway when we talk about biochemistry. I don't want to get too off track, but essentially mycophenolate is going to act here. So it's primarily going to inhibit the formation of guanine, whereas the 6-mercaptopurine should be more of a global effect between the purines. And I want to say too, for both of these, you do see mycophenolate, in patients that have had renal transplants. But in general, I would say, especially azathioprine, 6-mercaptopurine, mycophenolate, you see these more with patients that have like autoimmune conditions like rheumatoid arthritis. And step one isn't really big on, management per se. But I would say overall, they're more classic for things like inflammatory disorder, more so than a transplant prophylaxis. Mycophenolate is probably the one that you do see sometimes with transplant prophylaxis, but just kind of keep that in mind. The other thing on here that I didn't really show in this pathway is methotrexate. So just remember methotrexate, and we'll go through this, like I said, in the biochemistry section. But methotrexate, that's represented here as MTX. So methotrexate is going to inhibit dihydrofolate reductase, okay? Kind of like trimethoprim, but it's going to do that in humans, right? So it's actually going to be used more as an immune suppressant agent because, again, if I'm inhibiting the building blocks of my DNA, right, that being the nucleotides in some way, there's going to be a global impact, particularly on the lymphocytes, which rely very heavily on DNA synthesis, right? And we can see that down here, inhibits dihydrofolate reductase. Again, if I'm inhibiting dihydrofolate reductase and I'm interrupting purine and pyrimidine synthesis in doing this, potentially, that's going to have an effect on ability to undergo DNA synthesis. Okay, so that's what methotrexate does. Now, remember, trimethoprim is essentially doing this in bacteria. Okay, so when we talk about like trimethoprim sulfamethoxazole, the trimethoprim component is inhibiting the same enzyme, but just in bacteria. So it's preventing bacterial DNA synthesis, right? So that's why it's an antibiotic. Methotrexate is doing this in humans. So that's curbing the immune response in humans, right, by inhibiting this enzyme, because now the person that's being treated with methotrexate, right, they can't mount a very robust immune response because they don't have the building blocks to do so. Like I said, we'll go through all the details of the pathway on this in the biochemistry section. All right, and again, high yield adverse effects. Pancytopenia is a big one. Again, this all has to do with the fact that we're in some ways inhibiting the production of the building blocks of DNA synthesis, of which these cells very heavily rely on. Now, one last thing on here, or two last things I want to talk about. The first one is when you give a patient allopurinol. So kind of remember what allopurinol does here. So allopurinol, remember, there's a purine salvage pathway, and we can also break down these purines, right? So guanine can get broken down by xanthine oxidase, okay, by xanthine oxidase to form xanthine. This xanthine can then get broken down again by the same enzyme to form uric acid, and then we can excrete this in the urine. Now, this can also happen with hypoxanthine, and again, I don't want to go into all the details per se in this video because the video will be quite long, but what we want to talk about here is, remember, this xanthine oxidase can get inhibited by allopurinol. Okay, and the concept here is I don't want a whole bunch of uric acid around if I have a patient that has gout. Okay, so allopurinol is frequently used as a maintenance therapy to kind of control the uric acid levels. What you have to understand here is that this 6-mercaptopurine can essentially end up forming hypoxanthine, right, as we start to break it down. The concept here is that this 6-mercaptopurine is kind of, in some ways, looks like an analog to things like guanine or hypoxanthine. And so the 6-mercaptopurine, right, I'm just going to put 6-MP here, this also gets broken down by xanthine oxidase. If I'm inhibiting my xanthine oxidase, what do you think is going to happen to this 6-mercaptopurine level? It's going to go up. 6-mercaptopurine levels will go up if I can't break it down. And you might be saying, well, will guanine levels and hypoxanthine levels go up? Potentially, but a lot of this will probably go through the purine salvage pathway, okay? So they'll probably go through the purine salvage pathway and form IMP, okay? And again, we'll go through all of that in the biochem section. The point here is that you get this buildup of 6-mercaptopurine, which is not going to necessarily go to form IMP. Instead, it's going to build up to potentially toxic levels, right? And inhibit too much of your PRPP aminotransferase. So just remember, if you have a patient in a board question on allopurinol and they're getting 6-mercaptopurine, there can be some serious side effects to that. And there's a lot of different ways they can word that, but you just have to remember that these two are associated in that way, in the sense that 6-mercaptopurine is broken down by xanthine oxidase, much like hypoxanthine and guanine. Finally, the last thing on here, just remember mycophenolate being associated with invasive CMV infections. So this is, again, an opportunistic infection that would, kind of push you in the direction of mycophenolate. So just kind of keep that in mind. All right, so we made it to the biologic immunotherapy. This slide has a little bit more memorization than any of the other slides. Now, one thing I might recommend doing, making sure you go through a lot of the immunobites and a lot of the flashcards to really make sure that you understand what each of these monoclonal antibodies are doing. Because more and more as time goes on, these monoclonals are getting asked about more and more frequently. Now, again, you don't necessarily have to know about management, okay, but there are certain targets you really want to be familiar with and certain adverse effects in some situations you want to be familiar with. So the biggest thing here for step 1 purposes is going to be knowing the names and their targets. If you can add on another layer to that, knowing the adverse effects. The last thing I would know, unless I highlighted in red here, is going to be the indication. Okay, so we'll go through this in just a second. I just want to make sure we talk about these TNF inhibitors, which also have some monoclonal antibodies, and then we'll jump into the immunologics here. Now remember, TNF, especially TNF alpha, right? We're thinking interleukin 1, interleukin 6, and TNF alpha, kind of as that initial acute inflammatory response, right? These are our acute inflammatory mediators that we talked about very early on in immunology section. So essentially what we're doing is we're inhibiting that TNF alpha response, right? Part of that acute inflammatory response. Okay, so the medications that can do this, there's a few different ones. Infliximab, okay, this is kind of like the classic one. Now this one is a chimeric anti-TNF antibody. It's not humanized. Okay, so it's been around for a while, which you can see here. And again, these, I would say in general, the adalimumab is probably the highest yield. But the point is you just have to remember these are humanized anti-TNF antibodies versus infliximab, which is chimeric. The one that gets confusing here is this etanercept, because unlike these other monoclonal antibodies, it's going to be a fusion protein that's kind of just floating around in the blood looking to bind up TNF, alpha or beta. Okay, so let's just talk about monoclonal antibodies really quickly here. So again, remember, monoclonal antibodies, we're talking about some antibody, again, that has a Fab portion and an FC portion. Okay, so you can imagine if I bind to a receptor, right, if I have some receptor, just like we saw with interleukin-2 and basiliximab, right, that antibody can bind to the receptor and essentially block it, just like we see with myasthenia gravis. And so that's basically what we're talking about with monoclonal antibodies. Notice how they all end in MOB, right? Monoclonal antibodies. But when you look at the name here of etanercept, you can see that it doesn't have that same suffix. Let's just say that we have some TNF alpha in the blood. If I block its receptor with an antibody, then the TNF can't bind to it. Now, the other thing I can do besides blocking the receptor is I can kind of create a receptor to just float around in the bloodstream, right? A soluble receptor that can basically cause the TNF alpha in the patient to bind to my receptor. Okay, so I can essentially eat up a lot of the TNF alpha, so I can decrease the level. So essentially, I'm going to say that I have this receptor with the TNF alpha bound to it. So now this TNF alpha can't go binding to the receptors in my host. Instead, it's bound to my drug. And that drug is etanercept. Oversimplification, but that's really all you have to know. Okay, the point is it's not a monoclonal antibody. It's essentially me putting a receptor in the patient that's just soluble, floating around, binding up the patient's TNF alpha or TNF beta. Now, the high yield side effects here to remember is going to be reactivation of tuberculosis. Now, remember that tuberculosis, right, you can have a latent stage of tuberculosis or you can have active tuberculosis. The difference here, right, if I had latent tuberculosis, you might do a study on me like a tuberculin skin test, and it's probably going to be positive. You can do also the interferon gamma release assay, which we'll talk about in the micro section. But in both of those situations, if I have latent tuberculosis, that means my body's fighting TB, it's just not active, right? I'm not symptomatic, I'm not contagious, but I have TB and I need to be treated for it. Okay, so we can screen patients for that and say, hey, this patient might not be contagious, they might not have an active infection, but the patient needs to be treated for tuberculosis before we start one of these medications. Well, why is that? Well, if I start one of these medications, right, and I start inhibiting, right, using the TNF alpha inhibitors, I start inhibiting the inflammatory response in this patient, and they're trying to fight off this TB infection, they have this latent TB infection, that TB infection could become active. And now I have a problem, right? So in the situations where you want to start a TNF alpha inhibitor, you should always be screening these patients for tuberculosis. Now remember what active tuberculosis is, right? If this infection is active, those patients will tend to be symptomatic, right? They'll be cough, they'll have potentially hemoptysis, chest x-ray findings will be positive, they'll be contagious, right? That's an active TB infection, okay, as opposed to a latent one where you don't really see the symptoms, but you still test positive. And the last thing I want to say about these, I didn't really include this here. This is more medium yield, but remember too, drug-induced lupus. So, I talked about this before in some of the previous sections, but again, the big three for drug-induced lupus, definitely going to be procainamide, okay, procainamide, hydralazine, and isoniazid, okay? So when you think about drug-induced lupus and you think about anti-histone antibodies, right? When you think about this, you need to associate this with these three drugs. Now, if you're going for bonus points, you say, okay, I got that all down, no problem. I have a little bit of extra room in my brain. Then you can add in this fourth one. And the fourth one is going to be TNF alpha inhibitors. These drugs that we're talking about here can also cause drug-induced lupus. Are they as classically asked about in this setting? Not really. But remember, they can cause these patients to have drug-induced lupus, and you'll pick that up with antihistone antibodies. It's going to be a lupus-like picture, usually on one of these medications. Okay, that just an added layer if you're feeling really comfortable with that. But again, it's not one of my big three. My big three for drug-induced lupus: procainamide, hydralazine, isoniazid. All right, we're going to clean this thing up and go through the biologics here. So, like I said, for each of these, I want you to make sure you know the target.
The target is the most important thing. So natalizumab, the target alpha-4 integrin. Okay, this is sometimes called Tysabri in real life, and the natalizumab is primarily going to be used for MS. And again, this is not an exhaustive list, right? A lot of these can be used 10 different diseases potentially. So, it's going to depend. But again, there are some high yield ones to know. So MS is very classic for this, usually a very severe MS. You don't go around giving natalizumab to everybody because the concern is it can cause reactivation of the JC virus. Okay, and this can lead to progressive multifocal leukoencephalopathy. And we talk about this a little bit in the neurology section. The reason for this is because you're inhibiting the immune response. In MS, you have autoimmune destruction of some of the oligodendrocytes. And so you're essentially trying to curb that response. And you do that by targeting alpha-4 integrin. Alpha-4 integrin is particularly important for white blood cell adhesion. Things like neutrophils have to get to the site of wherever this inflammation is happening so they can dump their granules and can cause pretty significant inflammation, right? And so the idea here is you don't want those white blood cells to bind to the integrins, to have rolling adhesion, all the things that we talked about in this unit. You don't want that to happen. And so you give a drug like natalizumab to prevent the white blood cells from getting to that location. All right, rituximab CD20. What's CD20? What do you think about when you see CD20? You think about B cells, right? That was a classic B cell marker. You don't really have to know a lot of the indications for rituximab because, like I said, this is another one where there's so many diseases that can be used for. But the big thing I want you to remember is reactivation of JC virus again with rituximab. What is the patient going to present with if they have reactivation of JC virus? Well, there's some classic findings that we talked about in the neurology section on CT scans, but just in general, I mean, you're looking for things like new focal neurologic deficits, new weakness, seizures, right? Headaches, vision deficits. They might be mistaken for having a stroke potentially, right? These are all things you might be looking for. All right, palivizumab is going to be very classic for the target of the RSV-F protein. And so we're going to see this a lot given in infants particularly as RSV prophylaxis. We're using it to prevent RSV. You might be saying, well, how is that? Think of this as a passive antibody. When we talked about things like tetanus immunoglobulin, right? Why do you give somebody that? Well, you're giving them passive immunity. You're giving them the antibody. You're not causing a response to happen. You're literally just giving somebody the antibody. Or the same thing with mom and the infant. Mom gives antibodies to the infant for that first 6 months. So we're essentially giving the antibody to RSV. The concern is that certain patients are at really high risk for getting RSV. Premature infants is probably at the top of your list, right? Also infants with congenital heart disease, right, would also be very classic. These infants are at a lot higher risk of getting RSV and having a really hard time fighting the infection off. And so usually we'll give them antibodies, right, passively against RSV, the RSV-F protein specifically, for an extended period of time. Omalizumab, we're talking about soluble IgE as the target. Okay, so soluble IgE, the idea here is this is IgE that's just floating around in the blood. Remember, we talked about mast cells, right, on the surface of mast cells in patients that have allergic reactions. This can also be a basophil, by the way. On the surface, we have this Fc epsilon receptor, right? So we have this receptor on the surface of mast cells that can essentially bind the Fc portion of IgE, right? So this patient might have some IgE that's binding using its Fc portion to the Fc epsilon receptor, right? Here's the Fab portion. And then when an antigen comes into the blood, right, that we've been exposed to before and binds to this IgE, we get cross-linking, right? And then we get degranulation of the mast cell. The idea here is with omalizumab is you're binding up. So if there's IgE in the bloodstream, eventually it might end up on one of these Fc epsilon receptors. And so the idea here is with this antibody, you essentially want to bind up all of the IgE using the omalizumab, binding to its Fc portion to prevent it from binding to mast cells. That's the concept. And when would this be used? Well, patients that have pretty severe allergic reactions. Okay, severe allergic reactions, particularly in the setting of asthma. Trastuzumab is going to bind to the HER2 new receptor. We'll talk about this more in the onc section. And again, we talked about in the cardiology section a little bit different types of cardiomyopathy. The trastuzumab is very classically associated with the dilated cardiomyopathy that's reversible when you discontinue the drug. And it can even be a low dose of this, right? You can use a really low dose can still cause this cardiomyopathy and you have to discontinue it to stop it. This is kind of juxtaposed to anthracyclines, which are cumulative dose dependent for cardiomyopathy, right? So again, talked about this in the cardiomyopathy video. Eculizumab is targeting C5. This is one that you really want to remember the indication, right? Paroxysmal nocturnal hemoglobinuria. We talked about this a little bit already in this section. I won't go into too much detail, but remember, there are certain inhibitors, CD55, which is going to be DAF, right?
and then also CD59, which is the membrane inhibitor of reactive lysis. And these are going to be on the surface of our red blood cells, and they're going to prevent our own complement from destroying our red blood cells. When we lose these markers, right, we're losing these complement factor inhibitors. Now our cells are up for grabs, right? Complement can bind there and destroy our own cells. And so we can give C5 inhibitors to essentially inhibit complement from destroying our own cells. But the problem is now you end up with encapsulated bacterial infections because you can't use complement, right? So that's commonly used to destroy a lot of these encapsulated bugs. And so you have to make sure these patients are up to date on their vaccinations. So bevacizumab is going to be a VEGF inhibitor, right? It's going to target the vascular endothelial growth factor. This is classically going to be used for colorectal cancers, not particularly high yield for step 1. And this can cause GI bleeding. Again, not particularly high yield. These two here are going to be EGFR inhibitors. Again, not particularly high yield. Just know the associated target. That's the big thing that you have to remember. Denosumab is going to be a rank L inhibitor. This is essentially going to be used to prevent the osteoclastic breakdown of bone, and that's going to be important for patients that have osteoporosis, right? You don't want them breaking down more bone. The idea is you're inhibiting that process to some degree so that these patients can have stronger bones, right? So less osteoclastic breakdown, but because of that, there's going to be less calcium going in the blood. So hypocalcemia is a major side effect. Interestingly, there's a lot of studies on this. Patients that are on these for a long time can actually be more prone to things like femur fractures. So you have to kind of cycle these patients off. So definitely certain bone fractures is actually one of the major adverse effects, although that might be a little bit beyond the scope of step 1. Pembrolizumab is a big one when you're talking about PD-1 inhibitors, which we'll talk about in a lot more detail in step 2 in particular, but again, associated with many cancers, just know the target. Abciximab is going to be your GP2B3A receptor. We'll talk about this again in the hemonc section. Very much used by a lot of the cardiologists prior to PCI, usually 24 hours before PCI. Remember, these GP2B3A receptors are essentially going to be on the surface of platelets that fibrinogen can bind to. When you inhibit that, you're going to eliminate essentially fibrinogen binding and essentially inhibit platelet aggregation. So the risk here is going to be bleeding. And again, like I said, we'll talk about this in the hemonc section. The last few on here, again, just knowing the markers is going to be important. I'll let you kind of look through that. This one in particular is very classic for psoriasis. So I would also remember, I'd put this in kind of like your high yield bucket. Ustekinumab, very classic for psoriasis and inhibition of interleukin 12 and interleukin 23. But that's going to do it for the immunology section. I hope y'all enjoyed this series. A lot of information here. Hopefully it's a little bit more digestible now.
Take 15 seconds to pause the video, read the question, and then we will go through the answer. Pretty challenging question here overall, just because, in some situations you're going to get questions like this where there's a lot of information and you have to efficiently get to the right answer. Questions like this are typically equally weighted to questions that are a little bit more straightforward. So it would be a bad idea to mark questions like this on the real thing. But anyway, let's get into this a little bit. So we have a 57-year-old male with past medical history of acute lymphoblastic leukemia. Previously treated with chemotherapy, presents to the emergency department with abdominal pain and diarrhea. He reports developing acute onset stabbing abdominal pain and chills a few hours prior to admission. This is pretty interesting. So he has chills, stabbing abdominal pain, but this all started, I think this is the key point actually here, a few hours prior to admission. So we're just going to note that. Interesting past medical history here. He also endorses 2 episodes of non-bloody emesis en route to the hospital. He's been hospitalized 4 times over the past 2 months due to numerous infections requiring antibiotics and antifungal medications after receiving a bone marrow allograft from a family donor. Okay, so this is a situation, again, when you're reading through these stems, what is something that jumps out at you, right? When you're reading through these stems, there's a lot of information. You're looking for that one thing that kind of calls your attention to something, right? Now, remember what we talked about in this unit. When you see bone marrow transplants or you see hematopoietic stem cell transplants, when you see that, okay, especially, right, these are the allogeneic, right, so this is getting transferred, again, from a family donor that probably has similar HLA compatibility. It doesn't mean that there's not going to be HLA incompatibility, but the key thing though, right, if we're just talking about organ transplants versus bone marrow transplants, when I see bone marrow transplant, when I see hematopoietic stem cell transplants, right, when I see this, I'm going to start to think about a graft versus host disease right off the bat, right? Because usually in a board question, when they test you on graft versus host disease, they're usually going to do it with hematopoietic stem cell transplants, bone marrow allografts. Very, very classic for this type of presentation. Now, they can also do this with a liver transplant, which we kind of talked about can present slightly differently in terms of like the liver enzymes and that sort of thing, which I'll get to in a second. But the point is, when you see this, that should zone you in. It doesn't mean that it's going to ask about graft versus host disease, but immediately my radar is now up. Graft versus host disease. This patient's on medications that consist of mycophenolate, immunosuppressant, prednisone, right, can suppress the immune system, cyclosporine, immunosuppressant, right? So this patient has all these infections, right, probably related to the fact that they're on immunosuppression because they had a bone marrow transplant. Oh, and by the way, they also had chemotherapy recently for this history of acute lymphoblastic leukemia, okay? So far, I feel like I'm in a good place reading the stem. The patient denies any history of alcohol, tobacco use, or recent travel. Okay, all right, so let's keep going here. So the patient's tachycardic with a heart rate of 108, vitals are otherwise stable. This is an important line, right? If you're thinking about, what's causing this patient's problems. Well, he's got all these infections from before. Is this another infection? Usually in a board question, if it's an infection, they're usually going to say, hey, the patient's febrile, or they might give them a white count, which I'm just kind of jumping ahead of here. If there's a leukopenia, it could mean infection too. But, usually they'll tell you something about the patient has a fever, and you might be saying, well, why is the patient tachycardic? I mean, it could be the patient's just in pain, right? The patient developed acute onset stabbing abdominal pain a few hours earlier. Tachycardia, in my opinion, especially from a clinical perspective, is probably related to that, but we're going to get into a little bit more detail here. So physical exam reveals jaundice, maculopapular rash over the dorsum of the hands bilaterally. Let's stop right there. That's particularly high yield. Again, what are the key things I'm looking for? I already have graft versus host disease on my radar just from reading that the patient had a bone marrow allograft from a family donor. Now you're telling me there's a maculopapular rash that the patient has. Remember, maculopapular rash is a classic descriptor of something we would see in a graft versus host disease patient. Why do we see that? Well, it's because the graft or the donor T cells, right, which you can see the right answer here, the donor T cells are attacking different organs in our host. One of those organs is the skin, right? The skin's getting attacked. The liver classically gets attacked. So remember, in graft versus host disease, the three things I want you to think about that are going to get attacked: the skin, which is where we get this maculopapular rash, right? The other organ here we said is the liver. And the other organ here sometimes will be the intestines. Okay, so the skin, the liver, intestines. Now, if the graft is the liver, though, remember, then it could present a little bit differently. But in general, if it's a bone marrow transplant, skin, liver, intestines is what I'm looking for. So how does the skin present? Maculopapular rash. So this patient also has tenderness to palpation. Well, that could be because there might be inflammation in the intestines, right? I'd be looking for potentially like hepatomegaly would also be very classic. This tenderness to palpation is in the left and right upper quadrants. You can also affect the spleen, right? Lymphadenopathy is absent. Now, this is an interesting point, and I don't think we're getting tested on this directly, but not to get too off track, why is lymphadenopathy mentioned, right? Really quickly here. So this patient had acute lymphoblastic leukemia. Okay, then the patient went through chemotherapy, right? So they went through chemotherapy, and now the patient had for more definitive management, right? They had a hematopoietic stem cell transplant or bone marrow allograft from a family donor. Okay, now the fact that they have this, though, they have to be probably placed on some immunosuppressive therapy, right? They're going to be on some immunosuppressive therapy so we don't get rejection. Okay, so the thing that happens here because of this that you have to kind of understand is the complications, right? So it could be that this patient potentially develops an infection, right? Maybe an opportunistic infection, maybe a CMV or HIV, right? They can get some form of infection. Now, one of ththese infections could be a Kaposi sarcoma, right? So HHV8 is classic, Epstein-Barr virus is classic, right? HIV, CMV. All of these can sometimes get asked about in a patient on immunosuppressive therapy after transplant. Remember, though, that these infections, a lot of them, like a Kaposi sarcoma, can go on to then lead to cancer, right, or malignancy, right? So a Kaposi sarcoma, which is herpes virus 8, human herpes virus 8, HHV8, this Kaposi sarcoma, I'll just put KS for Kaposi sarcoma, can then go on to have some oncogenic potential. Now, the same is true for Epstein-Barr virus, EBV. This can go on, and the classic one that sometimes gets asked about with this is going to be like a Burkitt lymphoma. Or in general, we can just put a non-Hodgkin's lymphoma, which we're going to talk about all of this in the hemonc section. I don't want to get too off track, but the point that I'm trying to make here is that these patients can get infections with some of these more opportunistic organisms. Patients that are on immunosuppressive therapy are at higher risk for this. This is why, most likely, they're mentioning lymphadenopathy here, because if the patient had lymphadenopathy, I'm going to want to biopsy that thing. I'm going to be thinking, now I'm a little bit more worried about some kind of malignancy, potentially a lymphoma, now from this immunosuppressive therapy that led to an infection with higher oncogenic potential. All right, we're off the detour, back on the main road here. So serum laboratory studies are shown below. We'll go through these in a second. Let's just keep reading. So okay, CT scan of the abdomen and pelvis reveals thickening of the ascending colon. I would contribute this mostly to the intestinal inflammation from the graft-versus-host disease, but it could be more of an infectious colitis versus an inflammatory one from the graft-versus-host disease. A liver biopsy is subsequently performed. Remember what I told you, if you've been watching this series, whenever you see biopsy in any question, that usually is one of the most important lines in the vignette because it's going to tell you something definitive. Now, you might not always know what the biopsy means, but it's usually going to give you some key information. Now, in our situation here, the biopsy is telling us that this is of the liver, okay? And it's revealing a moderate lymphocytic infiltration surrounding vacuolar steatosis and perisinusoidal fibrosis. So sometimes when you read stuff like this, it's a little intimidating, right? Like, what are they talking about? So when you see stuff like this and you're trying to figure this out, the key takeaway here is that there's lymphocytic infiltration. So we know that there's an inflammatory infiltrate here that's largely lymphocytic, right? These other things, the fibrosis to me kind of reminds me almost more of like a chronic process, even though this patient just started to have this pain. And then I also see this, there's no neoplastic cells are observed on biopsy. It doesn't seem like the question writers are really pushing us at all in the way of any kind of malignancy. All right, which of the following best explains the mechanism for this patient's pathology? Okay, let's just go through the labs really quick, and then we'll kind of talk about these options. So the leukocyte count is actually a little bit low here, which is actually not uncommon in graft-versus-host disease. In fact, you can have a pancytopenia in graft-versus-host disease. You could say, okay, well, the leukocyte count's a little low. Am I thinking more about an infection? Really, there's not any real indication in this question that there's an infection, particularly if we're thinking about these classic kind of viruses that are asked about. If you look at the HIV load, it's undetectable. CMV load's undetectable. Viral hep serologies, sometimes they'll give you like specific serologies. In this case, there's a lot of stuff being mentioned, and I think they just went with, hey, all of these are negative. Herpes serologies are also negative. If we look at the liver enzymes, the ALT is 477, AST 387, so these are definitely going to be elevated. They're not in like the shock liver range or the acute hepatitis range, right? If you're thinking like viral hepatitis, or you're thinking like a shock liver, which we'll talk about more in the GI and infectious disease sections, but in those situations, these labs will tend to be over 1,000. So there's some inflammation going on here in the liver, most likely, though, that's causing this transaminitis, especially based on this infiltration that we see. Total bilirubin's also quite elevated, might explain some of the jaundice. The amylase and lipase are normal, right? So we're not thinking as much of a pancreatic process, potentially. Thyroid stimulating hormone in the reference range. Blood cultures, no growth for bacteria or fungi. Okay, so that's kind of another key point. So, they're really not pushing us in any way towards a infectious cause. And interestingly, they also have an anti-double-stranded DNA antibody here, which is negative. Again, there are some key things, especially the things in red here, that I'm really looking at. And, when I'm reading a question on the real thing and I only have one color highlighter to use, I'll probably just use the yellow on the things that really count, right? The bone marrow allograft, the lymphocytic infiltrate, the maculopapular rash, right? Those are the big things that stood out to me. Let's just go through some of the options here. Now, so if you're kind of stuck between these, remember, the key thing you have to understand about graft-versus-host disease, and we go through this all in the dedicated video on this, when you're talking about graft-versus-host disease, so we have the donor graft, right? So the donor is going to give this graft, I'll just put G for graft, to the host. So the donor is going to give that graft to the host. Now that graft, remember, contains lymphocytes. And so what's happening is when I give this to the host, remember in this case it was a bone marrow transplant, so this graft went to the host. We'll just draw a little bone in here with the graft. Okay, so here's my graft with all the lymphocytes on it. And those lymphocytes, right, these T cells, largely T cells, are going to get out into the systemic circulation and eventually, at some point, can cause pathology. And we already said, where are they going to target? They're going to target the skin, liver, intestines. They could really target any organ, but these are the three that are classically asked about. And so if they go to the skin, right, what do we get? We can get a maculopapular rash, right? If they go to the liver, we can get an inflammatory reaction from the liver, right? So we can get a transaminitis potentially. We can have right upper quadrant pain or tenderness or hepatomegaly, right? These would all be kind of classic presenting symptoms. They can go to the intestines too. And we also saw some of that. We saw that there was some thickening of the ascending colon that's probably related to this, right? So these T cells are kind of branching out from the donor and they're attacking the host tissue. For that reason, this is a donor T cell mediated cytotoxicity. It's the donor cells that are causing the problem in this patient with graft-versus-host disease. Now you might be saying, well, how do I know that it's not the host T cells. How do I know the answer is not E? The host T cell mediated cytotoxicity would be more classic, right? If I had some organ, right? So again, here's my donor, okay? And in this case, we're going to give some graft over to the host. And let's just say that this is in the liver, for example. Okay, so here's my host. And let's just say that I give this graft over to this patient's liver, right? So here's my graft. And in the example of E, what we're talking about is the host's lymphocytes attacking the graft. Okay, so that's what E is talking about. Now remember, this is going to be more classic for an acute rejection, as we would call it, or acute transplant rejection. And we said this can happen a few different ways, right? The donor MHC1 antigens can get basically attacked by the CD8 positive T cells of the host, or the donor antigens that are MHC class 2 can get recognized by CD4 positive T cells, turn into T helper 1 cells, activate interferon gamma. Macrophages are brought to the site of the graft to destroy it. So we went through all of this in the videos already, but this would be an example of more of a host T cell mediated cytotoxicity because it's the host's lymphocytes that are doing the damage here. And again, in this situation, we have a bone marrow transplant, which again automatically calls my attention to graft-versus-host disease. And then the fact that we have all the classic presenting signs would make this a better explanation in terms of a donor T cell mediated cytotoxicity versus the standard kind of transplant rejection we would see with the host T cell mediated cytotoxicity. C, antibody mediated graft ischemia. So what's this referring to? So this would be very classic for a patient that has a hyperacute rejection. It's usually in the first 48 hours, could be in minutes as soon as they put the graft in. But essentially, it's because the host has pre-made antibodies that as soon as you put that donor graft in, those preformed antibodies are already targeting that graft for destruction. Usually, if this is asked about in a question, it has a lot to do with ABO incompatibility, and you get like immediate thrombosis of the vessels of that graft, or at least pretty quickly you get thrombosis of the vessels, and then you'll see graft ischemia. And so that's very classic as a type 2 hypersensitivity reaction, right? Because the antibodies are preformed, they're mediating the destruction via complement of the graft. Whereas if we're talking about like a graft-versus-host disease, right? So graft-versus-host disease, this would be more of a type 4 hypersensitivity because it's a cell-mediated cytotoxicity. The same thing for an acute rejection, right? In an acute rejection, again, type 4 hypersensitivity, right? Because in acute rejection, it's host T cells that are mediating the cytotoxicity. Option B here, host RNA polymerase transcription of viral proteins. If we're talking about something like CMV, HIV, right? These viral pathogens can essentially hijack our cells and cause our RNA polymerase to then transcribe viral proteins for them, right? So if this patient had a detectable viral load, for example, we might be suspecting this a little bit more, but I don't think there's really enough information to potentially make this the best answer because all of these viral loads are negative, okay? So certainly that could be something you see in this patient. These patients are at higher risk for that because they're on immunosuppressive therapy, but doesn't seem very classic, especially based on all of the more classic findings we see with graft-versus-host disease. Latency-associated nuclear antigen binding of P53. A lot of times in board questions, there'll be an answer on there that's completely something you probably have never seen before. Latency-associated nuclear antigen is something that we see classically with HHV8, human herpes virus 8, which is, remember, when we're talking about Kaposi sarcoma. Okay, so Kaposi sarcoma. Now, the thing that we have to remember about Kaposi sarcoma is that you can actually still have skin lesions there, but it's usually not this maculopapular rash. It's usually more of like a purple, pink plaque that you're going to get, and it could bleed and it can ulcerate. And again, patients that have Kaposi sarcoma are these patients that are on immunosuppressive therapy. They get, an infection or reactivation of HHV8, and this Kaposi sarcoma can lead to oncogenic potential, right? And so that's what you're primarily concerned about. And there's really no clear features of Kaposi sarcoma that I would wager to say that we would expect to see here. Kaposi sarcoma, you can sometimes have neoplastic cells, you can have lymphadenopathy, right? These patients are at higher risk for lymphomas, like a big one would be a diffuse B cell lymphoma. Again, we'll talk about all of this in the hemonc section in a little bit more detail. But so how does Kaposi sarcoma have this oncogenic potential? Well, for one, it can bind P53, right? Remember, P53 is a tumor suppressor gene, so it can basically inhibit the function of P53. And the other thing it can do in cells that it's infecting, it can inhibit the FAS-induced apoptotic pathways that would destroy those infected cells. Okay, and so then these cells live longer, right? You get rid of your tumor suppressors, and so you start to kind of transition into this direction of a more malignant process, right? And especially if you're immunosuppressed, you have an even harder time fighting this virus. But again, that's what this is referring to. Again, not completely relevant to what's happening with our patient, although it's certainly something that we would be concerned about in a patient on immunosuppressive therapy. Big picture, the thing that you want to look for, if you're looking at bone marrow transplants or hematopoietic stem cell transplants or even sometimes liver transplants, always keep graft-versus-host disease in the back of your mind. Remember that it classically involves the skin, liver, intestines. And again, when you get to these larger stems with all this information, just look for something that really stands out. In this case, there were some really specific things that we talked about that took us down the pathway of graft-versus-host disease.